Mr. Charlie, user might be Jaykumar sir. Yesterday also he had the name user.
Okay.
Should I admit them both?
I have admitted user. Dr. Nupur also I am admitting. Prashant. Okay. Good morning to all the delegates and the esteemed speakers. Alembic, the makers of cloth, welcomes you all. It's an honor to host such a distinguished program and the panel. Have a great day that's full of a scientific feast. Without a delay, I would hand over the proceedings to Dr. Gauri Kapre. Over to you, ma'am. And the
सारे जहां से अच्छा हिंदोस्तां हमारा हमारा सारे जहां से अच्छा हिंदोस्तां हमारा हम बुलबुले हैं इसकी ये गुलसितां हमारा हमारा सारे जहां से अच्छा हिंदोस्तां हमारा हम बुलबुले हैं इसकी ये गुलसितां हमारा हमारा सारे जहां से अच्छा।
Good morning, everyone. I, Dr. Gauri Kapre, welcome you all to the midterm phonocon of the Association of Phonosurgeons of India, organized by Sri Satya Sai Institute of ENT, Guntur. This year, because of the global pandemic, all the academic events have shifted to the virtual platform. And although I'm sure we all miss the live interactions and the live surgical sessions, it certainly hasn't dampened the spirits of anyone. The faculties are as enthusiastic to teach, and the delegates are as eager to learn. So, without further ado, I cordially invite Professor Phanindra Kumar, the organizing chairman of this International Midterm Conference of the APSI, for the formal inauguration. Welcome, sir.
Thank you, Dr. Gauri. Good morning to all colleagues and participants from India, and good evening to all guest speakers and friends from abroad. At the outset, I want to thank the executive body of the APSI for choosing me to organize the midterm Phonocon 2020. As a founder president of APSI, I feel fortunate to organize the first international webinar-based conference of APSI. The focus in this conference would be on the juniors as speakers. I hope with all your good wishes and cooperation, the event is going to be hallmark in the history of APSI. Before we proceed with inauguration, I had to pay my tributes for two important persons in my life whom we lost in the month of September. One is my mother who used to bless me for every meeting or for every event I organized during my career. The second one is the internationally famous film playback singer S.P. Balasubramaniam, Padmasri S.P. Balasubramaniam, who inaugurated our Melody Voice Clinic at Hyderabad in the year 2000, which is considered the first voice clinic of India for professional singers in the country. Now, we proceed with the inaugural function by our chief guest, Mr. Manoj, with a brief introduction to him. Manu or Nagaru Babu is a most popular, famous Indian playback singer. Manu has sung almost 25,000 songs in 14 Indian languages. He received the prestigious Kalai Mamani Award from the government of Tamil Nadu and the Best Singer Nandi Award for many songs from government of Andhra Pradesh in 2000. He has been awarded by many popular cultural associations in India. Manu has done more than 3,000 live shows around the world. He is very simple, compassionate person. We are very thankful to him for accepting our invitation as a chief guest in spite of his busy schedule. But he is held up in a aircraft because the delay in aircraft. So he sent us a recorded message, which I am going to now play before everybody. With these few words, now I invite our chief guest of today's function, Manuji, to deliver his message and inaugurate the conference.
Good morning. I feel honored and privileged today for being invited as a chief guest to inaugurate the virtual midterm PhonoCon 2020 organized by Association of Phono Surgeons of India with Dr. Palindra Kumar as organizing chairman. I remember that APSI was initiated during a national phonosurgery workshop in 2003 at Sri Satya Sai Institute ENT, Guntur. The interesting aspect is that in the same workshop, my brother Shahid Babu, who was also professional singer, underwent phonosurgery for vocal cord paralysis, and his voice was restored like a miracle by Dr. Palindra Kumar. The specialty of phonosurgery, which was introduced for first time in India by Dr. Palindra Kumar 2 decades before, has become a ray of hope for many professional voices users, especially singers in India. I am happy to see that APSI has reached international standards, and I wish the midterm PhonoCon 2020 should end up with a great success. I thank the organizing committee of the conference for giving this opportunity, and I declare midterm Phono 2020 is open. Jai Hind.
Now, thank you, sir. Thank you very much. As you told, we organized a workshop in 2003 where Jay Kumar was also there as a faculty when we operated his brother, who is also a professional singer, and for vocal cord paralysis, theraplasty, and reduction, a voice was required. And the interesting aspect is the same person was allowed to give a welcome song during our first conference of the Association of Phonosurgeons of India in 2005 at Hyderabad. So, thank you, sir. Thank you very much. Back to Dr. Gauri.
Thank you, sir. It is indeed wonderful to have someone as prestigious singer as Mr. Manoj inaugurate our conference, and I thank you so much for that. I now invite Dr. Amitabh Roy Chaudhary, President of the Association of Phonosurgeons of India, to deliver his welcome address, please. Dr. Roy Chaudhary.
Good morning, viewers and all the faculties. It is my privilege on behalf of the Association of Phonosurgeons of India to welcome you to this first ever virtual conference of our association. As you know, we are fighting a real unknown disease, and because of that, as Dr. Gauri said, we have to shift our all the academic programs in the virtual conference. And I'm grateful to Dr. Fanindra Kumar to have taken this trouble of organizing this conference on the behalf of the association. Yes, indeed, in this pandemic, we have lost many of our colleagues by who lost their life by serving. So we would begin our conference by paying homage to all these people who have uh, lost their life in this pandemic in our from our fraternity. Now, I also thank Dr. Mr. Manoj for inaugurating our conference, giving his valuable time. My sincere gratitude to all the international speakers, namely Dr. Saliman Ahmed, Dr. Dinesh Chetri from the US, Dr. Kishore Sandhu from Switzerland, and Miss Kate Young from UK. I should be failing in my duties if I do not think about the galaxy of Indian stars who have not only contributed to our conference but who have shown extensive interest in the virtual conference the moment it was decided to organize. Now, ladies and gentlemen, laryngology has become such a vast subject today with all the branches of swallowing, airway, and voice. It is impossible to cover entire aspect of laryngology in a one-day virtual conference, but we have tried our best to pick and choose the most relevant, important, and also some contemporary topics so that you take home at the end of the day some messages, some information about laryngology. And with this, I would again extend a very hearty welcome to all our viewers from the country and abroad. I wish this conference a grand success. Thank you. Namaskar. Long live APSI.
Thank you so much, sir. Like Sir mentioned, we have a day that is jam packed with academics, and it promises to be a very exciting day. We have 4 international speakers, as Professor Roy Chaudhary just mentioned, and we have the who's who of laryngology in the country too. So, our first session will be a keynote address by the international faculty, Professor Soliman Ahmed from the USA. And to chair this session, I invite Professor Fanindra Kumar, who is the organizing chairman of this midterm Phonocon 2020 of the APSI. Professor Fanindra Kumar is the Emeritus Professor of ENT, Guntur Medical College. He is the founder, president, and chairman of the Association of Phonosurgeons of India. He's a member of the Voice Foundation and the International Association of Phonosurgery. He is also the scientific advisor. He was also the scientific advisor for the World Voice Congress in 2010. Dr. Fanindra Kumar has been invited as a speaker for numerous national and international conferences, and he has, to his credit, publishing many innovative and research articles on thyroplasty and adenine adduction techniques. He is well known in India for popularizing office-based laryngeal procedures and office-based surgeries and laryngeal framework surgeries in India. He also has, to his credit, first time describing the technique of office-based laser cordotomy for bilateral vocal fold paralysis as an innovation in laryngology, and he described this in the year 2012. I request Sir to please chair this session and also formally introduce our first speaker, Professor Soliman Ahmed.
Thank you, Dr. Gauri. I feel it's my proud privilege to introduce the very famous laryngologist from the United States and my friend, Professor Ahmed M.S. Soliman from Philadelphia. Professor Soliman is a professor of otolaryngology and head and neck surgery at the Lewis Trade School of Medicine at Temple University in Philadelphia. He completed his medical education, residency in otolaryngology and head and neck surgery, and also his fellowship in laryngology and voice disorders at Johns Hopkins University School of Medicine. He is currently the Vice Chair of the Department of and also Director of Voice, Airway and Swallowing Center, and the Associate Director, the Temple Head and Neck Institute. His clinical practice focuses on laryngology with emphasis on airway disorders. He is a fellow of the American Academy of Otolaryngology Head and Neck Surgery, the American Bronchoesophageal Association, the Triological Society, and the American Laryngological Association. He is the recipient of numerous awards, including America's Top Physicians, America's Most Compassionate Physician, and has been elected to the prestigious the Castle Connolly Top Doctor Philadelphia magazine from Philadelphia from 2011 to 2020. Dr. Solomon has authored nearly about 50 peer-reviewed publications and book chapters. He serves on the editorial board of American Annals of Otology, Laryngology, and Rhinology, the Journal of Voice, and International Journal of Otolaryngology and Head and Neck Surgery. In addition, he serves as a reviewer for nearly every major publication in the field. He has served as the president of Philadelphia Laryngological Society and Pennsylvania Academy of Otolaryngology Head and Neck Surgery. Now, it is my proud privilege and above all these things, is very compassionate person. Now, I cordially invite Professor Ahmed for his keynote address on the contemporary management of adult laryngeal stenosis and then advances. I invite Professor Solomon, Ahmed M.S. Solomon.
Sir, I think there is some connectivity issue at Professor Solomon's end, and he's not yet unable to log in, I think. In the meanwhile,
he's already available, I think. Just yes, he joined actually.
Dr. Gowri,
yes, sir.
Meanwhile, can we go through the whole day's proceedings
Yes,
for the
sir.
audience to know
Yes, sir.
what is on for the whole rest of the day?
Dr. Solomon has just joined, but I will just introduce the day's proceeding till he starts his.
Sure.
So, as the audience is aware, laryngology now encompasses 3 sub-branches, so to say: voice, airway, and swallowing. And this day's activity planned to give you an overview of all the relevant and latest in all these 3 subspecialties. Our first international speaker, Professor Solomon, who has just joined us, is going to be talking about airway. Then we have Dr. Dinesh Chetri, who is going to be talking a little bit about neurolaryngology, voice, and airway. We have, following that, a panel on swallowing disorders by none other, Professor Jaikumar Menon. We have invited talks by consultants all across the country. We have a symposium on benign vocal cord lesions, a symposium and panel on functional voice disorders. Then Professor Kishore Sandhu will be talking to us about airway surgery for suprastromal collapse. We also have consultant research paper presentation, which should be a very interesting session with very interesting topics in it. And the last and not the least session would be a panel on the future of phonosurgery in the country. I'm sure all the young members in the audience are looking forward to it. So without any delay, let's get on with the academics. Professor Solomon, sir, are you ready with your presentation?
Yes, absolutely.
All right. Welcome, sir. Good morning in India. And
Yes.
so you may go ahead, sir. Thank you.
Sure. Well, thank you very, very much, Dr. Vaidya. It's a pleasure and an honor. I wish I could be there with you in person. Hopefully in the near future, we'll be able to. Can you see my screen?
Not yet, sir. Not yet.
Okay. Give me 1 second. Okay, how about
Yes,
now?
we can, sir. Yeah, we can.
All right, fantastic. Let's do a slideshow. And there we go. All right, again, I wish I could be there with you in person, hopefully very, very soon. Next year. In the meantime, I wish you all the best, and hopefully everyone will stay safe. So again, Professor Valuri, thank you very, very much for the invitation. It's a great honor. I'd like to talk to you about a subject that's certainly very near and dear to my heart. I've spent the greater part of my academic career really focused on it, and that's the subject of adult laryngotracheal stenosis. So I'll share with you some of my thoughts and insights and some good video, we hope, too. So obviously, this is not a new condition. This is a condition that's been around for some time, although with different etiologies. So in the early 20th century, it was primarily infectious causes. So diphtheria and TB were the primary reasons. In the early 20th century, Chevalier Jackson brought the idea that high tracheotomy, or kind of brought attention to the idea that high tracheotomy can be an iatrogenic cause for this problem. Later on in the 20th century, we had more motor vehicles on the road. As a result, more laryngeal trauma, the so-called padded dash syndrome, where the larynx is crushed against the dashboard of the car and resulting against significant scarring as a result of that. So 1970s, and particularly the Vietnam War, endotracheal intubation really produced many survivors from respiratory illnesses. Unfortunately, many complications as a result of the intubation, particularly in those days where they had high pressure cuffs that were being used routinely. 1980s and 90s were more of these mini bikes and snowmobiles and ATVs and more laryngotracheal separation, where riders are going through and get an injury directly across their neck, either crushing or sometimes completely separating the larynx from the trachea. And of course, in the 21st century, although it's been around for a while, we're understanding a lot more about idiopathic and autoimmune causes for stenosis. So depending upon where you practice and what kind of practice you see, you'll see different etiologies. So if you've got a population that's primarily Northern European, females in particular, you'll see much more idiopathic stenosis. If you are in a major trauma center like myself, I see much more polytrauma and iatrogenic causes, again, from lots and lots of intubations. The Cleveland Clinic, for example, is an institution in the US that sees many patients. In fact, they're a referral center for Wegener's. So a lot of these autoimmune conditions, GPA as it's more correctly termed now. And they see, again, autoimmune is the largest part of their practice. So this is from Temple. This is from my first 8 years of practice there. So I arrived from an institution that was very similar demographically to Temple. I was in Baltimore and I came up to Philadelphia. Both were inner city hospitals. Yet I was seeing many more patients with this problem. So my first thought perhaps was maybe our patients were sicker. Maybe they have more diabetes, maybe they have more COPD, maybe they have more hypertension, maybe they're intubated. I just weren't sure exactly what. Maybe they were smoking more. So we looked at our patients and basically compared this first 74 patients that I had seen with 74 patients that were admitted, intubated, but wound up not getting laryngotracheal stenosis. What we found is essentially there was no difference between them in terms of the, how sick they were. No difference in COPD, no difference in diabetes, smoking, et cetera. What we found was kind of the most common causes, kind of what you would expect. So, having a previous tracheotomy increased the chance of having stenosis by 11-fold. If you've been previously irradiated, almost 6-fold. If you've been intubated more than 48 hours, it was almost 4-fold increase for getting stenosis. But this is the one that kind of had me thinking a little bit. So any kind of intubation, for whatever reason, even if it's non-airway surgery, increased your chance at Temple, at least, where I practice, almost 2-fold. So, the question was why? Why is this? And so our next thought was, could this perhaps be genetic predisposition? So we partnered with the pharmacogenetics group at our School of Pharmacy. And Mercelin Anise, who's a laryngologist at the University of Miami now, was a resident with us at the time. And again, we're working with the group at the School of Pharmacy. We looked at a variety of genes. So we looked specifically at the single nucleotide polymorphisms in genes that are involved in wound healing. So TGF-beta, MMP1, and CD14 were the ones that we looked at. And in addition, we also looked at all the other things, all sort of the typical demographic items. And as you can see here, there was no difference in the demographics, or past medical history or other comorbidities. But what we did find was that at least, among the small group of patients, when there's about 40 patients in each group, there definitely were differences, statistically significant. So some of these nucleotide polymorphisms predisposed patients to getting stenosis, and we found 3 of these. We were really excited about this one here, which actually seemed to give protection against stenosis. So this was our most recent study. After that, we looked at a larger group, 138 patients. Half of them were patients with stenosis, and the rest were controls. And the interesting thing that came out of this study was that African Americans were slightly more predisposed for getting laryngotracheal stenosis. So we thought this was, again, interesting. It still was relatively small numbers, so we'd like to confirm this with a larger study. We need about 300 patients, 150 in each arm. But we thought this was particularly interesting in light of the fact that Caucasians are much more likely to have the idiopathic type. So in addition to genetic predisposition, which is what we think our patients have, you also need a pathophysiology. You need an immediate cause for getting stenosis. So for external laryngeal trauma, the mechanism is, of course, a disruption of the cartilaginous framework from the trauma. This results in bleeding underneath the perichondrium. The overlying mucosa is frequently disrupted. And then when the blood is resorbed, the underlying cartilage is often lost. So in place of that, there's collagen that's deposited, and then with time, that collagen contracts. And because the trauma can really be anywhere, the location of the stenosis can be anywhere. So contrast this with the typical endotracheal intubation kind of mechanism. So the endotracheal intubation results in ischemic necrosis from that tube sitting against the mucosa, direct pressure on it, causing the mucosa to ulcerate. Secondarily, then bacteria come in and becomes infected. So you either have a perichondritis or maybe even a chondritis. And in its place, where you have this inflammation, you get fibrosis, it contracts. And because typically the greatest areas of pressure are the posterior glottis with the endotracheal tube and the upper trachea from the cuff, those are the 2 areas that you generally see the pathology. That's where you see the stenosis with endotracheal intubation. The idiopathic type of stenosis, we know very little about. We know primarily they're female patients, almost invariably all of Northern European ancestry. And this is from Guri Sandhu's group in the UK, where he basically set up a series of guidelines, kind of diagnostic criteria. For example, these patients should not have any evidence of vasculitis and any kind of caustic or thermal injuries, and they must not have been irradiated or intubated in the last 2 years. We always check serum markers for a variety of kind of autoimmune conditions. You can see in this group, the pathology is primarily submucosal. It's in the lamina propria. The overall, the underlying cartilage is actually normal. So regardless of the etiology, the patients present pretty similarly. They present clinically with hoarseness. They have biphasic respiratory stridor, usually, progressive. It usually occurs between 30 and 60 days, and many of them even beyond that, out to 3 months. Sometimes we'll see it depending on how slowly progressive. But it's not immediate. Generally it does not take place within a day or 2 of extubation. It's really much more delayed than that. And they have to have this history of laryngeal insult, at least for the acquired type. Now, the ones that present less than 30 days, this was an unpublished work, a little kind of small study that we did within our institution, again, with a relatively small number of patients. But we found is the patients that present earlier. So those that present, less than 30 days, and frequently the ones that present, within a couple of 2 or 3, 4 days of extubation, they tend to not do quite as well. In fact, they'll wind up requiring many more procedures, and the time between procedures is considerably shorter. We need to make this kind of a little bit of a larger study. We're collecting some more data to see if it really pans out in a larger number. But that's certainly our clinical impression among our own patients. When you see these patients, laryngoscopy, whether it be in the office or the ER, is very, very important. Put a little topical, and I know Professor Valuri is very familiar with this. He can do anything awaken anyone. We put a little topical anesthesia, a little lidocaine, and we're able to pass the scope down through and see the pathology. This was a patient that was intubated and presented with progressive stridor, and sure enough, she's got a pretty pinpoint tracheal stenosis there. Imaging is not necessary for everyone. But it is very helpful, particularly if there's, if you want to rule out cartilage collapse from the outside. So not just endoluminal scarring, but you're looking for collapse on the outside. I think the caveat here that's very important to remember is the CAT scan has to be done with 1 millimeter cuts. So you got to be very fine cuts through the area of the larynx, upper trachea, or you can potentially miss it. The typical is, 2-3 centimeter cuts, or even 1, and you can miss it very, very easily. And you think that, okay, they have no area, then you don't see any stenosis, the patient must be fine, when in reality, that's just not the case. 3D reconstructions, you can see here, sometimes are helpful. And we like to quantitate it as much as possible as well. So we usually do this, and really the single best test to use to quantitate how obstructed they are, how symptomatic they are, is flow volume loops. You can ask the patient to inhale deeply. They have very small units that the patients can carry themselves at home. And this is the typical kind of cookie cutter pattern that we see, where both the inspiratory limb and the expiratory limb are both blunted. Endoscopy, again, is very, very useful in these patients. We usually combine it to be both diagnostic and treatment. So we take them to the operating room. Managing the airway is always a little bit of a challenge, depending upon, how narrow they are or whether they have a tracheotomy or not. We're big fans of jet ventilation. We use it almost exclusively, or at least 95% of our patients. If you don't have access to jet ventilation, there are a couple of other options. One is intermittent apnea, which we use in our very large patients where they're just not effectively ventilated using jet. Thrive is another. We just kind of high flow oxygen in the nasopharynx to kind of keep them breathing on their own is another option. Or using an LMA, so using a laryngeal mask airway, but then you have to use a flexible bronchoscope through it, rather than rigid instruments, which is primarily what I use. So when you do your endoscopy, you're trying to figure out a few things. You determine how long the stenosis is, how narrow, so we get an estimate of the percentage narrowing, where it is. Is it tracheal? Is it subglottic? Is it posterior glottic? Is it some combination? Is it soft or is it scarred? You assess the arytenoid mobility. We take lots of photographs and videos usually. And then we usually treat at the same time. If it's soft, we'll inject some steroids. We may remove granulation tissue with our microdebrider, sometimes with a laser. Certainly if it's scar, we use the laser on that and balloon dilation. I'll show you some examples later. So here's some examples of endoscopies. This is a patient who had external laryngeal trauma many years earlier. Only has one vocal fold on the left. You can see that they're trached, and it's just a laser tube in here. So they have some tracheal stenosis, but also stenosis up supraglottically, where the whole right true vocal fold is gone, replaced with scar, and there's the scar band across the posterior aspect there near the arytenoids. Another here, this is somebody who had COPD, intubated, getting more and more short of breath. And, the question, is it a COPD exacerbation or is it something else? And when we saw him in the office, it was very obvious that he had stridor, not just wheezing. And when we took him to endoscopy and treatment, we were able to treat this endoscopically and get him markedly improved. He had really a multi-level tracheal stenosis. This is somebody who had a tracheotomy, and as they were trying to decannulate the patient, became very short of breath, became stridorous, and sure enough, an endoscopy. I mean, you really have to try hard to cause this kind of damage with a tracheotomy, and I think what they did, some kind of crisscross incision of God forbid knows what exactly they did, but thankfully we were able to clean this up with some microdebridement, with some laser dilation, steroids, and mitomycin C, and she's done well for years. Percutaneous trachs, I don't know how many you're seeing. We're in the US seeing many of them now. That's actually the primary way that tracheotomies are done. This patient here got off easy, just a little bit of exposed cartilage, as you're going to see. An eschar, we were able to clean that up fairly quickly and get them decannulated. Sometimes they're not quite so lucky, like this patient, where the most common kind of injury we're seeing after perc trachs is this collapse of the anterior wall, which is not really particularly amenable to dilation or laser. It's just kind of collapse. And unfortunately, they all wind up getting resections if they're healthy enough. This is the typical pattern that we see in patients with idiopathic subglottic stenosis. I'm not sure why. You always kind of get this dimpling. It's almost pathognomonic. It doesn't always involve the subglottis and sometimes the upper trachea as well. It's usually much more inflamed, so when we laser it, it tends to bleed a little bit more. And beyond it, looks pretty normal. All right. So when we, if you want to study something, if you want to communicate effectively among different clinicians taking care of these patients, you really want to classify. And the best way to classify I've found, and I think most people in the field have found, is the anatomic method. And this, was described way back in 1992 by Tom McCaffrey, who I think is well retired at this point. But we divide it into glottic, subglottic, upper tracheal, or some combination. The glottic stenosis can be further divided into anterior, posterior, or complete. And the tracheal stenosis can be anterior or circumferential. So we'll talk about each of these in turn now. So an isolated supraglottic stenosis is generally pretty rare. Invariably, it's a result of some kind of unrecognized injury, usually at this level here, at the hyoid or thyrohyoid membrane level. Frequently, these are unrestrained passengers in automobile accidents where the injury, again, crushes the upper part of the larynx. The force goes in this direction. And then you get these fractures. The whole, this portion is set back, as you can see here. And you have to really be kind of creative with the treatment. So sometimes endoscopic laser can work. Sometimes you have to go so far as to do a supraglottic laryngectomy or even a transhyoid pharyngotomy to get at it. There's another technique that was recently described. So this is a patient of mine who had was shot actually with a gunshot wound through and through the supraglottis. Came in the middle of the night, was seen by one of my colleagues. They did a trach, which was obviously appropriate. They did a DL. Didn't look too bad, so they didn't have to do very much. But unfortunately, there was enough raw tissue there that it pretty much scarred down circumferentially. And this is kind of when I'm seeing him in the office a few weeks later. And he's got this almost pinpoint. He's still tracheotomy dependent. And a pretty small view you'll see. Once you get through that, I cut that portion out just for time, but looking through, his vocal folds look normal underneath. So I learned this from my colleague Taner Yilmaz in Ankara, and I think Professor Valuri got a chance to meet him as well when we were together in Dubai. He came up with this, and he does, if you know his work, he does a great deal of endoscopic suturing. And is really quite facile at it, but he uses the same technique, this endoscopic Z-plasty, for glottic stenosis as well as supraglottic. And he's published, I think, 9 patients was his most recent series. Basically, where you make this inverted or this V-shaped flap that's superiorly based, that's partial thickness, and then the lower portion of the second half thickness-wise is divided laterally, and then you suture this superiorly and then this inferiorly, and it really widens things quite nicely. It's never perfect, but it's considerably better. So this is our patient that I showed you earlier that I did an endoscopic Z-plasty. In fact, I did it on both sides. Not perfect by any means, but considerably larger, now has a voice, and now is able to be decannulated. And I think if he ever, again, he's relatively young, if he needs to be intubated in the future, it can probably be done with a small ET tube. You can still see here he has a little bit of granulation and still hasn't quite settled down, but I think eventually will. And I was able to inject him just in the office with a little bit of steroid. This is only a month out from the procedure. So again, I'm pretty hopeful for him. Anterior glottic stenosis really varies. So if you have a thin web, you can probably just endoscopically divide it and put a little mitomycin C and it'll probably do okay. Thicker webs are more problematic. You're probably going to have to do those open with a keel or like we do here, and you can do these endoscopically or the traditional way, which is really open. Or again, you can use the technique, and this is one here where I did a while ago, open with an umbrella type keel, or you can use a very similar Z-plasty technique that, again, Dr. Yilmaz described. I haven't done it. It's a little bit tougher, I think, working there. But he has some wonderful videos if you go to his website. And again, he's published this as well. This is one I just saw recently, somebody who had multiple laser excisions, unfortunately with a CO2 laser. In fact, I saw it earlier this week. Multiple laser excisions of a glottic cancer, both sides, and came into my office on Monday, stridorous. Unfortunately, this is not only scarred, this also had cancer in it when I took her, trached her, and had to take some biopsies and open this up. So she's looking probably at a total laryngectomy at this point. Posterior glottic stenosis. We're seeing more and more of this these days, and it's most commonly from intubation. Again, think about the endotracheal tube sitting right here, putting pressure on this area. Again, this is where you get ulceration, fibrosis, after infection, and then it contracts down. Always with these patients, you want to intervene early if you can before the joints become fixed. In fact, you want to palpate them. You want to make sure that the cricoarytenoid joints are not fixed. Rarely, you might have to use a laryngeal EMG if it's old and you're not sure whether it is muscle activity or not. But again, for the most part, palpation will give you the answer that you need. A variety of techniques have been described for this. There's the endoscopic trapdoor where you elevate the mucosa, you cut down, you remove the scar, and then you lay the mucosa back down and you suture it. Sometimes better in artist renditions than it is in reality. Sometimes we, if all else fails, we'll wind up doing an arytenoidectomy to kind of give us some more posterior airway. More recently, though, and I'll show you that in a second, there are some other techniques that come up. So this is the best possible posterior glottic stenosis, right? This little scar band, you go in, you divide it, and when you're done, it looks like this. You pat yourself on the back. The patient is, has a trach now, but you get them extubated, and they love you for it. This is here showing you it's one of the arytenoidectomy technique where I make a lateral kind of C-shaped incision. I elevate this up, remove the medial portion of the arytenoid cartilage, and I'll often put this back and put some sutures in to kind of retract it laterally and keep it less likely to scar down. But more recently, Dr. Zeitel's up in Boston really came up with this ingenious idea. And again, if you know him, he's a big history buff, and was able to find some old article that kind of described this similarly, which he adapted the technique to use for these patients with posterior glottic stenosis. So he calls it the interarytenoid spring, or that's self-retaining. And this is what it looks like. You basically use a Montgomery type T-tube, which you modify by making some cuts. You cut the superior edge in, your superior limb, and this is what it looks like when you're ready to put it in. The patients have to have a trach. In fact, you pull the trach out, you insert it through the stoma, you pull it out through the laryngoscope, and then you put the trach back in. And this is one here that I did. So again, working through the stoma, I'm passing it in while my assistant is grabbing it here and pulling it. You'll see it pops into place. We've pre-measured it and made some cuts. So this is not the first pass. This is probably our third pass after we measured and we know exactly how it's sitting. And you're going to see here in a second, I'm going to pass the tracheotomy tube distal to it. There we go. So the patient keeps this in, in Dr. Zeitel's description, he said 3 months. But when you speak to him, and I speak to him about this, he basically said it was more for the convenience of his patients who kind of came from distances. We've used 2 months among my patients in Philadelphia, which tend to be more local, and they've done still pretty well. So here it is what it looks like. Before you put it in, you make some posterior cuts in order to release the scar. And this is what it looks like when you're done the way it's sitting. Now, moving on to complete glottic stenosis. So, posterior, anterior, often combined with subglottic. These are usually just absolute messes. Invariably, this is due to some unrecognized external tracheal trauma, laryngeal trauma. The one thing I would say about this is that you want to avoid this. You want to teach your EMTs, you want to teach your ER doctors, you want to teach all your local ENTs to refer these patients in sooner so that you don't get to this problem. Because invariably, they're going to wind up either with a laryngectomy or with a permanent trach because you can't solve this problem too easily when you have multiple layers, particularly when they involve the glottis as well. Subglottic stenosis, you can have a chance of fixing it endoscopically pretty well. And this is somebody here again with subglottic stenosis. We're able to use the laser on it, which you can see here, just working through a Dito laryngoscope, from Pilling. Using the CO2 laser, I'm making my radial cuts, and I've made already 3. In a subglottis, you can make 4 cuts because posteriorly you have cricoid. So again, it's less likely that you're going to perforate through. And then usually after I'm done lasing, I'll inject steroids, some Kenalog in the islands that are left over, and then we'll dilate it up. And then when you're done, this is what it looks like. This is him back in the office a few weeks later. And again, he's nicely opened and breathing well. Unfortunately, nowadays we're seeing more patients that look like this. This is somebody that I saw recently, had COVID, was intubated for a week or 2, was trached, and then they were unable to decannulate. So they referred the patient for evaluation. This is what you see. This kind of very diffuse edema. It's not scar that I can laser. It involves both the glottis and the subglottis and even the upper trachea. Now, luckily here, her joints are mobile. So the way I manage these is by, basically dilating up, injecting some steroids first. You can see here the retinoids are mobile. She had some granulation down here, which I cleaned up. And when you're done, it looks pretty good. The real question is it going to stay open like this or not? And that's the real question. She actually did okay. I just saw her back, a couple of weeks ago. And she's, stayed relatively open. She still hasn't been decannulated, but I'm working towards that. Why they're looking different, whether this is a COVID process or really just related to the fact that she was a smoker before that, is not really clear. But again, we're seeing these earlier now before they're scarred, and again, more in this stage. So laryngotracheoplasty, I can tell you that I rarely use it in adults for subglottic stenosis. Again, it's much more effective in children where they heal so much better. They have much better blood supply. Their cartilages are not ossified. A typical kind of boat-shaped incision. I haven't done one in years for this reason. Again, they don't work quite so well, but this is basically what you do. You're making your anterior cut, your posterior cut. You put 2 different pieces of cartilage grafts in, one posterior, this is your posterior graft, your anterior graft. We usually have, you need to stent these and have a trach below. This is one that I did a few years ago, again, is rib that I harvested. Made a larynga fissure, and again, made the posterior cut here, and you can see I'm trying to dilate up the posterior cricoid that I split, and then you put a graft back here, and then another one anteriorly over a stent. And again, you keep them trached. But again, adults don't do so well. They tend to scar down much more commonly. So I've, for the most part, gone away, and we're doing many more cricotracheal resections for this group. In fact, even in children, they're using many more cricotracheal resections. So this is a patient of mine here. You can see right away that tracheotomy is pretty high. You can see like her thyroid notch is here, and her cricoid is about here, and the tracheotomy tube is really high. Again, reminding you that high tracheotomy is an iatrogenic cause. So the setup here, you know, she's got under a great deal of extension. We made our incision. We divided the straps and retracted them laterally. You can see here, now we put an endotracheal tube, an anode tube, a wire reinforced. You can see the scarred area above it, and the thyroid notch is here, cricoid is here. I've kind of divided, and I'm elevating posteriorly and taking out the sort of the diseased cartilage little by little. Here's the piece that I removed. And then when I'm done, you're bringing it to, you can see the anterior portion of the cricoid has been resected. You can see an endotracheal tube from above has been pushed through. And here I am bringing the trachea, sewing the trachea up to the thyroid cartilage. And when you're done, again, here's your trachea sewn anteriorly to the thyroid cartilage. Obviously, you can't remove the posterior cartilage of the cricoid, or else you won't have any structure to the airway. So always the posterior cricoid has to be intact. For isolated tracheal stenosis, invariably these are going to be from the cuff of the endotracheal tube, you can imagine. In fact, here you can actually see a little bit of lost cartilage at the posterior glottis. Thankfully, she didn't scar. This patient didn't scar back here, and her narrowing is only in the trachea. So for this group, the short segment, you know, CO2 laser is very, very effective in treating it. I don't need a bronchoscope for most of these. I can use a subglottoscope to get down there. And again, it gives you much more working room in that its lumen is considerably larger. I use jet ventilation usually for these, but you can use intermittent apnea. If you got a healthy patient, you can just insufflate oxygen, have them breathe on their own. Most of my patients aren't quite that healthy that they can tolerate it. I'll usually make 3 cuts because posteriorly here you have membranous trachea and you're much more likely to perforate through, so you don't want to do that. So you tend to do 3, 9, and 12, or sometimes I do a little bit of a kind of a chevron here and then almost like, 12, and then, 5 and 7, followed by dilation of mitomycin C. So here it is. This is a different patient, but here's I kind of do these cauliflower type incisions, dilate. This is the subglottoscope that I use. It's got a built-in jet ventilation port, which makes it very nice to use. I can also suck smoke through another port. These are the Jackson dilators. They're made of brass. I think they're the same ones that Dr. Jackson used way back, and I still have them at my institution. And I used them for probably easily 15 years before I moved on to the balloons. The balloons have the advantage of giving you kind of a radial rather than a tangential type dilation, so less tearing. I can also get considerably larger. So, through a scope like this, you can only get so large a dilator in through and through. Even through a Dito, you can get no more than about a 34 French. 35 French is pretty hard to get through a standard Dito. Whereas here, I can go up to 16 millimeters very easily, which is a lot more than 34 or 35 French by passing through. I wasn't a believer and I know, in this at all, and I know that Dr. Chetri is on with us in this meeting. He and I had this discussion early on, and we were trying to design a study to kind of show, is there a difference between the two? It's pretty hard. You have to follow them out for a long period of time to really prove is one better. So we were able to never to kind of compare them side to side, although I can tell you just anecdotally and from my experience, I find the balloons work considerably better. Let's see. So here we go. This is working through the subglottoscope with a CO2 laser. Here I am. I made the 9 o'clock cut. I'm making a 12 o'clock cut now with a laser. I'll make another one out here. And then you dilate after that. Here it is, the balloon. Balloon coming out. This is the rigid balloon that I use. There are also semi-rigid ones that a lot of my colleagues use around the country. And then again, you'll see when you're done, it looks pretty good. It looks actually quite impressively good. And then we apply mitomycin C. Once in a while, I have a patient that has a difficult angle where I cannot get a laryngoscope or a subglottoscope in them to be able to access. Again, I have to tell you, in my practice, it's pretty rare. It's probably less than 1 or 2% of my patients I can't do this to. In that case, you put an LMA in and you place your bronchoscope, and you can use the flexible CO2 fiber here. Again, if you don't have jet ventilation or your anesthesiologists don't feel comfortable using intramain apnea, this is a good technique you can use. I just find it a little bit less wieldy. I don't think I can do quite as much with this that I can when I'm looking directly at it and using a micro manipulator. But again, there are people who use this technique almost exclusively. Just a couple of words here about endoscopic laryngotracheoplasty. So you have this A-frame deformity, and there are lots of theories as to why it forms. One is certainly how the tracheotomy is done. Vertical incision is much more common, or if there's any angling or weight on the tracheotomy tube, it can lead to this as well. And traditionally, these were all resected externally. If you read Dr. Grillo's papers, Dr. Matheson's papers from the Mass Eye and Ear, that is their technique. So this is Guri Sandhu, again, came up with this endoscopic laryngotracheoplasty technique, which I like quite a bit, where he uses a CO2 laser to make these two kind of C-shaped cuts. He takes it all the way out laterally to the perichondrium. His series, I think, of about 40 patients. He had one patient that had some subcutaneous emphysema, which resolved spontaneously. I usually apply mitomycin C on it. His series, actually, he did 2 treatments 6 to 8 weeks apart to keep it from reforming. Some patients I found, I've used this a fair bit in my patients. Some of them do well with one treatment. Others will get a lot of granulation. You've got to go in and clean that up. Montgomery T-tube. I used to use this much more earlier in my career, less so now. Usually the indications are somebody who's failed laser therapy, somebody who's just too sick to undergo resection, and with a tracheotomy tube in, they don't have much of a voice. Failed resections. I have a patient now who has a very long segment stenosis. It's not even a stenosis, it's really malacia. You put a tracheotomy tube in him, he's got absolutely no voice, and he's a physician and needs to work. Doesn't have time to get a resection quite yet. He needs to kind of settle down a little bit. So I manage him with a T-tube. Important thing to remember about T-tubes is that they've got to be really taken care of meticulously. Both the upper limb and the lower limb have to be suctioned out. And they have to be changed, usually at least every 9 to 12 months, and sometimes sooner if they get seeded with bacteria, or else they can become quite a mess. This is just a brand, there are different brands for them. Boston Medical makes them as well, but this is basically the typical design. And here it is in a patient and the frontal view. This one was in a patient for 17 years, and nobody took it out. Everybody was afraid to take it out, and the patient came to me really not able to breathe and reeking, horrible odor. We had to take him to, everybody was afraid because normally the way you take these out is just grab and pull. But I think if you did it with this one, it would have torn and they would have been left with a foreign body in the airway. So we had to kind of suspend this patient and very meticulously clean it up all around and loosen it up from the surrounding trachea, take it out. And then and with him, I actually just managed him with a regular tracheotomy tube. he wasn't a resection candidate. Resection, tracheal resection, as opposed to cricotracheal resection, is actually easier in a way. Again, this is a patient who has a tracheal stenosis. I usually reserve this for patients who are young. So again, invariably, it's the trauma patients, 18, 20-year-olds, they're healthy, they're not diabetic, although you can do this on diabetics successfully. They're younger, they're healthier, they're going to do well. Males have bigger tracheas, they're also going to do better. So here it is, again, the same technique. It's very similar to cricotracheal resection. We do a kind of a horizontal incision in a skin crease, dissecting down. You divide the strap muscles and retract them laterally. This is somebody that doesn't have a tracheotomy. Makes it a little bit easier because it's less things to, less things to be in your way, less trachea to resect. Here it is, again, once the area is resected, I put these Prolene stitches to kind of give me a little bit of a pull. We intubate the lower part of the trachea with an anode tube. Now you'll see we'll intubate from above, take out the anode tube, and then close it. Close it in layers, the posterior wall first, the posterior membranous portion. I usually do this with PDS. And we tie all those down, and then you tie the anterior row. And this is what it looks like when you're done. So we used to put these Grillo stitches, as we call the chin to stitch to chest, to keep them from pulling their neck back and potentially ripping. Nowadays, we're using these kind of devices, which we have our occupational therapists design. I think we just wrote this up. It was just accepted for laryngoscope. So the last, I think, 10 or 12 patients that we use this on. But it's a custom orthotic that that they can design for you preoperatively and are quite comfortable. This is the last one that I did, which is almost 5 or 6 centimeters that we resected. I have to tell you, with this one, I had my thoracic colleagues work with me on it. They're much more cavalier in getting down into the chest and really pulling up. They were able to mobilize the trachea down to the carina and pull it up for me. So it made closing it much easier. And even though this patient was diabetic, she was young, only in her 30s, which made it easy. And you can see one of the stitches still there, a little PDS stitch. It looks pretty good. And this is only about a month out from the resection. So she did very, very well. You can practice this. It's technically a little bit challenging, especially if the tissues are inflamed. Dr. Isaacson, one of my colleagues, and I developed a sheep model that you can do this on. It's actually very realistic. It's about 1.25 times the size of a human trachea. But you can use goats, you can use sheep, you can use pigs. Again, very helpful in practicing with residents and the suturing, so that you don't waste much time in the operating room. This is an open access journal article, World Journal, so you can access this for free online. And here we just resect it a little bit. And again, putting in a posterior row and then the anterior row. And here's the bronch after we're done, which we usually do for our patients. You can see I didn't do it perfectly here. There's a little dehiscence. If this were a real patient, it'd be a problem. So a little bit about pre-stenosis here. And, because, again, I'm at a center where we have lots and lots of patients who are intubated, lots of patients that we have to take for tracheotomy. We've been doing more laryngoscopy on those patients and seeing things that look like this. And these are tubes that have not been in for a very long time. Yet there's, again, you can see sort of stenosis in the making. Here's the mucosal ischemia. It's probably bacteria. If you culture this, you'll get bacteria. We usually do, and we treat it with antibiotics. The question is by intervening early in this patient group, by putting mitomycin C, by treating with antibiotics, by treating with PPIs, by treating with steroids, are we going to prevent stenosis from happening? Again, a tough study to do, but it is something that we've been talking about on a national level, trying to get a multi-institutional study to do this. I can tell you among my patients, whenever possible, we try to, if I'm taking somebody for tracheotomy, or we've decannulated, or if they're extubated somebody, they're hoarse, we do a laryngoscopy and we see something that looks like this. We try to take them to the operating room and again intervene using those things that I just mentioned, in the hopes that it'll keep them from coming from developing a stenosis. I can't prove for sure, to be honest with you, whether it does or not. And sometimes in cases they work, but maybe if I didn't do anything, they would have also done well. It's hard to know. This one here, a little bit more extensive injury with a, you can see the arytenoid has been fractured. So we debride the necrotic tissue, inject some steroids, apply mitomycin C, treat them with antibiotics and steroids. So again, not for everyone, but they may be useful. So in the next portion of the talk here, I'm just going to tell you a little bit about some of the research that we're doing and kind of what it spurned from. Some of you may remember back in 2008, in fact, it was at our American Bronchoesophagological Association meeting, and really this whole concept of tissue engineered airway and tracheal transplantation. This is from Paolo Macchiarini's group. This was the first patient that they published at the time. This was a young woman, I think she was 30, and had tuberculous kind of infection of her airway, had a subglottic as well as a left mainstem bronchus stenosis. And this is from their first paper where they were able to put in basically a tracheal transplant. They took a piece of trachea from another patient. They were able to decellularize it. They seeded the inside with the patient's own epithelial cells and the outside with the patient's own chondrocytes. And then after months of really developing this graft, put it in surgically. They reportedly, followed the patient. You can see here before and after. She's much, much better. The left mainstem is broken, is wide open. They apparently took biopsies and showed, healthy tissue. And a patient was discharged on postoperative day number 10. So the story went. A couple of years later, here he is, Dr. Macchiarini. So rather than spend a lot of time making a graft from a patient and seeding it in vitro, which was quite expensive, he came up with the idea of making these biopolymers, as he called them. It's a nanocomposite biopolymer, which were designed, were 3D printed based upon a CT scan of the patient to make them custom for each one. Of course, then they grafted these into patient and were able to use a variety of kind of growth factors to make the patient's own, have the patients basically reline them in vivo after they've been implanted. And the whole world was really very excited about this until really wasn't very long until lots of these reports started coming out that maybe these patients weren't doing so well. And there was a whistleblower at the Karolinska. And again, headline after headline after headline of how these patients weren't doing so well, and perhaps some of this, some of these studies, some of this information that was being disseminated wasn't true. Unfortunately, we had the opportunity to take care of one of these patients who was transferred to our institution for a trachea and lung transplant. This was a young girl who had, of all things, hyperhidrosis, so had sweaty palms. In Turkey, wound up having a thoracoscopic kind of sympathectomy. During that procedure, her trachea was injured. They tried multiple times to repair it, fistulized, basically lost her right lung, and then eventually was transferred to the Karolinska to have Dr. Macchiarini put in one of these, nanocomposite biopolymer artificial tracheas in her. And I can tell you, so this is bronching through her tracheotomy tube. This is her left mainstem now. This is the nanopolymer. This is her native trachea. You can see the sutures here. And I can tell you this doesn't look alive, right? That certainly doesn't look realigned. Looks pretty dead. And this was before we transplanted her. Unfortunately, at first we were able to do a lung and trachea transplant, which traditionally have not done very well, but our transplant surgeon was able to put in another vessel, sew in another vessel to feed the trachea. So she did quite well for a while, then unfortunately, developed a lot of other complications and wound up eventually passing away. This was really quite a dramatic case for us. She literally died in my arms as she bled out eventually. And really inspired us to kind of go back to the drawing board and say, we know what he did, just, it was, he moved a little too quickly. I don't think the science was really quite there. So again, we worked with our bioengineering department, Dr. Plechko and her team, who are really experts in studying cartilage. And interestingly, before she worked with me, she was working mostly on articular cartilage with our orthopedic group. But we were able to convince her to work on tracheal cartilage. And so this was the first study, we did. We looked at measured compression, of trachea using, so the idea is that most of the studies that were done on tracheal strength were tensile strength, which is less important for transplantation than compression strength. So she had a device that were able to basically, test the compression of trachea. We had samples that we got from the biobank, basically tissues that were rejected for transplantation. And we were able to show a few different things. So certainly with age, as you got older, the stiffness went down significantly. It became much more compressible. And this was almost directly related to the amount of collagen. So the more collagen, the more stiff. And as you got older, you lost that collagen. We're able to use here IR spectroscopy to be able to determine non-invasively the amount of collagen that's present. We're also able to determine the proteoglycan content, again, using this FTIR, which is Fourier transform infrared spectroscopy. And also, when we looking at the younger versus the older group, clearly the amount of proteoglycans went down with age, as did the water content as well. We had this device, so actually we were able to kind of do this endoscopically. So you can potentially do this without having to cut the tissue open. You can use a probe. This is just in a cadaver model, showing proof of concept that you can do this in vivo potentially on a larynx to determine content without having to cut it. We moved on again to develop scaffolds, very similar to the technique that Macchiarini and his group used. We're able to take trachea, native trachea, and completely decellularize it using an enzymatic detergent method. To do so, we're able to follow the process using, again, FTIR, this mid-IR imaging spectroscopy, to see how it was decellularized, not just decellularized, but how the collagen content went down, how the proteoglycan content went down. And basically, this is a process. You have to wash it enzymatically for 25 different days in order to completely do it. More recently, we're able to kind of speed up this process to do it only in 6 days. That paper is still in the works. So again, we've got a lot of future directions that we're working on. We still need a multi-institutional study to confirm our findings with the single nucleotide polymorphisms. We need about 300 patients in total. We need 150 stenosis patients and 150 controls. Hopefully we'll get to that. We need to do whole genome sequencing of this idiopathic subglottic stenosis patients because that group we know has to be, somehow genetic. Since it's all women who get it, they all come from the same, genetic background, same kind of cultural background. So there's probably very strong evidence. And there's one paper that came out already looking at one family. I have a family of patients as well that both mother and daughter have the same condition. We're working on this rapid decellularization method and eventually, hopefully, transplanting in an animal model, but we're not there quite yet. So again, I just want to summarize. I hope this is kind of whirlwind tour. Laryngotracheal stenosis is definitely a challenging problem, no doubt about that. We have a lot of different tools and techniques, but the future is bright, and I hope that we'll have many more of these patients kind of smiling and giving us the thumbs up because they've done well and have been decannulated and they're happy. Just want to acknowledge that can't do this work alone. The group from Temple here, these are all former residents of mine that have worked on these projects with me. The group from the pharmacogenetics lab, Dr. Kranitsky and his wife, Natalia. Statistics, you need a good biostatistician to do this. And of course, our bioengineering group, Dr. Plechko and her team. which are really instrumental in doing all the scaffold studies and the FTIR studies. I'm going to stop here and just say thank you. It's a great honor. I hope we see each other again in person. I hope I get an invitation at another point to come there and see you all in person. Thank you very much.
Thank you, Professor Ahmed. In
Quite
fact,
welcome. Is there time for questions or did I go too far? Let me check the time here.
in
We should have
fact,
hopefully time.
thank you, Professor Ahmed. In
My
fact,
pleasure.
the management of laryngeal stenosis is tricky and still continues to be a challenging problem for many otolaryngologists and airway surgeons. I feel we're all very much benefited with your wonderful, educative, and illustrative keynote lecture on these advancements in contemporary management of adult laryngeal trichostenosis. Once again, thank you for accepting an invitation in spite of your busy schedule and for your academic contribution to midterm PhonoCon 2020. We hope you will visit India soon for our physical meeting too in the near future and relish your hospitality. Thank you, sir. Thank you.
Thank you. Thank you very much. I'll stay on a little bit longer, but it's about midnight here. So if I get sleepy, you'll know it. Thank you
Thank
very
you
much.
so much, Professor
Thank
Ahmed.
you.
And
My
it,
pleasure.
yes, and we do understand because of the time zones, it's a really inconvenient time for you. So special thanks
at
for
all.
that as well. And it was
It's my-
really a very enriching lecture to learn from you.
Thank you. It's my pleasure.
Once again, and like you said, we hope to meet you in person someday in India.
Same here. Thank you.
So, with this, we shall move on to our next talk, and that is by Dr. Dinesh Chetri, who is also from the USA, and he will be talking to us about office-based laryngeal surgeries. And to chair this session, may I invite Dr. Amitabh Roy Chaudhary, the president of the Association of Phonosurgeons of India. Dr. Roy Chaudhary is the professor and head of the department at Vivekanand Institute of Medical Sciences and AMRI at the Laryngology Unit in Kolkata. In addition to being an expert laryngologist, Dr. Roy Chaudhary is an accomplished skull-based surgeon and a cochlear implant surgeon, and he has been a mentor to many CI centers in West Bengal, Assam, Manipur, and even in Bangladesh. He has numerous publications and book chapters to his credit, and he's the co-editor of the Textbook of Laryngology, the official textbook of the APSI, a must-read book for all the budding laryngologists and phonosurgeons in the audience. Sir has been a faculty and keynote speaker at various national and international conferences and has been an invited faculty at the European Otolaryngology Congress in Brussels. So I invite you, sir, to be the chairperson for the next session. Amitabh, sir.
Thank you, Dr. Gauri, for the kind introduction. I indeed have the pleasure to introduce Dr. Dinesh Chetri, who is the professor and vice chair of the Department of Head Neck Surgery at the University of California, Los Angeles. He has authored over 100 publications, and most of them have been related to neurolaryngology, swallowing disorder, which is his key area of work. And his many projects have been funded by National Institute of Health for his excellent work. And his general interest includes, as I said, neurolaryngology, surgical treatment of spasmodic dysphonia, malignant growth of the larynx, and dysphagia evaluation and management. He also authored a book called Dysphagia Evaluation and Management Otolaryngology, which I had a chance to browse, and it's an excellent book, a very must read for all laryngologists. And he also volunteers externally as a council member of the American Laryngological Association and the associate editor of the Laryngoscope, the famous journal. And he has also led many international missions in Asia as well. So the topic he's going to cover today is it's like a hot cake in today's laryngology world, office-based procedure in laryngology for surgeries, procedures and surgeries. And he has been doing this for a good few decades now. And none other than him is the best person to talk about this kind of office-based procedure, because these procedures have transformed the way we deal with laryngology patients today. I think we have already heard in the keynote address as well that so many things can be done, but it'll be nice to see what Dr. Chetri can do in the office and do justice to all our patients. Over to Dr. Chetri, and it is indeed a pleasure to have you again, time and again, in our Indian platform for sharing our knowledge and sparing your valuable time. Welcome, Dr. Chetri. I would invite you to share your screen and give your introduction. Thank you.
Great. Thank you, Amitabh, for your kind introduction and for everybody for inviting me to give this talk. Also for Dr. Solomon letting me know. I always learn a lot from you, and it's kind of amazing that you're still awake there. It's midnight, so I'm very impressed. Me, on the other hand, thought I would be sleepy, so I've got mine partially recorded. And it's also going to be about 30, 40 minutes, so there'll be a lot of time for discussions if needed. So I'm going to share my screen. Hopefully it works. There it is. And share computer sound. First, I'm going to hit share. You can see my screen?
Yes, we can.
Okay, let's start.
Perfect. Yeah.
Good morning, everyone. Thank you for inviting me to give this talk. It is an honor and a privilege to do this. I'm going to talk about office-based laryngology procedure. So as we all know, there has been an evolution of office-based laryngology. Laryngology actually started in the office, but we were very limited because of lack of anesthesia and instrumentation that was limited to headlight and laryngeal mirror. So laryngology then went to the operating room because of the development of better anesthesia, microscopes, rigid Hopkins rod endoscopes, the CO2 laser, and microinstrumentation. But now laryngology is coming back to the office. So what's allowing the shift in laryngology to office-based practice? Well, there has been technological improvements in video endoscopy with the flexible chip-tip endoscopes, the ultra-thin transnasal esophagoscope. We now have fiber-based lasers like the KTP laser and the CO2 laser. We're doing new things like dysphagia evaluation and balloon dilations. We've also figured out new ways to approach the larynx in terms of anesthetizing the larynx and using new injectables and even old medications like steroid for airway stenosis. So what do you gain by office-based procedures? Well, you gain savings of time and increased efficiency. So for me, and in the operating room, a procedure time may take 30 to 60 minutes with a turnover time of 30 to 60 minutes. In the office, the same procedure may take 15 minutes with a turnover time of 5 to 10 minutes. Sometimes repeated procedures are also better done in the clinic. So if you're doing frequently laser of laryngeal papillomas, this might be something you might want to consider doing in the office. Some patients are difficult to intubate, like radiated patients or older patients who are at risk of anesthesia. And so these procedures might be better done in the office. For injection augmentation, you can monitor voice quality in the office. And most importantly, the patients can also drive themselves to your office and go home the same day. And there is overall cost savings in doing it this way. However, there are some things you do gain by going to the operating theater. What are those? For example, you get better precision. For me, I prefer to do intraoral cysts in the operating room. Also, if you want very fine control of laser ablation, for example, for medial surface focal fold papillomas, it's better done in the operating room theater. Operating room also has microscopic magnification with true colors, and what you have to rely on in the office is the color on the video screen. Also, there are more trained ancillary personnel in the operating room theater, and most importantly, complex lesions or procedures are best done in the operating room. For example, I still do most of the airway procedures in the operating room. So now we're really doing a lot of things in the office, right? In the nasopharynx, we can do biopsies, injections, and dilations. In the oropharynx, we can do swallow evaluations, biopsies, injections, lasers. We are doing significantly more in the larynx. Besides traditional laryngoscopy and video stroboscopy, we can do biopsies, we can do injection augmentation, we can do therapeutic injections, and we can do lasers. With transnasal esophagoscopy, we're now starting to own the esophagus. We can do diagnostic endoscopy, simple biopsies. We can do dilations of the esophagus. You can inject Botox. I do all my tracheoesophageal punctures in the office using transnasal esophagoscopy. Also, we can enter the trachea. And once we can do that, we can do our endoscopies and biopsies, steroid injection for airway stenosis, and even balloon dilation if you wish. So I'm going to briefly cover the most common and impactful in-office laryngology procedures. I have listed the most common procedures that I do in the clinic, and I've highlighted the ones that I'm going to talk about today in red. So first, I'm going to talk about vocal fold injection. So vocal fold injection augmentation is primarily done for symptomatic glottic insufficiency. I ask whether this is an early injury or if the patient is an OR candidate. If the patient's not an OR candidate or it's an early injury, I will perform injection laryngoplasty in the office, and this can be repeated again. If it's a late injury and there's no chance of recovery and the patient is a good OR candidate, I will do framework surgery in the operating room in these patients. The technique I use is a percutaneous injection augmentation using a transmembrane or transcartilaginous approach. Of course, there are many ways to inject the larynx, including percutaneous transtracheal, transthyrohyoid, transoral via the long needle, or transoral via channel scope. The injectables I'm currently using is Renu-Voice Gel or Renu-Voice, which has the calcium hydroxyapatite. Other injectables that are available are mostly hyaluronic acid based. There's also a new injectable called Silk. The advantage of going percutaneous is that it's really fast. It typically takes less than 30 seconds to inject the material. There's minimal discomfort, no need for laryngeal anesthesia, and the results are excellent with experience. However, there is a learning curve. The injection itself, while viewed on the video monitor, is done by feel, so you can't directly see the needle going into the vocal fold. It may also be difficult in very obese patients, and of course you need somebody to hold a scope for you while you're doing the procedure. So I'm going to go through the injection technique step by step. This is a transmembrane technique, step 1. The first thing I do is I palpate the anterior laryngeal landmark. Most importantly, feeling for the cricothyroid membrane, as you can see my finger touching the neck there. I do inject a small amount of anesthetic on the skin over the needle insertion site, and that makes it much easier for the patient to tolerate the injection. Step 2 is to place the finger over the cricothyroid membrane at the inferior thyroid ala, so I know exactly where the inferior border of the thyroid ala is. Next, I take a needle, a 27 gauge needle, and I just touch the inferior border of the thyroid cartilage, and I make the needle tip to the cartilage contact. So I know I'm at the very low border of the thyroid cartilage. Next step, I take my finger and I just slide that needle underneath the cartilage. The reason to do this is because as soon as you slide that needle under the cartilage, you enter the paraglottic space, which is where you want to inject your material. At this point, I do bend the needle towards the paraglottic space. So in this case, going transmembrane, I want to go slightly up and slightly lateral, visualizing the paraglottic space adjacent to the vocal process, and then inject the material while watching it on the video monitor. So here is a video. I am palpating the neck with my finger right at the cricothyroid membrane. Next, I'm going to put my finger at the cricothyroid membrane so I know mentally where the larynx anatomy is. The needle is now touching the cartilage. I just push that needle under the cartilage, and I know that as soon as I push it underneath, I'm in the paraglottic space. Now I'm going to point that needle laterally and superiorly towards the paraglottic space, and then go ahead and do the injection while you're looking at the video monitor. Leave it at that. Leave it at that. Leave it at that. Now, how do you do the transcartilaginous injection? The palpating of the landmarks is exactly the same. You want to put your finger at the level of the cricothyroid membrane. However, in this case, as you palpate the cartilage, you want to go perpendicular and through the cartilage. And as soon as you feel the pop of the needle going through the cartilage, you are in the paraglottic space. So again, at this point, you can bend your needle laterally, sort of visualizing the vocal process, and go ahead and inject your material in the paraglottic space. So here's an example of the needle going perpendicular through the cartilage. As soon as I feel the pop, then I will bend the needle towards the paraglottic space and perform the injection. So the key to successful injection laryngoplasty using the percutaneous technique is to mentally and physically target the paraglottic space and avoid superficial injection while getting adequate medialization. I find it very useful to bend the needle. For the transmembrane technique, I feel the inferior border of the thyroid ala with the needle and just slide that needle just underneath and then bend the needle up and lateral in the paraglottic space. And in the transcartilaginous technique, you want to go perpendicular to the cartilage, and as soon as you feel the needle pop through the cartilage, you want to bend that needle immediately lateral and posterior until you get into the posterior lateral paraglottic space and do your injection there. So similarly, I'm going to talk about Botox injection for spasmodic dysphonia. There are, again, many ways to inject Botox. All are effective. None have been compared one to another. You want to use what you are comfortable and familiar with. So there's percutaneous transcervical, which is how I do it. Some do it transtracheal by seeing the needle in the trachea and then pointing it towards the vocal fold. You can do you can also inject transthyrohyoid, transoral, with or without EMG guidance. So again, the technique I use exactly what I showed earlier. I find it very useful because it's very quick. And also for Botox injection, I do not need visualization in the monitor, and it's done completely by feel. The target muscles for adductor spasmodic dysphonia are thyroarytenoid and lateral cricoarytenoid muscle. And as you can see in the figure on the right, the TA and the LCA muscles are exposed to the paraglottic space. So if you inject your Botox in the paraglottic space, you will get that Botox to both muscles. And so I personally feel that you do not need EMG guidance to inject Botox for spasmodic dysphonia. Similarly, for abductor spasmodic dysphonia, the target is the posterior cricoarytenoid muscle. And again, I do it by feel. You can go transtracheal directly through the cricothyroid membrane and then through the through the lamina of the cricoid into the PCA muscle, or you can rotate the larynx and inject it posterolateral to the thyroid ala. So here's an example of Botox injection for adductor spasmodic dysphonia.
And transcartilaginous injection. One.
So that's using the point touch technique, feeling the cricothyroid membrane first.
And they place it here, cricothyroid membrane. Transcartilaginous.
So you want to feel the cartilage, feel the needle pop through, and as soon as you pop through, you want to hold that needle so it doesn't go any further, and then do your injection. Botox dosage is practitioner dependent. I typically inject 1 to 1.5 units bilaterally. I want to talk a little bit about laryngotracheal anesthesia, because once you can get adequate anesthesia to the larynx, the world opens to you in terms of the number of procedures you can do. So it's worthwhile talking about how to get adequate laryngotracheal anesthesia. So the medication I rely on is 4% lidocaine. That is a topical solution. You can do this transnasal using a laryngeal gargle. So you want to take a channel scope and give aliquots of 0.5 mil while the patient phonates. A total of 3 to 4 cc of 4% lidocaine is needed, and it typically takes about 2 to 3 minutes to get adequate laryngeal anesthesia. Another way that I prefer now to anesthetize the laryngotrachea is the transtracheal anesthetic spray, where first you palpate the cricothyroid membrane, then I use a small amount of 1% lidocaine with the epinephrine so the patient tolerates the whole procedure while you're doing your 4% topical lidocaine injection. So again, typically the injection is done in the subglottis with the needle inserted between the cricoid and the thyroid membrane, so that's a transmembrane technique. I will spray about 3 to 4 milliliters of 4% lidocaine in very small aliquots while the patient phonates, and that's a critical thing to do. I use a 1-inch 25 gauge needle, which I find to be quite useful compared to longer needles because you will avoid getting into the posterior membrane of the trachea. So the figure on the left shows you the trajectory of the needle in the thyrohyoid technique. This was from the initial paper discussing this approach. And then a second paper came showing the figure on the right where they suggested that performing a double bend of the needle was good, one at the hub of the needle and one more distally. And so that's what I do. The other advantage of this technique is that you do not need to purchase a scope with a side channel. You can use a regular flexible scope. I do anesthetize the skin first. I palpate the thyroid notch, I double bend the needle, and then I insert the needle into the skin, and then I aim nearly vertically down. So here you can see palpating the thyroid notch with my finger on the left hand. The needle is double bent, goes in first, and as soon as you enter the skin, you want to point vertically down. And then this is a view through the scope. If you look at the area of the petiole, that's where the needle should come out. That's the ideal location for the needle to come. And then because you have the double bend, you can point the needle to either side of the vocal fold, and you have extreme control because even if the patient swallows, the needle stays in place. This video just showing laryngeal gargle or anesthetizing the larynx with 4% lidocaine prior to performing procedures. So now that we've learned how to adequately anesthetize the larynx, I'm going to talk about laryngeal procedures requiring laryngeal anesthesia. So the first I'm going to talk about is KTP laser of the larynx. The KTP laser I use in the office is the Aura XP laser. It's a KTP laser with a wavelength of 532 nanometers. This laser is going to be no longer available. And so there is a new laser out there called the Blue laser, which is a 445 nanometer wavelength laser. And both of these are lasers whose energy is absorbed by oxyhemoglobin, so you can deliver precise coagulation to tissue while leaving the surrounding tissue unaffected. So here's an example of a professional singer who had a hemorrhagic nodule. She has a major singing event in 2 months. And so at presentation, you can see she's got a hemorrhagic nodular polypoid change in that left vocal fold. I put her on complete voice rest for 2.5 weeks, and she comes back and she continues to have this hemorrhagic nodule, and it didn't look like it was going to go away anytime soon. So at that point, I performed KTP laser in the office. You have to be very gentle and use very small amount of energy. So I gave her 28 joules of KTP. She came a week later. It looks a lot better. She got one more treatment at this time, 26 joules, and the lesion is gone 3 weeks later. And then she was able to go ahead to her event that she had signed up for. The most common use of office laser in my practice is for laryngeal papillomas, especially for my patients who have recurrent papillomas. They do not like to go to the operating room and prefer just to come to the office for laser. And so for these, you can see on the right upper hand corner, there is very little papilloma in the petiole of the epiglottis, as well as in the left false vocal cord area and the ventricle and some of the true vocal fold. And this is an excellent candidate for office laser. And for these, you want to use more than the last case, about 150 to 200 joules per session. And this patient comes every 4 months or so and gets his laryngeal papillomas ablated. Next, I'm going to talk about airway evaluation by the use of office tracheoscopy and bronchoscopy. And I think one of the most useful procedures we're doing in the office now is flexible laryngotracheobronchoscopy, because it's one of the most effective procedures for preoperative assessment of airway stenosis. You can assess the entire airway, and once you do this, you typically do not need to order airway imaging. So office tracheobronchoscopy is done to assess the characteristics of a stenosis. If you look at the right upper picture, you can immediately see a subglottic stenosis and a normal trachea underneath. So that person does not need an airway endoscopy. However, if you look at the right lower hand picture, you can't see really the stenosis very well. So this is a perfect candidate for an office bronchoscopy. So you can see that there is multi-level stenosis in this patient, and what you're looking for is the severity of the stenosis, the length of the stenosis, the distance from the vocal folds. You know, what kind of stenosis is it? Is it webby, thick? You're kind of trying to decide how you're going to treat this, whether with laser or dilation. Will you have any difficulties managing the airway, etc. So after this, you have a pretty good sense that you're going to manage this with perhaps lasering and dilation, and there are many other ways to manage the airway. Here's another situation where office bronchoscopy is very useful. This was a patient who came with hemoptysis, and you can see that there is an invasive tumor in the right subglottic and tracheal area. This patient has invasive thyroid cancer, and a CT scan was done to confirm that. Here's a novel approach that we talked about earlier. Nowadays, patients who require frequent dilations in the operating room can now have these office steroid injections performed. After laryngotracheal anesthesia, the needle again goes through the cricothyroid membrane, and you can adequately inject Kenalog steroid to the trachea. And this particular patient was requiring frequent trips to the operating room, and the operating room treatments could be delayed by doing these injections in the office. Next, I want to talk about one of my favorite procedures, transnasal esophagoscopy. This has completely transformed our practice and is a very useful technique to assess swallowing from the nose to the stomach. So what is a transnasal esophagoscope? It's basically a 5.1 millimeter flexible scope with a 2 millimeter working channel. Before we had the working channel, we could do nasopharyngoscopy, laryngoscopy, stroboscopy, but we were very limited. Once we added a channel and air supply to the scope, we are now able to do so many more things. So the working channel allows the ability to give topical anesthesia close up, so you can do close-up laryngoscopy and bronchoscopy as I covered earlier. Because there's a working channel, you can place an instrument through it, and so you can perform biopsies, excisions, and injections. You can also apply air pressure through the channel, so you can perform esophagoscopy and the ability to do tracheoesophageal punctures in the office. And finally, because you can pass catheters through that, you can do esophageal dilation through a guide wire, and you can do a laser endoscopy. So here's the basic setup. You have a T&E scope that's connected to the video processor and air pump. You need a suction and tubing going to a vacuum source. And then you need some topical anesthetics, typically 4% lidocaine on pledgets. So I just wanted to point out on the left, the minimum outlay for something like this is $67,000. And of course, with all of these things we're talking about in-office procedures, the ones that require technology such as lasers and transnasal esophagoscopies, they do cost a good amount. So I'll go briefly through the technique. First, with patient positioning, you want to position the patient upright on the exam's chair in your outpatient clinic. Nasal anesthesia is the key. So I typically use a spray, a decongestant, and a topical anesthetic. Although nowadays with COVID, we're doing mostly cotton pledgets soaked in 4% lidocaine. You want to leave it there for 2 to 3 minutes. Typically, pharyngeal anesthesia is not needed. However, there are some patients who are sensitive, very gaggy, and you want to give some anesthesia there. Sometimes I will just give 2% viscous lidocaine to be swallowed. Typically, it can make the patients feel like they have some difficulty swallowing, and also sometimes it makes it hard for patients to manage secretion. So I typically will not use pharyngeal anesthesia unless required. This is the technique, pre-COVID technique, where I would spray some nasal congestion and anesthetic, followed by placement of cotton pledgets, and then you wait about a couple of minutes, and then you are ready to do the procedure. There are some discussions about how to hold the scope. I use the fishing pole method, where I can hold the scope with my left hand, and then I insert the scope with my right hand. This is a short video that shows the full transnasal esophagoscopies. You can see that I'm going through the inferior meatus. The first bend is in the nasopharynx. Then you are able to see the oropharynx and the hypopharynx. I typically like to approach the esophagus through the piriform sinus. So here I'm entering through the left piriform sinus, and as soon as I'm at the apex of the piriform sinus, I ask the patient to swallow. It's very critical that you time pushing the scope as the patient swallows, and typically the patient swallowing should create a little vacuum that allows the scope to literally fall into the esophagus. Then you continue down looking for any abnormalities. Here's a patient who has a very patulous lower esophageal sphincter and slightly irregular Z-line, and you notice all those abnormalities. And on the way back, you also want to visualize all walls of the esophagus, giving small puffs of air so that you are able to look for conditions that might be causing the patient's symptoms. So I'm just going to go through a few pearls. When is esophageal exam needed, and why is it very useful? So I would say that esophageal exam is needed when oropharyngeal swallow is normal in a patient complaining of dysphagia. Here's a patient who was complaining of dysphagia to all food consistencies. I performed a office endoscopic evaluation of swallowing fees, which was normal. So I performed a transnasal esophagoscopy, and I could see that there was significant amount of food and liquid impacted in the lower esophagus. This patient has achalasia and was referred for a hilar myotomy. Here's a patient who is a 56-year-old man with dysphagia to solids over the past few months. He also noted a sensation of food sticking to the back of his throat, which was alleviated by coughing. He denied heartburn or chest symptoms, and laryngoscopy and swallow evaluation was normal, so therefore he received a transnasal esophagoscopy. This showed a large hiatal hernia, distal esophageal erosion, and Barrett's changes with peptic stricture. So this was a patient who required endoscopy with biopsy, dilation, and starting on a proton pump inhibitor. Esophageal exam is also needed in all post-chemoradiation patients with dysphagia. Here's a patient, 58 years old man. He had chemoradiation therapy for base of tongue cancer. He is NPO and has a gastric tube. A swallow evaluation in the office showed that he was unable to swallow. So a transnasal esophagoscopy was performed, which showed a complete stricture of the upper esophagus. So this was a patient who required an antegrade, retrograde dilation, and I also performed an epiglottic surgery for the thickened epiglottis. And so I almost have a rule, somebody who has had a chemoradiation therapy and the gastric tube placed during chemoradiation therapy and then comes to you with inability to swallow is NPO, this patient will have esophageal stricture until proven otherwise. Esophageal exam is also needed when you do a swallow study and you see esophagopharyngeal reflux, or patient complaints of regurgitation of food. So here is a patient who had dysphagia symptoms over 2 years. I performed a office esophagoscopy, and you can see in the right piriform sinus, he has food that is regurgitating after being swallowed. So this was a patient who received a transnasal esophagoscopy, and you can see on the right picture there is a Zenker's diverticulum, a pouch where food collects, and the esophageal inlet is just anterior to that. And so this was a patient you could diagnose as having a esophageal pouch, and you can plan your surgery at the same clinic visit, and there was no need for a esophagram. This is another patient, 77-year-old man with severe dysphagia and post-cricoid pooling. He had food pooling in his piriform sinus, post-cricoid area, as you can see in the picture on the left. And so I performed a transnasal esophagoscopy, and I felt that it was difficult to go past the upper esophageal sphincter. So this was a patient who received a modified barium swallow study, as you can see on the right figure, and he has a cricopharyngeal bar. So this was a patient who received upper esophageal sphincter myotomy. Esophageal exam is also very useful in patients with dysphagia and a history of anterior cervical disc fusion surgery. This is a patient who has a history of anterior and posterior neck C-spine fusion. He had dysphagia after his anterior neck fusion surgery, and he had a modified barium swallow study where they noted that the cricopharyngeus was prominent with reduced upper esophageal sphincter opening. He also had piriform sinus residue. So I performed a transnasal esophagoscopy, and what you can see on the right lower hand picture is that there is a esophageal perforation with exposed cervical spine hardware. So this was a patient you could then schedule for perforation repair and reconstruction of the perforation. You could also make a case that esophageal exam is indicated in nearly all cases of suspected extraesophageal reflux symptoms. For example, chronic cough and glottis. So here's a patient, 75-year-old female, complains of chronic cough and dysphagia. She actually denied any heartburn or regurgitation symptoms. Laryngoscopy is normal, and swallow evaluation is normal. So she received a transnasal esophagoscopy. The exam shows Barrett's esophagitis and a hiatal hernia, so this patient was referred for manometry, pH study, and a fundoplication. So transnasal esophagoscopy is invaluable in the assessment of patients with dysphagia, especially when the oropharyngeal swallow is normal, or you suspect esophageal strictures, or you want to evaluate for gastroesophageal reflux disease or peptic stricture. Patients with globus, chronic cough, extraesophageal symptoms may also benefit from transnasal esophagoscopy when the laryngeal exam does not account for the patient's symptoms. And then it's also quite invaluable in assessment of head and neck cancer patients, patients with Zenker's diverticulum, and dysphagia after other neck surgeries such as anterior cervical disc fusion surgery. Finally, I'm going to talk about management of esophageal stenosis following head and neck cancer treatment. So typically, the stenosis nowadays is treated with a CRE balloon, which stands for Controlled Radial Expansion Balloon. This is typically used because it's easy to use and it's a compliant balloon, so it doesn't cause as much tearing or perforation during your dilation. So typically I perform my initial esophageal dilation in the operating room, and sometimes these patients require repeat dilation in the office. So I will perform my 1 or 2 dilations in the operating room, and I will give the patient the balloon dilator catheter to take home. So to do the office esophageal dilation, you use the transnasal esophagoscope for direct visualization of the pharynx and esophageal stricture. The balloon dilator is introduced usually through the contralateral nasal cavity, and the dilator is advanced from the nasopharynx inferiorly while the T&E endoscope follows it to make sure that it's going in the right way. Then once it's in position in the postcricoid area, I will inflate the balloon very gently, and keep it inflated for about 10 to 15 seconds. Typically, the patient will tolerate a slow dilation, and then you want to remove it and finally take one last look through the with the esophagoscope to make sure that you did not get any false passages or any significant rips. Okay, so I think as laryngologists, we do voice, airway, swallowing, and we should be experts in all of them. So I tried to give a little bit of a taste of each of those areas. Hopefully that was useful and interesting. Again, thank you very much.
Wonderful. Thank you very much, Dr. Chetri, for giving a detailed overview of the entire scenario of office-based procedure, which is the talk of the day today, as I said. And you have shown us that there are some procedures which needs to be done as an office procedure primarily by choice, like injection laryngoplasty, which is the best option. And there are many procedures probably we have been doing in the past with microlaryngoscopy, but we can gradually shift many of them to justifiably to office procedure, and going beyond the voice box or larynx is trachea, tracheobronchial tree, and esophagus, as you have shown. Since we have a little bit of time, but it's customary not to have any questions in international guest lecture, I would just ask one or two comments from you, because India being a country where people are gradually transiting to more and more office procedure, where you have an established center. So many people, after listening to your mesmerizing talk, would be interested to take up this office base in their practice also. So what would be your advice to these people who would like initial challenges and caveats and things? Because it will be very useful, because sometimes it can be dangerous if you do not know which patient to choose for an office procedure. You did mention briefly in the beginning part of your talk, but if you can elaborate on that quickly.
Sure. So I think, for something like India, you have to kind of decide on the investment first. How much money are you willing to invest in the laser and the TNE? But if that I think comes secondarily. I think the first thing is to be very comfortable with accessing the larynx and being able to do some of the things you would do in the operating room in the clinic. So for example, you can do steroid injections very easily in the larynx. You can do injections of granulomas very easily. The biopsies, you just need one channel scope, so which is also an investment. So first, perhaps you start with procedures you can do with using the basic flexible scopes that you've been using anyway. So injections and diagnostic endoscopies. After that, you go to, for example, doing a steroid injection of the airway. Very easy. You just need a regular scope, anesthetic, and your hands. And then as you continue on and you develop a very good patient base, let's say you have lots and lots of patients with papillomas, well, that's a perfect time to think about perhaps purchasing a office laser with the flexible fiber and then doing those in the office. So I think you can very much do it in a graduated manner, as long as you understand how to deal with these particular things and make sure it's appropriate. You can have the adequate control of the airway if you're going into the larynx and the trachea. But first, you have to have the interest, and then the capability, and then the money, and then it'll all happen.
Okay, thank you very much. And what has been your, in your rating, the most difficult procedure to perform as an office? Also, I would like to draw your attention here that our very own Dr. Phanindra Kumar, he's published a paper recently regarding doing office Kashima's operation also. So, I mean, just mentioning that from Indian counterpart. But what has been your worst scenario or most difficult case in office base overall?
Yeah, I think doing anything to the airway is a little bit dicey, and so just be careful. I know some of my colleagues have said they would like to dilate the trachea, for example, in the office. Absolutely, you can do that, but just know that if there is bleeding or patient passes out, you're ready to take care of it. In the esophagus, really the difficulty is injecting Botox to the upper esophageal sphincter. It's not easy to actually assess first if there is UES dysfunction, and second, to do any procedures to the upper esophagus, upper esophageal sphincter. Otherwise, I think we can, after anesthetizing the aerodigestive tract, you can pretty much do anything.
Yeah, and one more important thing I think I just want to highlight here for the junior people, that this is, as you said, that anything on the airway can be dangerous. So you should have access to, like you mentioned, if the patient passes out, then you need to have access to a crash stream or whatever, because in our practice, Indian practice, we do not have big institutional practice everywhere. People do work in smaller places and they don't have access to bigger hospital. So at least we should be, I think, what do you think?
Well, I think, again, I haven't done any dilations, but I do tracheobronchoscopy frequently. I think bleeding is fairly rare. You certainly could dilate some very small webs, but again, you want to get some experience in the operating room, get a sense of whether they bleed or not before you do that. So try simpler things to start.
Yeah, so I think this is going to change the future. I mean, the face of laryngology in the coming days. Where, if I ask you, maybe this is the last comment I want to hear from you before we move on to the next session, is that right now, what percentage of your laryngology practice is office-based and, rest in the OR setting? And how do you see this changing in next 10 years?
Well, I would say, it kind of depends on what you include. So if I included that I do a lot of swallow evaluation fees and TNE and laryngoscopy, stroboscopy, it's a lot, right? So, but if you're thinking about actually procedures that you would typically do in the operating room, and now you've transferred to your clinic, well, that might be about 30–40%.
That's a great deal, yeah. And do you expect these things to go up in the future? Maybe because as you are going more and more deeper into the airway, and with your experience dealing with more and more difficult issues in the office as well, maybe.
I'm not sure. I think we're looking for another technological advancement, and then that will open up more avenues.
Sure. So I think with that, we would gradually wrap up this session. Lots of comments coming from you, Dr. Nupur, Dr. Gautam. Many people are saying that it's an excellent talk, and all of us have benefited so much from your talk, and thanks for your time.
Thank you, Dr.
Thank you. I really appreciate it. Have a good conference. Bye-bye.
Thank you very much indeed. Over to Dr. Gowri for gradually going to the next sessions. We are a little ahead of time, but I think we can gradually start our moderator for the next symposium to introduce the topic, and maybe we'll gain some time and get some time for the question answer session at the end. So if nobody has any objection, we can gradually proceed to the next session. Dr. Gowri, please.
Yes, sir. Once again, we thank the international speaker, Dr. Dinesh Chhetri. It was really an amazing talk. We had a first talk by Dr. Solomon where we had extensive open airway surgery being done. And now we had these minimally invasive office-based procedures being done. So it has already been a fantastic day, and it only promises to get better and better as we move on further with the academics of the day. The next session that we have, in fact, we have covered now airway and a little bit of voice as well. So the next session that we have is the swallowing symposium. And as a moderator for this session, I invite none other than Dr. Jaykumar Menon, sir. He is the director of Dr. Jaykumar's laryngology group at Thiruvananthapuram and head of the Department of Laryngology, PRS Hospital at Thiruvananthapuram and Aster Medicity, Kochi. He is also the head of the dysphagia unit at Amrita Institute of Medical Sciences in Kochi, where he does a lot of dysphagia work with head and neck cancer patients as well. He is the honorary consultant in laryngology Sri Chitra Tirunal Institute of Medical Sciences and Technology at Thiruvananthapuram. Dr. Menon has been the founder, vice president, and the past president of our association, the Association of Phonosurgeons of India, and he has published many papers in national and international journals, and he has contributed to chapters in 5 textbooks on laryngology, edited 1 textbook on swallowing disorders in head and neck cancer surgery. He has been credited with having described a clinical sign in the diagnosis of abductor spasmodic dysphonia, and his special areas of interest are bilateral vocal fold paralysis. He does laryngeal renervation surgeries as well, as we know, and neurodysphagia, professional voice care, pitch altering surgeries, as well as spasmodic dysphonia. So with this introduction, it's my pleasure to invite Dr. Jaikumar sir. He will first give you a little bit of a brief of the session, and then the speakers will begin. Over to you, sir. Sorry, sir. Yeah.
Dr. Gauri,
Yes, sir.
Dr. Jaikumar being the pioneer and father of deglutology in India, I would also request him to tell the audience, the attendees, how this specialty has evolved in our country before we take it up to the symposium. Thank you.
Yes, sir.
Over to Dr. Jaikumar, please.
Good morning, Gauri. Good morning, Amitabh. Good morning, everybody. I'm audible? Okay.
Yes, sir. Perfectly.
Already we have 2 great lectures by Professor Soliman and the Dr. Dinesh Chetri. So now we move on to the swallowing disorders. Before that, let me tell that this is a very auspicious day for Keralites, because this is the 64th birthday of our beautiful state. So greetings from Kerala. We will move on to the topic of swallowing disorders. It's a huge topic. It is rapidly evolving. I remember some 10-15 years back when it was fairly in its infancy. The most of the talk in the swallowing disorders was just in 1 lecture, like swallowing disorders, 30 minutes. From that day, it has gone to a specialty which cannot be even covered in 1 or 2 days. So what we are going to do topics, because I teach everywhere. So we are just going to do basic things in the main symposium. Of course, there are other talks, like I'm happy to know that Dr. Shama is talking on transnasal esophagoscopy later in the day. Dr. Anurag is talking on presbyphagia, and Dr. Vidyadharan is head and neck cancer associated dysphagia. And of course, we heard something already about transnasal esophagoscopy from Dinesh. So the importance of swallowing is definitely being understood better and better. But one thing I have noticed that the number of the medical doctors, the laryngologists taking up dysphagia is still not very high. It has attracted lots of swallowing pathologists, I agree. That's actually a very welcome thing, because they are the people who actually manage, they do the swallowing therapy and all. But I sincerely request all the youngsters, especially in this field, to take up this specialty of deglutology. It is very fast developing. Previously, we had just, it was just swallowing disorders. Now we know that because of the vastness of the specialty, it has been branched. Like oncodeglutology, which deals with the head and neck cancer surgery associated swallowing disorders, the neurodeglutology, which deals with the neurological problems, pediatric and neonatal deglutology, which deals with the pediatric and neonatal issues. And by the way, let me tell that, next month, the Kerala State APSI is actually conducting our annual meet, and 1 day is actually entirely being given for pediatric and neonatal deglutology. It's a very challenging, very fascinating, very upcoming specialty. So all these subspecialties are coming, and of course, I am sure that a little later, presbyphagia or deglutology or swallowing problems in old age also will catch attention. It's not at all right; it's very common, but probably very, very rarely diagnosed, because most people think that they will have some problem. So unless we go into the details, we are not going to know that. So all these things show that deglutology is fast developing into a major specialty. So today what we will do is, we will talk about, we are not talking about the management today because that the time period is too short. So we have three major talk. One is on the basic clinical evaluation. So aim of this symposium is to make all of you, especially the youngsters who are not familiar with this specialty, make them comfortable in dealing with it. So the first talk will be on the bedside evaluation and clinical evaluation of the swallowing disorder. And the second and third talk will be about the major two instrumental evaluation technique, the flexible endoscopics evaluation of swallowing fees, and also by the video fluoroscopy. So these are the two. Of course, there are a lot of new things that are coming. We already heard about transnasal esophagoscopy. We'll hear it again a little later. Then there is laryngeal EMG, two-channel laryngeal EMG is there, manometry is there, pharyngeal manometry, pH metry. We don't have the time to cover all those things. We won't be covering that. But we are going to the three major topics, which I'm sure that will. So, will be bedside clinical evaluation of a swallowing disorder. This is very, very important. How to take a proper history, how to do a clinical evaluation, and then decide upon whether to go about instrumental evaluation. This topic will be presented by Dr. Susmita Ghosh. She is a MRI Hospital, Kolkata. She is one of the most promising persons in the swallowing disorders in the country. She has shown great interest in this field and she has been continuing her good work for the last few years. I have been fortunate to be one of her mentors and teachers in her earlier period, and I have watched with great fascination at her in the development she has made in this particular specialty. Welcome, Susmita, for your presentation.
Sorry, I'm interrupting you for a second. I just have an announcement for the delegates before we begin the symposium. As you are aware, for the keynote and the international guest talk, we did not have a question answer session as is customary. But here onwards, for all the symposia and panels, the questions from the audience are most welcome. You can please send in your questions in the question answer tab that you have on the screen, and all questions will be moderated by Dr. Jaykumar sir to the respective panelists. Thank you. And over to you, Dr. Sushmita.
Thank you. Thank you, Dr. Menon. And good morning, sir. You are my teacher and my mentor. And good morning to all my respected seniors and friends. Also, thanks to the organizers for giving me such a big chance. So today my topic is bedside clinical evaluation of swallow disorder patients. As we all know, swallowing is the process by which the bolus is transported from the oral cavity to the stomach while protecting the airway. It has three phases, but at the bedside, we mainly evaluate the oral and the pharyngeal phases. And of course, we should have a good idea about the neural control to get an idea where the problem in the swallow mechanism lies in the particular patient. The candidates we usually evaluate at the bedside are the neurology patients, those with head and neck malignancy, and elderly debilitated people. The issues addressed when we evaluate the patient are the nutritional status of the patient,
Smita?
diet
Hello?
modification.
We can't see your PowerPoint.
Oh, sorry, sir.
You have to share the screen, open the.
Oh, okay, sir. So sorry. Let me see. I had shared. Now, can you see, sir?
Yes.
Okay. So today my topic of discussion is the bedside clinical evaluation of the swallow disorder patients. Now, swallowing is the process by which the bolus is transported from the oral cavity to the stomach while protecting the airway. It has 3 phases, and for the bedside evaluation, we mainly look at the oral and the pharyngeal phases. Of course, we have to know about the neural control to get an idea about where the problem in the patient lies in the swallow mechanism. The candidates for bedside evaluation are the neurology patients, head and neck malignancy patients, and elderly debilitated people. The issues we address when we examine the patient are the nutritional status, the diet modification needed for the patient, instrumental evaluations required, the specific treatment protocol, and of course the medical diagnosis. But as laryngologist, our main concern is whether the patient is aspirating or not. That is the swallow safety. We cannot lose the patient. And here lies the importance of early bedside evaluation. And we cannot afford to wait till the patient is ambulatory for instrumental evaluation. Like any other clinical examination, it consists of history taking and clinical examination. And this is the picture of one of our patients and our swallow therapist with whom we work as a team, Mr. Bhaskar, examining the patient. We thank him for sharing the picture with us. A few things should be kept in mind before we go for the evaluation. The most important is the cognition of the patient. Depending on the cognition of the patient, we do the assessment. Some patient may be so sick that he neither can give history nor we can go for clinical examination. Then the only input we get is from the medical records. In some, we can assess the patient clinically, but he cannot convey to us his problems. Here we depend upon the relatives, the family of the patient to give us the history. Also, another important issue is that whether the patient is on oral feed or on alternate feeding methods like nasogastric tube or peg feed. Now, the chief complaint of swallowing varies from patient to patient. Some complain of food sticking in the mouth, or there may be cough during each feed, prolonged feeding time, or some may have the inability to take most of the meals. Almost more than 50% of the meals the patient cannot manage orally. The current status of the patient, whether on oral feed or non-oral feed, and the duration of this non-oral feed is very important to give us an idea how much disuse the swallow mechanism has already been in. Onset of the disease, neurological, oncological, physiological, and the progress of the disease. If the disease itself is a progressive disease with a bad prognosis, we can give an idea to the patient or his family how much we can help him out with the swallow management. Now, the consistency of food. Dysphagia specifically to solid. It gives us an idea that it may be due to a space occupying lesion, or it may be to liquids. The temperature of the food. Some patients will say that he has a swallowing problem but feels much better when he's taking a big warm bolus. So this at once tells us that there may be an underlying cricopharyngeal spasm which opens up with the stimulation of a large warm bolus, and also specifically sour bolus is very helpful. There may be a history of regurgitation of old food particles in cases of esophageal diverticula. History of weight loss. The nutrition of the patient, the nutritional status of the patient, how much muscle mass is lost is very important. How much the patient can pick up with the management we give and also the breath support of the patient. There should be a good coordination between swallowing and breath for safe swallowing. So history of weight loss is very important. Now for aspiration, we have to take the history of cough. Immediate cough or delayed cough. Some cough immediately on taking the food. That is, he cannot control, the patient cannot control the food and the food is going into the larynx. So it is an indicator of primary aspiration. In some, there may be a delayed cough. That is, the cough is occurring after some time of taking food. So this is because of secondary aspiration. The food is pooling up in the vallecula, in the piriform fossa, and later it is trickling down into the airway. But absence of cough does not mean that there is no aspiration. There may be a silent aspiration, which is much more dangerous. So we have to probe in the history whether the patient is having recurrent chest infection, changes in body temperature, changes in the post-swallow voice quality. Next, we come to the clinical examination. The clinical examination starts with the oral phase. The oromotor functions, the structural and functional integrity, the control of oral secretions, whether the patient is being able to manage his own saliva or is it pooling in the mouth, it is drooling, the sensation of touch, temperature of food, the taste of food. Mouth opening. We ask the patient to open the mouth widely. You see, to take in the food bolus, we have to open the mouth. And this is more important in patients who have undergone a surgery or post-radiation where fibrosis has set in. A minimum of 3 fingers width should be there between the 2 incisor teeth for the patient to introduce the bolus into the mouth. This is our patient being examined for mouth opening. Next is the lip closure. The patient shut the lips tightly and blow. So we look at the lip seal. Lip seal is very important for the containment of the food bolus. Next is the tongue movement. This is a Parkinson patient. There's a mild clumsiness, early onset. Tongue movement needs to be assessed because we need to move the tongue for the formation of the bolus. So this is our patient being assessed for tongue movement. Next is the pharyngeal and the laryngeal examination. We have to observe the patient when he's swallowing his secretions or during the dry swallow. There may be frequent throat clearing or mild cough, or the patient may be observed to swallow a multiple of times. So here we can get an idea that there may be pooling in the piriform sinuses, or that there is a weakness in the laryngeal elevation and the patient is giving multiple efforts to swallow in his secretions. The voice quality, wet is wet, then there may be secretions pooling up in the throat. Tremor in the voice, indicative of a neurological disorder. There may be hoarseness because of laryngeal palsy or some space of laryngeal elevation, because laryngeal elevation is very important in the pharyngeal phase of swallowing. It protects the airway. It helps in the pharyngeal pump mechanism and opening of the cricopharynx. So laryngeal elevation is very important. We have to observe when the patient is swallowing the dry swallows, whether the larynx is moving or not. And of course, there is a 4-finger test or movement strong enough to move the larynx upward. So this is a 4-finger test. We place 4 fingers in front of the laryngeal prominence and ask the patient to swallow and observe, and we feel the larynx sliding below our fingers. So this is the 4-finger test for the laryngeal elevation. Next is the neck movement. We see the free movement, range of movement of the neck. This is important is post-radiation fibrosis. If there's a fibrosis of the neck muscles, the laryngeal elevation may be hampered. There may be some amount of food particles entering the larynx, but the patient has natural reflexes, the sensitivity of the larynx and the strength of the cuff. The patient senses the food in the larynx and coughs it out. So there is a penetration, the food goes to the level of the vocal fold, but the patient can cough things out. So the patient may be safe for swallowing. But if the cough strength is poor and the laryngeal sensitivity is poor, then he cannot assess food entering the larynx and may aspirate. So that is dangerous for the patient. Next is a trial swallow. We observe the patient use clear water in increasing bolus amount. First, we give just 5 ml of water. If we find that the patient is safely swallowing, we gradually increase the bolus. But because in some patients, in small bolus amount, there may not be any problem. But when we increase the bolus amount or the speed of swallowing, then the problem starts. And during the act of swallowing, what we observe is oral spillage, whether the lip seal is fine, any retention of water in the mouth, that is whether the tongue movement is strong enough to push the food backward, nasal regurgitation in palatal palsy, post-radiation fibrosis of the soft palate, there may be nasal regurgitation. The cough strength, whether after swallowing the patient is clearing his throat frequently. It may be because of poor laryngeal elevation, all the food has not gone in, or there may be pooling in the pyriform sinuses because of palsy or inadequate opening of the cricopharynx. Next is the laryngeal elevation, whether it is proper or not. The patient may swallow a multiple of times. Also, we can get an idea whether the patient is aspirating or not if it is a silent aspiration through neck auscultation. And of course, the post-swallow voice quality. After the patient swallows, we ask the patient to phonate and then listen to his voice, whether it is clear or it is wet because of pooling of secretions. So this is the trial swallow. The patient is swallowing and we observe the swallowing, the laryngeal elevation, oral, and whether the mouth is dry or there is retained food. Next is neck auscultation. We ask the patient to swallow the water and listen to the clicking. There will be a high-pitched shrill sound of fluid passing through a narrow pipe. Also, if there is weakness of the laryngopharyngeal musculature and there is a delayed elevation and there is delay in the pharyngeal phase and food going into the esophagus, then the patient will swallow a multiple of times. And during neck auscultation, we will hear multiple clicking sounds. Next is the forced swallow voice. After swallowing the water, we ask the patient to phonate, say ah, and we listen to the voice quality, whether it is a dry voice or it is wet because of pooling. The pulse oximeter. We use the pulse oximeter during swallowing. It is a very simple, non-invasive method. It measures the desaturation during process of aspiration. And in patients who are very sick, it may be the only means with which we can get an idea whether the patient is aspirating or not. We may not be able to perform anything else, just the pulse oximeter. So it is a very useful tool to give an indication in very sick patients. Of course, there are specific clinical examinations depending upon the case. In neurologic patients, the various cranial nerve examinations. In the head and neck oncology evaluations, specific evaluations like the laryngeal crepitus. Here we are observing the laryngeal crepitus. Laryngeal crepitus may be a retropharyngeal abscess, but there are a few things we should keep in mind. If it is a very thick soft tissue, thick neck with thick soft tissue, we may not get the crepitus properly. Also, when we are examining the laryngeal crepitus, we should always keep in mind that the patient is sitting in a very relaxed position. A patient who is very tense with tense musculature, it is very difficult to elicit a laryngeal crepitus. So, bedside evaluation is the earliest opportunity to assess the aspiration risk. We have to decide whether the patient will be continuing on oral feed or we have to shift him to a non-oral feed like nasogastric feed or PEG feed. Also, it helps us to start the initial swallow management. It is very important to start it early because we have to maintain the nutritional status of the patient. We have to prevent the disuse atrophy of the swallow muscles. We have to work on the laryngeal sensitivity and of course, maintain the neural plasticity till the patient recovers. Also, another point, the counseling of the family members, it is very important. It is a long run process. So we need cooperation from the patient and from the family members to help the patient in the management of the swallow. The support of the family to the patient is very important. It also gives an idea about the further instrumental assessments needed to which the patient is subjected to as soon as the medical condition improves. And this is going to be taken up by our next speakers. Ideally, it needs a teamwork of ENT surgeons and swallow therapists because we should give a comprehensive care to the patient. So we can come to the conclusion that like a sapling, the clinical bedside examination is the fundamental of swallow assessment on which we build up the tree of our instrumental evaluations, management protocol, so that the patient can gradually improve with a bright future, with a quality life, because our ultimate aim is to give the patient a happy social life. Thank you.
Thank you, Susmita. Very nice presentation. I hope that the small points. Susmita, can you stop sharing the screen now? Susmita, can you stop sharing the screen?
I've stopped.
Yeah. Okay. Thank you. So a very nice presentation covered everything, and I hope that the juniors who listened to her talk took notice of the small points, but very important points like auscultating the neck, watching the act of swallow, using the pulse oximeter, listening to the voice. All these things are very simple trick. You don't require very expensive equipment or anything like that, but they give very, very valuable points to the diagnosis of this complex issue. Now we move to the instrumental evaluation. So first talk will be on the flexible endoscopic evaluation of the swallowing, and this is to be given by Dr. Sanjay Subbaiah, who is a consultant ENT surgeon and laryngologist at MS ENT Center in Bangalore. He is also a visiting consultant to the prestigious NIMHANS, institute, the Neurology Institute in Bangalore. So we can safely say that Sanjay is the leading neurolaryngologist of our country. He has got a lot of experience with the swallowing disorders of neurological patients, with lots and lots of patients attending NIMHANS there. Sanjay has been working as a laryngologist for quite a long time. He is one of our senior most fellows from Trivandrum, and I am very proud to introduce Dr. Sanjay Subbaiah as the next speaker. Welcome, Sanjay.
Thank you, sir. I hope I'm audible and my screen is visible.
Yes.
If there's any issue with the videos, I can stop my video so that, because I thought Shushmita had some video issue. Or I'll continue. If there's an issue.
Now it is okay. Now it is okay.
Okay. Thank you for the organizers and APSI and Alembic for this opportunity. And I'm happy to have trained under Dr. Jayakumar Menon. And today is also an auspicious day for Karnataka because it is also Karnataka Formation Day also. So there's been a very elaborate presentation by Sushmita. So now I don't have anything else is left. She's covered more or less everything. But I'll go into the instrumentation part, the instrumental evaluation of swallowing. And in this piece, flexible endoscopic evaluation of swallowing is a very important instrument. So I'll just speak on the interpretation of PEACE. This is basically an investigation where a flexible endoscope is passed in the nose like this. And then afterwards, you can have a bolus which is given via the mouth and the patient is asked to swallow. So you can have a real-time evaluation of what is happening. The FEASE per se test has two parts. A first part is the evaluation, which I think as most ENT surgeons, we know how to do a simple laryngoscopy with some added points of evaluation of swallowing. After this, you have the second part, the bolus feeding. So this is what I mentioned. The first part, it is common. The last 3 points are what is very important in a swallowing perspective. You assess the secretion. And lower the secretion, the more dangerous it is. And chances of aspiration are more. And then afterwards, you do a dry swallow, cough reflex. And most important, you make an assessment whether you could proceed to the next part of the examination. The other evaluation is basically like any standard laryngoscopy. In the second part, we introduce a bolus and then you can evaluate what are the findings and what is the patient's awareness. Many of the time, the patient themselves would have a protection or a response you can evaluate. So this is parts of PEACE. PEACE has actually, as an investigation, it has evolved from since 1988, where it was started as a small bedside evaluation using the endoscope for those institutions or cases which did not have access to modified barium swallow or video fluoroscopy. After that, the recording system came, then the video recording, we started to record and replay and educate. Then you, by 1996 to after that, the scoring system came. And then afterwards, we have separate protocols for various diseases. Now the latest one is the metrics, where is it possible by scoring by the piece only we could say what are the neurological diseases or what are the, if you could make a diagnosis like an audiometry is a thing. So these are, it's gradually evolved. So this is actually an image of only last year, but it looks like as if it's a good old days with COVID and all the PPI. So this is a classical where you are also, you're able to see, you have to involve the patient attenders. The patient should also be able to see if possible. So you could educate them later on what are the problems. And if you teach a maneuver, why is it necessary to do a maneuver? So it is patient and relatives education is also very important. When I did the evaluation, I said whiteout is a very important part. This is where you insert, when the scope in place, you ask the patient to do a dry swallow. When they do a dry swallow, you can see that the pharynx, base tongue, epiglottis contracts and hits the scope. So you just see a white glow of light, what you saw now. So this is a very important sign. This is an indication that there is a hyolaryngeal elevation and pharyngeal contraction with base retraction. It's a very good sign. The flip side is that many of the times we can't see the active bolus entering into the upper part of the esophagus. So this is a normal swallow. I just it's standard. So bolus enters the vallecula and then it stimulates the swallowing. And then there's a whiteout and then everything is cleared. There's no residue. And then the next bolus is coming, that's clear. There's no aspiration, no residue. So basically to interpret a FEASE, you have to understand the physiology of second stage of swallowing, oropharyngeal stage. This is nothing but a story of 4 sphincters, the velopharyngeal, the upper esophageal, the laryngeal vestibule, and the oropharyngeal sphincter. So in this, what happens? The four sphincters, they open and close at various intervals. So they convert the respiratory pharynx into a digestive or alimentary pharynx and revert back to a respiratory pharynx in a fraction of few seconds. So within this time, the bolus has to enter into the esophagus. If by chance the laryngeal vestibule will not close or it opens up early, you can have the bolus entering into the larynx. This is called aspiration. Or if the propulsive force of the pharynx is not adequate, the bolus might not enter into the upper esophagus. It might be retained in the oral cavity or in the pharynx. So you actually have two types of issues. So you could have an impaired safety where the bolus enters into the larynx, or you can have an inadequate bolus entering, you can have impaired efficacy. Both impaired safety and impaired efficacy cause oropharyngeal dysphagia. So what are the consequences? Why is it important? Why should we assess? Because impaired efficacy will lead to malnutrition, dehydration. Long-term can also lead to sarcopenia. Impaired safety, aspiration pneumonia and recurrent aspiration pneumonia can lead to death and very frequent hospitalization. So in fees, what are the signs of impaired efficacy? Spillage and residue. In impaired safety, penetration and aspiration. In other words, if these signs are seen, it implies that there is impaired efficacy or impaired safety. This is spillage where the bolus leaks into the pharynx even before the swallowing. You can observe and see. Luckily for me, the milk didn't enter into the larynx. Otherwise, I would have had an accident. So it enters into the piriform sinus even before the swallowing has started. This is called spillage. This shows there's a weak glossopalatal seal. Base of tongue is weak, not adequate. Pharyngeal contraction and altered sensation of the tonsillar pilus. So each sign you see, you try to make out what are all the physiological mechanisms involved in that, and your treatment will be aimed at correcting those specific physiological mechanisms. This is residue is a very, very important sign, and residue is basically a pre-swallow saliva or post-swallow bolus retention. Secretions you can see. This can be due to, like mentioned, tongue base weakness or pharyngeal weakness or failure of the relaxation of the upper esophageal sphincter. So this is after a bolus is given. You can see that there is a residue in the piriform sinus, and this is a smashed banana. If there is a residue in the piriform sinus but no residue in the vallicula, very likely that it can be due to upper esophageal issues. If there is residue in the vallicula and residue in the piriform sinus, then it can be due to pharyngeal contractions being little weak. So if there is a residue, the scope will get coated, and so you won't be able to see properly. So that is a sign. So all this shows that there is a residue. That actually we also make out in what consistency, what are the quantity of the bolus for which residue is seen. Accordingly, you can also plan the management. This is an all-round, all over the pharynx, there is a global residue. And then afterwards, you can also manage. I'm giving the patient little water, and then you see that after he has the water, the residue is disappears. So like this, we can also educate the patient for management. You can see that they had water, and then you can ask them to have alternate consistencies. It's disappeared. The next is penetration, where this is an impaired safety, where the bolus enters into the laryngeal vestibule, but it is above the vocal folds. It's milk, there is penetration. Then aspiration. So this is basically due to impaired hyolaryngeal elevation and or impaired laryngeal vestibular closure. This is aspiration is where bolus enters the laryngeal vestibule and passes beyond the vocal folds. So this is a recording for those who missed. These are still images. You can see that it has entered into the laryngeal vestibule and gone beyond the vocal folds. So the advantage of recording is that you can replay it and you can see and confirm a diagnosis. So depending on what is the sign, then you can hypothesize what is the mechanisms which are involved, and your management will be aimed at rectifying deficiencies in those muscles or mechanisms. Scoring is also very important, and it is very, you can know the your treatment, if it's working or progressing, or if you have to change. So you have penetration aspiration score, and then you have the residue. You have a scoring system where you could do the scoring. Then in many of the workshops, the most important question, or everyone wants to know, is should we start the feeding or no? So it is actually a difficult question to answer, because it's a highly, you'll have to individualize and you have to assess various parameters. But nevertheless, this is a nice flow chart which is there, which will describe in a stroke patient when to start oral feeds or when not to start. So if there is penetration and aspiration of saliva, you don't obviously do the next level of testing. You can start, you can't start oral feeding, fifth and sixth scoring systems. Similarly, you do for liquid, pudding, solid food, and depending on that, you could either say whether to start partial nasogastric feeding and partial oral feed, or you can start full-time oral feed. Depending on this scoring system, you can do that. This is a nice thing. So this was a study in 2019. It was a paper. It was earlier to this COVID thing, but in today's era, this is how we are managing. But I think it is a very nice screening test which has mentioned in that, and I use this test. So in this test, what we actually do is, it is based on scoring by Hayado, in which he used 4 items. We use only 2 items: salivary pulling and glottal closure reflex. And then afterwards, we score it 0 and higher. And if 0 and 1, you can start oral feeds. No need to do the next part of the test. This way, we can reduce the amount of time we have with the patient. If there is anything 2 and above, you have to do the normal bolus test also. This way, it will help us to screen and see whom we do bolus test and whom we don't do bolus test. And then this is broadly about differences between modified barium swallow and fees. So obviously, oral stage and esophageal stage, you are not able to make out, which you can make out in video fluoroscopy or modified barium swallow. Okay, thank you.
Thank you, Sanjay. Very comprehensive coverage of the flexible endoscopic evaluation of the swallowing and with special emphasis on the salient points. We'll come to the discussion at the end of all the three talks. So stay back, there will be questions. So we'll finish off now the next topic, that is about the video fluoroscopy or the modified barium swallow. Now, still, some 10-15 years back, there was no doubt that this was the most important exam investigation, the gold standard investigation in fluoroscopy. That has been challenged now, but still, fluoroscopy holds its own fort because obviously, FEES has got some problem, like going to the oral stage, esophageal stage. Of course, that can be circumvented with the newer scopes. But still, fluoroscopy remains one of the most important, if not the most important, investigation of choice in swallowing disorders. So to talk about video fluoroscopic evaluation of the swallowing, we have Dr. Manju Isaac from Trivandrum. She is my colleague, my student, and my assistant. And one important thing about Manju is that she is one of the very few persons who has been practicing only laryngology for. She is a dedicated laryngologist and working only in laryngology. So she will be talking about the fluoroscopic evaluation of swallowing disorder. It's not a real evaluation, it is the interpretation of the fluoroscopy findings. So she will be basically going about the normal, the fluoroscopic anatomy and physiology, and also the possible or different abnormalities. Over to Dr. Manju. Share screen.
So good morning all. The interpretation of fluoroscopic evaluation of swallowing. So this is nothing but shadows of certain structures and the interaction of these shadows with the barium flow. The technique requires attention to protocol. That is, the protocol means the appropriate preparation of the oral contrast medium and the proper positioning of the patient and image acquisition. And knowledge of normal anatomy and physiology is very important. We all know for the criteria for the bolus that it should vary in consistency or viscosity, and it must be sufficiently opaque to allow easy interpretation of bolus flow. We use Varibar, which contains barium sulfate. The lateral view should capture the lips anteriorly, the soft palate superiorly, the spinal column posteriorly, and the upper esophageal sphincter inferiorly. The patient alignment is critical. One way of judging is looking at the mandible. So, best alignment is signaled by a single outline of both rami. And in the AP view, we can assess the barium flow as well as the vocal fold mobility. So this is the plain fluoroscopy where we can assess the even the vocal fold movements. There is an alternate view where the patient is positioned in an oblique way so that the shoulders will not obstruct the pharynx. And this is sometimes the best position for diagnosing small pharyngeal pouch or a diverticulum. This is an MBS impairment profile which include 17 physiological components starting from lip closure to esophageal clearance. So coming to the oral phase, two events, that is bolus preparation and bolus propulsion, happens at this phase. We will see in details with the help of these still images. So when the bolus is kept in the oral cavity, it is positioned on the dorsum of the tongue like this, and the tip of the tongue presses against the maxillary incisors. And the posterior part of the tongue elevates against the soft palate. The soft palate push downwards and touches this part of the tongue. This is very important. This is glossopalatal sphincter, which actually prevents the premature spillage of the barium into the pharynx. So what happens next? The part of the tongue then goes in a piston-like manner posteriorly. That is, it pushes the bolus into the oropharynx. At the same time, what happens here, the glossopalatal sphincter releases. So the soft palate moves posteriorly to touch or come in contact with the posterior pharyngeal wall now. The tongue actually moves down and anteriorly to accommodate the bolus in this oropharyngeal area. And next, the posterior, the soft palate now is in touch with the posterior pharyngeal wall and the side wall of the nasopharynx, which include the superior constrictor, oppose each other to get the seal here. Now what happens here at the posterior part of the tongue? Along with the pushing the bolus to here, the tongue moves now down and anteriorly and down to accommodate here. And then along with the hyoid, the tongue move now anteriorly and upward, so that the sagittal diameter of this pharynx, upper part of the pharynx, increases. And at the same time, the salilopharyngeus, the upper constrictors, also elevates this part of the pharynx, so that in the transverse diameter of the pharynx also increases. So let us see some abnormal videos with this. Now we can watch the barium in the oral cavity with some spillage of the barium anteriorly. So there is no lip seal here, and there is abnormal movement of the tongue here. There is no propulsive phase, and the tongue is not touching in contact with the palate. So there is absence of glossopalatal sphincter, and the patient is actually moving his head backwards. He is doing a head tilt backward so that he can aid in swallowing. Because there is no glossopalatal sphincter here, there is premature spillage of the bolus into the pharynx and even into the laryngeal vestibule. The second video, you can watch the repetitive antero-posterior movement, rocking movement of the tongue here. This is nothing but tongue pumping or a swing movement of the tongue, which is a characteristic feature in the Parkinson's disease. We have seen how much importance tongue has got in the bolus preparation as well as propulsion of the bolus. You can watch the barium now much down in the oral cavity, that is in the floor of the mouth, as if it is in a tray, and there is no propulsive forces. There is no propulsion of the bolus. Now you can see the barium in the pharynx, and as a result there is penetration and aspiration. Now we will move on to the pharyngeal phase, the most complex phase of the swallowing. So what happens here? Two events. Mainly the bolus propulsion through the pharynx into the esophagus, and there should not be any misdirection. So what happens? The piston-like action of the posterior tongue actually helps in directing the bolus in a shoot-down manner through the pharynx. So this was the last still image we have seen in the oral stage. So that is the beginning of the pharyngeal stage. So the nasopharynx here, the soft palate is sealing off here. So the nasopharynx is sealed, and the bolus should not go back into the oral cavity, and it should not go into the larynx also. And now here in the still image, you can watch the hyoid, which is much higher up, because the larynx has to move up along with the back of the tongue, and whole larynx and cricoid moves up, so that the glottis is protected now. So the nasopharynx is protected, oral cavity is sealed off, and glottis is protected now. There is opening of the upper esophageal sphincter. For that, upper esophageal sphincter should be relaxed first, and there is easy stretchability at this segment, and there is a traction force because of the hyolaryngeal excursion. That is, the cricoid is pulled anteriorly to open the upper esophageal sphincter, and the bolus is easily getting passed into the esophagus. These are the events. And on moving, you can watch here, there is retroflexion of epiglottis. That is, larynx is coming back to its normal position now. You can watch the epiglottis coming back. But I can say that it is not 100% normal, as you can still say some staining of the barium here. That this we have seen. We will move on to some abnormal video. So here you can see the stasis of the barium here. And there is a regurgitation of the barium into the nasopharynx. So the palate is weak. Here in this video, you can watch the anterior part of the larynx. You can see that even though the hyoid is moving upward, it is not sufficient. There is defective bolus propulsion. That is infrequent hyolaryngeal excursion. This video, we can see that the barium is misdirected into the laryngeal vestibule, but it is above the vocal fold. So this is called penetration. And now in this video, this is again misdirection of the barium. This is the level of vocal fold. You can see that the barium has gone beyond the vocal fold, and you can even appreciate the cough reflex of the patient. That is aspiration. That was a lateral view. Now, what happens in the AP view? How you diagnose aspiration in the AP view? Because in stroke patients, it is very difficult for us to position the patient in a sitting up posture, the physiological position. So, we will be screening the patient in a lying down position. So there will be a midline barium line you can see along with the normal barium flow in the esophagus. Sorry, this video is not working. This is another video, lateral view, where you can see there is multiple attempts from the patient to swallow, but the barium is still in the pharynx. What happens here is the upper esophageal sphincter does not open. So as a result, you can see there is secondary penetration and even aspiration. You can see some barium in the nasopharynx too. So there is all three misdirection we can see in this video. This is another video. You can already see what happens here. The anterior as well as the posterior wall of the trachea is already stained by the barium, and patient is having a good cough reflex. But the barium which he aspirated doesn't get cleared despite all effort. So the cough efficiency is poor. This is another video. We can appreciate the aspiration here, but the patient is not coughing out. So the cough reflex is poor, but on asking him to do, he could clear out. So this means that he has, though poor cough reflex, cough efficiency is good. This is lateral view. A barium is now in the oral cavity of the patient. Patient is swallowing. Watch here, at the level of C5, C6, there is a smooth bulge from the posterior pharyngeal wall. So this is a sign of idiopathic cricopharyngeal spasm. This is the bump, the smooth bulge at the level of C5, C6. This is best visualized in lateral view. This is another video, but you can see a defect here, a shelf-like defect here at the level of C5, C6. This is a post-cricoid web, which is a characteristic feature in Plummer-Vinson syndrome. This is the AP view. There is stasis of barium here in the pharynx, in the piriform fossa, left side more than right. So from this video, we can conclude that there is weakness of the left side. Here in this lateral view, there are regular indentations from the posterior pharyngeal wall. This is nothing but osteophytes, which can cause significant swallowing problem if it is too big. But even if it is small, it can cause problem if it is the location is related to a sphincter or a post-cricoid area, because it can cause some soft tissue inflammation, which can result in dysphagia. This was a video of a retroesophageal goiter. We can see a soft tissue opaque shadow here. That is a huge retroesophageal goiter. This was obstructing actually the bolus transport and was causing secondary aspiration. Here also we can see a round shadow over here that is getting filled here with the barium. So this is a pharyngeal pouch, and this is the same pharyngeal pouch in the oblique view. Some interesting oropharyngeal dysphagia signs. These are still images. This is an AP view. We can see the stasis of barium high up in the pharynx, that is at the level of the vallicula. It actually resembles a sunglass smiley. And here again in the oral cavity, the oral vestibule, it looks like a mustache. All these signs are described by Dr. Jaykumar R. Menon. Here again, this is a still picture of the motor neuron disease, where fasciculation of the tongue and the barium also forming in the same shape, the irregular surface we can see, which resemble the surface, dorsal surface of a reptile, crocodile sign. And here again, due to tongue dysfunction, the barium we can see in the oral cavity, and it resembles a sea turtle. Here again, you can see the barium in the oral cavity. This is a case of Parkinson's disease, where the slow movement of the barium could be appreciated, that is going into the pharynx, which resemble a caterpillar. So the key points in the pharyngeal stage is the amount, how much the patient has aspirated. Is it significant? Is the aspiration consistent, and which consistency, and what was the amount, and the patient's response? Does the patient clear the throat, or did the patient cough out, and was there any response or no response? And the position of upper esophageal sphincter is important. The status of the UES, relaxed or open, the residue, how much is the residue, the location, whether it is in the valliculae or piriform sinus, and the strategies that reduce the amount of residue. And some part of the esophageal phase also could be assessed at the end of the pharyngeal stage. The part of the esophagus is visible. So is there any backflow or a contrast retention or any motility issues, a small fistula or diverticulum is there or not? That all can be assessed. This we know the 8-point penetration aspiration scale by Rosenbeck and Robbins, 1 to 8. And finally, the esophageal stage. The bolus is propelled in the esophagus to the stomach. So some abnormal videos are here. This is a corkscrew pattern of the esophagus. You can see some regular indentations over here with the secondary aspiration. This can cause significant aspiration, significant dysphagia problem to the patient. It is also called the nutcracker esophagus. And here, this is stasis of the barium in the esophagus, and there is significant delay of barium into barium in the esophagus with the absent or very little barium flow into the stomach. So this is nothing but achalasia cardia. This was an interesting case. The patient came to us with a history of severe cough, chronic cough, and a cough while taking food. And she had significant weight loss too. So when we did the face, we couldn't find any anatomical problem in the pharynx and upper airway or any functional problem. But on giving ice cream, she coughed violently, and we could see the stains of the ice cream in the subglottis and upper trachea. And we proceeded with the fluoroscopy. We could, this is in the esophagus, and we could see a connection into the left bronchus. So it was a bronchoesophageal fistula due to malignancy. And this is the lower esophageal sphincter area and the barium filling into the stomach. This is actually a backflow of the barium into the esophagus back. It was a video of a reflex. So finally, how to read the examination? Does the patient exhibit the physiologic or an anatomical swallow abnormality? And the pharyngeal residue, that is indicative of a pharyngeal movement disorder. And we have seen what are the some strategies we can take during this fluoroscopic examination. It should be read in a dark room in a slow motion, frame by frame. This is the final fluoroscopy report. It includes the physiological impairment, the PA score, the penetration aspiration scale, residue, and the amount of residue, the delay, time delay, stasis, and finally the dysphagia diagnosis. These are my references. Thank you.
Stop sharing.
Sir, you're on mute, sir. Sir, your mic is on mute, sir.
Jaykumar sir, you're on mute. Can you unmute?
I think they are having some audio issue, probably.
Yeah. Now, I think now you can hear me?
Yes, sir. Yes, sir.
Yeah.
We can hear you.
Yeah. Thank you, Manju. I think what Noor and Farida madam told is correct, because there were few videos which I also couldn't see. So they were actually videos, I think, some technical issues, but you could see, some beautiful pictures and videos. So fluoroscopy is definitely one of the very important methodology in diagnosing swallowing disorders, especially the oral stage. We can get a lot of signs, like when the tongue moves abnormally. And what I want to highlight here is that one of the biggest problem with the fluoroscopy has been, many times we had given so much of emphasis to the lateral view alone. That is not really correct, because for the laterality, especially for the oral function, the floor of the mouth, the tongue, the soft palate, and the thyropharyngeus, very importantly, you need an AP view, because lateral view always give the overlap of one side over the other, and naturally you won't be giving much idea about the laterality. And it is very important to identify the site, because it is going to change your plan of management. Even a simple swallowing therapy technique will actually vary. If you know that the right side of the base tongue is not working, you can actually put the foot on the left side. So that plays a very major role. So fluoroscopy is still very, very important, provided it is done in the selected cases. And also AP view is very important. And I just want to add something. Previously, there was a concept that, barium is highly, if it get aspirated, it can create a lot of problems. So especially in pediatric age group, people recommended the other things like gastrographin and all. But now I think it has gone the other way around. Now we know that even though gastrographin can be used, if it is aspirated, sometimes it creates a lot of pulmonary reactions. So now we have gone back to barium again. So a previous clinical evaluation, what Susmita has done, and endoscopic evaluation of the swallowing, what Sanjay has done, will generally give clue how safely or how securely you should go with the fluoroscopy. If you are in doubt, don't do it at all. If you have got small doubt, you go with a very, very small amount and be ready with all setup, to retrieve the aspiration. Then you can actually safely do a fluoroscopy. That shouldn't be a problem at all. So this is in a nutshell about all the general, the most important, the basic investigative techniques for the swallowing disorders. We have got, I think, few minutes. Gauri, is that right? So if there are any questions from the audience, we can discuss that. We can direct it to the concerned speaker, or any other comments.
So we have 10 minutes. We have 10 minutes with us.
So I don't see in the chat box any question as such. Is there any question, any clarification from any of the speakers?
I think there should be some question, Dr. Jayakumar, in your WhatsApp, if there are any. Could you check?
Okay, so it should be only in the WhatsApp?
Yeah, should be coming to you, if at all. Otherwise, you can carry on for 5 minutes.
Yeah, right. So I just want to tell the few more things, because this is very important. We know that the swallowing disorder specialty is evolving. So these are the basic investigation we should have. Everybody should have. Anybody who deals with the swallowing disorders in an institution should have these three things: with the bedside evaluation, the endoscopic evaluation of the swallowing, as well as the fluoroscopy. Now, one of the questions many people will be asking is that fluoroscopy is not available everywhere. So how to go about that? The problem is that the convention, the real fluoroscope for the swallowing, for the deglutology, for the urology may not be available in every hospital. But you can actually get in touch with the cardiology people. They will usually have. Only problem is that it may be in the ICU, so we'll have to go with all this gown and all sterile precaution. But that is a small penalty you're paying for a very good investigation. Orthopedics people have CM, and most of the CM have got the recording facility too. With the image intensifier, you can actually get high quality pictures, but the problem of radiation may be a little bit higher for that. But taking into all consideration, you can actually do a good fluoroscopic examination in short intervals, even with the CM. So that is one alternative. So even if your hospital don't have a fluoroscopy, don't worry about it. You can either collaborate with your cardiology colleagues or the orthopedics colleagues. Generally, that should be possible. Then the other investigations which all are coming is one most important thing will be a pharyngeal manometry, which again is not very common. Usually it is in the field of the gastroenterologist. So if you've got a gastroenterologist colleague who uses the pharyngeal esophageal manometry, you can very well go with them and learn. The good thing is that usually the gastroenterologists are not very interested in the upper 2-3 the terminals, that is the thyropharyngeus and the cricopharyngeus. They are more into the esophagus. So we can actually do a collaborative work. We can actually get in touch with them, and we can actually study the pharyngeal manometric changes in with different kinds of swallowing problem. So if a manometer is available, use it. You will have more and more details, more and more documentation. You can actually present more papers. pH metry, if it is available, great. It will actually give some clue regarding the acidic, non-acidic pH and all. But then LEMG is actually a great option to have, but again, not many people will have that. And it is a double channel LEMG. That is, you do the thyropharyngeus and cricopharyngeus, because in lateral medullary syndrome, classically you get the incoordination. Sometimes the thyropharyngeus may be abnormal, sometimes the cricopharyngeus may be abnormal. So you can get very good consideration. We have got a question from Nooper. If you want to start doing TNE, which is the best way to proceed? What is the learning cut? What are the precautions? Okay, I will tell my own experience. I think one of the problem with the TNE is that right now TNE is a very expensive equipment. That's a problem. But we had Dinesh talking about that cost. It will come somewhere around 40 lakhs in Indian rupees. I don't think that is very possible in most of the centers. But the earlier version of the TNE was not very expensive. It was below 20 lakh. Now TNE, how to proceed? Actually, transnasal esophagoscopy can be done by people who are familiar with the flexible laryngoscopy. What you need to do is that the concept is just like the rigid laryngoscopy, rigid esophagoscopy. We will tell our juniors, don't force your esophagoscope into the esophagus. You should wait for the cricopharynx to open up. In that split second, you have to advance. Similarly, what you do is make the patient in comfortable sitting position, very little anesthesia. You don't anesthetize the throat, then it will become very bad. You can actually use just jelly alone. Pass the scope down into the larynx, into the larynx, just like you do a flexible laryngoscope, and go to one pyriform fossa. Go near, after watching the larynx, after doing the standard flexible laryngoscopy, keep the tip of the flexible laryngoscope in the pyriform fossa. Don't touch it. Just go and pyriform fossa. And then ask the patient to swallow. So what will happen? When the patient swallows, the larynx goes up and it actually telescope the esophagus, our scope. So rather than our scope going into the esophagus and pharynx should come up and telescope the tip of the scope. That is the trick. The tip of the scope in just short of the mucosa of the pyriform fossa, apex of the pyriform fossa, and ask the patient to swallow. Generally, you will be suddenly in that split second, you will see the lumen of the esophagus, just will be inside. We also use the technique Sharath Mohan used to describe, that I also use. We give some aerated drinks to drink. So we give a straw and give Sprite or 7-Up, something like that. So patient is sitting like this. In this position, you can see that what will happen, it is almost like chin tuck. So when patient is using a straw to take aerated water, two things it happen. One, because of the chin tuck, the cricopharynx open up better. Second, because of the aerated drink, the esophagus open up. So it actually facilitates the movement. Once you are into the lumen of the esophagus, it is not very difficult. You can actually continue passing till you see the stomach. So the difficult part in learning transnasal esophagoscopy is negotiating the TNE. So the golden rule is that don't put your scope into don't push the scope into the pharynx. Rather, you should wait the pharynx to come and telescope your own scope. Then you are into it.
Dr. Jayakumar, sorry to interrupt. We have 2 questions in your WhatsApp message, and those should be the last question you take.
Okay.
Hopefully, then we can start the next session.
Okay.
If you can wrap up quickly answering those questions.
Sure.
Thank you.
Sure.
Thank you.
The first question is 25-year female complaints of difficulty in speaking and hoarseness after COVID. On examination, vocal cords are normal. What could be the cause of hoarseness? That is not a... shall I answer that question? Because that is not related to the
I don't think it's a dysphagia question.
Yeah, yeah.
So
So we'll go to the next.
you can personally put
next-
a comment in the chat box
Yeah,
later on.
sure.
Yeah.
The next question was, what do you see with the pulse oximetry? What exactly is the information you get? Okay, that's a very important question, because when you know that when you don't have the facility for the flexible endoscopic evaluation of the swallowing or fluoroscopy, and you are asked to assess a patient in the bedside evaluation, one best thing is that after all the clinical evaluation, what you can do is just put a pulse oximeter and give 5 ml of clear water. If patient has an obvious cough reflex and aspiration, he will cough. The danger here is that if patient has got a silent aspiration, that is what the pulse oximetry is going to solve the issue. So if patient has got a silent aspiration, patient saturation may come down. It may not come down with 5 ml. So if there is no problem with 5 ml, give it 10 ml and then 15 ml. Don't give more than 15 ml. If there is significant aspiration, you are giving just clear saline or clear water, no particulate matter. So if there is significant aspiration, saturation will start falling. It will come down to maybe early 90s or late 80s. So that is going to give a clue. That is the thing. Any other question?
We have come to the end. Yeah, Dr. Shama, are you here?
Yes, sir.
Please come in and conclude.
Thank you, Dr. Jayakumar, sir, for the wonderful symposium.
We don't have your video. We need your picture.
Charlie. Okay. Yeah. Okay. Can you see me? Yeah.
Yeah.
Thank you, Jayakumar sir, for a wonderful symposium. All the speakers were very great, and as usual, sir, we could have pearls of your wisdom regarding dysphagia. So we had a wonderful session. So now we are going to start our invited talks. So let's invite in Colonel Rakesh Datta, who's going to speak on outcome-based research in phonosurgery. He is a professor ENT at AFMC Pune, editor-in-chief, Medical Journal of Armed Forces of India. And he has a special area of interest in laryngology and voice disorders, biomedical publishing, and medical education technology. So, Colonel Datta, can you please share your screen?
Yeah, can you hear me?
Yes.
Great. So I'll just share my screen first. So can you just give me a feedback if my screen is seen?
Yes, we can see you.
Okay,
and
that's
we can
great.
see your screen. Yeah.
First class. So good morning, everyone, and it's nice to be back on an academic platform of phonosurgery after a while. I'm sure all of us are in COVID duties and a lot of COVID-linked things. So nice to be back. I'll talk about something different, and it's outcome-based research in phonosurgery. This is something which I wanted to share for some time now. And I'll just talk about why this topic, what are these outcomes I'm talking about, why are we why are they so important, and what we should do ahead. This is important because I can see mostly people who are attending are experienced laryngologists, and they have a huge amount of work. So this is an old chart. This is 2016, I think. It was 2016, and you see India is not quite there yet in the research map. This is all types of research which is done. Number of papers published that particular year, 2016, and you see India doesn't rank too very well high. And if you see our population, obviously we are not pari passu with our population, the research output. The volume of output or the volume of work which we have is immense. And you can see this train, this signifies the amount of work which each one of us is doing. The amount of types of cases, the number of cases which we see is immense. The quality of work is also Indian. Okay, so we have these quality of works. You can see this fancy new Vande Express, Vande Bharat. And you can see this also is produced by us. So the quality of work is also not a challenge. So we have the numbers, we have the quality. An interesting article, which is again not very fresh and pertains to data up to 2014, where only 25% or only 4% of the institutions of this country produce more than 100 papers. So if you read that again, it will be shocking. This is medical papers. We are not talking about IITs, we're not talking about IISs. We're talking about medical colleges here. So only 25 institutions in this country have got more than 100 papers per year. And their contribution is 40% of the country's total research output. More than half the colleges or more than half the academic institutes of the country do not have a single publication during this period. So, and we're talking of a 10-year period. So is this not shocking? I was always shocked by this thing. What we are practically doing is this. We are producing top quality research and destroying it ourselves. So we have fantastic work, but poor science. So the idea of this talk today is to talk how can we improve science in this particular field of phonosurgery. And I view it from a different aspect today. After being in this publishing field or as editor-in-chief, making decisions for the last 7 years plus, and last 3 years have been particularly hectic in this particular multi-specialty PubMed Index journal, where I receive up to around 700 manuscripts in a year. The view from the other side of how Indian research, Indian data is not up to it is an angle which I would like to share. One very fundamental thing which we need to understand, science is measurement. Surgeons seems to understand this lesser. Science is measurement. Everything needs to be measured. So if science is measurement, we need to make sure that we measure what we are doing. And good science is accurate and careful measurement to the extent that if we do the same experiment again, if we share a study or we do a research, it should be that robust that if the reader were to do the same thing, he would get a similar result. Okay, so that is how it should be viewed when you are doing a particular research. So good science is accurate and careful measurement. Another very, very difficult thing for surgeons or maybe even some clinicians to understand is the parameters which we measure are of different types. Apples and oranges are different. They are not everything is a particular percentage, not everything is a something which you can mean. And what I'm referring to this is essentially data. This is not a research methodology class, but remember this fundamental point where data has to be treated with a lot of respect. And at the outset, when you're forming a research variable or an outcome variable, make sure that it falls and you know what type of variable you are measuring. Nominal, ordinal, interval, ratio, these are all types of variables when you collect data. How do you define an outcome variable? An outcome variable is what changes happen in an experiment when you do a research. A research is like an experiment or a study where you're trying to gather data after a particular period of time or go back in time and gather data. So what changes are occurring? So now remember, science is measurement. So you need to make sure that this outcome variable is a measurable parameter. So what are outcome variables in phonosurgery? The next talk will talk a bit more detail in about subjective and objective parameters. I'm not getting into that, but just summarizing them. First is how others hear it. The doctor, the people, how your voice is heard, an acoustic analysis, how it looks, how you see it in a particular scopy, how the patient feels about it, and certain technical parameters. Now remember, these are all, everything can be made into an outcome variable here. You just see. So how does it sound? So when I'm speaking, there are so many phonologists here who can probably start already grading it in sort of various parameters. One of them can be a Grubauer scale, grade, roughness, breathiness, asthenia, strain. We're not getting into technical details of these scales. A shorter scale called GRB scale, and a very interesting scale where we are trying to convert this into numbers into a sort of visual analog scale by using the CAPE-V. So these are scales which tell us how the person sounds. They suffer from a huge problem, and that is subjectivity and bias. Till the research caters for subjectivity and bias, it's not going to be good research. So these scales are used, but research based on them is not usually very sound. It's like wine tasting. You're trying to convert an art into science. Everyone may have a different take on it. So definitely when 2-3 people are doing the same scale, they may have a very varied outcome. Okay, you may like someone's voice, which is slightly husky, you may not. So it's full of subjectivity. And this is an attempt at converting art to science, but this is an outcome variable. Acoustic analysis is next. Something which our friends from speech language pathology who will be here are very fond of. Remember, these parameters also have got the huge limitations, but we'll first talk about them. We have maximum phonation time, which is a very good sort of simple, straightforward outcome variable when we are talking about something like a phonatory gap. Fundamental frequency, we're talking about shimmer, jitter, Surzer ratio, harmonic to noise ratios. The huge drawback with this is the function may not be the same as form. What you may have as a structural problem may not be what your functional parameters show, and vice versa. What I mean is you cannot use them as very good, accurate outcome variables. Change in shimmer is not what is going to determine a good outcome. Whereas change in MPT might in certain cases. So you have to understand your data and respect it well. The changes in these particular things may not be appreciated by the patient himself, leave aside the machines. The patient themselves might feel, fair enough, you did a surgery just because of one particular parameter being wrong, but it's not affected me. Not a good parameter, again, to take, not good outcome variables. This is what surgeons mostly do. Take a good video, take a good, and do a good high-speed video nowadays and other fancy tools coming up. Again, the form may not be as same as the function. You might have a very subtle defect, but a very severe form of dysphonia and vice versa. But definitely this is something which we do. A huge challenge here, and then probably over a period of time, this might get sorted out. Stroboscopy is an attempt of measuring the video. Again, science is measurement and accurate measurement. But by making measurements, are we losing the sort of woods and just looking at the trees? Many times we lose out on using video as a good objective and outcome variable because visualization is not measurement. Showing a video is good science when it comes to showing an improvement to the patient or maybe in a conference. But when it comes to research, you need to have some measurable criteria, maybe some index, maybe some measurement, which like video stroboscopy have, mucosal wave. So these things have to be understood. And this is one of the major important times. This happens not only with ENT surgeons, but even with others. They say, we have a video, so this is the evidence. So this is an evidence, yes, in that sense, but it's not a measurable outcome. Next, we come to how the patient feels about a particular problem. That is a very important place where a lot of research and a lot of research is reported on. And these are the voice handicap index, a shorter version called VHI-10, aging voice index, you have LPR indexes. This has another problem. Suffering may not be the same as form or function. Now, the patient's suffering may be out of sync with a sign. Suppose he has a small nodule, does not mean that the patient may not be suffering more or less and vice versa. So this has got one particular problem. But remember one thing, this is something which matters most to the patient. This particular parameter is something which matters most to the patient because they have come with a problem and this is where the problem is getting solved. They have not really come for changes in fundamental frequency, which they may not have ever heard of. There are other technical parameters which form very good outcome variables. And for example, maybe operative time, the side effect of an intervention using a particular technique, using a manipulation versus a particular injection technique, complications of a procedure, or a cost-benefit analysis. These give indirect evidences or indirect benefit of a particular intervention or your experiment, if you can call it. And they should be used also but are primarily not the reason why again a person has come to us. So they are very indirect they are indirect evidences and they are indirect benefit. So that is something which one should remember. As the technical parameters as outcome variables are not necessarily perfect, but definitely they have got their advantages. Where are we? So what do I choose finally? What should a person choose? I think it is important to understand that what to choose is what matters to the patient most. And this is where quality of life index is. Remember now, when we had that data chart, we had a lot of variety. So this is an ordinal, this is a categorical sort of variable, which is in order. So it's ordinal variable. You cannot do a mean. That what I mean is if a person chooses from a scale to 1 to 10, the difference between 2 to 4 is not same as difference between 6 to 8. These are not mathematical, they are just numbers given. So they are difficult to handle in a conventional mathematical sense. However, there are statistics for this, which we are not going to cover. We're not talking on that. But remember, quality of life indexes are very good measures when you want to report your results or interventions or following a surgery. Choose something that is measurable. Video is not a measurable tool. Remember, this is something very important for us surgeons to understand. It should be reliable. It should be valid. Most of you would have done your research workshops and understand this reliability and validity, how outcome is more important to handle the data appropriately. As we just mentioned, the data has to be handled with the right statistical tool in the right way. And I think that is what an outcome, good outcome variable. And that's how the research will get published and accepted and cited. The proof of the pudding is in the eating. So eventually it should be cited in a positive way and cited so that this research matters. What should you do? What should we all do? We should start measuring our work more accurately. Measuring actually many times is left to our assistants, our residents, and measurement is like ikathe kar lo, just gather everything, and then that's not what the right thing is. Measuring your work should be done as a matter of as equal passion as if we do the surgery. We should use validated tools, saying that I have decided this is good, this is fast, this is bad, will not work. And this is how a lot of research of our country gets rejected. We don't use tools which are validated. If you have such a good tool, validate it, go through a process. For those who are in colleges and all, try to make sure that the time when PGs do their thesis is the time when both guides and the students both learn. Even the guides learn at that time many particular things. We should encourage, we have now these online workshops on the SOYAM portal. We should respect the data and treat it very well. Then only it will get published, and then only our research. As we said, we are producing Vande Bharat, but we are traveling in those trains. So we need to really look at it in a very serious way. And finally, we have to publish outcomes. And publishing is a tedious process, but that's a separate thing. But it has to be published, and it should be published. Our experiences, one does not have to wait for a path-breaking research to publish. Even every experience is unique, provided it's put in the right perspective. There's a possibility to publish. Finally, I'll wind up by thanking the organizers and the Association of Phonosurgeons of India, Dr. Virendra Kumar and his team, and everyone, Dr. Jay Kumar, Dr. Amitabh Raichaudhuri, Dr. Unni, and Dr. Nupur. Thank you so much. It has been a pleasure. And after a great gap, I was back to a bit of phonosurgery talk. Thank you so much. I think there were no questions, but I'm happy to take if there's time.
Thank you, Kalna Datta. So I would like to invite our next speaker, Dr. Kabikant Samantre, who will be speaking on subjective and objective analysis of post-operative outcome of endolaryngeal phonosurgery for benign vocal fold lesions. Dr. Samantre is a professor ENT and head neck surgery KIMS, Vice President Association Otolaryngology Bhubaneswar branch. He was past Vice President of APSI and past honorary secretary of APSI. He has a fellowship in otology, Cos Clinic, France, and fellowship in SRBD Mannheim, Germany. So, Dr. Samantre, can you please take over? One request to all the speakers, please complete your talk within 12 minutes, which is the allotted time. Thank you.
Hello.
Yes, we can hear you.
Yeah. So, good morning, everybody. This is the way that we people are meeting nicely, maybe by this conferences. So, my thanks to Dr. Rakesh also, because he has made my work a little bit easy, because whatever he has talked, that this is the outcome of this my talk. This is a research analysis. What we are giving. So giving you a little bit introduction, because time is very less to talk on this topic, because this is a research methodology and how we are researching and publishing, taking data, taking these data to the patient, and we are collecting this data from the patients for the doctors, and this is an analysis. So once just cross-quoted, the human voice is the beautiful instrument of all, but is the most difficult to play, difficult to play. So it is quite evident how voice plays a pivotal role in our life. So my point is here to analyze the objective. How to analyze our surgery, because all people are doing surgery, and we have to face the patient, the public, and to the surgeons, maybe young or older, but people has to answer for their work. So subjective and objective. So we know we'll precise our discussion here, because Rakesh has given a baseline for this talk. So you will what objective things we are doing, mostly the stroboscopy, and what the subjective things we are doing. And I am here only talking about the VHI 30, not 10, because 10 is a precise one, and my final outcome what will come out. So these are the objective analysis. Somebody should remember, actually, laryngeal visual assessment. Stroboscopy is one of them, and we are discussing on stroboscopy, perceptual evaluation of the voice, acoustic analysis, electrolaryngography, electroglottography, aerodynamic measures, voice accumulator. People are doing a lot of things, objective things, but mostly if you want to do a surgery, everybody comes to gold standard in mind. Okay, I should I have a stroboscopy? If I have a stroboscopy, what data I should get from the stroboscopy preoperatively, and during operation what to do, and post-operatively how I compare these data, and I approach to my patient. This was you, and this is operated, and this was the data you got from your questionnaire. So laryngeal visual assessment about this stroboscopy, inspection of the structure and dynamic function of the larynx and rest of the vocal tract, vibratory patterns of the vocal cord during phonation. This is the main aim of the stroboscopy. So we should do all these things: video laryngoscopy, fiber-optic laryngoscopy, video stroboscopy, chemography, high-speed digital imaging. So video stroboscopy we have done in our research here. So everybody knows about this video stroboscopy. I should not take time for these things. So the transnasal flexible video laryngostroboscope is for the less gag reflex. We are doing sometimes the nasal one and sometimes the oral one with the 70-degree scopes. So these are the parameters. I should tell the parameters. I should not elaborate these things now, because there's a very less time. So what things we should do? We should look before surgery once a patient comes. So doing a stroboscopy, not just imaging. So we have to analyze this data. You should know what I should present to the patient, what data I should collect. One is the vocal fold free as contour. This is one. Second is mobility, whether it is a normal, reduced, both the chords, whether there's absent mobility or you cannot judge. So one is that pre-edge contour is important, then mobility, then supraglottic activity. So supraglottic activity in your video stroboscopy, you should get the data. So your compression, lateral compression, how much the interposterior compression, what is the sphincteric compression. So you should analyze these data, supraglottic activity of this vocal fold, then regularity and periodicity. Regularity and periodicity of the movement of the vocal cord, both the from never regular to always regular movements, that is 0% to 100%. So regularity you should know. You should calculate the amplitude, the percentage of the amplitude. Prior, what is the amplitude? You did the surgery, what is the post amplitude? Then you can go for the subjective one. So then mucosal wave. You can calculate the percentage of the mucosal wave from the stroboscopy. So these data, if you are not aware of these data, if you are not calculating those data, so how can you convince your patient? How can you convince yourself? I am getting this data, I am doing this surgery, and I am getting this post data, so that you also get a satisfaction of your surgery. You can give a report to the patient, and you can publish a lot of data, or you can get good papers or good research work out of these things. So just doing a stroboscopy is, I think, doesn't carry any value nowadays if you are not analyzing the data in a proper way. Then glottal closure, that is complete closure to incomplete closure. So so many variations there. Absence of closure, variable closure, and could not be judged. These are the things I'll show in some tables. Then left-right phase symmetry. So these things also be calculated, phase symmetry. Then vertical level, what is the level of the vocal fold, up and down, and then vertical levels. Then phase closure, right at the point of the contact with the phase closure, this should be calculated. Then non-vibrating portion of the vocal cord. Once you have a you have a growth, you have a mass, because I have researched here, I have done a work on benign lesions. So if there is a lesion, whether this part is vibrating and how much portion is vibrating, whether left cord portion is vibrating and right cord portion is vibrating, your percentage of vibration also will show in your outcome of your surgery. Then so you should describe the lesions, like its position, color, shape, whether it's a multiple lesion or the single lesion, whether it is present on the surface, present on the free surface, and the superior surface of the glottis. You should do description of the lesion. Then arytenoid position, one of the thing that you should analyze from the stroboscopy. The position may be described as normal, to affected, to for medial. So the position of the arytenoid described in relation to the normal position of the cartilage in the cricoarytenoid joint. So position of the is also an important point. Then arytenoid movement is very important. You can palpate them. You can see the movement that right and left, both arytenoid movement should be judged from the stroboscopy. Then coming to these are, because I have focused here the stroboscopy, because most of the surgeons now they are focusing on, they are getting data from the stroboscopy. But you should analyze, you should make a table for these things, and you should analyze this data for individual patients. Then only you can identify the problem, what they are facing, and what you are doing and what you did. Then about the subjective outcome assessment, what Rakesh was talking about very nicely, and we are also doing this BHI. That is for that. Why do we do it? Quality improvement and the movement towards the value-driven healthcare system. Because nowadays you can face a lot of questions. Even in medical legally, you did a surgery, you did a ear surgery. What is my outcome? You did a voice surgery. What is my outcome? If after the surgery I am facing a problem, if you have some data pre-operatively, post-operatively, then what the patient, even if you ask you can see, sir, this is your problem and I did it. Now you are giving the questionnaire and answer of this problem, and now you are getting this outcome. So faced with these resources, limitations, and accountability, clinicians need to delineate the value and impact of their services. You should give an impact. Yes, sir, I have done it, and this is your result. So impact on communication ability. So these are the need to treatment largely determined by the patient's degree of disability. These are things, the methods available for subjective assessment. This is a form of patient's self-rated vocal handicap or rated quality of life questionnaire we are doing. So there's a lot of options available. Option 1, 2, 3, 4. So you have to choose the option, what is the best one. So we have choose the BHI 30 because these are the subjective options for you, and you should choose, you should know at least what are these. So patient questionnaire and vocal performance, VPQ. That's just questionnaire performance. Then the BHI, the most accepted, I think, by Jacobson and et al. BHI 30. BHI 30. Then VRQ, OL, and voice. Voice is one of the scale. And then VAP, that is voice activity and participation. Voice handicap index, BHI 10. BHI 10 is a shorter form of the BHI 30. So in BHI 30, you have to face 30 questions. The patient has to face 30 questions, and these questions are made on different aspect of the patient's here, functional aspect, the behave, physical aspect, and emotional aspect. 10 questions are divided, and each 10 questions patient has to answer. Because the problem with these things are, I think Rakesh has done once, he has done in Hindi, so we put in Oriya. So and even if we are giving in English, it was originally available in English. So it should be done in different regional language, because India is a diversity of languages. So people should do for their own language. Then only your patient can listen it, read it, and answer it. So these are the questions. So 0 is never, then almost never, 2, 3, 4. These are the grades of the questions. I am reading some of the questions. This is the functional questions. One is, my voice makes it difficult for the people to hear me. So patient will answer, in which stage I am, in which stage I am here. So like my voice problem causes me to lose income. So this is a functional problem. So there's a 10 questions are here. So in like that, in a physical aspect, there are also 10 questions. In the same way, I run out of air when I talk. People ask, what is wrong with your voice? So they grade it. How often people take you talk like this? How often people ask you? How often people, I used to use a great deal of effort to speak. So how often you face? So these are the questions the patient has to answer, write or tick, and you have to get the data. Then the last part is the emotional 10 questions. So like I am tense when talking, other because of my voice. Sometimes you get a stammering, sometimes you get a choking, sometimes you get a like I feel annoyed when people ask me repeat, you repeat. So these things are answered by the patient. So there is a subjective analysis must be in your clinics, or it should be told to your patient. Then coming to this is the total BHI paper that we have made, or we got it in Oriya. I will show you in the last. So you have to put to these patients, and the score is 0 to 30. If you are getting the score is mild, minimal, amount of handicap, then 31 to 60 moderate, and 60 to 120 often seen in patients with the vocal cord paralysis or severe
Dr.
vocal.
Samantare, sorry to interrupt you. You have just 2 minutes left.
Okay, I'm finishing this. Then this is the grading of the BHI 0 to 30, mild, moderate, and severe. So and these are the auto values. So I'm showing immediately, and the BHI 10 what we are not using. Then is a case discussion. I'm showing you right vocal cord polyp. This is a pre-strobo picture, the one of the patient. Then coming to this is the analysis. This is the pre-strobo interpretation. We analyze everything that the preoperatively. Then this is the BHI of the same patient, like it is BHI is totally 65. So from that, then we did the surgery. Then after we analyze these data after 1 month and 3 months. So this is after 1 month of the surgery. This is the post-op strobo of the same patient. Then you see, you can analyze. This is the post-op. This is the post-op strobo analysis. Most of the things are normal, both side convex. Then regular the periodicity. Then mucosal waves are near about 50%, and arytenoid moment are normal. Everything. Then you see that 1 month BHI is around 29. So as I told you, 12 BHI analysis is a good result. So 65 to 29 is a good result in 1 month, and we will analyze this type of patients in 3 months also. This is another patient, pre-op strobo. This is a cyst. This is a left cord cyst. So you see how we analyze in the strobo. In the like it's a right VF, so that amplitude is less than 75. That is a posterior gap, and phase symmetry that open phase predominant. So the normal vibrating portion, that is 20% is affected here, and left is normal. So the same patient who did a VHI in urea. So the VHI is around 44 for this patient, and operated, and I analyzed this patient in 3 months. This is the same patient after surgery. The strobo of the, you see the strobo, and we analyze, and this is the result. You see the non-vibrating portion is reduced to 0%. So you can analyze your data, and after 3 months, the VHI is 0. So the patient tells how the result is. So this should be, I think, attached to our patient's diary, that you got this, and after 3 months you got this. So regarding this is one of the outcome of scoring system of endolaryngeal surgeries, and in this era, we should be more documental for these things. And if you are doing a strobo, you should make it a proper way of strobo analysis, and it should be given to the patient. And if you are doing a surgery, it should be given to the patient. It should be done in different Indian languages because it is important. And I think the Rakesh had done in Hindi. So if somebody has done, this should be shared, and this is scores can be given to the patients. It is one of the better method among the available scoring system. Stroboscopy in comparison with the VHI is helping the surgeon to analyze his work pre and post operatively. So, but things that our from the APSA level also, we should talk in these different forums, and we should give data and analysis of these things. Thank you.
Thank you. Thank you, Dr. Samantre, for the wonderful insight into the analysis of post-operative outcome. Now let me invite Dr. Ravi Meher, who is a professor of ENT, MAMC, Delhi. His special interest lies in laryngology, and he also works as an honorary secretary of Association of Photolaryngologists of India, Delhi branch. He is going to speak to us about our methods and outcomes in management of subglottic stenosis. Dr. Ravi Meher, please.
Thank you, Dr. Sharma. Okay, can you see my slides?
Yes, we can.
Okay, so I will be talking about the subglottic stenosis, and at the outset, I would like to thank the organizer and the APSI for inviting me for this talk. So regarding the subglottis, subglottis actually extends from the undersurface of the vocal cord to the lower border of cricoid cartilage, and it is one of the narrowest portion of the airway in infants. And if we see the definition of subglottic stenosis, in the term babies, anything which is less than 4 millimeter of diameter at the level of cricoid is termed as subglottic stenosis. And in preterm babies, anything which is less than 3 millimeter is termed as subglottic stenosis. So there are different types. One is the congenital stenosis, which is present at birth, and another is the acquired stenosis, which is after the birth, and it occurs because of trauma. So if you see the congenital stenosis, it is secondary to the inadequate recanalization of the laryngeal mucosa during development, and it constitutes only 5% of the cases of total subglottic stenosis. And if we see the types of subglottic stenosis, we can have membranous type and the cartilaginous type. In membranous type, what happens? There is basically increase in the the size of the laryngeal mucosa and the mucosal glands, leading to narrowing of the subglottis. While in cartilaginous type, there is basically lateral shelving of the cricoid cartilage. So this is in fact, it's the cricoid cartilage which becomes more of elliptical in shape, right? The congenital stenosis is present at birth, and in mild cases, it might be totally asymptomatic. Acquired stenosis, the most common cause for acquired stenosis is the prolonged intubation. And other causes can be blunt trauma, fumes or smoke inhalation, caustic ingestion, chronic infections like tuberculosis, leprosy, typhoid, and Wegener's granulomatosis, etc. Acquired subglottic stenosis usually presents after 2 to 4 weeks of trauma. And it depends on the subglottic stenosis. The development of acquired subglottic stenosis actually depends on the size of the endotracheal tube. Larger the endotracheal tube, longer the duration of intubation, and using force during intubation can lead to acquired subglottic stenosis. So to prevent, it is important that we must ask our pediatrician friends to use the smallest size of endotracheal tube, which is adequate for ventilation of that child. So that will prevent many cases of acquired subglottic stenosis. What are signs and symptoms? Most of them will present with stridor, which is biphasic. Some patients might be having cough and dysphagia problem. And these are seen mainly with milder cases of subglottic stenosis, where they can have features like acute laryngotracheobronchitis. Diagnosis, imaging, we can do imaging, but in children, in infants, especially the X-rays are very difficult to take. But you can see a steeple sign on X-ray, and CT also you can have. CT will tell you the size and the site of stenosis. The important thing is that we must get a high resolution 1 millimeter cut for diagnosing these cases, because otherwise sometimes if there's a small segment stenosis, it might be missed on CT. So rigid endoscopy is the gold standard, and during rigid endoscopy, we must evaluate the site of stenosis as well as the length of stenosis, which is important. Plus, you must also evaluate the other parts of the airway, the nasopharynx, the nasal cavity, as well as the hypopharynx, and the rest of the trachea and the bronchus for any other coexisting abnormalities in the airway. Cotton-Myers classification, I think everybody knows about it. Grade 1 is stenosis of 0 to 50%. Grade 2 is from 51 to 70%. Grade 3 is from 71 to 99%. And grade 4 is there's complete obstruction. There's no lumen visible. The management, you can do, there are two types of management. One is the endoscopic management, and other is open procedures. So we'll come to the congenital stenosis. Most of the milder cases, they must be managed conservatively. And since it is a self-limiting condition, as the child grows up, the congenital stenosis, the cricoid size increases and the patient improves. It is only with the severe cases or the grade 3 subglottic stenosis, which are actually management for surgical cases. Intubation, again, if patient has a mild subglottic stenosis, congenital subglottic stenosis, intubation in these children might cause further trauma, and it can lead to acquired subglottic stenosis, which might require surgical management. So ideally, if you can, you should manage the milder cases conservatively, and they can be managed by putting nasal cannulas and oxygen mask rather than intubating. Acquired subglottic stenosis, grade 1 and grade 2, they are asymptomatic or minimally asymptomatic, and they may be observed, and they may be managed conservatively. Grade 3 and grade 4 are symptomatic, and they will require surgical management. Balloon dilatation, it is usually reserved for milder cases for grade 2 and 3. And the indications are if the stenosis is small segment stenosis, right? Or it is thin or web-like. Long segment stenosis cannot be managed by balloon dilatation. Soft stenosis and immature scar. If there is a mature scar and long-standing stenosis, obviously these cannot be managed by balloon dilatation. And there should not be any cartilage involvement, right? So what are the advantages of balloon dilatation? Basically it's a minimally invasive technique, and it is atraumatic because it avoids any sort of mucosal trauma, and it exerts purely radial force over the airway. So it minimizes the chances of trauma as well as airway rupture. And obviously there is a manometer attached to it, so you can actually fine tune the amount of dilatation which is required and for a particular stenosis. And these catheters are long and narrow, and these are very flexible, so you can easily negotiate through the stenotic segment. How do you calculate the size of balloon? So the size of the balloon is calculated by the size of the endotracheal tube which will be used for intubation of a child of that particular age. So suppose there's a 4-year-old child and you can intubate with 5 millimeter endotracheal tube. So the outer diameter of endotracheal tube is 7 millimeter and the balloon size is also 7 millimeter. So that is how you can actually calculate the size of balloon. And obviously before inserting the balloon, you have to do some adjunctive maneuvers like scar division and steroid injections, and that can be done by sickle knife or cold instrumentation or by laser if you have. And generally these patients will require multiple dilatation. So after interval of 1 to 3 weeks, you can do repeated dilatation, and most of the patients improve after balloon dilatation. Expansion procedures. So these are the open procedures which can be done. These are of two types. Basically, you can put an anterior cartilage graft or a posterior cartilage graft. Again, you can combine both the things if the stenosis of severe grade. Right. So what we use is the costal cartilage from the rib, and this is from the 5th rib. This costal cartilage has an advantage that you can have large piece of costal cartilage. It is easily accessible, and it is robust, strong cartilage, and you can easily carve it with the knife. And you can make a flange formation which is required for anterior posterior required grafting. During the costal cartilage harvesting, you must preserve the inner perichondrium, right? You have to take the cartilage with the perichondrium on the lateral surface, but the medial side of the perichondrium is left in situ. And after harvesting, you must irrigate the wound with saline, so that if there is any leak or there's a pneumothorax, you can actually see and manage it on table, right? You should not use cautery near the cartilage, and there can be complications like pneumothorax and hematoma, and if there's a pneumothorax, you need to put a chest tube. For anterior costal cartilage graft, you need to open the cricoid. Basically, you have to open the cricoid on the first 2-3 tracheal rings, and the indications are actually failed endoscopic management with suprastomal collapse, or for the patients with milder and moderate cases of subglottic stenosis. And the cartilage is shaped in the form of a boat, right? And that is placed between the split end of the cricoid cartilage and is sutured. So that will increase the lumen of the subglottis. Posterior cartilage graft, again, you have to carve the posterior cartilage graft in a flange like fashion, and there are 2 grooves on both the sides so that it can actually snap between the posterior cut end of the cricoid cartilage. And for this, again, you have to do an anterior cricoid split, and then you have to go for the posterior cricoid split. This procedure can be done endoscopically also. The posterior cricoid split can be done endoscopically, but you need a long cautery and special instrument for that. The indications for posterior cartilage graft is severe subglottic stenosis, posterior glottic stenosis, and if there's a stenosis which is accompanied by bilateral vocal fold paralysis caused by either by it's a paralysis or there's a cricoarytenoid joint fixation. So lastly is the open procedure. You can do a cricotracheal resection. Again, the indications for cricotracheal resections are severe subglottic stenosis or if there is structurally inadequate subglottis. And if their previous attempts to airway reconstruction have failed, then this is the method of choice. And the advantage of this method is that you are actually anastomosing the normal trachea with the posterior cricoid and the lower border of the thyroid cartilage. So there is less, the results are very good, but it is technically more difficult procedures. The relative contraindications for the cricotracheal resection is if you have a low-grade subglottic stenosis, obviously you can manage with either balloon dilatation or anterior posterior cricoid split. If the stenosis is within 3 millimeter vocal cord and in the conditions where it is difficult to mobilize the trachea. For example, if there's a tracheoaxial fistula which has been repaired or there is surgery or injury to tracheoaxial septum. So in these cases, the mobilization of the trachea from the esophagus might be difficult. So these are the relative contraindications. For the complications, so there can be complications because all the airway surgeries can have intraoperative complications like desaturations, pneumothorax, bleeding, and aspiration. Post-operative complications can be wound infections, granulation tissues which can be formed at the site of anastomosis. There can be dehiscence. So for cricotracheal resection procedures, you have to put a chin to chest suture so that there is no abnormal force on the anastomotic site, and there can be graft dislodgement and displacement, and obviously there can be problems because of the recurrent laryngeal nerve injuries. So these are the complications which can occur after cricotracheal laryngotracheal reconstruction. Thank you very much.
Thank you, Dr. Meher. That was a wonderful presentation with nice pictures. Now I would like to invite Dr. Pushkar Lele to share his presentation on NBI in laryngology. Pushkar Lele has, Dr. Lele has fellowship with Steiners, Germany in CO2 laser. And he has been doing laser surgeries for past 23 years and has conducted live surgical workshops at his hospital. And his special area of interest includes head and neck surgery and phonosurgery. And to be very different, he is a very active marathoner and loves reading and listening to music. So Dr. Lele, please share your screen.
Thank you for inviting me to this forum, and thank you for the generous introduction, Shama. Can you hear me? Yeah.
Yes, we can.
Yeah, all right. I'll just share my screen now. And okay, is the screen seen as well? Okay.
Yes.
Okay, so I think narrowband imaging is not very new anymore, and but it's not so common as it should be. So we all know that your light is made up of broadly three colors, the RGB. And if you toggle with them, then you can enhance the appearance of blood vessels in the mucosa. And that is what the NBI technology is using. So selectively, the superficial vessels absorb the bluish tinge, look brownish, the deeper ones look greenish. This is the equipment that you need, the NBI generator, the recording unit, and of course, you should have a strobe unit with it, with a nice monitor. The most notable application for this technique is undoubtedly the early diagnosis of malignant lesions. The NBI works in identification of vascular patterns, actually. And the more complex and the more dilated the vessels and the more intriguing the patterns, the more likely that this is going to be a malignancy. So essentially the vascular patterns are divided into types 1, 2, 3, 4, 5, and then the 5 is divided into further 3 types. So we will look into the patterns as we go. A normal vasculature is type 1. Here you see some dilated vessels here, and this is a type 2 pattern along with a nice polyp here. The polyp is picking up, showing up as a dark colored structure uniformly seen. So this is a vascular polyp. Similarly, you can see that this is a granuloma on the on the arytenoid surface, not showing vascular patterns here. So this is a contact granuloma, not a malignancy, nothing to be worried about. This is a polyp. You can see how an NBI shows it a little differently. You can see how vascular it is. You can plan your surgery. Maybe for a polyp, it's not that big a deal, but you can basically see the vascularity of everything. So the base of the polyp looks vascular. NBI has got tremendous application in benign conditions. So you can see this is a sulcus on the left vocal cord because the way the scope is angled. And if you look at this vocal cord, you can see the sulcus so beautifully with the NBI. So differentiation between lesions, differentiation between sulcus and then the pseudosulcus can also be very easily seen. So I'll show you a slide of a pseudosulcus in the later part of the presentation. Keratinizing lesions show up as white patches with the underlying vasculature, which is increased, and this is a vocal cord strain, which you can make out. This is a type 4 pattern. Type 4 pattern is with dilated vessels. These are called as IPCLs. So intrapapillary capillary loops. And the wider the loops, the more possibility that this is going to be a malignancy. Over these patterns, you can see a white area, which is kind of a white out, hiding the lesions below. And this is called the umbrella effect. You can see that the dilated loops are a little wider and they're discrete but wider. And this is a typical malignancy seen. We don't actually need an NBI for that, but this demonstrates the type 5A pattern. This is again type 4, smaller IPCL patterns. It's a right vocal cord lesion. In this, you can see that the blood vessels are meandering about, and this is a typical type 5 pattern, which with meandering vessels. This is again an indicative of a malignancy. This is a right vocal cord growth. You can see on the strobe that you have a non-motile area, lesion on the right vocal cord, which can be excised completely with the laser. Recurrent respiratory papillomatosis again is a very big application for narrowband imaging, both pre-op and intra-op. So in intra-op situation, you can pick up small areas which you have otherwise missed. And you can see this beautiful papilloma sitting on this vocal cord and smaller lesions involving these cords and the anterior commissure as well. Intra-op, the same lesion. Post-excision, maintaining a strip of intact mucosa here. Another large papillomatosis case. This is a huge cyst on the left vocal cord. You can see that there is no vasculature seen in that. Again, the sulcus vocalis on the cord. And this is the pseudosulcus, which is seen, which is because of the edema of the vocal cord. And you can differentiate between a pseudosulcus and a sulcus on NBI very well. Bilateral keratotic patches. It's a type 3 lesion. No abnormal vasculature seen. Post-operatively, this turned out to be a benign lesion. Look at this part of the this big mass sitting here, absolutely no abnormal vessels seen in this. This was excised and turned out to be just a polyp. Whereas in contrast, you see this lesion and there are some IPCL patterns seen here, and this turned out to be a malignancy. So you can differentiate straight away between a benign and a malignant lesion. So the same lesion, and I know that I have been allotted a shorter time, so we will go through it in a little jiffy. So this tumor was excised completely, and sorry, so we, okay, and all right, sorry. So this is a complete excision of that same thing. So you can completely excise that tumor. Also, in the narrowband imaging, you have already seen that this particular thing is not showing in a vasculator. So this is just a contact ulcer. This gentleman had operated 20 years back, and he just said, "Come, please, doctor, just have a look." And we picked up this lesion with an IPCL pattern. You can make out that the lesion is extending from all this area. So was operated. This was a lesion, wide excision, and turned out to be a malignancy. Just incidentally picked it up. So, similar technologies are available with other manufacturers. iScan from Pentax is one such. I'm using a TNE routinely in my OPD, and we are picking up a lot of lesions. We are doing all biopsies, small procedures, vocal cord injections with a TNE control. And one such case, I'm just showing it to you. This is standard esophagoscopy. Patient had persistent symptoms. On iScan, this is showing a doubtful lesion. It's actually just occupying one part of the circumference of this esophagus. We biopsied it, turned out to be positive for squamous cell carcinoma. These applications are just to complete the list. COVID times is changing things, but we are ready for them. A simple trick is to put a surgical mask on the patient's face and make a very small hole which just accommodates the scope. So once you're through the mask, then you have less risk of an aerosol. Of course, the surgeon who's doing it, his mouth and eyes and everything is covered. The usual precautions apply, and all other personnel stand away from the patient. So this is a small change that we are doing in COVID times. And thank you very much. So stop screen share. Yeah.
Thank you, Dr. Lele. That was really a wonderful talk. Now I would like to invite my dear friend, Dr. Shruti Dhingra, who is an assistant professor of ENT at MAMC, New Delhi. She was instrumental in setting up a laryngology lab at ESIS Medical College and Hospital, Faridabad, as an HOD. And not the least, she was the first one to organize the Mid-Phonocon last year, and we had good memories about it. So Shruti, please take over.
Thank you, Shama, for giving me the opportunity. And okay, is my slide clear?
Yes, Shruti.
Okay, thank you. So my topic is the aging voice, and the interest in this field actually grew when my grandmother, about 5 years back, said that she could not sing bhajans anymore, and she used to sing beautifully. And when I looked into her larynx, I couldn't see anything. There was nothing I could pinpoint and tell her that this is wrong. And I felt really bad for her because at that time I didn't understand this topic too much. There are not many patients of the aging voice who present to the laryngologist really in clinical practice. So I think it's important to understand what goes on in the larynx as we age. So we know that the aging population is one of the most significant challenges of healthcare today. And it is said that by the year 2050, the number of people who are over 60 years of age is almost going to double. And the incidence of dysphonia in the elderly can range anywhere between 12 to 35%. It is communication is very essential for elderly because it helps to maintain their sanity and be part of social groups. And not only do they, if they have a problem in speaking, in addition to a problem in hearing, it can lead to a lot of loss of self-esteem, anxiety, and depression. So let us understand what is the difference between presbylarynges and presbyphonia. Presbylarynges is a term that is used to describe the microscopic changes that occur in the larynx with aging, whereas presbyphonia is a change in voice. Now, this can happen with aging not only because of the microscopic changes of the larynx, but associated things like diaphragm, pharynx, systemic disorders, neurological conditions, COPD, etc., etc., etc. It is important to understand that not all patients who have presbylarynges may actually have presbyphonia. So almost 50% of patients who do have structural changes in the larynx actually don't complain of any voice change. So in a very interesting article by Dr. Sataloff and team that was published in the Journal of Voice in 2012, they analyzed 175 patients with voice complaints in the age group of 65 to 89. And what they said that in most of the cases, one or the other cause could be identified. However, in 1/4 of the patients, there was no specific diagnosis. And this is the category of patients that was labeled as having presbyphonia. So as we age, now we understand that there is atrophy of the epithelium. If you compare these two pictures, you can see that in a normal adult, you will see these nice microfolds. But as you age, these there is well demarcation of these cells and deep sulci. Also, microvilli, which are present on the epithelium, disappear with age. The structure of the lamina propria is very important. The constituents, their orientations is what gives strength to the lamina propria. The hyaluronic acid, which is present, gives the viscosity and suppleness in the vocal cord. And we are all familiar with this collagen fiber structure, which is arranged in a nice, interlocking wicker basket-like appearance, which gives the lamina propria strength. But as we age, the intermediate and deep layers, which form the vocal ligament, they thicken. The elastic fibers are branched, they become disorganized, rough. The collagen is totally rigid and fibrous, and hyaluronic acid, which gives the suppleness to the voice and the viscosity, that decreases considerably. So very nice picture to show you this. This is the adult superficial lamina propria, and you see these collagen elastic fibers are parallel to each other, whereas as you grow old, they become completely dense and irregular, and this is a high power magnification of the same. Now, in the Rinke space, which is the superficial lamina propria, and in females, what happens is that there are edematous changes. So a lot of this lamina propria is interspersed with fat because the estrogen content decreases and the cords become edematous in females. So men can have thin atrophic cords and a higher pitch as a result of that, whereas older women after menopause and estrogen deprivation have lower pitch and edematous vocal folds. So I think this is a very important point to understand. Also, the muscle fibers decrease in number, as well as the fast twitch and the slow twitch, both of them decrease. And not only that, the nerve and the neuromuscular junction also undergoes changes. So if you see the recurrent laryngeal nerve, the total number of myelinated fibers decrease, the neuromuscular junctions deteriorate, and in addition to that, there is collateral sprouting at the motor end plate region. Now, the glands which are present in the ventricles, the mucus and serous glands, they lubricate our vocal folds. So if this is the picture of a normal serous and mucus gland as is seen in an adult patient, whereas this is what happens as you age. So there is a considerable loss of serous and mucus glands. And because of this, the secretions become thick, viscous, and they also decrease in quantity. So no matter how much water you drink, your throat always feels dry, and there's something stuck and you want to clear your throat. And also I have already said that there is loss of the microvilli. And in addition to that, there is less lubrication. So my mucociliary transport, which is the first defense, is also hampered. Now, ossification, this is of interest because a lot of people where we want to do injection laryngoplasties through the thyroid cartilage. So what happens is that ossification is complete by 65 and occurs earlier in males. It is interesting to see how ossification begins. So it begins in the posterior and inferior part and proceeds anteriorly towards the oblique line. So this is how it progresses from a 22-year-old to a 73-year-old. And this is in a male. So in a male 73-year-old as compared to a female, there are larger areas of ossification, whereas in a female, the anterior part is comparatively less ossified. In the cricoid cartilage, it is the posterior lamina starts ossification before the anterior part. And arytenoid, now this is again very interesting because it is the muscular process where the ossification starts. So this gray shaded area is the elastic cartilage and the white area is the hyaline cartilage. So it's the hyaline cartilage which undergoes ossification starting from the muscular process and progresses anteriorly. And the elastic cartilage does not undergo ossification. So if you take a cut section from the vocal process of the arytenoid, the anterior elastic cartilage and the posterior hyaline cartilage. So really this part where the vocal cord is attached does not undergo ossification, whereas the rest of the arytenoid, everything gets ossified. In the cricoarytenoid joint, there is a significant loss of cartilage matrix. So if you were to see the cricoarytenoid joint surface, you can see these cracks and defects, which are signs of wear and tear of the cricoarytenoid joint. Obviously, because of a loss of synovial fluid, there is hampered movement, and the nice gliding motion of the arytenoid over the cricoid is hampered. In addition to all of this, there is kyphosis, and if kyphosis sets in, there is a decreased intrathoracic volume, decreased chest compliance. Now, maximum inspiratory pressure is the index of diaphragmatic strength, and this exponentially decreases after the age of 65 years. So if you don't have a good, lung capacity and volume in your lungs, then there is a poor pulmonary reserve, which is definitely going to affect subglottic pressure and your degree of phonation, pitch, and loudness. Along with that, there is atrophy of everything else, including temporomandibular joints, salivary glands, etc., etc. And there may also be slow, clumsy movements of lips, palate, tongue. So when does presbyphonia become clinically relevant? When would you actually think of intervening in an elderly who is above 60 years of age? So most of these patients will have hoarseness, voice tremor, decreased intensity. Mostly they will tell you that I'm not able to sing if they are part of a choir, as in Western countries or in India. They are not able to sing, and this really affects them and their social gatherings. Also, the fundamental frequency decreases, maximum phonation time decreases. So all in all, when a female gets addressed as sir and a male develops a glottic fry, is when you will think that, yes, now is the time that you must intervene. So Etter et al. In 2018 have developed an aging voice index, which has 23 questions. And this has been compared with the voice quality of life index, and it is said to be a very valid and reliable assessment. And this is only designed for older adults. So it has pertinent questions for older adults and maybe a good aging voice index for them. So what do you see? You put in a scope, what are you trying to see? You will see vocal fold atrophy because of the thinning of the thyroarytenoid muscle and increased ventricular show. You can also see bored vocal folds resulting in incomplete glottic closure and prominent vocal processes. Now, if one is not aware, these prominent vocal processes may sometimes be mistaken for nodules. And this can be a real disaster if you think these are nodules and take up the patient for any surgical intervention. Vocal fold edema is mostly seen in elderly, like I've already explained. This is could be ring case, and it can be a problem in females. And tremor, laryngeal tremor also starts to occur in elderly, and secondary muscle tension dysphonia. Obviously, because of bowing, there is a glottic insufficiency and all signs of secondary muscle tension come into play. So it is now important when you see bowed vocal folds in an elderly, you must rule out other differential diagnoses which can coexist actually in an elderly patient. So one of them is Parkinson's, where you will have other features like rigidity, bradykinesia, tremors. Then you have unilateral or bilateral paresis. Unilateral may be easy to differentiate, but bilateral paresis of vocal folds can be a bit of a challenge, and we'll come to that in a minute. Sulcus virgatia, sulcus, if present, will have a history of long-standing hoarseness, again, bowed vocal folds, and scarring of vocal folds. If there is any history of any kind of surgery or radiation, you will have scarred vocal folds, bowing, insufficiency, and all of those features. So how do you differentiate bilateral vocal fold paralysis, oblique paresis from presbylarynges? So definitely in bilateral paresis, there will be an asymmetry of bowing. The right and left side may be asymmetric in the degree of bowing. There may be a level difference. And you will also have some associated swallowing difficulties. Also, adduction and abduction will be impaired. But here there will be prominent arytenoids, symmetrical sort of bowing. And if there is no swallowing difficulty for other reasons, swallowing will be okay. And this is one of the areas where an EMG may be a great guide to differentiate between bilateral paralysis from presbylarynges. So now, in addition to that, neurological causes which coexist in these elderly population like stroke, tremor, upper motor neuron disease, lower motor neuron disease, all of these will have other findings like other clinical features of the disease. Amyotrophic lateral sclerosis, where you have difficulty in articulation, and multiple sclerosis, which will have spasms, tremors, and Parkinson's. So a very interesting case I'd like to show you. I want you to focus particularly around the eyes of this patient as you hear her voice.
Ato kabilampuia katasamsi ding he aman hampa hindip dep muntia ang kwala sa zela hola lui panga ang puizel he.
Happy birthday.
Happy birthday to you. Happy birthday to you.
Sorry. And if you see her hands, you can obviously make out this tremor. So all in all, she had this sort of an abductor spasmodic with breathy voice, with some tremor, and she was diagnosed as a case of essential tremor and was under neurology care. So if you do see a cause, treat the cause. If you see anything, treat that first, of course. Most of these elderly patients will do well with bronchodilator therapy, as they may be COPD cases, and that's all you would want to do. Speech therapy is plays a very important role in this group of patients. So what they are trying to do is having wrong compensatory maneuvers, and if you stop those, that's all they will need. In most of them, if you do good counseling and psychological support and tell them that this is not a life-threatening condition, that will do the magic. All they want to know that this is not, a life-threatening problem that they are suffering from. So counseling and speech therapy play a very, very important role. Surgery is rarely indicated, only maybe in 5 to 10% of patients you want to take up surgery for injection medialization or type 1 thyroplasty, basically to close the glottic gap and to take care of the bowing. I don't want to dwell on this too much, but one has to keep in mind that vocal cords are mobile and they do have, some sort of a vibratory movement. So you would not treat them on the same lines as you would treat a paralyzed vocal fold. So rejuvenation is an upcoming thing, and basic fibroblast growth factor and hepatocyte growth factors are in clinical trials. So these, what these growth factors do is that they increase the number of fibroblasts, young fibroblasts, which in turn stimulate the production of hyaluronic acid. And if we can get this into clinical practice, it will really change the scene of bowed and atrophic vocal folds. Clinical trials are ongoing yet. So the take-home message is that impaired vocal fold function can lead to a loss of self-esteem and isolation. It is a real problem. It should be addressed and not shoved away that, oh, you're just growing old. Not all presbylarynges are pathological. Keep an eye on associated pathologies, neurological conditions. Look for lung function, rule out COPD, rule out other structural causes of bowing. Do not mistake prominent arytenoids for nodules. And counseling and voice therapy do the magic. They really solve most of the problems. Thank you so much.
Thank you, Shruti. That was a wonderful, wonderful insight into aging voice. Learned a lot of things from it. So now let's welcome our own Secretary of APSI, Dr. Unnikrishnan Menon. He is an assistant professor at ENT Department, Amrita Institute of Medical Sciences. He is a president of APSI Kerala chapter. He is in charge of voice clinic and a part of a swallowing clinic. Uni sir, please take over.
Thank you, Shima, for the introduction. Hope I'm audible.
Yes.
Yeah, so I'll share screen. Is the screen on?
Yes, sir.
Yeah, thank you. So it's both feels good and probably bad to be on the last of the invited talks, but I guess we are ahead of time or exactly on time, so there's no undue rush for me. So research is an important aspect of any scientific endeavor, especially medicine. We already saw some relevance to it in the previous talk, especially starting with Colonel Datta's about the importance of research and publishing. So this particular talk of mine focuses on that. Yeah, I would like to imagine that I'm standing on this virtual stage and thank APSI and Vanendra Kumar sir for inviting me for this session of MidPhonoCon. So this is the topic, and greetings to all of you from my institution as Amrita, and specifically from my state, Kerala Day, which is celebrating its birthday today. Yeah, so these will be the objectives of my talk. So basically, there is what I've done is try to cover as much of literature review as possible over the last 4 to 5 years, to include the topics of diagnostic and therapeutics, in which new research and new inventions and new articles have come up, and time permitting, details of some of the more practical research work. So this is how the talk is laid out. And a lot of gratitude for this particular online website by Tatla and Fishman, ENT Audiology News. There was a lot of information on this particular site itself. Yeah, so the coming up work now, this is personal work as such, is all what I've collected from literature review, as I mentioned in the first slides. So diagnostics, we all say that videolaryngoscopiscopy is sort of the gold standard for phonatory studies for the vocal fold vibration. But as Kabir Khan said, and we all know that there is no real quantitative parameters, and there are some things that can be missed also. We know that OCT is a new thing, optical coherence tomography, but what one study has done is to combine Doppler, which is used in other fields of medicine, with OCT. So it's Doppler OCT, which becomes a promising new technique for quantitative non-contact imaging of vocal vibration. And this is the publication scheme 4 years back in Scientific Reports. So there they claimed that they were the first visualizers the awake patients' vocal folds, and they could see the what they've called as the vertical cavity surface emitting laser source could be used to identify the entire depth of the twin vocal folds. And they've said that this is a more reliable and economic peer-to-peer assessment, although they've not mentioned anything about the cost, but they say that this is a more economical while encountering lesions of the larynx. So Doppler OCT, one new diagnostic modality. When you talk of glottic malignancies, what do we desire? We desire early detection to catch it in time at the very earliest stage in our OPDs if possible. Or if you have missed it, the patient is on table and about to be operated, lesion to be excised, then we would like to know the differentiation in vivo of between the normal tissue and the malignant tissue. So there are a lot of things that have been described for this. Due to lack of time, I have not included all those things. But one interesting thing is this, that is laser-induced autofluorescence, LAIF, or a lot of fancy acronyms that you'll find in this particular talk. So LAIF or FLIM. So this is based on the concept of fluorophores. So there are some tissues in the vocal fold like collagen, elastin, etc., which act as fluorophores, which means they absorb and can emit light. So when light is shown on these, there is a difference between the way a normal tissue, that is a normal collagen, normal elastin, normal keratin would reflect it, and the way affected, and especially affected, we mean affected malignancy would emit the light. So these modalities can be, LIAF or FLIM can be used to distinguish between normal tissues and squamous cell carcinoma of the vocal folds. So again, a new diagnostic modality. Now, artificial intelligence, we know, is taking over the world, and especially in medicine, they say pathology and radiology all could be completely taken over. So yes, rather than being negative about it, let's see if there are positive sides to it. And this one study, which is from China actually, so published in eBiomedicine. So they've called it the deep convolutional neural network. So what they've done is they've collected literally, and collated literally thousands of images of scans of CA larynx cases, and then given it over to AI. And what they've come out with is that it holds a potential for substantial clinical impact, including improving the diagnosis rate is one thing, which is fantastic. And that second word, I would like you to focus on that second underlying word, telemedicine. Now, of course, it has relevance when it's published. That was last year, 13 months back, actually. But now, in the present pandemic world, we know the huge importance of the fact of telemedicine. People are avoiding going to hospitals. We also, being ENT laryngologists, we are struggling with how close can we get to the patient by doing a scopy. So telemedicine, using artificial intelligence and being able to early diagnose of glottic malignancy from afar. That sounds fantastic, actually. Absolutely what the doctor ordered, if I could say. So let's look forward to this DCNN as a part of artificial intelligence. Now a little bit of therapeutics. And I'm sure most of you all will be familiar with these pictures, what it represents, that is laryngeal pacing. So advancing techniques in the management of the paralyzed vocal fold. So we want to make the vocal fold move somehow. So one is by pushing it, that's just pure mechanical. Now there is reinnervation, various techniques which are no longer new actually, but still it has its own challenges, including the learning curve and the technical issues. The one new thing is pacing. And the big name, of course, that we all know is Andreas Müller, who first wrote about it in neurolaryngology 3 years back. And the one principle behind it to understand is that peripheral nerve lesions are mostly not about complete palsy, but about synkinetic reinnervation, which is as bad as a parasocial palsy. And so what we want to do is stimulate the required muscle as close to it as possible, as close to the muscle as possible. And so using a pacing for this. Excellent write-up on this in the OCNA of this year, the first issue of the OCNA of this year by Müller and his colleague. Those few quick points. It is useful to overcome the cases where surgery cannot be done, the deficit of surgical procedure. EMG is a must, especially to identify the concept of the fact of sign kinesis. It's not really fully proven. I believe FDA is still not approved. European authorities have their partial approval, but still in the works. Minimally invasive is the advantage. And lastly, the current focus is on synchronization with this respiration also. So both the laryngeal functions, phonation and respiration, something really to look forward to. laryngeal pacing to re-innervate the internal laryngeal muscles. Now, what if going one step ahead, innervation does not work, nerve cannot be stimulated? Could we then stimulate the muscle directly? Now, here comes this new thing that's published in Nature Communications, actually not so new if you see, it's 5 years back, the concept of optogenetics. Now, some muscles have this protein that is channel rhodopsin, CHR2. So what happens is, if it's light is shown, it could be made to function without a typical neuromuscular junction, neural function happening. So the optogenetics can be used to stimulate cell type specific stimulation. And this can then be extrapolated to make individual intralaryngeal muscles. So this is again in the works, proof of concept still going on. So optogenetics to make the muscle move directly. Tissue engineering, this is a familiar term, but I would just like you to focus on the journal that publishes Material Science and Engineering, which is not even a medical journal. And both of these talk about the fact of vocal fold tissue engineering. So one has used hybrid scaffolds and others use carbon nanotube composite hydrogels. And we all know what this is most useful for in the larynx and vocal folds with scarring and sulcus vocalis. So sulcus vocalis, there are so many of these things that have been described: hyaluronic acid, atelocollagen, transforming growth factor, etc., etc. And these have been published in an OCNA from last year. The one interesting thing, I think Shruti already spoke about it, hepatocyte growth factor, I thought it important to include because it's done by the big man of the vocal fold, that's Hirano. So Hirano and colleagues, 2018 published their results, phase 1 and 2 clinical trials using this HGF, and they found good improvement in vocal fold respiratory function. And as we speak now, the phase 3 trials are on, so looking forward to HGF used in sulcus vocalis. And vocal fold scarring, something else that's coming up in a big way is the mesenchymal stem cell, so MSC, for stem cell therapy. It's useful for vocal scarring also, and also you'll see later for post-glossectomy cases also, it's come up as a big thing. Animal studies have been successful, and there are 2 ongoing clinical trials. Another vexed problem for us laryngologists, the recurrent respiratory or laryngeal papillomatosis. So there are lots and lots of things to take a whole talk in itself, but just 2 important things I thought I'll put in here in the concept of proven research. One is the vaccines. So after a 5-year study, Australia has come up with the definitive statement, the first demonstration that HPV vaccine may hold promise in the eradication of RRP is what they're saying, eradication of RRP. Then systemic bevacizumab, again, there are conflicting reports, some saying good, some saying not so good, not useful, etc. Anyway, Children's Hospital of Philadelphia and Johns Hopkins are both coming out with protocol for its use, assumed for the pediatric cases only. Some office-based procedures, again, we had a whole fantastic talk on in the morning by Dr. Dinesh Chetri. Just a quick word on what is new in these. So for the area of chronic cough, this is something that have been described, botulinum injection into thyroid node muscle, supralaryngeal nerve injections with triamcinolone and local anesthetic, and carboxymethylcellulose for augmentation. And there's something new, pride of place in this talk of mine, in this very recent publication. Our very own Chandra Kumar sir has described a real challenging, technically challenging case method of doing Kashimas as an office procedure. So please do read up on this. Another big name that is in dysphagia is Belavsky. He has described GOOSE, which is an office procedure that's guided observation of swallowing in the esophagus. So it's one step ahead of the TNE. So all these can be studied in the esophagus by you doing a GOOSE. Now for laryngeal carcinoma, we know there are, or in general head and neck carcinoma, there are a lot of treatment modalities coming up: oncolytic viruses, cancer vaccines, immunomodulators, and T-cell therapy. Many of these have been described in the Journal of Cancer Metastasis Treatment. Quickly touching upon few ongoing trials. The first one is for vocal glottic laryngeal malignancies. Real tongue twisters here. Pembrolizumab in combination with talimomacin laherpavec is an ongoing trial. And then there is the immune modulatory granulocyte, macrophage, colony stimulating factor. These are all familiar names, or increasingly becoming familiar names for most of us. These are ongoing trials for laryngeal malignancies. Then nanotechnology, again, another big thing in biomedical or medical science, nanotechnology, and specifically laryngology. What they're saying is the ability of nanotechnology to do with the problem of biofilms. So especially they're focusing on making instruments or tracheostomies and airway tube care instruments with nanotechnology so that the whole concept of biofilm and infections not happen. So this is published in Clinical Translation Medicine. Micro pattern surfaces is the word. Reduce bacterial colonies and biofilm formation in vitro. So this is a great thing to look forward to. In general, nanotechnology, if you are aware, there's a lot of things to offer to medicine, especially in vocal fold also. Two other things I already spoke about this, mesenchymal stem cell therapy. This is also being done by Belapsky for profound dysplasia, stem cell therapy. It's a novel murine xenograft model is being tried. And the other big thing is 3D bioprinting. So many things are being developed by the technique of 3D bioprinting. So this one particular thing is for use as tracheal transplantation. So 3-dimensional bioprinted tracheal segment implant. Pilot study has been done, published in IJOPL. Of course, it's been done as a rabbit tracheal resection. So extrapolation and possible use will be wonderful for the human laryngotracheal transplant. So 3D is something really to look forward to. So yes, if some of you all were not aware of some of the things that I spoke about and heard now, and when you hear it later, please remember that you heard it in this talk first. Personally, for me, it has been a fantastic voyage of discovery, preparing for this talk, and to know the wonderful things that have been happening in the field of laryngology, which can improve patient management. And so thank you all for a very patient hearing, and looking forward to, as we approach halfway mark of this fantastic MIT PhonoCon, looking forward to further exciting talks today. Thank you.
Thank you, Unis sir. That was really great. Now let's moving forward to symposium on benign vocal fold lesions. May I invite upon our president, Dr. Amitabh Roy Chaudhary, to moderate the session. He has been introduced in the morning. He's a professor and head of the Department of ENT, Vivekananda Institute of Medical Science, Kolkata. And other than being a great laryngologist, his interest also lies in cochlear implants and skull-based surgeries. Dr. Amitabh, sir.
Thank you, Shama. Ladies and gentlemen, after listening to the exciting talk right from the keynote till the research talks and clinical talks and invited talks from National Galaxy of Stars, we have now reached at lunchtime symposium. Now, many of, I would say majority or a large bulk of our clinical conditions that we face in our day-to-day practice is usually due to, usually due to vocal abuse and misuse, and also some various environmental factors. It is impossible to cover all the benign lesions in a symposium of 1 hour like this, but we are trying to focus today primarily on phonotrauma lesions happening sometimes in the background of subcongenital conditions of the multi-layered structured vocal folds, and also pre-malignant conditions, and later on touching on some surgical aspects of some of the conditions, so that you have a brief idea about the benign lesions. And to start our first talk, I would invite Dr. Bhagyashree Bokhare. Dr. Bokhare is an associate professor at Government Medical College, Nagpur. She is also the associate editor of our association journal, International Journal of Phonosurgery and Laryngology. She's got keen interest in laryngology with a special interest in professional voice use, and she is a very nice, excellent speaker as well. She is going to talk on benign lesions of the vocal folds with a special reference to phonotraumatic lesions. May I invite Dr. Bokhare, please, to start your deliberation after screen share. Thank you.
Madam, we can't
Dr.
hear
Sharma,
you.
yeah, there is some issue
we
with
can't
her
hear
voice.
You. Bhagyashree, ma'am, Dr. Bhagyashree.
We
Have
can't
we
hear
lost?
you, ma'am.
Have we lost her?
She's there. We
Yeah, so till she comes on board, basically, as I was telling you, ladies and gentlemen, most of the time when we start our laryngology career, we are faced with this common benign conditions of the vocal folds, like cyst, nodule, polyps, etc., and also the pre-malignant condition. So these are the things that we are going to discuss in this symposium while we get the internet connectivity issue sorted out of Dr. Bhagyashree. If it takes much time to sort this out, we could think of going to the next topic, which is going to be on pre-malignant conditions of the vocal fold. Have we had any
Bhagyashree ma'am, can you
connection?
hear?
Can you hear Bhagyashree? We have lost her apparently. Gauri, would you
Yes, ma'am.
mind? Would you mind?
Yes, sir.
Okay. So if we are not getting her back, can someone, Dr. Sharma, can you send a message to her that we are getting on with Gauri's talk, and then we can have her talk, because they're independent of each other. So I have the pleasure to invite Dr. Gauri Kapre, whom you have seen on screen since morning. She is a consultant laryngologist, otolaryngologist at Niti Clinics, Nagpur, with a very keen interest in laryngology, and also she is founded the first Botox clinic in the central part of the India. In addition to laryngology, I know that she is also involved in cochlear implantation as well. And she is a very active member of our association as well. So I would invite Gauri to take her talk on pre-malignant conditions of the larynx. And Dr.
Yes.
Sharma, can you inform Dr. Bhagyashree that we are going to have her next? Thank you, Gauri.
Thank you so much, sir. And let me take this opportunity to thank the organizers, Dr. Fanindra Kumar sir and Amitabh sir, for allowing me to share my thoughts here. I hope you can see my presentation.
Yes,
Should I
we
begin?
can. Yes,
Yeah.
yes, we can.
Okay.
Please
So
carry on.
in this symposium on benign vocal fold lesions, like Dr. Amitabh sir introduced, I'm talking about the pre-malignant lesions of the larynx. And why are we giving such special attention to these lesions? That's because, of course, there is the risk of transformation to invasive carcinoma. And especially there might be a difficulty in picking up an underlying carcinoma in situ in a relatively benign looking leukoplakic or keratotic lesion, especially in cases of recurrence. And you know that recurrence is a bane of these particular conditions. I like to call them the white, the red, and the ugly. The white being the leukoplakia. These are the white keratin producing lesions of the mucous membrane of the vocal fold, and may not always be indicative of underlying malignancy. The red are the erythroplakia, which are the red lesions of the mucous membrane, and they represent areas of underlying vascularity, and they are more likely to be indicative of a malignant, underlying malignant lesion. The ugly part, of course, is a combination of the both, that is the erythroleukoplakia, and those are the ones you should be most aware about because they are more likely to have underlying malignancy. So for example, you have a lesion like this, which is a keratotic looking lesion with surrounding increased vascularity, or you may have a more diffuse bilateral involvement of the vocal fold with irregular white plaque keratotic looking lesions. Both of these do have the potential of being malignant and therefore deserve excision, biopsy, and definitely deserve attention. Sometimes you might have a white patch on the vocal cord, but it might not be keratosis or a leukoplakia for that matter. For example, a cheesy white patch with surrounding hyperemia is more likely to be a fungal laryngitis, and you should be able to obviously distinguish between the two. Sometimes you might even have a junior colleague coming up to you and saying, oh, I can see some thick white patches on the vocal fold. But of course, this is nothing but just thick mucus, and simply asking the patient to clear his throat will totally change the picture of your laryngoscopy. What is the etiology for these conditions? Well, of course, you know that smoking is one of the most important predisposing factor, the glottis bearing the brunt of inhaled smoke. And we do know that all malignant as well as pre-malignant lesions are more common on the glottis. And why is that? It's thought to be because the rima glottidis, being the narrowest region of the airway, offers maximum resistance to airflow, and probably the airborne carcinogens, just like those in inhaled smoke, are deposited over the vocal folds. Alcohol, for that matter, is more likely to be involved with supraglottic lesions. And of course, we do know the synergistic effect of alcohol and tobacco smoke. Human papillomavirus, especially the type 16 and 18, are known to have potential for malignant transformation in papillomas. The role of reflux in Barrett's esophagus and carcinoma of the esophagus has been proven. However, there is only a very questionable role of LPR as far as pre-malignant lesions of the vocal folds are concerned. And radiotherapy to the surrounding neck structures can be another risk factor. The two popular classifications are the WHO classification and the Jubjana classification, and it might be anything from squamous cell hyperplasia to the more sinister carcinoma in situ. The dysplasia, of course, is subcategorized into the more benign kitten mild dysplasia, or you may have something as the more aggressive variant like the severe dysplasia or even a carcinoma in situ. The carcinoma in situ, of course, as we know, is nothing but hyperplastic or loss of polarity of nuclei of the epithelium. However, these changes have not yet breached the basement membrane and do not attain the characteristic of an example. If you had a leukoplakic lesion like this with white patches on both sides and irregular surface, you would definitely want to biopsy that. But the picture on your right side, which is more extensive, more bilateral involvement of the vocal folds, but this is flat and smooth and therefore less likely to be malignant. Of course, the high-risk epithelium, like I mentioned, the ugly part of it is the erythroleukoplakia with irregular granular surface involving a large surface area. So this picture definitely has the potential for having a malignancy. It would be amiss if I didn't talk about HPV here. And like I said, that 16 and 18 type virotype are associated with malignancies and has been found to have 25% prevalence. But you do also have papers that have detected HPV in equal amounts in normal laryngeal epithelium. So we don't really know how much of a role it does actually play. The trouble comes in when you see a papilloma patient. Do you biopsy him each time? How much tissue do you send for histopathology? And when do you actually suspect a malignant transformation? So I would suggest that when you have an adult onset papilloma, we all know that they don't behave as aggressively or they are not as recurrent as the juvenile onset ones. So probably you should send a biopsy each time, especially when you feel that the lesions are coming more rapidly than you are expecting. And whenever you do send a biopsy, rather than taking a punch from the front of the papilloma, you would like to take tissue which is actually at the vocal fold epithelium, so you're able to ascertain the degree of invasion. Some pointers towards malignancy have been proposed, and if you have seen any of these features in your papilloma patient, definitely that deserves to have a detailed biopsy done. But although rare, it is not unheard of. So this was a 21-year-old female who had a very tiny papilloma on the superior surface of the left vocal fold, and it did turn out to be malignant. So we had to be a little bit aggressive in our excision, and you can see the scar from the surgery in the next picture. This is, I think, 10 days post-op. And the histopathology here, the typical feature is the coilocytes, where you see a raisin-like nucleus in the cell and vacuolization of the cytoplasm. And the mitotic figures on the top will show you that this particular pathology specimen has dysplastic epithelium and potential for malignancy. The game as regards pre-malignant lesions is more a case of spot the difference. Which one is a malignant lesion? Which one is pre-malignant? Which one is benign? So the gold standard, of course, is microlaryngoscopic examination, biopsy, and histopathological examination so that you're 100% sure that you have not mixed a cancer. White light endoscopy in your OPD is good enough to pick up keratosis or leukoplakia or erythroplakia. The NBI, which we usually rely on for picking up vascularity and hence a potential for malignancy, might not necessarily be very useful here because the thick keratosis might often hide the underlying vascularity. But a very interesting paper in our journal by Dr. Nerurkar has shown that in fact the demarcation of the keratosis against the rest of the vocal fold can be sometimes picked up better with the NBI filter. Other modalities, more of theoretical importance, are autofluorescence with application of colored dyes or injection of colored dyes into the lesion, and contact endoscopy, and molecular markers. Molecular markers like cyclin D1, Ki67, and cortacin have been consistently associated with malignant transformation. And of course, the goal of the treatment for these pre-malignant lesions is prevention of malignant transformation or early detection and treatment of a subsequent laryngeal cancer. So the treatment could, of course, is just excision and histopathological examination. One must remember that it might not always be an invasive cancer. So to walk the fine line between overzealous excision versus mucosal preservation to ensure a good voice is very important. If you do the subepithelial infiltration technique, it's a good idea because it will give you some idea about the degree of invasion of your lesion, whether it is stuck to the vocal ligament or whether it is a truly epithelial lesion. Also, it provides you hydrodissection, especially if you're using a laser for excision. Lesions of the anterior commissure especially require special attention because it is important to have good exposure, and you might want to use a particular anterior commissure scope to give you a good exposure. And in case there is a bilateral lesion, you might think of staging your resection to prevent a very aggressive resection in the anterior commissure region and prevent webbing. To go to the lateral extent of the lesion, excision or incision of the false vocal fold is not a bad idea. Here you can see in the image on the left that this image I think is a week or 10 days post-op, and you can see that I had made a cut here in the false vocal fold which has reasonably healed up. You may use a cold steel or a laser, it's man versus machine, but it's important to have really sharp instrument, good traction of the tissue with tangential cutting so that you preserve the subepithelial tissue as much as possible. If you are using a laser, most of us are used to using the CO2 laser. We use the super pulse mode. AccuBlade is useful in giving you shaped incisions to allow a good excision. But in the West especially, and also in India now, office-based surgeries are becoming increasingly popular, and especially the hemoangiolytic lasers can be used to vaporize recurrent lesions. The trouble, of course, being that you will not be able to get any tissue for biopsy in this case. Recurrence is the bane of this lesion of keratosis, and it is very often seen and usually equally extensive. It's as if you've not done any surgery to begin with. So the question is, do you biopsy each time again? So I would say that that depends upon the age of the patient, the predisposing factors, whether he's a smoker or not, etc. And you should always advise the patient to have these lifestyle changes, quit smoking, quit alcohol, have a regular follow-up with the patient, and make sure that you counsel them about the possibility of recurrence, multiple recurrence in the pre-op setting itself. It's a good idea to have your patients grouped as a low-risk case or a high-risk case, depending on their age, the nature of the lesion, the histopathology that you did have, and whether the patient has any predisposing factors towards a malignancy. And then you can tailor how long do you want to follow up this patient and how often do you want to operate and biopsy. So in the end, the more important part is to understand whether you're dealing with something that is sinister or something that is really benign. And it's more important to keep your antenna open and be aware of the possibility of a malignancy. And pre-malignant lesions are more like a bridge between the benign and the malignant, and you just need to be aware. Thank you very much.
Thank you, Dr. Gowri. If you unshare your screen.
Yes.
Thank you very much for a very lucid presentation on benign pre-malignant lesions because it's a very difficult topic. And I would just I have just picked up that last thing that you said. When you're treating with benign lesions, you should have your antennas very strongly up there so that you can differentiate and you can do justice to this. Obviously, we without any further delay, we go to Dr. Bhagyashree Bokare, who's going to. She has already been introduced. You are audible and visible now. If you share your screen.
Thank you very much, sir. And my apologies for the thing.
Perfectly. Sorry, I had to go ahead with the next presentation. But carry on. Thank you.
Okay. So it is my pleasure and privilege to be a part of this CME today. Good afternoon, everybody. I will be speaking to you on benign and phonotraumatic vocal fold lesions. We all know that prolonged phonation causes phonotrauma. Imagine tissue that vibrates anywhere between 20 to 10,000 times every second. How can it not happen? But usually these things recover. However, when persistent phonotrauma occurs, it can lead to organic changes, and that will depend on how much trauma, how fast it happens, what are the recovery times between it, other aggravating factors, other supporting factors, including the genetic and the personality type of the person involved. So we are all familiar with all the structural changes that come with phonotrauma, and all of them share same clinical features regarding the voice problem or dysphonia, which comes with a specific hoarse or a rough or a harsh voice, which may be strained. There is effortful phonation and vocal fatigability, and some of these other complaints associated with the throat. And the laryngostroboscopy usually shows changes that are in sync with the vocal changes in the vocal mass and tension, changes in glottal configuration and closure. Viscoelasticities of the fold will dictate the vibration and presence or absence of any supraglottic hyperactivity. Also, we must never forget that coexisting pathologies are very common in the larynx and especially in these situations. We begin with vocal nodules because these are the commonest benign lesions that we have all seen, small, bilateral, symmetrical, localized lesions, typically located and classically caused by abuse, overuse, or misuse of voice over prolonged periods, hence these classical synonyms. They begin with a small reversible edema in the submucosal plane, followed by some neovascularization, and then replacement of that by fibrous or hyaline deposits. So early nodules on laryngoscopy are typically soft, reddish. They vibrate along with the whole vocal cord and are very responsive to voice therapy, which should be the main line of treatment. However, when they become long-standing, they can turn into firm grayish or white colors that can impede vibration and may need surgical intervention. So a non-surgical intervention first, primarily in the form of voice therapy, is extremely essential and pertinent no matter how bad the voice sounds at present. So this who comes like this, and with some therapy she now if there is no surgical improvement in spite of prolonged voice therapy, some people have tried local steroid injections or a microlaryngeal excision can be done. Laser, cold steel doesn't matter, but pre and post-op voice therapy cannot be underestimated. Vocal fold cysts, we know of two types. We have the mucus retention cyst, which is classically seen on the medial vibratory margin. It is very thin walled, it contains watery fluid. And we have then the epidermoid cyst, which is congenital in origin, but can be phonotraumatic in origin also, classically seen on the superior surface. It contains cheesy material, so thicker and easier to deal with. Now, stroboscopy helps you to define how is the pliability and the surrounding vocal cord there. Clearly, it is good in a small mucosal thin wall cyst and restricted with a large epidermoid cyst such as this one. So after pre-op voice therapy and vocal hygiene counseling, surgical microlaryngoscopic excision can be planned in these patients. Suspension microlaryngoscopy, the details of which will be shared by Dr. Amitabh, I believe, after this lecture. The steps will be gone through, but the most important thing is to have utmost respect for the microvasculature and microstructure of the vocal cords and depositing and redraping the epithelium after the procedure. Vocal polyp is what we come to next. It is an accumulation of fluid that is followed by ingrowth of connective tissue and deposits. It typically affects males who are middle-aged. They come as solitary, unilateral, soft, smooth smellings, may be pedunculated or sessile. And they're often associated with vocal trauma or irritants or most commonly cigarette smoke. So again, we have an episode of extreme vocal exertion followed by breakage of capillaries in the rhinge space, followed by edema formation, which then organizes into a hematoma, that then organizes into a polyp. So on laryngoscopy, we get a typical, sometimes gelatinous appearance, or sometimes a hemorrhagic or telangiectatic appearance, or sometimes a mixed appearance, like this. Treatment is by microlaryngeal excision, either by truncation or preferably by the microflap technique. Now we come to Rinke's edema. This is a accumulation of fluid in the superficial layer of the lamina propria, but it is in significantly large quantities, and it is quite typically asymmetrical. And it is almost always seen in smokers, although sometimes idiopathic, it can be seen with other sources of laryngeal irritation. It goes by several synonyms because of its typical appearance, which is like this. Initially, it comes as a mild edema on both the cords, then it may progress to bilaterally convexly shaped, medially opposed, turgid, swollen vocal folds till they start appearing as large, soft, pale, baggy, fluid-filled swellings on both the vocal cords, partly obstructing. Treatment is again microlaryngeal excision after elimination of etiologic factor and steroid trial, with complete due respect to the principles of phonomicrosurgery, which we will be talking about later. Now, chronic laryngitis is a very confounding condition which happens because of phonotrauma, in which there are a lot of undiagnosed cases and multiple issues all counteracting at the same time. It can be very challenging, but the important thing here is to be able to pick up any lesion that could be possibly malignant and ruling out any other important cause of neoplasia or anything like that. Now, phonotraumatic hyperfunctional muscle tension dysphonia is another very challenging condition. Now, here it is very difficult to say which is the primary cause first, like whether the egg comes first or the hen comes first kind of thing. And so treating this condition becomes particularly challenging, and the role for voice therapy and surgery both becomes equally important. Now, this is also very commonly seen in professional voice users and becomes an important aspect of this our practice as well. Vocal pole hemorrhage can occur with single episodes of shouting or loud laughing or coughing with upper respiratory tract infections and laryngitis. People on blood thinners and women in their premenstrual stages of their menstrual cycle are particularly susceptible. They come in different clinical pictures, and depending on the severity, the treatment is dictated. It is almost always treated like a vocal emergency, ranging from absolute voice rest to steroids if necessary. Then we have this condition called contact ulcer. This is definitely traumatic in origin. Now, the trauma can come by phonation or by intubation. If it is from phonation, it is typically seen in males who are vocally abusive or very aggressive speakers and have abusive throat clearing habits. They come concomitantly with reflux, smoking, and alcohol. And on laryngoscopy, they begin as a posterior laryngitis, turning into saucer-shaped lesions over the vocal processes of the arytenoids, as we can see in this slide. And then later on, they can turn into such firm granulomas. They can come bilaterally as well. And treatment after supportive therapy, if this doesn't resolve, relies on microlaryngeal excision. Sulcus vocalis, or a furrow on the groove, is a typical, condition which is typically congenital, but can be attributed to chronic phonotrauma as well. Ford has described 3 types depending on the depth of the sulcus, that is the epithelium going inside. And here, stroboscopy plays an important role because it is important in deciding how much of the mucosal wave is either present or absent, which will dictate to the extent to which the voice therapy and the surgery will be balanced in terms of treating this condition. Now, treating this condition is a really challenging task. One must understand the risks and limitation of surgery, and there has to be a motivated collaboration for voice therapy from the patient. Endoscopic options begin with simple injection. Injection, if it is done for closure of the phonatory gap, can be done with fat in the paraglottic space, or if it is done for enhancing the superficial lamina propria, it must be done more superficially with collagen. Then we have fat implantation, where actually you make an incision on the superior surface, put some fat there and suture it up. Next option for us would be something like elevation and reposition, which is redefined by Ponte's technique, in which there is slicing across right angles along the vocal folds and then elevation and redraping of the mucosa over the vocal ligament. Then for the less experienced people and patients with more significant phonatory gap, our old medialization thyroplasty is always a good backup. And one of the recent ways to tackle this condition is doing a mini thyrotomy and entering the subepithelial space from outside and elevating the epithelium so that you can deposit some lamina propria enhancing material into this space. Now, vocal cord scar is another difficult condition to treat. The etiology can vary from phonotrauma to surgery. And in stroboscopy, it is important to look for non-vibratory segment and the phonatory gap, which can be seen in these patients, because then that defines our treatment options. If the phonatory gap is significant, you might want to supplement it with a medialization, thyroplasty, or fat injection. However, if the phonatory gap is very little, then an external injection under local anesthesia, like you see Gauri doing here under fiber optic laryngoscopy with hyaline collagenase is extremely effective. I can't underemphasize and stop talking about the need for voice therapy in this patient and the importance of ingraining vocal hygiene, the concept of vocal hygiene in all such patients of ours. Also, the importance of voice therapy, which is direct when you educate the patient, with supportive therapy, as well as indirect voice therapy, which is done with the help of vocal exercises and instruction in respiration, posture, breathing, and resonance, etc. So the take home from today's talk from me would be to come to this problem with a careful and accurate diagnosis, rule out malignancy carefully, and offer the most optimum treatment balancing surgery as well as voice therapy. Thank you very much for your attention, and I must thank Gauri for a couple of her audio-visual inputs which I have used for this presentation. Thank you very much.
Thank you, Dr. Bhagyashree, for doing the most difficult task of today's program, because covering so much things in 10 minutes. I have been asked to talk a little bit about phonosurgery, phonomicrosurgery. So if I'm allowed to share my screen, just 1 second. Is my slide visible now?
Yes, sir.
Okay, thanks. Now on slideshow?
Yes, sir.
Okay, thanks. So basically, I have nothing to declare for this talk. Phonomicrosurgery is surgery to improve the vibratory characteristics of the layered microstructure of the vocal folds, with the primary goal of improvement of voice quality. That's the only difference from other surgeries, that here the primary goal is improvement of voice quality, and we are dealing with most of these conditions that has been discussed. It will not be possible to cover all the things that has been discussed. I'll just give an overview of why and how this surgery is executed. There are manifold challenges for phonomicrosurgery. Firstly, delicate multi-layered structure is a big challenge. Second, we do not have any control over wound healing. Post-op care has to be meticulous, and sometimes the patients already have a lot of maladaptive behavior, which can lead to phonotrauma even after surgery, and that can lead to a recurrence. So that's a very important point to be discussed. So essentially, phonomicrosurgery is not just a single stage surgery. It's a process from the time the patient walks into your clinic till you have cured the disease and also given him change his lifestyle as well. So I'll just highlight that whatever surgery we are going to talk about, phonomicrosurgery, we are dealing with this layer, epithelium and mucous subepithelial layer, which is the rinky space, and that will dictate whether we are able to give rise to this kind of mucosal wave to the patient, and that is the thing that we should keep in our and that's the thing we should keep in our mind. And one more thing important is that, as you can see in this animation, there are 2 or even 3 lips of vibration, but the vibrations always starts at the lower lip, and we must pay attention to the infraglottic part of the medial aspect of the vocal fold, which will ensure that there is good phonation in the postoperative period in the long run. Coming to microlaryngoscopic surgery, this procedure has stood the test of time because of various reasons. Firstly, it's a controlled procedure. It gives adequate magnification. Both hands are free from surgeon. Obviously, we can perform precise surgery. Today, we have the option of using a video laryngoscope, where a video endoscope is inserted in the slot provided in the laryngoscope, and you can get a much panoramic or better view through a video laryngoscope. But you cannot use a laser if you are using a video laryngoscope through a micro manipulator. You have to use a fiber laser for that. So that's about microlaryngoscopy. Now, most of the time, the most important thing in phonomicrosurgery is getting a good exposure to the lesion. If I play this video, you will be able to see that many a times we struggle with the assistant trying to press the anterior part of the larynx to expose the anterior part of the larynx completely. And there is a lot of movement. So we prefer to tie a band like a bandage, strap the neck to make a fixed things like to ideally we should have an exposure like this when we are considering phonomicrosurgery. Secondly, it is optional, but we routinely do that. We take a telescope of any size, 0-degree telescope, to evaluate, go close to the lesion and evaluate a lot of things, and also do a lot of palpation, because many a times your diagnosis can change. You can find out an unnoticed sulcus which you could not pick up in the clinic, so that your management and diagnosis changes. So you need to again evaluate with a magnification and palpate. And this has been highlighted by Dr. Gowri as well, that if you do a subepithelial infiltration, it gives you 2 advantages. One is it bloats up the lesion. It shows how deep the lesion is. Especially it is useful in case of keratotic and white lesions. And it also gives you a vascular plane to start your dissection and continue your dissection, which will be hopefully easier if you infiltrate. Coming to a very conventional MLS, what I think Dr. Bhagyashree has said, that there are very stubborn cases of vocal nodules sometimes which may not be amenable to voice therapy, and you may have to do surgery. So it's very simple but important thing is that you palpate and make sure that there are no deeper infiltration to this condition, and then you can actually amputate these lesions. Simple. And this has been the mainstay of microlaryngoscopic surgery in the earlier decades. Only in the last 2 decades or 3 decades, things are changing. Why? Because people thought that if you have a lesion like this, where there is a larger area of the vocal fold, which is vibratory area, which is affected, and it is probably deeper than just sitting on the epithelium. So if you do surgery like the previous video I showed you, then you may land up in a situation like this where there is a crater. And if this crater is bound to heal with a fibrosis, and that fibrosis will obviously dictate towards a negative vocal outcome. And therefore, this microflap concept has evolved, where you would still put an incision lateral to the lesion. And this is similar to, I always tell my juniors that this is similar to dissecting a sebaceous cyst, which we do. Just elevate and dissect the whole thing and put the flap back. So that is the concept which was described in order to have mucosal cover intact, which helps in faster healing, number 1. And by avoiding the damage to the deeper layer, by doing direct dissection of the controlled dissection of the lesion, we prevent stimulation of fibroblasts by staying lateral to the vocal ligament, thereby hopefully no scar formation. So either laterally, and later on people thought that incision can be shifted more medially, because you are doing too much unnecessary dissection sometimes for a smaller lesion. But then the problem is, so this is a classical condition of a classical microflap. This is a mucus, this is an epidermoid cyst, where you have gone and made an incision just lateral, reasonably lateral to the lesion, and elevate, what I say is 270 degree of the cyst, going all the way down up to the infraglottic part, as you can see here. And once you have elevated this part, you are now left with this cyst with an anterior and posterior band, which has been reported by Dr. Nupur Nerurkar as pearl in a string. So this is the pearl and these are the strings. So if you release the string by a very sharp dissection, your pearl will be delivered. And finally, the last part of this 360 degrees left, which is very deeply adherent to the vocal ligament usually, and which you can dissect under direct vision from there, and therefore you can get a good, good excision, as you can see the entire cyst in toto, and then you can actually see that there is no remnant here. You can see the shiny vocal ligament here, and the entire flap is saved here. But this is good for a cyst, but there will be some condition, and this is a classical flap where you can see the cyst has been removed, and this is a very lateral microflap where a classical flap is shown after the excision. But the problem with this kind of flap is that there are some studies which have shown that because you are doing a lot of dissection, this may result in some unnecessary stiffening of the area which were earlier normal. Moreover, whatever you do, mini, micro, whatever flap you do, you are destroying the connection between the basement membrane zone and superficial lamina propria. So these anchoring fibers are destroyed anyway. So the basic principle now today is that be minimalistic in your microflap, and this is why something called mini microflap has evolved. So this is lateral, this is medial, this is mini. Mini is basically you make an incision bang on the lesion, and then still you follow the principle of dissection, staying away from the vocal ligament. And sometimes there is a mucosal loss because the lesion itself forms the medial boundary of the vocal fold, and you have to sacrifice it. It doesn't matter in the end. I'll show you some of the results. So this is a mini microflap surgery where you can see this polyp with some cystic changes is forming the most of the vocal fold here, and you make a mini microflap incision which is just bang lateral to the lesion. And the moment you elevate the flap properly, you can actually see the shiny vocal ligament here. And the moment you can see the vocal ligament, you are in full control and you are dissecting it, just paying attention to the inferior glottic mucosa, as I have told you. But because this part of the vocal fold, vibratory area, has been formed by this lesion itself, it will be impossible in this case to dissect a subepithelial dissection of this condition. So this is the infraglottic shiny mucosa, as you can see here, which is preserved, which will be good for future phonation. And then you stay and remove as little healthy mucosa as possible. And though there will be a mucosal loss here, this will epithelialize nicely because there has not been any rough dissection, and it's a very clear dissection of the vocal ligament. So with that, this kind of situation, there's no problem. And you can also see the results of this kind of patient 7 days post-op. This is the right vocal fold which was operated. You can barely make out that there has been a large mucosal loss there. Complete glottic closure, and you will see the stroboscopic picture in 6 weeks after some time, where you can see that you cannot make out that some surgery has been done on this right vocal fold here. The complete glottic closure, symmetrical mucosal wave. So the point is, losing the mucosa does not mean, it's the principle of mucosal dissection, layered dissection, which is the essence of microflap. Just adding a little bit note on laser. Laser has some edge over the cold steel because it gives you a controlled depth of incision and dissection at times, especially for vascular lesions and angiomatous polyps, and where you have feeding vessels or accompanying vessels. And because you are doing it through a micromanipulator, there is no handshake. So it is more stable. And at the end of the day, it's surgeon's preference. If you have an access to a good laser, you may use part of your surgery with laser. So this is a quick video of a laser polyp, which is in a fast forward mode. As you can see, a laser, AcuBlade laser is being used, and you can make the incision with laser. And because it's an angiomatous polyp with a cold steel, this would have been a lot of mess here trying to control the bleeding. But with laser, it's much easier because you can control with a little bit of patty also at times, and then you can dissect and cut this. You have still dissected it off the rinky space, and you have removed the thing, but with a little bit of finer movement. And you can see the stroboscopic picture where there is mucosal wave symmetry, and there is hardly any glottic incompetence. So this kind of results are possible both with cold steel and laser. So essentially, stroboscopic evaluation is always helpful for all lesions that you do. Voice evaluation and documentation is necessary to dictate or to evaluate the postoperative outcome, and also for patient counseling. Preoperative voice therapy lays down the foundation for this kind of surgery and a good outcome. Timing of surgery is important. One small note is that if you have a professional singer, a lady who you would not want to operate on this kind of patients when during their menstrual period or something, because there is something, or any upper respiratory tract infection, because then you have an extreme vascularity and your plane will be lost. So time is important, and obviously a planned return to voicing and good judicious voice therapy gives the final touch, like an artistic touch, to the vocal outcome of this patient. And there are some cautions that if you have an infraglottic polypoid looking lesion like this, you should be a little wary about the vocal outcome in this patient. If you have a huge white lesion like this in the stroboscopy, which shows that there is a complete loss of movement of the mucosal wave. And sometimes if you have a mucosal bridge or multiple polyps, then and with a sulcus, you should be a little careful about what you do and what you promise to your patient. That's very important. It's the dream of every laryngologist to have this kind of result, and that's what we should achieve, that at the end of the operating table, you should be able to see that this kind of lesion has gone, and it should be almost be a spotless situation. But as I said, it's a process. So surgery is one thing, but giving a good voice is a complete thing. So coming to the end, you should abide by the principle, but do not be dogmatic about preserving a mucosal flap, because a little bit of flap loss is acceptable, provided you have done justice to the layered micro dissection. Respect your layered structure, as I said. Avoid penetration of the vocal ligament, which will avoid stimulation of a fibroblast and thereby scarring. You should have sharp instrument or laser, choice is yours. Timing of surgery, as I said, and as I said, realistic expectation. For example, in a sulcus vocalis, you cannot give a very good expectation to the patient. Even for white lesions, they will recur, like Dr. Gowri said. And pre-op, pre and post-op voice therapy does the final touch for our surgeons. I would finish with saying that this is a famous saying from a German musician, that human voice is the most beautiful instrument of all, but it is the most difficult to play. The musicians also play with the voice box, and we as a surgeon also play with the voice box. So we have to train ourselves and get that expertise and respect all the physiology, so that we can really play with the voice box and give them good vocal outcome. Thank you very much. I will just stop sharing. With that, I would will take the questions in the end. I would invite Dr. Phanindra Kumar now, who is going to talk about office-based procedures. He has already been introduced earlier in the inaugural program, but he is the founder, president of Association of Phonosurgeons of India, and he is also the organizing chairman of this conference. So over to Dr. Phanindra Kumar for screen sharing. Thank you.
Thank you, Dr. Amitabh. Shall I go for my screen sharing?
Yes, please.
Are you getting my screen?
Yes, we have.
Yeah. Good afternoon, everybody. First of all, let me thank again the organizing committee for allowing me to talk on this special subject, the office-based laser surgeries for benign vocal fold lesions. Now, till now, you have very good picture about these benign vocal fold lesions from and how they are treated. But there are some situations where that is not the micro surgery cannot end up, because there are some problems sometimes every otolaryngologist will face, particularly in patients who have got a a short neck, and a short neck with a circumference of 34 or 23 centimeters, about that, and limited atlanto-occipital extension of the less than 19.5 centimeters, definitely predicts difficult laryngeal exposure. So I get number of times from my colleagues the referrals, because they started the procedure, they could not visualize the larynx, they could not see. So when the life is more precious than the voice, first, then you have to save the life. So in such situations, the alternative for a microlaryngeal surgery or phonomicrosurgery would be the office-based laryngeal surgeries for benign vocal fold lesions. So when you get a patient like this, you can see a short neck man with a very short neck, and you can see the trismus here, a contracted mouth here, and similarly you find here a very anteriorly placed mass in the vocal fold, in the larynx. Here you find very anteriorly placed mass, which one of my colleagues could not reach on the microlaryngoscopy. So he is the patient who is got that mass anteriorly placed, and he has such a short neck. At the same time, he has another problem of the straight spine here. Can you see that? So in such situations, it is very, very difficult. And whatever the methods you apply and what are the scope you want to adopt, or even whatever the type of postures you want to adopt, sometimes it becomes very difficult to have good exposure of the larynx. This is on one hand. On the other side, you got the problems with the patients, aged people with cardiovascular and high-risk cases for general anesthesia also becomes a difficult task for the microlaryngeal procedures. So in such cases, the advanced the office laryngeal procedures have taken up a place where we are facing problems for microlaryngeal procedures. Now, the other aspect of the advantage of microlaryngeal procedures are the cost factor and the time also. Because no need for admission or ICU care, patient can just walk in and get out of the hospital within few hours. Coming to the instrumentation, we use commonly flexible laryngoscopes with a working channel. Usually, we should have flexible laryngoscope, two laryngoscopes, the right and left with the right and left channels for the convenience of our procedure. And preferably, now we are getting chip-on-tip laryngoscopes. We are now in hospital, we are maintaining up 6 FL scopes with the working channel for our procedures. And you can have different types of flexible laryngoscopes where you can use it for a cold surgery, and similarly a fiber laser. Different fiber lasers are being used, and I prefer to use a diode laser because it has already been proved its effect on the benign vocal fold lesions in the literature. At the same time, it is portable and cost effective. So these are the reasons we are using fiber laser as diode laser. Now, most important aspect of this office laryngeal surgery for benign vocal fold lesions is patients should be assessed for anxiety and pain tolerance. That is very, very important. And counseling is the most important factor before selecting the patient to optimize the setting for a procedure. At times, you have to give mild sedative. You can give about 30 minutes orally to start the procedure, and sometimes the procedure may last even up to 30 minutes to 1 hour. So in such cases, you have to give a mild sedative also. Comorbid conditions such as cardiopulmonary diseases, movement disorders, and use of anticoagulation therapy must also be assessed and kept in mind. So these are very important. So you are doing these procedures in the office-based, not under the care of an anesthetist or any operating room facilities. So beforehand, one must be very careful in assessing properly the fitness of the patient for the procedure. Coming to the anesthesia aspect, usually all the procedures and all the procedures we are doing at local anesthesia, office laryngeal procedures, the procedures includes transoral space, usually 4%, most preferably, rarely 10%. Transnasal application of 4% lidocaine, either with epinephrine or with xylometazoline, can be applied for creating a roomy nostril. This is very important because most of the patients who are undergoing office legal procedures, they feel a lot of discomfort in the nose, not in any other aspect of the throat or in the larynx. So it is very important to anesthetize the nose properly. You can also do a transtracheal topical injections with 1% xylocaine or direct instillation of trachea through your working channel. And they are fast and easy. You can inject about 1 to 2 ml of 2% to 4% xylocaine. Next, sometimes you can also inject the transendoscopic injection of 1% or 0.5% lidocaine without epinephrine for local hemostasis, and also useful like something like hydrodissection for the surgery. Sometimes you have to go for a superior block, particularly when you think the mass is larger in size and is going to consume more time. Then you can do a superior block. The procedure is you palpate the thyroid space, place a 25 gauge needle just inferior to the greater corn of the head bone and superior to the thyroid cartilage. And you can inject 2 to 3 ml of local anesthetics, that is 1% xylocaine, into the space that you can block the superior nerve on the one side where you want to operate, the ones unilaterally. And important thing is most of the official procedures, most of them are traditionally done in the sitting posture in the office chair. So this is how a patient enters the patient like this, and ability to spray for also a bag. After that, you can pass it as well. Either you can use a cold instrument possibly with a full protective protection. That is very important. That is the usual position, usual adapt, and most of the lesion procedures can be done in this position. For lesions, particularly for when you want to do a small local nodules, biopsies, polyps, and something like that. But so this is the procedure I'm going to show you how you can exercise a small vocal nodule, very tiny microscope, as you see here. These office procedures, you have very tiny instruments and very difficult to injure the vocal ligament. Very, very difficult. See, this tiny nodule can be removed precisely without much trauma. Such a tiny nodule. And at the same time, you can find immediately after surgery also, you can go for a stroboscopy here. You can find, and you can see this immediately. You can see strobe on the table and see the mucosal pattern is not disturbed much, and there is not much trauma to the vocal fold. So you need not worry about the trauma caused by these instruments in office procedures. They are as good as a phonomicrosurgery technique. And similarly, how you can remove a polyp, I will show you. Simple polyps like this can be removed, can be avulsed like that, just like the other Dr. Amitabh is talking about a microflap. You just pull it out from the surface of the vocal fold without much trauma. So when there is a vascular lesion, you can use a laser. One is to minimize the vasculature, and at the same time, you can also debulk the lesion. So once you, the vasculature is reduced with the laser, then you can use the forceps again to remove the mass. But usually, when you are applying laser, usually you take a biopsy first and then go for the excision. That is usual thing. Otherwise, your biopsy pattern may be disturbed after using the laser. So usually you take a biopsy and then go for excision. When you have a larger lesions, when you have a extensive lesion, then I prefer to do a large masses and complicated cases and nervous individuals. I do them mostly in the office in the lying position with or without laser. And because I found the patients are very comfortable even for a little longer procedure when you do it, and good with a good hemodynamic stability. And I found that the handling of instruments is much more comfortable both for surgeon and the assistant. You can find here how I am doing something like a hydrodissection here. You can find I am injecting the solution into the local fold. You can see that 1% solution I am injecting, and the flap is elevated from the underlying vocal ligament. And you can see just like Amitabh was talking about mean flap technique. I am applying the laser on the superior surface of the vocal fold because the mass is elevated in the vocal ligament by injection of an hydrodissection technique. Because you are not going to damage the vocal ligament. So you can perfectly remove the mass. See, not much defect is left after the excision. So you need not worry about the vocal ligament or scarring, anything like that. So similarly, you'll find a horny lesion here. These are the cases I got referred from my colleagues because either due to the problem of the rigid endoscopy or for general anesthesia. So again, I am injecting here the fluid of 1% silicane with epinephrine, and now the laser goes on the superior surface. I'm not going medially, and the dissection goes along the superior surface of the vocal fold between the vocal ligament and the margin of the mass. And I'm very specific. I'm not going to touch the vocal ligament. I'm very particular. I should be very careful. I should not touch the vocal ligament. So once the mass is separated, it is quite bloodless surgery. You can see here. You can remove the mass in toto without leaving any defect. So this may take about 15 minutes time, and you can see the patient will be talking on the table and he will be very comfortable. You see, you can find after that, just like any microsurgery surgery, you are not leaving a big scar or much trauma. So I have been doing these procedures for the last 15 years, more than a decade. I had done more than 1,600 cases, and I don't find any complications or difficulties, and I can say almost I have given up the microlaryngeal surgeries, and most of the patients are preferring to do only on office-based procedure only. Here you find the, I am showing this video because the preoperative stroboscopy, which is the management polyp here, quite a large polyp on the looking on the anti-surface and the medial surface. So when you do a in the office laryngeal procedure, the laser, so you do not be afraid that the people will be disturbed or vocal damage, scarring, all this is fine here. A very good smooth mucosal patch of the vocal fold, a very good. So this shows, and in my experience, I found there not much difference I find between this, either microsurgery technique or the microsurgery or the office procedures. So our vocal outcomes are also excellent. We don't have any problems. Now we'll have some picture about the advantages and merits and demerits of the office procedures. Now you know that office laryngeal surgeries can safely be applied in high-risk cases when they are not suitable for general anesthesia due to poor general condition, and also in cases where the lesions cannot be exposed by with endoscopy or extreme cervical spondylosis, contracted mouth or various degrees of trismus, etc. So the future phonosurgery is going to mostly a office based. Coming to the demerits, of course, we have some difficulties. Its usage is restricted mostly in professional voice users like singers, but nowadays we have started doing on singers also, and we have taken up as a study with a hydrodissection technique on the office based. And similarly, when the patients are very nervous and they're not cooperative, it is very difficult to manage them. And very large vascular masses with the threat for airway also is very difficult and not a good case for office laser procedure. The other aspect of disadvantage is instrumentation cost. And most of the fiber optic laryngoscopes are almost like disposable instruments. They work only for maximum 3-4 years with a good maintenance, very important, and you need at least minimum two fiber optic laryngoscope. And we had to need a lot of practice to work. So I advise you to start doing the office procedures only after practicing in the outpatient or in a clinic, the diagnostic procedures, the injection techniques, and then you go for the surgical techniques. That is always better. Another disadvantage is sometimes if the masses are very too large and may consume more time, then we will go away multi-stage procedures. These are the demerits sometimes we had to face or we had to come across in the office laser procedures. Thank you, one and all. Love all, serve all. That is the way to God. Thank you very much for this opportunity.
Thank you very much, Dr. Phanindra Kumar, for that brilliant, eye-opening talk on as we are transiting from microlaryngoscopy to office-based procedures more. I'll quickly answer, before we get on to the next session, quickly answer one question from Dr. Prakash Munka. He has asked about which polyps do better with laser surgery over cold steel. Actually, it's not a question of, to answer your question, Dr. Munka, it's not a question of which polyp you select for laser. If you use laser, then you have an advantage. I would prefer, because if you have access to both cold steel and laser, I would prefer to use angiomatous polyp, use laser, CO2 laser for angiomatous polyps, and also polyps which have got a lot of ectasia, lot of feeding vessel, lot of accompanying vessels, because if you laser weld them, stop them, close them, then probably there is chance of more chance of future hemorrhage will be less, and in spite of phonotrauma, the patient may not get the same polyp in the same spot again. So that is the advantage. And also during the course of dissection, as we said, it will be better to handle any bleeding, and you can create an avascular plane, and it is easier to find your planes and bearings right. So that is what I would say, that for angiomatous polyp and polyps with their associated ectasia on the vocal fold will be a good option for laser, in addition to the other things that I have shown. And if there are no other questions, I think I will stop here, because we have already overshoot our time from the session, and we would hand over to our Master of Ceremony, Dr. Shama. Thank you. I personally thank all the speakers of this session, Dr. Phanindra Kumar, Dr. Bhagyashree, Dr. Gauri, for doing excellent justice to the time, because it's a very difficult topic which you have covered in such a short time. Thank you very much, all of you.
Thank you.
Thank you, sir. Thank you so much.
Thank you very much.
Pleasure to be part of this.
Welcome, Kate. Miss Kate Young, I think you will be introduced officially now. Shama?
I think Shama is frozen.
Dr. Shama?
I think Shama's maybe not connected video. So
Gauri, take over.
Yes, sir.
Yeah.
Yes, sir. So we just we need to go on to our next
Dr.
session.
Farida is already here. Yeah.
Yes, ma'am.
Introduce.
So Dr. Farida Wadia is going to be our speaker for the next, our chairperson for the next session. And Dr. Wadia, of course, is from a consultant at Sai Anjali ENT and Head and Neck Clinic in Surat. And she's a visiting surgeon at many hospitals, and she is trained in head and neck cancer surgeries from JJ Hospital. And she has been awarded with the Travel Fellowship in 1989 at Tata Memorial Hospital. And she has been working as a professor of ENT at Surat, Bhavnagar, and Rajkot. And her area of interest, of course, are head and neck surgery, parotid and thyroid surgery, facial nerve surgeries, and she has participated in many national and international conferences and been active in the involvement in the organization of two major conferences in the past, the CGCon at Daman in 2018 and our last year's PhonoCon 2019, which was a grand success. So over to you, madam, to chair the next session, please.
Thank you and good afternoon, everybody. It's really been an academic feast, and I have great pleasure in introducing Dr. Kate. Dr. Kate is a qualified speech and language pathologist from La Trobe University in Melbourne. She now runs the Derby Voice Clinic, and she's the lead speech therapist over there. And she heads the department at the Royal Derby Hospital in UK. Dr. Kate has been the former president and treasurer of the British Voice Association. She's also a member of our Indian Association of Phonosurgeons, and has been to India several times to present her wonderful work on voice disorders at our national conferences. I must say that all her sessions have been very, very well attended, not only by the speech and language pathologists, but all of us ENT surgeons too. She's such a wonderful speaker. Dr. Kate has published and presented on complex voice disorders and head and neck rehabilitation procedures. She has taken keen interest in prevention of voice disorders in professional voice users and has framed voice therapy procedures for laryngeal framework surgery. Her interest in voice has been lifelong, and she has been actively involved in choir performances since a very young age. Over to you, Dr. Kate.
Thank you very much for your lovely introduction. I'll just, it's a pleasure to be back, even though I'm not feeling the temperature. And I shall screen share as I move in. Are you able to hear me adequately?
Yes, we are.
Okay, I'll just, brilliant, just share. There we go. Are you able to see that?
Yes, very clear.
Lovely. I shall just pop into Power. So my first presentation today is to do with the use of nasal endoscopy for voice therapy and biofeedback techniques. Thank you very much to APSI and my colleagues and friends there for the kind invitation to join your conference today. I hope it's not too long before we meet in person again, and it's a privilege always to be part of your meetings and conferences that are always of a very high level. I'm very fortunate to be working in the way that I can use nasal endoscopy more regularly in both therapeutic practice and in voice clinic practice to benefit our voice caseload and to achieve efficient results and quicker results, and also manage more complex patients who are not becoming well. So I'll run through some of the thoughts behind how the service has been set up, as there are differences between different countries in the way that our professions work. And I hope that creates an understanding of the boundaries of our professional work. A few photos, if we're not traveling at the moment, this is the lovely country town just up the road from Derby, and Derby itself, which is quite quiet at the minute. Now, voice therapy, which is my profession, is derived from a knowledge of anatomy and physiology, but also historically, it has come from pedagogy of actors and singers' voices. And a lot of that training, which is extremely detailed, successful, etc., has been achieved blindly with a lot of acoustic and auditory feedback to achieve results and sensory feedback, but all without view. And we now embark upon a really exciting phase in therapeutic delivery. Vocal parameters at the basis of voice therapy can be changed due to vocal plasticity, setting up new muscle patterns in our body, and enables us to achieve optimized efficiency in our phonation to create our best voice quality to deliver the patterns of voicing that suit the environment or the job at hand that we wish to use our voice for, whether it's social, professional, or hobbies. However, as a therapist, we equally need to know what's wrong in order to fix it, and that may be a muscular pattern as much as a lesion or a neurological issue. And very important alongside that, to have the patterns in front of us to inform a suitable approach to therapy, as our movements and delivery of laryngeal gestures will provide different muscle setups in our larynx, body, etc. Necessary also for us is to have insight into how these problems started, and they can be leftover patterns that give us a clue as to the direction of therapy to give us a. I'm just going to start a timer. I'm really sorry I forgot to do that at the beginning because I've not got a timer on my computer. To give us an understanding of where the patterns are coming from and what we need to target. Once you're very experienced in the voice clinic, it is very obvious to voice practitioners that the largest group of dysphonic patients actually don't have a neurological or pathological lesion, and the majority of those patients will be reassured and referred to voice therapy. This is important to understand because once that detailed, beautiful view with strobo-video-laryngoscopy has been achieved, we then move directly into blind working. Once we have that assessment, there may be many factors that are precipitating the dysphonia, and as we work, we change this setup and parameters of the patient's muscle delivery of their voice style. And when we're not successful in therapy, or we're only partially successful in therapy, we need to go back to voice clinic and reassess. And in very busy voice clinics, this puts quite a lot of pressure on clinics for a functional review. And this is where the understanding has come from and the clinical push to use vision in the therapeutic pathways under a parallel clinic system. In addition to that thought, biofeedback is very powerful in teaching or allowing patients to actively be involved in creating muscle change, not just a therapist delivering, demonstrating and teaching, but actually seeing directly the results of the movement change they're creating. So when we look into biofeedback literature, it's a self-regulation technique where patients learn voluntary control over involuntary body processes, or what they seemingly thought were involuntary body processes. For example, some aspects of breathing or heart rate, for example, is another physiological use of biofeedback in some therapeutic deliveries. This intervention, however, requires specialized equipment to convert what's happening physiologically into meaningful visual and auditory cues. So, as well as a well-trained therapist, we also need the well-trained delivery of biofeedback processes in therapy. In our setup, we would be using a screen such as the computer monitor attached to our strobo-video-laryngoscope, and the patients can receive direct feedback that helps them develop control over their muscle patterns while they're delivering an exercise, and they see the direct experience and the direct result of what they're aiming to deliver or reproduce following direction from the therapist. They can see their bodies, they're being guided, they are being given guidance as to what they're interpreting and to move their physiology in a healthy direction. And it can be very reassuring for them to understand, if I do this, this is the amount of change I receive in my body setup. If I do this, this is the actual type of change I receive. A very common reference to biofeedback is surface electromyography, if that's familiar to listeners. And another very simple biofeedback method is if you think about dance training halls, for example, ballet, there's mirrors all the way around the room, because where a dancer might feel they've put their limbs or their body into a particular shape, actually seeing exactly what they've done at that moment and matching the sense of their proprioception of where their body is in space and time with actually visually what's going on is very powerful. So they might feel their leg is 1 foot off the in height off the floor, but actually it's 2 feet. So they've not created a symmetrical shape with the dancer next to them. When we look at speech therapists, using nasal endoscopy. In the 1980s, speech therapists and surgeons embarked upon voice clinics, whereas previously we worked very independently of our ENT colleagues, receiving referrals and never viewed our patients' larynxes. The joint assessment was established in the 1980s, as now is just a gold standard practice, and we wouldn't consider functioning differently at this time. But alongside this, there became, in the 90s, a question whether strobo-videolaryngoscopy would be available or useful to the speech therapy practice. And the initial position statement over use of this as a tool for therapeutic purposes was written by Asher in 1998. We've had in the UK a position paper from early 2000s, but now last year I had the good fortune to be on the group of therapists. There were 7 of us with the Royal College of Speech Therapists to look at the change in our professional functioning and rewrite the position paper for endoscopic evaluation of laryngeal procedures for function, for the types of clinics I'm speaking about, and some of the follow-up clinics, for example, the laser follow-up clinic that I'm involved with in my service. And this contributes to a significant efficiency and in targeted therapy delivery, as well as confirming diagnosis and working very jointly with our ENT colleagues. It's important to understand it's very skill and experience based. It's based around a very strong core of a voice clinic in each centre that may be considering this level of service, and is not, the competency base is measured annually to ensure that skills are maintained, and is very much linked to the culture and the understanding within the department. It's not a standalone service. We function as speech therapists, therefore, in a variety of clinic types. Voice clinics, advanced practitioner clinics, which is a service delivery model that's becoming more thought through, with therapists working at the top of their license to support follow-up for example, head and neck procedures and other laryngeal procedures, alongside the ENT colleagues, where we have not only a surveillance role, but also our therapeutic roles and allied health professional roles to add in survivorship and other monitoring services that fit within our skill set, such as a patient getting older with hearing impairment needing to be picked up and direct input being provided in that session. We are working in awake laryngeal procedures. It's much more common in the injection laryngoplasties in the UK to have a therapist in the theatre to monitor the larynx and the voice change with the consultant who's providing the surgery to tailor the procedure. And then the laryngeal intervention clinic, singing intervention clinic, which is therapy under view, and our voice therapy review clinics for planning targeted therapy. And there's a lot more knowledge and a lot of discussion happening in a very positive way with the boundaries of our profession and our license for working. We would obviously complete voice assessment, and where findings don't fit with the parameters of our clinic and service delivery, we would be moving directly to get our consultant colleague in as a specialist laryngologist who's working in parallel to us to come into the clinic immediately. We also video all of our assessments, and that will enable us to have detailed discussions with the consultant should we find something that doesn't fit with the remit of our clinic. There are direct voice protocols that we work to, and there's a lovely book by Sue Jones, who's my colleague nearing retirement, who works at Wythenshawe Hospital in Manchester, who has really been a core member of our speech therapy profession with this high level of skill, developing the speech therapist role nationally. And she is a wonderful lady and has done wonderful things for our profession. And one thing that we do know as voice professionals of all backgrounds, that we need a detailed assessment that's repeatable with standardized forms of adequate level of depth of understanding that is repeatable, so we can look at change and we can use it also to direct our therapy. So spoken voice protocol in Sue's literature, looking at a lot of detail of movement, sustained sounds, changing volume on sustained sounds in pitch, and looking at where we might start trying therapeutic trials. We do put in quite a lot of sentences which are vowel loaded to look at pharyngeal shape change and looking for overwork or underwork or asymmetry. And I shan't go into too many details because I am speaking to a very knowledgeable base of voice professionals. Now, this is a lovely gentleman who's actually a voice professional himself. He and his wife have done a lot of research and taught, and they are voice coaches and singers. And he very kindly let us video him at one of the conferences my surgical colleague, Professor Judd, and I were teaching at. So there's a few movements here that I thought would be valuable to talk through. I hope the sound is okay. Unfortunately, the sound didn't start. He's actually doing nga, nga at this stage. And then we move through the palate so we can look at symmetry. And you'll hear my colleague Owen's voice. So we're looking, he's actually got quite a lot of AP constriction, but we had a bit of performance pressure for him. Nice normal adduction and abduction.
1, 2, 3, 4.
But he's a natural baritone and he's underpitching quite significantly. Long sounds, you can see a little bit of asymmetry. And already we've got quite a lot of information that we might like to trial some techniques with him. A little bit of bowing as he goes up into a higher sound with stretched vocal folds. And a little bit of over-contraction of his pharynx, but it seems to be his pattern in speech voice. Can rectify that with increased airflow, so that's a therapeutic technique to increase vocal fold contact. So he's doing a nice noisy breath in and breath out. You can see whether there's any lesions, any loss of thickness of the cords, and how much the arytenoids are swiveling and if the pharynx gets involved, so the constrictor muscles. Looking at some nice symmetry. Unfortunately, he twangs with a high amount of tension and asymmetrically, so he has a lot of additional tension in the left side. Right, so I'll just move on to just some of the images. I'm sorry it's slightly shaky. It's to do with the file format being difficult to change. When we look at the singing voice protocol, additionally, we do set ourselves up to be able to assess our patients seated or standing for assessment. We've got a little stool in our room for taller patients. It is helpful to get the singers to, one, think of a song they do want to sing prior to the assessment and to warm their voices up. Otherwise, we're not actually getting an accurate understanding of their muscle patterns, because a warm-up prior to performing is a really normal muscle setup for patients. But we have to remember these patients are vocal athletes, and these vocal athletes need to be treated as an athlete. We may need to repeat movements such as repeating glides as they get into the movement, get used to having a camera in their nose, and just keep trying again. So do that again, improve your technique, think about how you would deliver that, and starting to look at what they're achieving. Is there cricothyroid tilt in there? Is there tongue backing? If they change their airflow, are there pitch breaks? And trying to move through that to have a look at what sort of control they have over a particular movement. Like any athlete would do if they were saying, well, see how I can throw this shot put differently as I do multiple repetitions or tennis serve. We wouldn't just assess one delivery of that particular movement. We would assess several to see what repeated movements are there. And we would want to assess different vocal genres depending on what they use in their performance voice, so that we can have an understanding of the different gestures or laryngeal setup that they use for each of those styles. And then Jeremy, who's very kindly let me use his video, has got a musical theatre and an opera style that I'll show you in a moment. We would certainly want to look at, in singing voice observations, very detailed about volume change, loud and soft, and looking at constriction patterns. the flexibility of laryngeal gestures. Are they just going into the same setting continuously? And then begin diagnostic therapeutic techniques and turn the patient to see the screen. When we have a second screen, the patient can have the screen in front of them, and then we have the screen in front of them. Otherwise, we tend to work sideways and then they can see the screen. It's not ideal, but there is a cost implication for having an additional screen at this time. So here is Jeremy again. He's first singing a musical theatre style, then he goes into an opera style. You hear that he's a baritone, and interestingly, if you watch, he's much better in reducing his tongue-based constriction in the operatic style, just as a taster for what we're looking at.
When somebody loves you, once again you're beautiful. Oh, ich ist und aus Iris.
Yeah, absolutely. Okay, so I'll just go along, and then he did some nice sort of sirens.
Sometimes.
Oh, hang on.
Sometimes.
Would you like to see anything else yourself?
So this is an interesting
yes,
technique.
Noisy H, silent H.
So he's making a noisy, and then he goes into silent H.
How about on an E shape?
And what I did there was he was doing noisy, and then he did E. And that E position really brought, in that last little video clip, really brought his tongue base forward. So that's really powerful for us as therapists. We know E vowel brings the tongue body forward, but it was so dramatically different. It would be a starting point for therapy, and then we try and place different vowels as we look at the vowel map inside our mouth to move between. And then to actually, if we were doing nasendoscopy therapy with him, actually looking at vowel shape variation to show him what he was creating, and then using targets to release tongue base, such as a tongue root release exercise, manual therapy, and there are a number of other techniques I shall come to. So I'll just move along. It doesn't want to. Oh, there we go. So I'll just check that hasn't skipped. Right. So looking at, this is from Sue's book, and I acknowledge that this is a really beautifully set out piece of work. If we're aiming, once we've completed our assessment, to design therapy, if we're seeing features here, we then have a whole tool bag as a voice therapist of what exercises are we going to be using to actually create the appropriate muscle setup or the appropriate functional change to optimize voice production. So if we look here, for example, at reducing glottic or false vocal fold constriction, so that's thyroarytenoid muscle work, we could use silent inspiration. So you saw, and I'll show you exercises in a moment, you saw the silent E, that released a lot of tension in the false vocal folds. Silent giggle, accent method, I'll show you that exercise in a minute, which is just very much letting go of the larynx and running air through with articulator vibration. Breath before tone, which is just putting in a little bit of breathiness rather than starting with pressed vocal fold contact. Or, for example, sob or whine, that's very like a whingy puppy dog at the back door in the rain wanting to come in. It's very and releases that sort of nasality and resonance feature, releases a lot of tension at the laryngeal level. But when I'm teaching medical students, or we have registrars in and they're saying, well, how do you know what to do? This is just a lovely snapshot when you have those short amounts of time to explain professionally what we do, which is not just our whole degree, but a body of experience across our professions. So it's a nice starting point to explain the tools available to us and the flexibility within our profession, and we only add to this more. And this also doesn't particularly include body work, etc. So looking at biofeedback in this context, therapy is, the biofeedback therapy is a process of training as opposed to treatment. So if we have that view, we are asking the patient to have a go, use the exercise and see what the result is. For example, we would do that, say, here's the skill-based to tie your shoelaces, have a go. Did that work? No, it didn't work. What parts didn't work? Let's try that bit, let's try that bit, let's try that bit. Or a bicycle, we've got to get on the bike, we've got to have a balance. You can have some instruction, but you've got to work through that movement in the experience of your body, delivering that movement. So the patient becomes an active learner, they own their own therapy, and they therefore have a really good therapist-patient relationship. It's not being done to them. They're actually creating the change themselves with specialist guidance. And that's a very good inner body learning process, because where therapy might not transfer, some of that is a lack of learning the movement in the body, and sometimes the emotional mindset of owning the change. So I'm just going to show you some exercises. This is my larynx after I had a slight issue with my right vocal folds. Any of those experienced clinicians out there may pick that up. But accent method, which looks such as, and it's very much using your respiratory system. Sorry, you can't see where my hands are, and relaxing up here and just using articulators. Let's see how that looks on nasendoscopy. You can see nice larynx lowering, letting go of the constrictors, suprahyoids, and lovely tongue base forward, and very open AP openness. Okay. Giggle release, which is what we use as silent breathing, and really opening out. So we use lots of facial expression to teach it, and then we release, we can remove that facial expression as we just create that posture internally. This is a wonderful exercise to use with View. So you can see there's a really, really limited thyroepiglotticus muscle constriction. There's lots of symmetry. And going from silent breath into E, trying to remove that thyroepiglotticus tension and AP constriction. There we go. Moving on to semi-occluded vocal tract exercises. These are very much a cross-trainer of exercises that we use. This one's the bubble blowing version of it, where we have a 500 ml bottle of water that's half full of water with a straw that goes into it, very much like this. Should have had that next to me. Blowing like so. Creating a lot of relaxation through here and laryngeal drops. They've had people in CT scanners using this exercise, and you see the constrictors and suprahyoids relax and the larynx releases, very much like yawning. And you can see here the bubble blowing step here, and you get lovely AP relaxation, medial relaxation, and an increase in amplitude of vibration. And this can be used as woo or brrr. These are all semi-occluded vocal tract exercises, and there are more where they came from. There we go. Twang, very useful to use twang very overtly to create a forward resonance, to really project the voice. You can turn twang, which sounds very obvious in this example, but turn it into speech twang, and that can create efficiency and reduce a lot of workload in professional voice users such as lecturers, teachers, swimming teachers in particular, who are in very noisy environments, or people who work outside, such as a tour guide operator, for example. And I know some of these techniques have been used. I listened to a lovely lecture of a gentleman who, when in the stock exchange, they had to shout. They needed to really project over their colleagues. So there is necessary narrowing, but it's symmetric. And a little bit of belt with the hey. Posterior vocal fold closure is a very subtle movement. You want to get the interarytenoids involved. This is glottal stroke, which is just tapping the chords together, like so. And we'll have a little look at that on the video. See that tap, tap, tap. Really useful to see that one, but there's some lovely coordinated people who can deliver that with just listening. And again, you can see the posterior glottic gap is completely closed in both examples. Oops. See, that's closed. And I'll just see if I can move to there. Importantly, we need to consider alongside this that we don't need to see all of our patients using this nasendoscope. There are a cohort of patients who can be receive therapy delivered appropriately as traditional therapy with body work, for example, and they don't need a view for their therapy. So this isn't a 100% of patients needing this as their treatment delivery process. It's useful to check in on patients. There are some patients who really struggle with body learning, or it's a very complex change they're trying to create, or they're high-level professionals who need much more detailed understanding and confidence in what they're achieving. So this is the nature of what we're using. I had a really lovely video that won't play for you this morning of a therapeutic delivery of tongue-based relaxation and AP deconstriction in a female singer who sings with our ballroom dancing competition TV show. And she, unfortunately, the video just format wouldn't work, so I apologize for that, but it's really useful to see subtle changes and then talk through what the patient's experiencing and what they feel they can see and what they would like to try again. So they become very much in the driver's seat of therapy. So we need to guide them, teach them, and give them an opportunity to experiment and learn, because that experimenting and just trying it is very, very useful for the patient to own what they're trying to achieve. Just another thought regarding using biofeedback, which is used very well in the UK, particularly with our professional voice users. We have a physiotherapy service in London run by Ed Blake, physiotherapist, that works with a lot of our professional performers and singers, whether it's musical theatre, opera, rock and pop, and they will use ultrasound to work on breathing and appropriate posture. So I've sent some of my singing colleagues, singing patients to his service, where they will have ultrasound on their abdominal muscles or the muscles that the physiotherapists have identified as not working appropriately or working at a too high a level, or one set are working at too high a level and another set are not engaging appropriately. And there will be ultrasound while they go through a set of exercises, so they can see directly on the ultrasound, are they actually using their abdominal muscles, which ones, how much, what happens if I do this differently. And then the specialist physiotherapist who's being trained and has a high level of experience will then guide them through a set of exercises. Very interestingly, having worked with patients who've received that service, and then when they come back for follow-up therapy with myself, there's a significant change in learning after a short number of sessions, and very much an engagement in what they've learned and their own self-rehearsal at home. And I found that very interesting, and their ability to explain what they're doing with their body, the vocabulary, the depth of understanding of knowledge, and it's very powerful. And the female singer I mentioned, she has returned after different tours with her singing engagements. Obviously not at the moment, but she would come back after, say, a year, and she would still know that exercise in quite a lot of detail. So I think the learning that we provide with biofeedback does have a higher likelihood to really stick, particularly if we're working with people who really challenge their voices and their speech and voice delivery to the upper limits of their capacity, such as these voice athletes in their professional working lives. So I hope this is an interesting topic to you. I've found it very interesting. Our patients find it very interesting. It's only a small number of people who find it's a little bit squeamish to look at their own larynx. We wouldn't choose to put those patients in the clinic. Or the ones who tend to feel a little bit faint when they're having a nasendoscope. And so we would have some fairly common sense clinical decisions around selection of a patient to join in that service, and the patient would be well counselled before arranging the appointment. So along with this, it can be very useful to have direct understanding of the movements and what might be the blocks to progressing in therapy. And we have found with some of our patients where we use our speech therapy follow-up clinic as a joint professional clinic with another speech therapy colleague for a second opinion, that actually working through some of these exercises with patients who are a bit stuck in therapy is that we can sometimes unload how much of this is physical, where there's a strong belief from the patient that this is a physical problem and we haven't enabled them to resolve the physical problem, to start seeing that actually my larynx is working quite well. And then when I do these movements, I actually can change that. But why am I not sustaining it? Or why am I not able to take it from an exercise delivery through to a sentence or a conversational delivery? And it has actually been able to lift the lid on some of the conversations we have around emotion and voice, where previously we may have found it a little bit more complex to get into those discussions. We can also do negative practice with patients, and they can see where they fall into bad habits or they mimic their worst possible voice. They can see the additional load of muscle work or poor habits on their larynx, and will actually diagnose the problem for you, saying, goodness me, no wonder I'm getting vocally exhausted by about lunchtime. Look at what I'm doing with my larynx. And that ownership is wonderful, because they then begin to buy into paying attention to the small pieces of information they're receiving in their feedback as they're using their voice earlier in the day, to think, I need to do something different now. I need to put my strategies in now. I need to check in with my body. How am I producing this sound? Not just run with it and hope I limp over the finish line of the day with whatever voice I have left. And that ownership of the subtle changes I've noticed in our group of patients has generally been improved. Another, which is beyond the scope of this particular presentation, looking at larynx and body work, we can actually do movements and also include our body work with patients, either prior to the assessment or scope, take it out, do the body work, scope again, and review, for example, singer's gym and other stretching type exercises and manual therapy. And this is very useful to demonstrate to patients the need to make the body and voice connection and the strategies that they have been taught and the powerful impact they have on their overall laryngeal gestures and delivery of their voice function. So to conclude, voice therapy is a very comprehensive profession, enabling us to provide this in the most comprehensive, detailed manner to enable our patients to recover and benefit from therapy. We see strobovideolaryngoscopy as a tool to allow us to do our jobs at the highest level of our license and our skill base with our patients. Biofeedback is essential to consider and has all sorts of therapeutic benefits, is that the patient is learning and owning, not just being treated. Our detailed assessments, both in voice clinic and in our speech therapy-led clinics, mean we have direct links from treatment planning from those assessments and ensuring that we have created the best pathway of management for those patients. Our patients' experience of their voice problem is essential, and them linking that experience of the sensations in delivering their voice and the reliability and their own anxieties and emotional content is absolutely essential for them to own the recovery process and own the changes that is theirs to make in their body and to create new patterns and new understandings and new self-management. There is no rush to diagnose. And there are times when we unload the larynx and the patient unloads their emotional experience and unloads what they're doing to then understand at a deeper level. So bringing patients back to clinic can be very, very useful to create appropriate change, not just take the edge off the main issue. And I'm very pleased that our profession is accepted at using these tools so that we can build in really successful biofeedback efficiencies, improved pathways, and improved treatment times for our patients, who then are less likely to return to our clinics. And we have the satisfaction of creating stable change with our therapy. And I hope that delivery has been interesting to you, and I will leave my presentation there. And thank you once again very, very much for allowing me to contribute to your conference and your very kind invitation.
Thank you, Kate. That was a very informative talk, a very wonderful talk. We realized how important biofeedback mechanism is now. And needless to say, no laryngologist will be successful without a good speech therapist by his side, a speech pathologist. Also, I very much liked your comparing a singer to a voice athlete. It was a wonderful talk. Thank you.
Thank you very much.
Thank you, Kate. Thank you, Farida Madam. Kate, that was a really wonderful talk. Now let's move forward and going to the session on functional voice disorders. I shall like to invite Dr. Nupur, none other than Dr. Nupur Nerurkar, to moderate our next session. Madam is the head of Bombay Hospital Voice and Swallowing Center and runs a fellowship training program. She was a president of Association of Phonosurgeons of India. She is the chief editor for the textbook of laryngology and author of Atlas of Phonosurgery. She is the first Indian to be elected fellow of American Bronchoesophagological Association as well as American Laryngological Association. She's an executive member or committee member of the International Association of Phonosurgeons, currently associate editor of LPV, official publication of the British Laryngology Association. She needs no more introduction, a teacher and mentor to many of us. Madam, please do the needful.
Thank you so much, Shama. I'm just going to try to share my screen. So at the outset, I just want to congratulate Dr. Phanendra Kumar, sir, for this very excellent academic endeavor today. It's running beautifully. I've learned a lot. And can you all see my screen, Shama?
Yes, ma'am.
All right, great. Also, thank you to Dr. Amitabh, the president and the association for this opportunity. So the symposium we have now over the next 1 hour is functional voice disorders. And we do know that functional voice disorders are basically categorized into two. One would be the muscle tension dysphonia group, which we're going to have Dr. Anika Joshi talking about. And the other is the psychogenic voice disorders. And Ms. Kate Young is going to be talking about speech therapy in both muscle tension dysphonia as well as psychogenic conversion disorders. So then what am I talking about? I'm just going to come to that. When we talk about muscle tension dysphonia, and I'm not going to be covering MTD, but we do know that MTD could be primary when there is no lesion per se.
Madam, just 1 second. Have you started sharing your screen? PPT?
Yes. Are you not seeing it?
No, we are not seeing the PPT.
I'll stop the share and restart it again. Are you seeing anything?
Yes, now we can. Now we can.
You're seeing this?
Yes, yes.
All right, okay. So what I was saying was functional voice disorders are basically MTD and psychogenic. And in the MTD group, and you're seeing this now, Shama, right?
Yes.
Okay, excellent. So in the MTD group, we have the primary and secondary, with primary basically meaning that there's nothing really organically wrong with the vocal folds or the larynx. But in secondary, there is a lesion, typically on the vocal folds, but somewhere in the larynx, which is probably responsible for the muscle tension dysphonia. And so therefore, I do not think of secondary muscle tension dysphonia as falling typically into the functional voice disorder group. I think of secondary muscle tension dysphonia more as a bridge between the organic and functional, because it's probably an organic lesion which resulted in a functional problem. Now, secondary muscle tension dysphonia, we're all aware, is typically associated with a ventricular hyperadduction pattern and pain and tenderness. The patient will typically be wincing with pain the minute you touch their thyrohyoid or even in the cricothyroid space. So what then happens with ventricular hyperadduction, but no so that is in fact I'm going to be addressing, and do let me know if you can hear the voice. Shama or Gauri?
No.
No, you cannot. Okay. That is my mistake. Do you see the screen anymore? Are you seeing the screen?
We are seeing the screen which says that ventricular hyperduction, no pain, but we're not able to hear the sound.
Even not now?
No.
I have done. Is there anything from the technical angle? I've shared my audio.
Can you play
I'll
it
stop
again?
share. I can, yes.
Now I can.
3, 4,
Okay, good.
5,
Excellent.
6,
Thank you.
7,
Okay.
8, 9,
So this is
10.
the ventricular hyperadduction voice, which we particularly, have a very robotic kind of a voice. Now, this ventricular hyperadduction without pain, so therefore no MTD, could be non-compensatory, which is also called as usurpative, or it could be compensatory, which is also known as vicarious. Let's then talk a little bit about the non-compensatory ventricular hyperadduction. So what does this mean? There is a ventricular hyperadduction, but it is not compensating for any kind of a phonatory gap at the level of the vocal folds or any lesion at the vocal fold. Why then does it happen? It could be habitual or idiopathic. Then the patient would probably need voice therapy. It could be psycho-emotional, in which case the patient would need psychotherapy. It could be something which is neurogenic in etiology, like ADSD, in which case typically the golden treatment, what really we consider is botulinum toxin. And there is maybe some role of use of anesthetics or surgery to take out the false vocal folds in the situations which don't improve, which some people may want to go ahead with. Now, why are we doing all of this? Why are we doing voice therapy or psychotherapy, or why are we giving botulinum toxin? We are giving it so as to improve the patient's voice, because we do not want this ventricular hyperadduction, because it's a disservice to the patient's voice. When it's associated with pain and tenderness, then it becomes an MTD 2A. But what about the compensatory ventricular hyperadduction? Now, this ventricular hyperadduction is taking place to compensate for some phonatory gap, glottic insufficiency, sphincter not working at the glottic level. So over here, you can consider it as a good type of compensatory response, because here the body is trying to create a voice in a situation where otherwise the voice is not getting created. So this ventricular hyperadduction, in fact, is aiding phonation by minimizing the air leak at the glottic sphincter level. When the false vocal folds not only adduct, but also vibrate and simulate the vibratory pattern of the true vocal folds, it is then called ventricular phonation, or plica ventricularis, or ventricular dysphonia. So you can have ventricular hyperadduction without any kind of vibration pattern, or you could have it with a vibratory pattern also. Here, as I mentioned earlier, there is no thyrohyoid or cricothyroid tenderness. There's no pain, yes, gain. Typically we say no pain, no gain, but here, yes, gain. And when you do get the pain, then it becomes an MTD 2B. So in 1960, Arnold and Pinto had proposed a comprehensive classification system of 6 specific forms of ventricular dysphonia. But then this is a mix of both the compensatory and the non-compensatory type, in which an iatrogenic form also was recently added on. I find it easier to just go as compensatory and non-compensatory. What are the functions of the false vocal folds? Well, we know the most primitive function is basically the sphincteric mechanism of the larynx during coughing, swallowing, gagging, vomiting, that we know. It also lubricates the true vocal folds, and there is an antimicrobial defense mechanism. But the false vocal folds can be used intentionally for certain specific situations, like the Asian throat, what is known as the Tuvan singing, Mediterranean traditional polyphony rock singing. I'll just play a small clip. This is the Tuvan singing. very guttural kind of a sound. So that means a human being can intentionally learn how to create a vibration at the level of the false vocal folds. Now that is indeed interesting. So supraglottic hyperfunction, what we're talking about, could be bilateral false vocal fold overactivity, which you can see in muscle tension dysphonia. And typically in ADSD, you do get a bilateral false vocal fold overactivity. Or you can have a unilateral false vocal fold overactivity. Now, when would you see just one false vocal fold hypereduct and not the other? So this could possibly be a sign of underlying glottic insufficiency, and it has already been described in literature quite frequently recently as one of the signs of unilateral vocal fold paresis and also paralysis. So we observed in our voice clinic over the last 5 to 10 years that most of our patients who undergo a transoral laser microlaryngeal chordectomy do start developing, many of them do start developing a unilateral false vocal fold overactivity or hyperadduction. So we performed a study to establish the presence and pattern of ventricular hyperadduction in these groups of our patients. What were the groups? The paralysis and paresis, yes, but also the chordectomy group. So we wanted to know whether it's present, and if it's present, then what is the pattern of this ventricular hyperadduction? And I did this study with my colleague, Dr. Mahima Luthra, who is currently associate professor in Dehradun. And we've published our study in the Journal of Voice this year. So I want to take you through this study in the next few slides, actually. Our patient group, as I mentioned, were unilateral chordectomy, paresis, and paralysis. We had a total of 214 patients, and 154 patients belonged to the paralysis and paresis group. 60 patients belonged to the unilateral chordectomy group. There were certain factors where obviously we had exclusion criteria. Anybody who needed radiation therapy was lost to follow-up, or if the malignancy was present at the anterior commissure, if it was bilateral, those were patients who were not included. So therefore 60, and this was a 4 years retrospective study. Now, what did we consider as ventricular hyperadduction? Because when we went through the papers, it was very variable as to when would you consider something as ventricular hyperadduction. What we considered for the purpose of our study was when more than 50% of the true vocal fold width was being obliterated by the false vocal fold during phonation. How did we define the width of the true vocal fold? Well, we defined it as what you would see in complete abduction of the true vocal folds. So the width seen, which may not, again, mind you, be the actual true vocal fold width, because there would be a little bit of it probably hidden in the ventricle. But this is what we considered as the width of the true vocal fold. And on the basis of that, I want to just show some examples. This is a patient of left vocal fold palsy. And over here, we can see that there is a contralateral ventricular hyperadduction. So we have the right false vocal fold obliterating almost the entirety of the right true vocal fold. So this is contralateral. This is just a video stroboscopy of another patient who's got right immobile vocal fold, and you see the left false vocal fold, which shows hyperadduction. So again, a contralateral in the case of paralysis. Here we come to a patient who actually is pre-medialization and post-medialization, because we wanted to see that if you perform medialization, does that hyperadduction slowly then disappear? So we see the large phonatory gap pre-medialization in this left immobile vocal fold. We see a hyperadduction of the left false vocal fold. And over here, we see post-medialization that the hyperadduction to some extent has decreased. But in this particular patient, it is ipsilateral. Over here, we have a right vocal fold paresis. And when the patient is phonating, we see once again that there is a contralateral ventricular hyperadduction, which means the left false vocal fold is obliterating almost completely the left true vocal fold. In fact, most of the paralysis paresis were contralateral, and I'll come to that in a bit. I'm going to share with you one interesting patient who was referred to me from Kolkata with a history of suddenly voice has gone away after extubation after a surgery, and they suspected a arytenoid dislocation or subluxation. So he came to Mumbai, he flew down the very next day. Now what we see is the right vocal fold is sluggish. Can you also notice that there is contralateral hyperadduction? So big phonatory gap, breathy voice, and contralateral hyperadduction of the false vocal fold. The patient stayed in Mumbai and our therapist gave therapy. Within 1 week, this was the voice. So phonatory gap, much better. Decreased phonatory gap, better mucosal wave, but left-sided ventricular hyperadduction persists, which is the contralateral hyperadduction. So if this patient comes to you at this situation, the left hyperadduction actually then becomes a sign to think of a right paresis. And finally, a month later, the same patient, when there is in fact recovery of motion of the right vocal fold, you see the hyperadduction also disappear. Okay. Now, what about post-cordectomy? Here's a patient following a right type 2 cordectomy for malignancy. And what we see is an ipsilateral ventricular hyperadduction pattern in cordectomy. This is a patient who has a left type 3 cordectomy because there's a large phonatory gap. We will hear the voice of the patient over here. There is a breathiness to the voice, but a strain also. Mm-hmm. And I'm going to play the strobe also.
5, 6, 7, 8, 9, 10.
We can see in the strobe that there's a left type 3 cordectomy, phonatory gap, and an ipsilateral ventricular hyperadduction. You can actually see the false vocal fold trying to reach out and close that anterior phonatory gap, which is a spindle-shaped gap which is present. This is another patient of a right type 3 cordectomy. This is pre-operatively. So no ventricular hyperadduction. This is, of course, the NBI of the patient. So what we are seeing is pre-operatively no hyperadduction. And then post-operatively in the same patient, we have a bilateral ventricular hyperadduction pattern. Not only on the ipsilateral, but it's bilateral. So basically our results were that ventricular hyperadduction was present in 54% of our vocal fold palsy patients, 63% of our paresis group, and 60% of our cordectomy groups over this 4-year period. And within this ventricular hyperadduction, if we studied the type of ventricular hyperadduction, then it was a contralateral hyperadduction in 88% of the paralysis patients, 80% of the paresis patients, and 77% of the unilateral cordectomy patients, in which case it was an ipsilateral hyperadduction. So contralateral was seen in most of our paralysis paresis and ipsilateral in our post-cordectomy group. Within the cordectomy group, when we studied, you can see from this graph that as the type of cordectomy is increasing, that means from type 1 to type 2 to type 3, the percentage of ventricular hyperadduction is also going from 33% to 54% to 81%. The type of the ventricular hyperadduction predominantly remains ipsilateral, but as we move towards the type 3 cordectomy, the contralateral or the bilateral ventricular hyperadduction is also seen frequently. So now, the very interesting question of whether the false vocal folds have any muscle at all, because there's so many opposing concepts. Earlier on, we always felt that there was no muscle really in the false vocal fold, and it's the thyrohyoid contraction which causes ventricular hyperadduction. But then there's a theory which was put forward that the false vocal folds are composed of glottic thyroarytenoid muscle, which is ascending upwards. Then there is a theory which was put forward that there is the presence of a muscle distinct to the false vocal fold laterally in the paraglottic space, and possibly even a combination of both, a little bit of the thyroarytenoid muscle going up to the false vocal fold posteriorly and a muscle distinct to the false vocal fold There are more theories coming up. Hypertrophy just of the false vocal fold, hypertrophy of a specific ventricular muscle, molding of the elastic laryngeal cartilages. This is Tornod's theory, by the extrinsic laryngeal musculature. And then we have Young et al.'s theory, which basically is the adduction of the contralateral false vocal fold is seen in unilateral vocal fold paralysis, which occurs by the contraction of the ventricularis muscle lateral to the false vocal fold, which is supplied by the RLN. So they are saying that therefore, because one side is paralyzed, the opposite side, which is not paralyzed and is supplied by the RLN, is getting supplied by the RLN even in the false vocal fold level and contracting. But Reidenbach has a different theory where they have said that there is not just one distinct muscle in the false vocal fold, but three: anteromedial, anterolateral, posterolateral, the posterolateral being the strongest, and that these are supplied by the superior laryngeal nerve. So contraction of this superior posterolateral muscle causes the majority of the contraction of the false vocal fold. Now, by this theory, then one can explain why there could be contraction of the false vocal fold even when that side is paralyzed. So it can explain bilateral ventricular hyperadduction or ipsilateral ventricular hyperadduction following unilateral vocal fold paralysis. But we do know that in unilateral vocal fold paralysis, you never get a complete denervation. There's always some residual innervation. There's always some synkinesis. So that itself can explain false vocal fold motion. It's also possible that the fibers that innervate the ventricularis muscle are more resistant to injury than the fibers that supply the thyroarytenoid muscles. So there are a lot of concepts and a lot of theories. The conclusion of our study really was that ipsilateral ventricular hyperadduction following unilateral cordectomy was a significant finding in our study. And what we proposed was, since we have following cordectomy a loss of volume, but no loss of neural supply, and we are seeing this ipsilateral ventricular hyperadduction pattern, there is a possibility of unilateral central phonatory control of the false vocal fold. With the contralateral ventricular hyperadduction, which is seen following unilateral paralysis paresis, which was also significant in our study, and it resonates with many previously published works, we can take home that a finding of unilateral ventricular hyperadduction may serve then as a pointer to the indicator of the occasionally challenging diagnosis of the vocal fold paresis. And I have a concluding slide here, which is very similar to actually what Dr. Shruti Dhingra showed us in her wonderful presentation on presbyphonia. This patient had been seen at a center in Mumbai, and he was an elderly 82-year-old man who was diagnosed by the ENT to have vocal fold nodules, which you really need to think, why would an 82-year-old gentleman suddenly develop vocal fold nodules? He was also advised surgery immediately without any voice therapy for nodules at the age of 82. Of course, I'm sure you all realize that these are prominent vocal processes because of presbyphonia. There's a good mucosal wave. In fact, what the patient has is a ventricular hyperadduction pattern of the left side of the false vocal fold and a very sluggish right vocal fold. So this patient has a right vocal fold paresis with a left ventricular hyperadduction, prominent vocal processes because of presbyphonia. So I think it's just so much of our reading, clinical application, which becomes important when we are managing patients, and also a little bit of common sense as to how to manage them appropriately and not cause major goof-ups. With that, I would like to thank you, and I will also stop my screen share. And we are going to be taking the questions in the end. So I would now like to introduce the next speaker of this symposium, and that is my dear friend, Dr. Anaga Joshi. Dr. Anaga Joshi is a professor and head of unit of Lokmanya Tilak Municipal Medical College and Hospital, Sion Hospital. She has a very keen interest in laryngology and also in skull-based surgery. She's also a dear friend with who I have worked for many years in Sion Hospital. And Anaga, please do go ahead and talk about muscle tension dysphonia. Thank you so much.
Thank you so much, Nupur. And it was such a wonderful talk. It's a completely new concept that you spoke about. Thank you so much for
Thank
that.
you.
And I'll just do a screen share. Okay, am I audible?
Yes, Anaga, we can hear you and we can also see your screen.
Okay, great. I don't know whether... Okay, so my topic for today is muscle tension dysphonia. Yes, partly it was spoken of in the previous lecture taken by Nupur, so wonderfully explaining the ventricular, the false chord hyperreduction. This talk is more in detail about the muscle tension dysphonia. So what is muscle tension dysphonia? It's a pathological tension of the laryngeal musculature caused by a diverse number of etiological factors, which leads to a disturbed voice. It occurs predominantly in women. More than 90% of the women patients are women, and account for 10% of the cases which are referred to the voice clinics. And you often see the most severely affected voices in these patients. You would say, what's in a name? There are various disorders named differently. So just to name a few, functional voice disorders are the voice disorders in the absence of organic lesions of the vocal folds. There's another condition which is called as a vocal abuse or misuse syndrome, which is the voice problems in non-professional voice users. This was termed by Kaufman and Blalock. And there is a Bogart-Bacall syndrome where vocal complaints occur in association with increased muscle tension in the professional voice users. So what is the pathophysiology of MTD? As you know, phonation demands a fluent and synchronized movements of the vocal folds. Now, what happens if there's an altered tension of the extralaryngeal muscles, which change the position of the laryngeal structures and the cartilaginous structures within the larynx, which eventually change the tension of the vocal folds and cause an altered and disturbed voice. The MTD can be because of organic hyperfunction, as even in the previous talk mentioned by Dr. Nupur. If there's an underlying glottic insufficiency, this adduction impairment leads to an excessive false vocal fold hyperfunction. If there is a laryngopharyngeal reflux, the acid reflux triggers an airway protective mechanisms, leading to closure of the glottis, coughing, choking, and tightening of the laryngopharyngeal constrictor muscles. Many a times, patient has had a history of laryngitis, but the false vocal fold phonation persists even after the condition is improved, as the patient gets habituated to that kind of phonation. In postmenopausal women, especially because of the changes that occur within the larynx, that is edema, muscular and mucosal dystrophy and atrophy, that can also lead to a compensatory mechanism leading to muscle tension dysphonia. Yes, this as wonderfully presented by Dr. Shruti, where when there is bowing of the vocal folds or the strength of the vocal folds is decreased, that again is compensated by a false vocal fold hyperfunction. If there is an underlying organic pathology, my voice is not coming. Hello?
We can hear your voice, Anaga.
But the voice from the audio, from the video is not coming, I suppose.
No, we heard her.
It's coming.
You heard her?
We heard her.
Okay. I'm not able to hear that.
Anaga, you won't be able to see yourself.
No, but I'm not able to hear the sound. Anyway.
It's coming. Sound is coming, Anaga.
Great. Okay. So this was a case of vocal fold sulcus. So her voice is the hyperfunction of the cause were compensated by a falsetto voice, that is a high-pitched voice, as you can see. I hope you can hear that because I can hear it.
Anaga, when you're talking and she's talking, then we can't hear over it. Just remember that.
Okay. Yeah, but you could hear the voice from the...
Yes, yes.
Video, yeah, okay. So non-organic hyperfunction is when the underlying vocal folds are normal. That occurs in personality factors where anxiety disorders and very anxious personality or any psychological stress factors, vocal abuse or misuse when there is excessive use of the voluntary muscles of phonation with incorrect vocal techniques, disturbed phonatory and respiratory gestures, and inappropriate squeezing of the supraglottis. Now, MTD has been classified as primary dysphonia when there is no concurrent organic vocal fold pathology and is associated with excess atypical or abnormal laryngeal movements. And as I said, occurs primarily, seen more primarily in women and accounts for 10 to 40% of the cases in the voice clinic. Secondary MTD is when the dysphonia and the muscle tension dysphonia is in the presence of an underlying organic condition. And it occurs as a result of the patient's overcompensation to the underlying organic cause. Diagnosing muscle tension dysphonia is of paramount importance, and that is the mainstay of the treatment actually, to diagnose first. So patient's history, the auditory perceptual features, that is patient's voice, has to be carefully looked into, laryngoscopic features, direct clinical examination, manual assessment, and a primary or diagnostic therapy. In muscle tension dysphonia is a condition where you require all modalities of diagnosis. So in patient history, so patient complains of laryngeal tenderness or soreness, pain, tightness with extended use of voice. Patient the pain radiates to 1 or both the ears, and patient typically has unilateral symptoms, which are more common. Patient can give a history of vocal fatigue or increased effort. There is a restricted dynamic range, and patient may be an obligate falsetto due to the overuse of the cricothyroid muscle. There may be excessive use or abuse of vocal voice, or there may be an underlying psychosocial history as well of stress. Can you hear the voice?
We can, Anaga, we can.
Okay. Oh. So typically the patient's voice is consistently bad across a range of speech tasks. There are no intermittent normal islands of normal speech as we see in spasmodic dysphonia. There is no improvement with falsetto or singing. And you find that these voice are most disorders voice with a normal findings in the larynx. And you don't get a particular type of voice disorder. You can have a range of voice qualities in such patients. So how will you differentiate it from spasmodic dysphonia? In spasmodic dysphonia, the voice breaks owing to this. In adductor spasmodic dysphonia, the voice breaks are due to the vocal fold hyperreduction occurring spasmodically during vowels, whereas in abductor spasmodic dysphonia, as in this case, you get prolonged voiceless consonants owing to the spasmodic hyperreduction occurring prior to the vowels. Laughing, crying, or whispering is completely normal or near normal in such cases of spasmodic dysphonia. High-pitched sounds often come out clearly. Whereas in MTD, the voice continues to remain tight in all these situations. There can be a variant of muscle tension dysphonia over and above spasmodic dysphonia cases. So hearing the voice is also important. As I said, there are the voice ranges across multiple qualities. You can have different qualities of voice. Typically, you see a lot of external gestures in the patient. There is abnormal jaw motion, neck extension, bulging of the neck muscles while talking, raised shoulders. If you had seen this patient. Another important thing in muscle tension dysphonia is actually palpating the larynx. In a normal larynx, there's no pain or tenderness over the larynx. You can feel the space between the thyroid and the hyoid cartilage. There is no restriction of mobility of the laryngeal complex. As against in muscle tension dysphonia, there may be pain on pressure over the larynx and the hyoid, over the major horns of the hyoid, or the superior cornea of the thyroid cartilage, or the external laryngeal muscles like the sternocleidomastoid or suprahyoid musculature, or the posterior belly of the digastric. There is diminished or sometimes there is absence of any space between the thyroid and the hyoid. And many a times the hyoid is almost intercepted into the thyroid cartilage. So the larynx is elevated, or there's a high carriage of the hyoid and the thyroid cartilage. And the diagnostic method for knowing that it is an elevated larynx is that many times when you push the larynx down, patient will have an improvement in voice. This is the way, if you push it down, the patient may have improvement in voice. On laryngeal examination, now these are the various types of muscle tension dysphonia. You can categorize them into these various types. So type 1 is laryngeal isometric, or that is specifically without any mucosal disease. So you can see a posterior open cheek. What happens in such cases is that the adductor and the abductor muscles contract simultaneously, which causes this posterior chink. Also, you see a reverse bowing of the vocal folds, where it's convex. The vocal cords have a convex edge, and it's called as a reverse bowing. Type 2 muscle tension dysphonia is when there is supraglottic contraction and the vocal folds are hyperadducted and are contract towards the midline. This is the case of vocal fold paresis, where you can see hyperadduction of the vocal folds. In type 3, there is anterior-posterior compression. So there is decrease in the space between the anterior and the posterior glottis. The arytenoid is pulled towards the epiglottis, and there is a posterior migration or posterior placement of the tongue base. In type 4, it's like an extreme squeeze of the larynx. So there is a supraglottic squeeze, and you hardly can see anything beyond the arytenoid and the epiglottis. You can't see the vocal folds. On video stroboscopy, you may find changes on the vocal folds, which may be the primary pathology which is leading to muscle tension dysphonia, or sometimes the muscle tension dysphonia itself causes certain hypervascularization or abnormal glottic findings. So you can have a range of findings such as uneven mucosal surface or dilatation of the blood vessels or abnormal glottic closure of the vocal folds. So now how will you manage muscle tension dysphonia? So the mainstay of treatment is management of the underlying primary condition, and second is the management of the secondary features of the muscle tension dysphonia. So vocal hygiene and education related to the vocal hygiene is of primary importance. Dr. Kate gave a wonderful lecture on voice therapy, and I think she will, there's a subsequent lecture of voice therapy for functional voice disorders where all these problems will be clarified by her. But this, just in brief, I mentioned that, so you have to identify the voice problem, look for any environmental adjustments that the patient can be asked to make. You have to advise regarding the vocal use, that is avoid screaming, shouting, throat clearing. These are the normal vocal hygiene advice that you would give to any patient. And of course, limiting the use of alcohol, smoking, and regular eating and sleeping patterns. Now, there is something which is called as a direct voice therapy, which is the mainstay of treatment for muscle tension dysphonia. And vocal exercises are given, which aim at targeting and strengthening the specific muscle groups. Like in case of impaired vocal glottal closure, you can give exercises to improve the glottal closure and efficiency. Also, you want to give certain exercises so as to decrease the tension of the muscles of the larynx and the neck and shoulders, as very well demonstrated. It was demonstrated by a video laryngoscopic findings. Dr. Kate excellently demonstrated those exercises. Typically for type 1 muscle tension dysphonia, you give a glottal fry phonation. This relaxes the vocal fold, two vocal folds. Also inhalation phonation. I think all this will be explained in the subsequent lectures. And all the semi-occluded vocal tasks, vocal tract tasks that Kate mentioned. Also advise the patient regarding the posture and improving the breathing during his speech. And general relaxation exercises, stress management, and psychological counseling is also of paramount importance. Manual circumlaryngeal techniques involve focal palpation, laryngeal repositioning maneuvers, and circumlaryngeal massage. Now, what is focal palpation? Actually, you look for any focal points of tenderness, you look for the extent of the laryngeal elevation, and then you do certain laryngeal repositioning maneuvers as a pushback maneuver where you digitally compress the larynx backwards, as well as pull down maneuver where you push the larynx in a downward direction, hold the larynx and push it down. A medial compression and downward traction, which involves pushing back as well as pushing the larynx in a downward direction so as to increase the thyroid space. Circumlaryngeal massage involves circular motion, pressure in a circular motion over different sides of the larynx, that is the hyoid bone, thyroid space, and the laryngeal thyroid cartilage. Give attention to sites of focal tenderness and nodularity, and procedure initially begins superficially, and then the massage, and then increases towards the depth with the increasing tension on the increasing pressure over the muscles. During the procedure, patient is asked to sustain vowels or to hum, and the clinician actually sees for any vocal changes that may be seen while you are doing the circumlaryngeal massage. This is the pre-therapy voice of the gentleman with muscle tension dysphonia.
78. Well, partly I do some contract work. Think that my voice is okay, and they feel that it's as good as the original.
This is after the voice therapy.
I don't know. I think it's okay. It doesn't bother me much now.
Medical treatment involves treatment of the laryngopharyngeal reflux. There is a lifestyle modification and dietary modification. So this was a case of, you can see all the signs of laryngopharyngeal reflux. Just a month of medical therapy with proton pump inhibitor and lifestyle changes has given this spectacular changes within the larynx with just medical therapy. Botox is given into the ventricular folds in cases of refractory, cases refractory to medical line of management and with refractory to voice therapy. So it can be given orally or through a flexible scope through its side channel, and around 5 to 7.5 units of Botox are injected into each vocal fold. Surgical interventions is actually perceived to treat the primary cause for the MTD, as if you have bowing of or presbyophonia or bowing of vocal folds, you can inject fat into the vocal folds. Or you can do, for vocal fold paralysis or paresis, you can do injection laryngoplasty. This injection is being given through the thyroid space. So you can pump up the vocal folds, thereby increasing the or decreasing the phonatory gap, and which will reverse the muscle tension dysphonia. This is pre-injection and this is post-injection. Somehow this is not playing. Okay. So this is, you can see the phonatory is completely closed down. In cases of scarring, you can do a subepithelial steroid injection. Consider this was a case of focal fall scarring with severe muscle tension dysphonia and severe vocal strain. And this is after injecting
My name is Gopal.
steroid into the
My address
subepithelial
Sri
space.
Ganesh Vikas Mandal, Tata Power Line, Social Nagar.
So to conclude, muscle tension dysphonia represents a long-term learned behavior that needs appropriately directed medical therapy or vocal training to correct it. It may represent a compensatory mechanism for an underlying weakness or neurological paralysis or lack of tension such as bowing. Strengthening exercises or reintroduce bulk into the vocal folds may be a solution for the vocal fold paralysis. If the underlying problem is because of stiffness or scarring, surgery might be directed. Surgery or intervention may be directed in softening the vibrating edge of the vocal folds or as subepithelial infiltration of steroid. You also need to probe deeper into the stresses and the psychological factors which may be leading to the muscle tension dysphonia. So it's very imperative that we diagnose muscle tension dysphonia and take the patient from pain to no pain. Thank you.
Nupur ma'am.
I can, yeah.
Nupur ma'am, I think is she not there?
Hello. Thank you.
Yeah, I can hear you.
Thank you so much, Anaga, for that fantastic overview on muscle tension dysphonia. We'll take the questions in the end. So we'll proceed to the last speaker, who is the wonderful Kate Young. Kate has been a friend of the association, I think, right since its inception. And I think we have all learned so much from Kate, and she and Sharath also have been coming to India almost every year since I don't know how many years. So Kate, it's truly wonderful to have you with us here. And Kate also runs her own workshops every year. I know I've visited her in Derby, where she's heading the unit of voice therapy, and she runs wonderful teaching workshops. So Kate is going to now take us through the speech language pathologist perspective in functional voice disorders. Thank you. Kate, you may share your screen.
Thank you very much. I'll just do that and share. Lovely. Thank you very much for inviting me to join your symposium. I just need to, hang on, I've lost my arrow to go to the presentation mode. Sorry, I cannot see my arrow.
In the meanwhile, for the delegates attending, please feel free to use the question and answer option to put in any questions you may have for any one of the speakers of this session. Okay. Thank you.
I might, hang on. Yes, I have an invisible arrow. So
do you want to stop your share screen and then restart and see if you find
yes,
your arrow?
I will try that if it allows me to. Not quite sure what I've clicked on there. Hang on, I'm just going to try and escape what I've done.
Sure.
Can anyone else take control of my screen? I don't know if that's possible. But
I think we have Charlie who can step in and let us know. I don't know if...
Charlie, I don't know if you can hear, but I can't see my arrow on my own screen, and therefore I can't even stop sharing.
Oh, I see.
1 second. I'll just stop your participant sharing.
Thank you. Oh, now I can. What I will do is I will share that. See, it's in PowerPoint, I think, where the problem is. Right, I'm there. Now, I think, are you able to share my screen, Charlie? Or do I need to do it myself?
I have to share it now from there.
Okay, I'm in the PowerPoint presentation. I don't know if you can, I'll just go into Zoom. Hang on. Right, that's there. Okay, I think we're there. I'm with, where are we? Desktop. Put my presentation back up. Now I'm in screen sharing and it's not giving me as an option because that one is finished. Right. I'll just go back to there and I will try again. Apologies, it's just that the arrow vanished. Back
It's not a problem. So in the meanwhile, if there are any questions, I have over here, I have a comment from Dr. Sanjay Gildial, and a question too, yes. Well, the comment is just that thank you, Dr. Nupur and Zaina, because he's been a beneficiary of the expertise, rehabilitated with voice therapy following sudden unilateral vocal fold paralysis about a year back. And you're very welcome, Dr. Gildial. You're a pleasure of a patient to have. You also have put in a question. Kate, are you successful?
If you want to answer the question,
this is a question to you regarding your previous talk. So I'm going to put it to you after this talk. So please go ahead.
Thank you. My computer has decided to listen to me, so I'm on. Thank you so much for inviting me to be part of your symposium. It's a delight and a privilege to speak alongside yourself and Aniga Joshi, and I really enjoyed both your presentations. I have a little bit more reading to do, Nupur, to go through your lovely paper. I'm going to speak to you about speech therapy or speech and language pathology perspective on functional voice disorders and have a look at the muscle tension and the psychogenic voice disorders. This is a World UNESCO Heritage Site in Derby, just to add a little bit of world travel to the presentation. So functional voice disorders, is it in the mind, is it in the muscles, or is it in both? And I think when we look at our functional psychogenic voice disorders, when this nice quote by Kerry Erie is, if the eyes are the mirror of the human soul, then the voice is the barometer of human emotion. And that fits very well with the anatomy, where our voice center is right next to the hippocampus, which filters emotion. When we look at normal voice production, we want to see complete glottic closure under just appropriate levels of muscle tension with relaxed false vocal folds, nice relaxed thoraepiglotticus, maybe a few other muscles in that system now following Nupur's presentation about other muscle groups that are theoretically involved in that setup, laryngeal and pharyngeal symmetry, and full length vocal folds being visible throughout phonation at different pitch and different volume levels. So normal phonation is actually contraction of lateral cricoarytenoid into arytenoids and relaxation of PCA. I'm just going to put my timer on because I don't see that on my computer. Functional voice disorders presentation is muscle tension, nicely outlined by both Nupur and Aniga, is looking at whereas a hyperfunctional voice disorder is characterized by excessive phonatory effort, placing undue stress on the anatomy and physiology, that then becomes a muscle learning process. So with a voice disturbance without structural or neurological pathology, just a performance-related hyperfunction. And this may be that the folds are failing to come together. And I'm talking in context of no neurology and no lesions, which is different to looking at the functional patterns that Nupur was speaking about, or Aniga regarding other conditions that cause hyperfunction. And looking at compensatory patterns that patients are using when they find themselves in an environment where their habitual voice production methods are inefficient for stamina, projection, or the athletic delivery of what is required, such as a teacher, for example. A functional voice disorder, therefore, we look for physical patterns. We might look for a lesion, as previously discussed, for a cause for speaking in that way. Glottic insufficiencies, which would be habitual, systemically caused, such as poor respiratory support, any atrophy, paresis, or other lesions, as well as emotional and psychosomatic. And then there's a primary cause. We can look at emotional issues being a primary cause of functional voice disorders, or the consequence, a secondary emotional change due to the consequences and impact of the voice problem. And what I'm going to try and do in my talk is briefly just contrast where we're looking at, is it more of a functional musculoskeletal issue, a voice use issue and patterns being established, or are there a psychological, psychosomatic background to the voice problem, and how we might approach these differently in this snapshot of a presentation. Our functional voice disorders appear in our clinics, in our therapy clinics, with presentations of altered voice. Hoarseness, not a very descriptive term, but an altered voice that does not suit that person and is different to their normal voice experience. fatigue, strain, sense of effort that is invisible to the listener or visible to the listener, pain, voice loss episodes or continuous inability to project, use dynamic range, very flat and monotonous voice if they've lost some of that intonation pattern, loss of pitch range, and a sensation of increased effort, and often falling into vocal abusive tendencies if they haven't already started with vocal abusive tendencies, and co-occurring muscle tension all the way down to respiratory support such as abdominal tension. Come along, computer. Psychogenic disorders are defined as the loss of voluntary control over normal striated muscle in, sort of move this, sorry, or over the general or special senses. So a psychogenic disorder can originate from a psychoneurosis, and these causes are generally a chronic anxiety state, stress, depression, untreated conditions, intra and interpersonal issues, and trauma. And to diagnose a patient with a psychogenic basis to a voice problem, they need to have at least one of the chronic anxiety, stress, depression, etc. listed to be present in their presenting condition. And the voice also must be fairly consistently affected. Generally, there isn't an organic cause for this type of voice issue. There. A flexible voice clinic, a strobo-video-laryngoscopy evaluation of the voice demonstrates the vocal folds are able to adduct and adduct normally in coughing and laughing, but there are abnormal patterns in speech. And often these patients do not understand that the laryngeal movements produced by exactly the same set of muscles for the non-voice function sounds and the voice and speech sounds. The different types of psychogenic voice disorders known to present are conversion, aphonia, and dysphonia. Pubophonia or mutational falsetto, for example, in a male who has reached puberty, their voice does not break into the male pitch range, or a conversion muteness, where a patient doesn't choose to speak, they don't open their mouth to speak either. And this is the more complex end of the scale. Often personality traits are linked with voice disorders, and a nice simple way to appreciate this is looking at this study where the majority of individuals with vocal nodules were found to have more of an extrovert personality, while the majority of individuals with functional dysphonia tended to be introverts who were pushing their larynx to perform in a situation where they would otherwise normally have preferred to communicate in a quieter manner that suited their character. In the voice clinic, hence having a multi-professional setup and the ability to refer on, we would have the core of the ENT and speech therapists, and in some lucky clinics we'll have psychologists attached to them or other physical therapists, singing teachers, osteopaths. A comprehensive assessment to ensure no other condition has been missed and identify all issues affecting the voice. Therapeutic trials can be very useful to identify the difference between muscle tension dysphonia or muscle tension patterns related to a psychogenic voice change. And cough or are very useful things, or to elicit normal laryngeal closure in a psychogenic patient, so that we can see that there is good contact between the vocal folds. Interestingly, placing a nasendoscope in patients who have these patterns, the simple placement of the nasendoscope can disrupt the preservation of the muscle tension that's reducing the patient's ability to use their voice or causing the aphonia. And some patients have better voice with the nasendoscope in their nose due to disruption and disorganizing their established habits, which is again very useful to note. For example, adding a bit of discomfort means that they change how they use their voice. We don't do that on purpose. Additional voice use targets in the appointment, such as singing and looking at voice professional needs, such as projection or considering environment. And very quickly in that early assessment process, looking at psychology, Is it causing stress? Has it come from a background of stress? Has the patient got insight to make those links? And doing that in a supportive, cautious way in the appointment, which has more than one person in that setting, so that it's not too confronting for the patient. And very also looking at if there are referrals on, not using those other medical conditions as a reason for the patient to latch onto to say, oh, it's okay, once I get my reflux sorted out, my voice will come back. Because once their reflux is sorted out, they say, well, why haven't I got my voice back? So if we've not introduced the concept of how much the psychological impact could be affecting their voice in relation to other small co-occurring factors, means that the patient may not then engage with talking through habitual voice use habits that are their responsibility to work on in therapy, and also psychogenic or somatic changes in their health and the way in which they use their body. So here I have just two very standard videos. Here we have a lovely tight larynx and pharynx of a patient who attended our clinic. Lots of pharyngeal movement, tilting the arytenoids forward, engagement of the false vocal folds.
And then can you just say hee 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 hee. Good. And make a nice sliding sound.
So lots more muscle engagement. And this patient's voice was exhausted very rapidly, speaking from the beginning of the day. This second patient is a conversion aphonic patient, and you'll see when she counts, she's aphonic with the cords splintered apart and a very static pharynx. And it's sort of an exhausted approach to using a voice, and a lovely normal cough, which is always reassuring. So I'll come to a patient. So I'm putting two patient examples. This lovely young lady was 17-year-old, finishing her final year at school, planning to audition for the Royal Academy of Music at London to train as a classically trained soprano in the operatic style. And she presented with a loss of range, loss of flexibility in range and projection, and really unable to engage in her singing lessons to create the maturity of sound that she was trying to move from 17 to 18 to 19 years of age. At 15, you'd be quite cautious with this because she's still growing, but she'd reached a maximum height. She was a very tall girl, and we realized she'd actually grown very quickly quite recently. So we needed to start considering that she had a very new instrument in a very new body makeup of being quite high. She was previously quite a short child who did a high level of training in gymnastics. And she presented, when we viewed her larynx, with unilateral tension or increased tension on the left side. She had a lot of clicky jaw movements, asymmetry, and sort of an S-shaped jaw opening. And body asymmetry. She looked like a sort of an elongated S shape in her movements. So I took that as a planning step to what I could look at offering her alongside her very good singing teacher in Derby. And I found after 3 sessions, I really couldn't move her forward in therapy. And it wasn't to do with what I was delivering from a voice therapy point of view. It was her body had issues that needed to be dealt with. So I'll come to what we did later on, but she was a very functional patient presentation with body and voice being impacted by lots of learnt habits and lots of forward body posturing and head posturing due to her gymnastics training that did not suit the alignment and the relaxation and the musculoskeletal balance required for singing and the relaxation at the upper part of the body. The second patient example is a really interesting fellow who's an absolute delight to work with, but a real challenge. He's a police officer, now moved to a new role in Border Control Force because of his voice change. He moved out of being a frontline police officer and had a rather unfortunate incident at work alongside both his parents passing away. And he was put in a very vulnerable position with no backup, where he could have received quite a lot of physical harm. He did also have a sports injury, reflux, And he fixated on his voice as being the main cause for underpinning most of his lack of success in life, profession, and moving forward with relationships and where he lived. So he put a lot of onus on his voice issue and has quite a somatic presentation. When we then look at how we approach these two groups of patients, these two types of patients, is we do still need excellent education, bring in the psychology conversations very early in a respectful, balanced way, creating a joint plan and stepping back where a patient wants to drag you down a route of, but if you just fix this, I'll be fine, and being very clear and respectful to say, actually, this is how it fits together, and here is an opportunity, and let's have a second opinion if it becomes a very stuck conversation. Health of body, voice, and emotion is essential. And we've also added information outside our clinic room to set the scene for patients who have the opportunity to read that before joining in conversations with us, which is a very useful starting point. We would treat with direct voice therapy, as described in a previous presentation, manual therapy with our musculoskeletal patients, but very cautiously stepping down that route of treatment choice with the psychogenic patients who might convert that we have actually caused something to that patient. So if we don't know them well enough, we do not do hands-on treatment with them. We teach them to treat themselves and their body work, and hopefully engage them appropriately with counselling and body work, which is fine for both groups of patients to do, but there may be pain associated with the experience of the exercises that it links with the condition. So how might we approach the psychogenic voice patient? We do need to have a look at how to make steps towards normal communication and useful conversations about readiness to recover, what that would mean to the patient in a supportive conversation with support of a counsellor if needed. We are trained to a level of counselling, but we're not psychologists. And I would say we're angels for you to tread, be cautious, because our psychology colleagues have trained for 5 years to a master's level with clinical experience and weekly clinical supervision, which we don't get when we deal with some of these highly complex psychogenic voice patients. And when it feels difficult, it's useful to step back and consider what support we need. It's not an element of our expertise, is actually just our skill base is not the same as a trained psychologist. So working well with these colleagues and being ready to be open about that with patients about where we feel we can take patients to with their treatment. When they're ready and they understand how their voice might return, I often say to them, your voice may return, just wake up in the morning and there it is, with or without any throat sensation changes. It might slowly fade back in, like turning the volume up, with some fatigue along the way, or you might have the voice that stops and starts and the gaps slowly get filled in as you get more and more bits of voicing in a sentence. And then I say to the patient, it would be interesting to see how your voice returns, but each of these are useful to know that they are normal. And if you share this with the people around you who are your main listening partners, let them know or bring them to the session, let them know what to expect and to enjoy that recovery, but not an expectation that if you can do it once, you can continue it, because that's still part of recovery. We'd start with vegetative or non-speaking tasks, throat clearing, and then prolonging that into production on vowels, extending that to intoning monosyllabic words, and putting in humming and good airflow. And on a hierarchy, working up to conversational voice and different hierarchy of listening partners. There we go. So looking at the outcome of these two patients, first of all, the 70-year-old singer who has now auditioned for the Royal Academy of Music, she had limited change in voice therapy with me, but actually needed a lot more voice work, body work to support her voice due to the causes and the issues behind her voice issue. So I did thankfully find an excellent sports physio through a specialist spinal physio colleague of mine at the hospital, who has seen her from a sports point of view and an athletic point of view. And she is discharged and pursuing her singing career currently. And I really hope that I see her somewhere performing one day. However, the more complex gentleman, who is the police officer, has had 2 episodes of counselling, really been very resistant to the information that he shares in counselling, which we would call counselling primary care, such as GPs are primary care. Secondary care would be when we come into an ENT department, for example, or a psychiatrist. And then tertiary care would be the next specialist level up. So at primary care level, he's not really engaging and taking the correct information with him to an emotional therapeutic option. We have tried second opinion, and in line with the last two presentations, in particular Anaga's, he has had a trial injection laryngoplasty to try and close the gap between his cords as a temporary measure to see if that will move him out of some of his excessive muscle tension patterns. And interestingly, following his second opinion, his OCD features and somatic features, he's voicing them a lot more clearly. And it's very much more obvious what type of secondary care he really needs. But there's still a lot of blocking of treatment. And he very quickly in sessions falls outside my skill set, as I'm not a psychologist or a psychiatrist. So I'm working with him to re-engage at the right level to help him achieve his goals for his voice and his life. So psychology, make early links in assessment and diagnosis. Consider inflammation, respiratory, neurological issues, which may be causing some of these patterns, and there may be a mix of presentation. And yes, Botox and surgical options for management and moving people out of very, very severe muscle tension patterns is useful, but extreme caution must be taken with these psychological patients with the psychogenic voice issues. So we need to get the correct diagnosis. We need to be open about emotional connections and feel skilled ourselves in able to do that and find our own clinical supervision and support. We do need to use like laryngeal deconstriction exercises, look at phonatory posture and body posture, and unlearn muscle habits where possible, enabling patients to be ready to move back into their normal voice. And as I say to many of our psychogenic patients, it's not just in your mind, it's well rehearsed in your muscles. It's a joint approach to improve your voice and to enable you to recover and reach your voice goals. Thank you once again for listening and your time, and I wish you well for the conclusion of your conference, and I'm delighted to have the chance to speak with you this morning or this afternoon.
Thank you so much, Kate. That was really wonderful. We are running out of time, but the president has permitted us 2 questions. So one for you and one for Anaga. Kate, the question for you really is for the previous session, if I may ask. It's from Dr. Sanjay Gildial from Mumbai. He says, fascinating overview. Dr. Katie would like to know what kind of instruction aid do you provide the patients to practice these biofeedback mechanisms at home? If you could quickly answer
lovely.
that.
Yeah, absolutely. So we have some nice programs now that I have access to us. So I know you can download Prat as an acoustic system. We have Opera Voice or Opera Vox. I also teach patients palpation while they're viewing. So if they're viewing and we actually palpate and say, if you can feel that space and you can see that set up on the screen, then I would use a lot of taught palpation. I use some of the acoustic settings. And back when I first studied at university, a good old-fashioned decent tape recorder, listening to yourself. Once you deliver it, you actually hear yourself and your skull vibrating. If you record yourself and play it back, you can have a few renditions of one exercise, listen to the difference and note down your experience and analyze that way. So we use that as a tool that's taught as an undergraduate speech therapist. But I add in palpation. Thank you.
Thank you. Thank you so much, Kate. Anaga, I hope you're on. Just one question for you, please. This is from Dr. Fukan from Assam. Anaga, in muscle tension dysphonia, as it's functional, would mood elevators act along with PPIs? Is it functional or psychological or both? So I think the question is, would you give mood elevators along with PPIs?
No, I don't give mood elevators because it's not a psychological voice disorder. It's not a psychogenic voice disorder. It's more as a involuntary compensatory mechanisms which come into place due to malalignment of the vocal of the Behaviors involuntarily happen.
All right.
So I don't give
got it.
mood elevators.
Got it. It's a more of a wrong compensation technique. So not needed.
Yes.
Mood elevators not needed. And with that, I think we're going to end this wonderful session. I thank you both, Kate and Anaga, for being part of this. And I give it back to Shama. Thank you so much. Bye-bye.
Thank you very much.
Thank you. Thank you.
Thank you, Nupur ma'am, for moderating this session. And it's always a pleasure to hear you, and we always have something new to learn. I would also like to thank Dr. Anaga and Dr. Kate for addressing functional voice disorders very comprehensively. And now we'll move on to the next session. We will have our international guest faculty, Dr. Kishore Sandhu, present a talk on suprasternal collapse and A-frame deformity, causes and treatment. The chairperson for this session will be Dr. Soumitra Ghosh. Dr. Ghosh is an associate professor at the Department of ENT and Head and Neck Surgery at Vivekanand Institute of Medical Sciences. Sir is also a consultant of the Airway Unit at Amri Hospital, Kolkata, and an editor-in-chief of the International Journal of Phonosurgery and Laryngology. Just for the audience, since there are traditionally no questions for the guest lectures, we can entertain questions for Dr. Sandhu in the next session, which will be an airway panel, and Sir is going to be an expert in the session. I now request Dr. Soumitra Ghosh to please introduce our guest faculty. Thank you. Over to you, Dr. Ghosh.
Yes, hello. Am I audible?
Yes, you are. We can see you, we can hear you. Carry on.
So, good afternoon, everybody. At the outset, I would like to thank APSI and Dr. Phanindra Kumar for organizing this beautiful Mid-Phonocon. Without losing much of time, I would straight away, I can see Dr. Sandhu here. Good afternoon. I think it's just past 12 at your place, or around noon in Switzerland. So, Dr. Kishore Sandhu, as most of you know, I would not spend a lot of time in wasting time so that we hear most of him. So basically, he is the chief of the airway sector of the Department of Otorhinolaryngology in Lausanne University Hospital in Switzerland. Though he is a son of a soil from India, he is also associated, he is a member of the Swiss Society of Otorhinolaryngologists and Head Neck Working Group of the Swiss ENT Society. He is an editorial board referee and reviewer of the International Journal of Pediatric Otorhinolaryngology, European Archives of Otorhinolaryngology and Head Neck Surgery, Laryngoscope, and the Annals of Otorhinolaryngology. He has got innumerable articles to his credit in the international journals, and he has got at least 8 chapters related to the compromised airway in children and adults. As you all know, many of us have attended many of his workshops, cadaver dissection sessions, and many of his lectures all over the world. His current research activity includes developing a bioengineered trachea. And last but not the least, he is a great teacher, and I owe all of my airway work to him. So over to Dr. Kishore Sandhu. We are all eagerly waiting for your talk, sir.
Thank you very much, Soumitra. It's really a pleasure. I'll really start the sharing of my screen so we get down to business very quickly.
Yeah.
Do you see me and you hear me? And do you see the screen?
Yes, I can see you and hear you. It's loud and clear.
And what about the screen? Do you see the screen now?
Yes.
Do you see my slides?
Yes, absolutely.
All right. Okay, here I go. So, in fact, thank you very much for this kind invitation. And in the next 20-25 minutes, I'm trying to sort of, share our experience in treating suprastomal collapses and the A-frame deformity and how exactly we look at it. So for the younger colleagues here in the webinar, let's understand what are these two issues. Both are dynamic tracheal collapses and they follow a tracheostomy. One, which is basically the suprastomal collapse, it prevents a decannulation in a child, and the A-frame deformity typically fails a decannulation in an adult. Both of them can be seen in both the age groups, but mainly the suprastomal collapse affects the child and the A-frame deformity affects the adults. Let's start with the suprastomal collapses. And in fact, the flow chart and the flow of the presentation is going to be in this particular fashion. As we said earlier, children are more affected by these collapses. Let's start by understanding what are the causes. So if you look at the anatomical reasons, those children who receive a tracheostomy early in life will have this kind of a problem. Remember, the cartilages in children are much more softer, they are much more pliable, and any kind of intervention on the trachea will lead to a partial arrest of their normal tracheal growth, and then that is going to lead into some kind of tracheal problems. What are the mechanical reasons? If you have a very large cannula in a small tracheostoma, and these are typically related to technical errors during a tracheostomy. So that would actually take us into a completely different tangential presentation just about pediatric tracheostomy. And I think it's an extremely important subject because, believe me, a lot of problems are related to tracheostomy. If you have a prolonged pressure of the cannula on the superior stomal rim, obviously it is going to press the suprastomal area much more endoluminal, and that's what is going to cause the collapse intraluminally. And then if you have peristomal infections, typically related to inadequate nursing and unhealthy stoma, as can be seen in some of our patients in the tropics and in the tropical areas. So how do you diagnose any of these two dynamic causes? Clinically, of course, it is going to prevent a decannulation, and basically the diagnosis is by an endoscopy. Remember, any airway pathology, the gold standard of the diagnosis is always an endoscopy. And the endoscopy is basically a dynamic, flexible, transnasal laryngotracheobronchoscopy in a spontaneously breathing child. So here you have a child who is tracheostomized. So typically we will remove the tracheostomy. We will block the tracheostoma site with a small gauze piece. You have the flexible endoscope going through a bronchoscopy mask. And this is the way, in fact, we will have the child evaluated with the stoma exposed, the tracheostomy cannula out, and then evaluating spontaneously breathing child on the inside. We published recently our algorithm in managing suprastomal collapses. And this is the way I look at the entire situation. So you have basically two issues, a stoma which is collapsible or a stoma which is static and non-collapsible. So if you're looking at a stoma which is non-collapsible, the next step that we want to know is what is the stoma size and what kind of tracheal length we're looking at. And depending on these three major points, you would then start looking at the various options that you have. So typically, if you have a stoma size which is adequate, then you could actually go ahead and do a transstomal excision, meaning you are excising that part of the superior rim of the stoma, but you are going through the stoma itself. Why? Because the size of the stoma is adequate. If you have a smaller stomal size, obviously your entry through the stoma is going to be affected. And that's where you would go transorally to excise it. You could use lasers, you could use cold instruments, you could use whatever tools you want. The point is what you are going to achieve at the end of it and through what approach. If you have the stoma, which is extremely large, more than 15 millimeters, that would require an anterior tracheal reconstruction by using a cartilage graft. And then if you look at the other problem of the tracheal length itself, you could either have an adequate length that would actually require optimal treatment would be a tracheal resection and anastomosis done in a single stage, meaning that the stoma plus the suprastomal collapse is excised monoblock during the same surgery. But if the patient has got a tracheal length which is inadequate, then that will require a little different kind of a surgery, as we will see a little bit later. So in a summary, if you have to look at suprastomal collapses, what are the points you want to consider? You want to look at the exact site of the tracheomalacic collapse. This is typically related to a superior rim, but you also want to look at the lateral walls. You want to see whether it is a peristomal collapse. Are these collapses associated with other obstructive lesions in the airway, typically granulomatous, fibromatous? Remember, we are looking at the stoma. So you have the cannula, which would be looking at creating granulomas and fibromas around peristomially or even at the tip of the cannula. What is the patient had in the past? Did he have a tracheal surgery? And of course, the size of the stoma, as we saw earlier. So if you have a suprastomal collapse with a minimal lateral wall collapse, you could do an excision or a primary closure with the advancement of the superior stomal rim. And this is very commonly used in the US, where they actually fix the cricoid, the trachea, and these two structures are stuck onto the sternum, and they do a cricotracheal sternal suspension. Now, if you have slightly advanced problems, meaning a severe peristomal collapse along with other synchronous peristomal lesions, ideal treatment would be a single-stage tracheal resection and anastomosis. And in certain cases, you would do a stomal rigidification if a resection is not possible. And of course, as we saw earlier, if you have a larger stoma and a stomal collapse, they will require an augmentation by using cartilages. So a significant obstruction of the endoluminal trachea with a suprastomal collapse, but with an adequate access through the stoma, would require very simply endotracheal intubation. This is going to push the suprastomal collapse on the outside, which can also be picked up by using a skin hook, and it can just be excised immediate post-op, and this is a couple of months later. So this is the way if you have a granuloma and a suprastomal collapse, but with an adequate sized stoma, it can easily be excised by amputating the granuloma, a partial amputation of the collapse itself, and then fixing the superior rim with the inferior rim. And this we have seen earlier in many presentations in the past. The ideal way you want to close a stoma would be by putting a couple of craniocoral sutures. Why? Because on the inside, you want to maintain a steady Roman vault at the stomal site. This is a severe peristomal collapse with a peristomal granuloma and obstructions around the stoma. Now, this is not going to be accessible through the stoma, and plus you have a dynamic larger collapse, and this will require, in fact, a tracheal resection and anastomosis, where you excise that part of the collapsing trachea along with the stoma. And this is the same patient on the seventh day following the tracheal resection and anastomosis. If the patient has already had a resection and anastomosis in the past, the only way in which you can take care of that is by external rigidification. So these are polydioxanone PDS plates, which are biodegradable, which are actually placed like a ladder, meaning on either side and like above and below the stoma, which in turn is going to fix the entire stoma and is going to rigidify that process. This is a 5-year-old kid coming from Hungary, And in fact, this is preoperative, this is postoperative, and this is a couple of months later, where you see the collapse is completely rigidified. You have an airway which is opened up, optimal, age appropriate, and non-collapsible. And if you have a larger sort of length, the only way in which you can actually manage this kind of a problem is by using costal cartilage grafts, because they are much more stable and they are able to close a larger defect as well. I think it's extremely important for us to realize that rather than going into treating a suprastomal collapse, we should begin our tracheostomy itself by trying to prevent it. So primary prematuration of the tracheostoma is extremely critical. It's not the shape of the tracheal incision. You could use a cruciate, you can use the Biox flap. Vertical tracheal incisions, we have our own problems with that, as we see a little bit later. But what is important is it's not the incision which is important, but it's the size which is very, very critical. And remember, this size needs to be similar to the outer diameter of the tracheostomic cannula, and this is what is going to prevent the pressure on the stomal rims. Adequate nursing, and as far as possible, we need to realize to close the stoma surgically and not eventually want the stoma to be closing medically. However, having said that, these sort of possibilities need prospective studies. These are observational studies that we are trying to sort of present in front of you, but they need to be validated by more larger and robust data. Operative technique itself, we use the Biox flap. So we use a single ring Biox flap, and this width should be the size of the stoma should be similar to the outer diameter of the tracheostomic cannula. So if we look at the suprastomal collapse, remember it's one of the important causes which prevents or fails a decannulation, usually in a child. Dynamic flexible bronchoscopy is essential for the diagnosis. Surgical correction would depend on local factors and prior interventions. And even more important, you need to prevent this particular problem by itself. That would actually take us into an A-frame deformity. Remember, the adults suffer more than a child. In a child, you have the cartilages which are much more flexible. They can easily be sort of, bypassed, and they do not present so much of a problem in a child as they would in an adult. We will look at the pathophysiology, the diagnosis, and then following with that, the management. So in a child, as we saw earlier, the A-frame deformity is much more distensible, and they would remain asymptomatic for a longer period of time. However, in a child, what happens is the site of the stoma itself undergoes ossification, fixation of the anterior hinge, and that actually allows a dynamic collapse of both sides of that hinge joint. So the lateral walls collapse, and this in fact would create a double glottis that actually leads to a fixed stenosis, which actually takes a couple of weeks, 2 months, 2 years. And that's the reason why you will have this kind of a dynamic collapse in an adult as compared to a child. The predisposing factors typically are percutaneous dilatation, tracheostomy. So you could imagine that cartilage fractures which happen because of pushing of and dilation process that actually goes in creating the tracheostoma. Vertical tracheal incisions lead to these kind of problems. Medical decannulation should be avoided. Unhealthy tracheostoma, and if you have an adult with comorbidities related to cardiopulmonary problems and diabetes mellitus, are going to be causes that can create more problems. Again, remember, you need to have more robust data to actually support these problems. So a localized tracheomalacic problem of an A-frame deformity will require proper diagnosis. So similar to what we saw earlier in a suprastomal collapse, typically this is a patient who does not have a tracheostomy, and the dynamic flexible bronchoscopy should be done under a local anesthesia or a simple DICE kind of a protocol. And the treatment would be a resection anastomosis, or depending upon what kind of presentation the patient had or a surgery he had in the past. So a simple looking tracheal resection anastomosis is going to give a fantastic result in a situation like this. Things change and every patient needs to be seen in a different situation altogether. This is a 76-year-old female who was actually radiated for a mucosal melanoma of the piriform sinus. She was obese. She required CPAP 24/7. So remember, the neck was irradiated. You cannot do a tracheal resection anastomosis and get away with it in a radiated neck. So what actually I did for this patient who eventually also had an A-frame deformity would be that I do not like to leave the airway dynamically collapsible. So I like to create my airway which is much more steady, static, and non-collapsible. So what I did was that I did a submucosal tracheal resection and anastomosis plus an external rigidification, meaning that area of the tracheal cartilages which were responsible for the collapse on the endoluminal trachea were excised, but keeping the the mucosa of the trachea. The adjoining tracheal cartilages were brought together and were anastomosed. But you could imagine that that would eventually lead to an endomucosal crowding of the tracheal mucosa. And that was the reason why I used, in fact, these PDS biodegradable plates on the outside and then PEXI, the collapsing crowding mucosa on the inside, to fix it on the outside. When this is done, the patient is sort of transformed, or a dynamically breathing patient is created intraoperatively so as to create the same kind of a situation and then treat it and then immediately see the result intraoperatively. So you saw the result which was preoperative because of the severe A-frame deformity. And this is, in fact, a couple of days later where you see the collapsing segment is nice and steady. Because of the COVID problems, there were 7 centers in Europe. We came together and we actually issued warning statements because a lot of these tracheostomies in centers in Europe, they were using dilatational procedures. And I'll sort of show you the problems that led to the issues that we are seeing today. So the warning statements that we issued were that respiratory symptoms are going to develop in these adult patients over the next couple of months. It's important that we share the laryngotracheal stenosis pathology and pathogenesis with our colleagues. High suspicion, early referral, and diagnosis is very important. These are the patients who would be in chronic or old age homes. They will require an additional treatment, and we need to centralize the treatment for these patients. We wrote this article in June, and in fact, this is what we are starting to see immediately in September. So this is a 43-year-old male, COVID positive. He underwent a percutaneous dilatational tracheostomy, and in fact, this is what we saw. And of course, we did a single-stage tracheal resection and anastomosis to treat this severe A-frame deformity. The point I'm trying to make is you will see these patients in the next couple of days or couple of weeks in India as well. So to conclude, the A-frame deformity is an important cause of decannulation failure. Mainly we see in adults as compared to we see in children. The diagnosis is flexible, dynamic, nasal, laryngo, tracheobronchoscopy, and the treatment ideally would be a tracheal resection anastomosis. Remember, there would be situations, typically irradiated patients, radiated necks, which present with different challenges. And that's where you need to think of out of the box and give them the right treatment. Always remember, the trachea has to be static, non-collapsible. Any kind of treatment you do, you need to have a stable looking trachea, because that is going to give you the results that you're looking for. I thank you again for a patient listening, and I'm open for any kind of questions. Soumitra, it's all yours.
Thank you very much, Dr. Sandhu, for this excellent talk. It was a really eye-opener for all of us. And presently into the COVID situation, as you mentioned, definitely we have to keep certain points in mind. As if you go by the protocol, no questions are to be asked in this session. So
yeah,
I think
from my side, it's perfectly okay. If there are questions from my side, there's no problem.
What we have planned is we just jump on into the next session, and any questions against your talk, I think we can take those questions directly for you. And in that case, I think we should straight away, Dr. Count is to moderate the next session as far as I know. Mahima, if you are there.
Yes, sir.
Yeah.
Thank you, Dr. Kishore, for that very informative talk. We now move on to our airway discussions. After a very interesting day of discussions on phonosurgery and swallowing, we now move on to the airway section. In this session, we have some interesting airway cases being presented, which will be followed by discussions and expert opinions by our very eminent experts. Dr. Gautam Khaun is the moderator for this session. Dr. Khaun, as we all know, is the Vice President of our Association of Phonosurgeons of India. Sir is also a member of the Board of Governors for the Indian Academy of Otorhinolaryngologists, Head and Neck Surgery, and a Chief Consultant at the Nightingale Hospital, Guwahati. Sir is also the head of ENT at the Pratiksha Hospital. The experts for this session are Dr. Kishore Sandhu. We just heard him in the previous session. Sir is from Lausanne, Switzerland. And alongside Dr. Sandhu, we have Dr. Renuka Bradu. Dr. Bradu is a professor and head of Lokmanya Tilak Municipal General Hospital and Medical College and Sion Hospital. Ma'am is also a consultant at Fortis Hospital, Mulund, and known for her pioneering work on endoscopic sinus surgery and skull-base surgery with extensive series on juvenile nasopharyngeal angiofibromas. Dr. Bradu has several textbooks and publications to her credit. Madam is a great academician and an inspiring teacher to many budding ENT surgeons. Our experts will be giving their valuable opinions on the cases presented in this session. The presenters for this session are Dr. Thirunavukarasu, or Dr. Thiru, as he is popularly known. He's a consultant pediatric ENT and airway surgeon at the Kanchi Kamakoti Child's Trust Hospital and Rainbow and Apollo Children's Hospitals. Sir has trained in pediatric airway surgeries at University Hospital, Lausanne, Switzerland. Dr. Thiru has airway presentations at both national and international platforms to his credit. He has been invited as faculty at the Asia Pacific Laryngology Voice Association conference held in Singapore. And he has also been awarded a gold medal for surgical video presentation at Tamil Nadu in the year 2018. The second speaker will be Dr. Soumitra Ghosh. Dr. Ghosh has been introduced in the previous session. Sir is an airway surgeon from Kolkata. Following Dr. Ghosh, we will have Dr. Arpit Sharma present a case. He is the consultant of head and neck surgery at PD Hinduja Hospital. He was initially faculty at St. GS Medical College and KEM Hospital, Mumbai, with a special interest in airway reconstructive surgery and endoscopic skull-base surgery. Following Dr. Arpit Sharma, we will have Dr. Biswajit Gogoi. He's present his case. He's the consultant of ENT and head and neck surgery at Pratiksha Hospital. He's also the director of Cochlear Implant Center at Pratiksha Hospital and the director at Pratidhwani, a center for child and speech language and hearing. Sir has received advanced cochlear implant training at Sydney in Australia and is an awardee of the LH Hiranandani Award by the Northeastern branch of the Association of Otolaryngologists of India. I now request Dr. Khan to please take over as the moderator.
Thank you, Dr. Mahima. Thank you very much for introducing the speakers, our experts for this session. And at the outset, I would like to thank Dr. Sandhu and Dr. Renuka ma'am for accepting to be experts in this session. This is a panel with a twist. We have got 4 speakers, as Mahima has mentioned, and we have 15 minutes each for each speaker. They'll be presenting for about 6-7 minutes. And then we have discussions for the next 6 minutes, 7 or 8 minutes. So that's 15 minutes each. I'd like to congratulate Dr. Phanindra Kumar sir at this juncture and thank him for giving so much space to airway in this midterm Phonocon. And with these words, I now request Dr. Thiru to come over and present his case, which is on laryngomalacia aptly, because the most common congenital pediatric airway problem is laryngomalacia.
Okay. Am I audible, visible? My screens are there?
Yes, yes.
Thank you, Dr. Khan, and good evening, everyone. Welcome our experts, Dr. Sandhu and Dr. Raduma. I'm going to present my little experience about one of the commonest problems we all encounter in day-to-day practice. So, laryngomalacia. So this is the presentation I made last year in IMPACT meeting at Rome and got published about the laryngomalacia. So far I have done 34 cases of supraglottoplasties. Most of them are type 2 laryngomalacia. And the indications are like combined indications like severe stridor and feeding difficulties and failure to thrive. So this is the most common indication for which I have done supraglottoplasties. So I use cold steel scissor to cut ariepiglottic fold routinely. I do that. And once I've done that, and then I ablate the redundant tissue there with the co-ablator. I use the laser, debrider, electrocautery, everything. And finally, somehow settled with co-ablator. I find this is very useful single tool because I can suck whatever is there inside and I can use it while the tubeless anesthesia is being given. And I can cauterize whenever there is bleeding, and there is no need for any fear of crossing the landmarks, whatever we are going to ablate. So only important factor I keep in mind is I don't cross the pharyngoepiglottic fold when I do that ablation. I stick always lateral so that I will not cross the medial mucosa while I'm ablating. And in the lingual surface of the epiglottis and also a little bit on the posterior one of the tongue, I ablate again with the co-ablator. And whenever there is a bleeding, I can straight away cauterize that. So usually I do like a rhomboid-shaped ablation, and I just keep it like that for the normal cicatrization to happen, and the epiglottis is being pulled anteriorly. I don't keep any endotracheal tube intubation for post-operative. So this is the usual situation. I have type 2 laryngomalacia. So when there is symptoms with type 2 laryngomalacia, I do supraglottoplasty and I get this desired result of rigidified epiglottis and the wide open laryngeal inlet. But this is not the case all the time. I have a little dilemma in choosing the patients. Like in this patient, this child is with Sandifer syndrome with hyperextended neck, crying all the time whenever the feed is going to be given. the child was all right till 1 month old, and then developed this kind of a problem for almost like 2 weeks, crying for almost all the time whenever there is the feed is given. And then we did the scopy. I saw there was a type 1 malacia, and there is a little bit of a cushion of cricopharyngeal mucosa is pushing forward. So maybe because of the reflex. And we did all the investigations, everything came up negative, and we were stuck at one point of time. I was pushed to do supraglottoplasty, but I was little reluctant because there is only a type 1 laryngomalacia. I was not very sure whether it is going to help the child or not, but finally I had to do the surgery. And after the surgery, I did very little, just release the area epiclotic fold and ablate the cuneiform cartilage and a little bit of hereditary issue there. And there is a good rigidification happened. And I was not very sure whether this is going to help this cricopharyngeal opening or the reflex problem. But finally, for my surprise, the child was very well treated. After the surgery, the child was absolutely fine. This is the 5th day of surgery, and the child was not having any problem at all. And almost like 3 months now, the child is doing very well. So this is another child with feeding difficulty and type 2 laryngomalacia. And there was a history of aspiration, so absolutely failure to thrive. So I had to go for a surgery and did the supraglottoplasty. And the thing was like, there was a dilemma whether to remove the NG tube because the child was aspirating before surgery. After that, we were very reluctant because it was not a safe swallow. And I did a fees examination. You can see the type 2 laryngomalacia is completely rigidified now. There is no problem at all. But you can see there is aspiration and mainly the penetration of the feed during the fees examination. We kept the NG tube intact and did the fees examination. And you can see that there is a nice penetration posteriorly, and after 1 month also. So we continue to feed the child with NG tube, and after 1 month, the child was able to be removed. So this child with the infantile spasm and type 1 laryngomalacia and type 1 laryngotracheal cleft. So mainly the child was admitted with the severe stridor, and because of this prolapse of the redundant mucosa anteriorly into the lumen. So I was again in a dilemma whether to go for a laryngotracheal cleft repair or do a supraglottoplasty. And finally, I decided to do both, and I did the laryngotracheal cleft repair because it's a type 1 cleft. I managed to put only 2 sutures after creating a raw area with laser, and also used the CO2 laser to do a supraglottic ablation on both sides, so that without touching the epiglottis. So I was able to do a good suturing of the laryngotracheal cleft, and also the supraglottic ablation and rigidification. You can see both the sutures, that's intact, and still there is some edema there. This was the 10th day post-operative, but the good rigidification happened and child came out well. So my questions to the experts. The indication, whether the same indication like what I did all these 34 cases, or you do anything different. And the next is the concomitant airway issues. The most of the time we do have a patient with laryngomalacia, laryngotracheomalacia, sometimes even pharyngomalacia. In that situation, will you do only the supraglottoplasty? Will it improve? I mean, it helped in a few cases for me also. And about the comorbidities, most of these children with the feeding issues may have neurological issues. And in that case, can we do supraglottoplasty and get away with the feeding issues? And the techniques, do you use anything different like laser or cold steel instrument? How do you do it? And about the anesthesia, you also do tubeless successive apneic anesthesia technique or anything different? And post-operative, I've seen some of the papers which is mentioning about the post-operative elective intubation, so that the anterior supraglottic region, which is being pushed to the posterior one-third of the tongue and kept it there so that the healing will be proper. But I don't generally do elective intubation except two situations where I had to do it. One situation was the child went home without any problem post supraglottoplasty. After 3 weeks, the child came back with severe stridor. Then I scoped the child and I saw there was a rigid cicatrization on the right side of the pharyngoepiglottic fold, and that is pulling the epiglottis on one side. Because of that, there was a stridor. So I had to release the pharyngoepiglottic fold nicely and create a raw area again and intubated the child for 3 days, and then child came out well without much problem. And what about the feeding? You generally start feeding immediately after the surgery or wait for it? What about the aspiration kits? Do you do routine feast examination? And about the follow-up endoscopy, do you do routine follow-up endoscopy? If yes, when are you doing it routinely? So these are all my questions. Probably, the reasonable questions, I think. So many people will be also interested in getting your expert opinion on that. Thank you.
You have done half my job, so I pass on the queries, whatever Thiru has put up, to the experts, whether you have done it the same way or you would have done it in a different way. Sir, madam, please come in.
Sir, you are not audible. Sir is not audible.
You can stop
Sandhu is not audible.
You can stop your
All right,
stream.
can you hear me?
Yeah, fine, yeah.
All right, thank you, Thiru, and thank you very much, Gautam. Hi, Renuka. So a couple of things, plenty of questions. So as far as the indications are concerned, my indications are absolute indications: cor pulmonale, pulmonary hypertension, failure to thrive, recurrent cyanosis, pectus excavatum, stridor with significant cervicothoracic retractions. These are absolute indications. Relative indications are aspiration, weight loss with feeding disorders or feeding problems, and recurrent hospital admissions. And then I have controversial, indications where social situations of the parents and for quality of life. What I mean by that is no child who is stridoring is accepted in a creche or, for taking care of the child whilst the parents are working. So in a situation like this, I still go in and do a supraglottoplasty. So these are my indications for doing a supraglottoplasty. If the child is syndromic, neurologic, as Thiru said, I would talk to the parents about the prognosis of the child. Would definitely talk to them about a tracheostomy. Sometimes, you have a severely affected neurological problem in a child where I would stay back and probably be very guarded with the prognosis and keep a tracheostomy just in case, speaking to them about a tracheostomy. And if there are associated synchronous airway lesions like what you showed, a laryngotracheal cleft, with laryngomalacia, etc., of course, it has to be done during the same time. Technique, I always do it with spontaneous breathing child, no endotracheal intubation. Whilst this anesthesia is given, we sometimes use successive apnea. Post-operatively, I always use the laser, the CO2 laser in an ultra pulse mode. Post-operatively, in fact, immediately after the surgery, we would put in a small nasogastric tube because the child is not intubated, but he's always kept on a CPAP machine. So whenever you have a CPAP added, I always have a nasogastric tube because, you don't want hyperinflation of the stomach. Oral feeds are started immediately, even if you have a nasogastric tube in place. And then within the first 24, 48 hours, depending upon how the child is feeding, etc., the nasogastric tube is removed. It's much easier to remove the nasogastric tube rather than insert it later on. And whilst the patient is on the CPAP for the first couple of hours immediately after the surgery during the recovery period, the nasogastric tube is removed as quickly as possible. Follow-up endoscopy? No, I do not do follow-up endoscopies. I watch them clinically, and I do not do follow-up endoscopies unless something is going wrong. Either there is a recurrence of the symptoms, and if there is a complication. So these are the ways I would sort of answer the questions that you have raised.
Yeah, Thiru, could you
Sorry?
Yeah. So, Dr. Count, a couple of things that I would like to say. One is I prefer the laser because, vaporization of excess tissue is better with the laser than with cold instruments, so that you can get a more precise vaporization of excess tissue. I haven't used the coagulator, so I can't comment on that. I think Dr. Sandhu gave absolutely exhaustive opinion on indication, so I don't need to go into that. One point I'd like to, actually 2 surgical points I'd like to make is, one is when you suspend the larynx, it's very important that you have a symmetrical suspension and that the larynx is not tugged to one or the other side, because then you can have you can misjudge the amount of mucosa to be removed, and you may land up removing more than is required on a particular side. So just make sure that your laryngoscope is exactly symmetrical. We also do it with an apneic technique, and occasionally we will put in, as if there's a hypercarbia, we would put in an endotracheal tube, and a small endotracheal tube, as small as the anesthetist will allow, and ventilate the patient and then go back once the hypercarbia is settled. And when we do, when I do raw area between the base tongue and the epiglottis, I usually take a suture with 4050 Wycliffe. I have one question that I'd like to discuss with Dr. Sandhu and with the other panelists, is that when there is a laryngeal cleft as well as laryngomalacia, so there is a issue of aspiration along. Would you do both the surgeries at the same time, or would you first repair the cleft and then go in for repair of the laryngomalacia? Post-op, maybe keep the patient on CPAP for some time, so that that tiding over of the edema and post-operative thing, so that it is not, the edema doesn't complicate the laryngomalacia. But I would think that I would do it in a stage-wise manner. What do you think, Dr. Sandhu?
Yeah, Renuka, so for me, I think, if it is, let's say we're looking at a type 1 or 2 laryngomalacia, morphological laryngomalacia. So where we are looking at the cuneiform cartilages sort of, dropping into the laryngeal inlet. So anyways, we are using the laser to correct the laryngotracheal cleft. So in that, if we have to excise this additional floppy area and just incise the aryepiglottic folds so as to just widen or lengthen the aryepiglottic folds, doesn't really make any difference. Yes, we do know that morphological cleft of the child may not necessarily mean that the child is not going to aspirate post-operatively. So cleft is not the only problem. The child could anyways aspirate afterwards, which could not be related to a morphological defect. But yes, if I see a very obviously floppy supraglottis, I would include that part in the excision whilst I am treating the cleft, because eventually it's the same situation. I think the 2 things which are important is a morphology of the supraglottis. So we're looking at the type 1, 2, 3 types, and then applying the various techniques depending upon what morphological type we are looking at, meaning that the same procedure that I would use for type 1 would be different for type 2, would be different for type 3. So depending upon what we find, we actually would go ahead and do the surgery.
Yes, I agree. And just a tip for the young surgeons, the juniors, the 2 areas I would particularly take care of so that I don't laser there is, one is the interarytenoid area and the other is the pharyngoepiglottic fold. So those two areas I would take particular care of while doing the surgery.
Thank you, Renuka ma'am. Thank you, Dr. Sandhu. And Thiru, could you stop share? Thank you for your presentation.
Yeah, thank you. Thank you very much.
15 minutes, I think we have discussed quite a bit. I move on to Soumitra. Dr.
Yes.
Soumitra, could you come in?
Yes,
From
please.
congenital, we are moving into an acquired problem now.
Can you see my screen?
Yes, yes, we can see your screen.
I'll just stop my video just a second. Just a second.
Could you put it on slideshow?
Yes, just a second. It's not working. That's why. Just a moment.
You can stop and go back.
Yes, I'll just stop and I'll go once more. It's okay?
No, it's not coming.
It's not coming. Once more. Can you see the?
Yes, yes, we can see the screen.
Is it there?
Yeah, it's there.
Okay. So let us straight away go to my case. 29 years old patient was intubated for 10 days for being treated for dengue, and it was in the month of December. After extubation, there is a little bit of lag. Can you just?
It's okay this side. We can see. Can you go?
No, it's the PowerPoint is not working. Can you just give me a second? I'll just stop it and start once more.
Start to reshare, please.
Yes. Is it there? Yes.
No, Soumitra, your slide is not here now. It went off.
It's not there.
Yes, it's come again.
Can you see now?
Yeah, we can see. Go ahead.
Okay. So a 29 years old gentleman who was intubated for 10 days for dengue in the month of December. He developed progressive dyspnea after 2 weeks of extubation, and he was tracheostomized at 1 month for progressive dyspnea. A CT scan was suggested, and a CT scan was done. And here you can see there are 2 levels of constrictions above the level of the tracheostoma. And if we go through a little bit of this reconstructive images, you can see again, there are 2 levels of constrictions above the level of the tracheostoma. So at this stage, the patient was referred to us, and we thought we were dealing with a patient of multi-level tracheal stenosis. And we put up the patient for a routine airway assessment, a dynamic study, and the patient was put under SEBO, as we all do every day. We assessed the patient, and there was the vocal folds were normally mobile, the arytenoids were normally mobile. So at the glottic level, it was okay. And as we went putting the scope down, we found out, as the CT scan suggested, there was stenosis just at the level of the first tracheal ring. And I was using a 5.8 flexible scope, and it was a bit difficult to negotiate the scope. And when we negotiated in, we could already see a second level of stenosis below the first level. And that was more or less a few millimeters wide. So practically, we were dealing with, again, 2-stage tracheal stenosis post-intubation. As we put our scope through the tracheostoma and counted our healthy rings back from the cricoid, there were 10 healthy rings left. So it was a grade 3 tracheal stenosis, multiple levels. And we initially planned for a tracheal resection and end-to-end anastomosis. Thinking back, we would have to resect at around 6 rings. So we gave it a second thought. I discussed with a few of my colleagues, and we thought, why don't we give it a try with the coblation-assisted reduction? Because the cranial stenosis seemed to be soft, and the distal one was, the caudal one was a bit hard as we palpated. So we planned for a coblation-assisted reduction. We used both the MLW and the LW ones, followed by local steroid injections. And mitomycin C, we kept in mind, we put in some mitomycin C and smear some steroid cream liberally. We planned for 2 to 3 sittings around 3 weeks apart, and then reassess and see how it goes. The basic idea of using the coblation was to downsize the level of the stenosis. And finally, if we at all had to go for a resection anastomosis, if by chance we could spare 1 or 2 more rings, so that we can reduce a less number of tracheal rings if we at all had to do a tracheal resection anastomosis. So in the first sitting, we ablated the left-hand side of the patient with steroid injections and copious amount of steroid creams. And after 3 weeks, we did the other side. So this is on the left-hand side, you can see the original lesion where we started from. And in the video, this is what we achieved after the first sitting. On the left-hand side, you can see the granulation tissue. And the first, we just crossed the first level, which was initially a grade 3. This is the second level. And there you can see there's a third level of stenosis, which is very soft or a mucosal type. So probably there were 3 levels, and I missed probably the last one. The cranial most, which was initially grade 3, has come down to grade 2. The middle one is still grade 2, and we have got a grade 1 at the lowest level. So in that sitting only, we again did the other half, that's the right-hand side of the patient with the coblation. I apologize the shakes because it's an edited video, and you have to hold a long tracheal scope or a long cystoscope sort of a thing, and the coblation went, they would fight with each other. You have to palpate and see that you are not eating away into the cartilages, because tactile feelings are the best tools for the surgeon. And after finishing off with the cranial one, we went for the distal one with the coblation, again with the LW one, and followed up with steroid injections. We put in mitomycin C, topical mitomycin C in the second sitting, that is the second intervention that we did after the 3rd week. And at the end of the second intervention, this is what we achieved. So we were able to downsize the stenosis segments, and we put in the patient with steroid inhalations, and again took up the patient after another 3 weeks. And this is what we saw after 6 weeks. So after 2 interventions, the patient was not dyspneic. He had little bit of exertional dyspnea, and there you can appreciate the 3rd level of the of the stenosis, which probably I initially lost. We were quite curious about the vascularity, so we just switched over to the Spectra B, and as we saw that the fibrous areas had little bit of vascularity, and these tufts of vessels are probably the future sites of granulation, which directed us to put in more of steroid injections there. And that's how it goes down below. And we just finished off with, again, a lot of steroid injections and smearing with the steroids. Now, this second sitting we did at the start of the COVID. So it was in early April. Incidentally, this patient was from a neighboring country, and he had to go back his home in Bangladesh. There were a lot of visa issues and all those things. So he went back and he lost to follow-up. he kept in touch with us. He was okay. He had a number 6 tube blocked. So he came back to us last week only, and this is what we found out after 6 months. That is 4 months of after the last intervention that we did. So right now we could downsize the type 3 stenosis to type 1, all the 3 levels. We have 11 healthy rings now. So probably we could gain 1 ring. He is on a number 6 uncuffed tube, tracheostomy tube, which is blocked. No dyspnea on normal function. He has got exertional dyspnea only. And as you can see here, the 3rd level still is there. We got this patient at 3 months. So that was pretty late. So the question is, we have to do something for this patient. What do? We redo with coagulation. We do incision under balloon dilatation, repeated steroid injections. Is it an office-based procedure? Or we straight away go for a tracheal resection and end-to-end anastomosis. So with that, I would like opinion of the experts about how to go on with this case.
Yeah. So, Soumitra, could you stop sharing so that we can have the speakers on the full screen? Renuka ma'am and Dr. Sandhu, your opinion, please.
Renuka, you want me to go first or you want to go first?
I'll give you my thoughts first. First of all, Dr. Soumitra, you've got quite a good result, I must say, and I congratulate you on that.
Thank you, ma'am.
But let me just share what thoughts would go into my mind if this patient came to me. I have certain indications for which I will definitely not do an endoscopic technique. Though you have proved me wrong here, but I would still like to share that. One is if there's a congenital subglottic stenosis, because we know that it will be cartilaginous more than fibrosis. Second is a patient who has failed a previous endoscopic attempt. And third is I don't like to do endoscopic procedures on 3 and 4 grades of stenosis. So I would actually go for a tracheal dissection anastomosis as a first stage, because you had more than 10 good healthy rings. So there was enough trachea with which you could have got that. And it would have been, I feel, a single stage surgery, with especially since the patient is from Bangladesh and not easily available to follow up. So I would have done that. Having said that, I must say that you've got a good result. I would actually, in this case, do steroid injections, and because you've got so far without open surgery, so I think you can push the envelope a little more. And I would inject steroids, and then actually what I do is I usually inject steroids, then I put a balloon and I dilate it slightly so that the steroid spreads well throughout the stenotic area. And then I take a triradiate incision and repeat the balloon dilatation. But I would not do, well, it'll depend on how much healthy trachea I have between each stenotic segment. But if I have less, if it's very close, then I would do it in a stage-wise way. So definitely the way I would have thought of this case is very different, but you've proved that you've managed to do it this way. And so I would say that given that you got so far, you could try and continue endoscopically.
Thank you very much, ma'am. Thank you very much. Actually, I was a bit reluctant to use the balloon because it was already 3 months old stenosis when the patient came to us. And my idea was if we could downsize and get rid of an open surgery. Dr. Sandhu, sir, I'm just waiting for you.
Yeah, I think, Soumitra, you got a good result. But, I agree with Renuka on a couple of things. That you have 10 rings distal to the stoma, and he's a young guy. He's 29 years of age. I think this is a situation that would mean that he's got the next 50 years in front of him. So you want the airway, that is going to be functioning correctly as well. So meaning that, we're looking at the mucociliary clearances. So whenever we are using any of these devices, finally we're looking at altering the mucociliary clearance to a certain extent. There are no studies that can tell you that, whilst we are doing balloons, we're using all kinds of devices in the airway, what happens to the mucociliary clearance? Today, we are not aware of it. In children, it's a disaster. In an adult, the margin of error is much more, so we can get away by these device uses. So coming down to how I would look at it is, he's a young guy, we would excise 5-6 rings with adequate maneuvers of either laryngeal drops, mobilizing the trachea. There are multiple ways of understanding preoperatively, intraoperatively, to avoid a tracheal dehiscence or an airway dehiscence that can allow you to do a good resection and anastomosis. So this is the way I would look at it. Plus, I would be very happy to have a good healthy trachea, which is going to remain with him for his lifetime. So in tropical areas, because the air is a little bit more humid, etc., I think, again, the story of mucociliary clearance, which is not adequate, doesn't play so much of a role. We get away with it. But having said that, he's a young guy. The same thing would have been in a slightly oldish patient. Maybe we could think a little differently. But again, I would look at doing a single stage resection and anastomosis. Your other questions of redo with coagulation, no, I wouldn't do it, because I'm very happy to think of time to decannulation as well. Meaning, today, if we have started any treatment, whether it is balloon, whatever it is, we've started any kind of treatment. But if we are going to decannulate him after 1 year of time, so the time to decannulation is pretty significant as well. So this guy is going to work, he's got a quality of life, etc., etc. So I think that needs to be considered as well. And again, all these, there are people who are publishing use of endoscopic procedures in grade 3 and grade 4 stenosis as well. I'm aware of that. But remember, these are all observational studies.
Yeah.
They cannot be repeated again in different centers. So I would say that findings and results should be interpreted with caution, because eventually you are probably going to sort of do it in the second time if there is a next patient, and also trying to share with your younger colleagues as well. So any of these observational studies should be interpreted with caution.
Thank you very much. So for this patient, again, the best option is to go for a resection and an end-to-end anastomosis, as both of you suggest.
Yes.
Thank you very much. Thank you very much.
Thank you very much. Kindly stop your sharing. I now call upon Dr.
Yes, please.
I'd call upon Dr. Arpit Sharma to come over.
Thank you, sir. Thank you, Gautam, sir. I would like to thank Dr. Phanindra Kumar, sir, and Dr. Amitabh, sir, for giving me this opportunity. Okay, can you see my screen?
Not yet.
Yeah. Can you?
Now, yes. You can see the screen.
Sure. So I will quickly start with my case. So I am presenting here a case of a 6-year-old girl, known case of a Wegener's granulomatosis 6 months back. So patient was having a renal and pulmonary involvement at the time of diagnosis. So she was started with a treatment with cyclophosphamide and steroid, and she had an excellent response to that. Incidentally, the patient had a complaint of hoarseness 3 months back, for which she was not really evaluated and given just conservative treatment. But just about a month back, she started having dyspnea with stridor, which was progressive. So for that, she was started with rituximab, with which the airway symptoms resolved for a week. But again, there was a gradual worsening of the airway symptoms. So when she presented to us, she was having a stridor as well as intermittent desaturation, also requiring oxygen. And you can see the chest retractions also as well. There was no history of intubation in past. So definitely it warranted an urgent airway assessment. So it's a good practice to, whenever you are doing an airway assessment, to if you are doing it planning to underdo a general anesthesia, just to take it under an inhalational agent and not to paralyze the patient, because then you will get to know exactly what you're going to be dealing with. Once you are there, so at least you will get an idea what you will be able to manage endoscopically, or you will have to kind of plan it as a either open procedure. Some may have a thought of doing a tracheostomy also right away and just secure the airway. Yeah, that is also right thing to do. But if you're confident of like creating an airway, good enough airway by doing an upfront surgical intervention, you can also do that. Again, then the choice is going to be either go endoscopic or an open, or when you are considering an endoscopic approach, then the choice is going to be between doing an intermittent apnea, jet ventilation, or using a Thrive. So whenever we are doing this, when we have done the primary assessment, it's better to go for a team huddle and discuss with your anesthesia assistant what is the best approach for this patient. After discussing and after gathering whatever your thoughts and your instruments, you should go ahead by kind of prolonging the general anesthesia. Now you can paralyze the patient. Then you should be clear what instrument you will be using next. Either it's going to be a suspension laryngoscope, or it's going to be a Macintosh laryngoscope or anesthesia laryngoscope. There, after that, you can use a cold steel to open up the stenosis a little bit, or you can use a laser or cobbletter. All of them are tools. Whichever is you feel the best for the situation, and whichever you feel confident doing with, you should use that. After that is about dilating whatever the granulation or the soft stenosis is there. So whenever we should keep in mind, whenever we are discussing endoscopic management, usually it is done for a soft, recent onset and a short segment stenosis. So then we can use a balloon, bougie, or a rigid bronchoscope. And very importantly, nowadays, more and more evidence is coming out of using and good results with the intralesional steroids in particular. I'm not really a very big fan of a mitomycin, but yeah, again, mitomycin C also has been used a lot of places, but with the unequivocal results. Okay, there comes the next. Everything will like kind of be important. We will have to think about the patient safety first. Whatever we are planning, it should be with the patient safety in mind. So after that, I'll just show you quickly the video of what we did. So we paralyzed the patient, and anesthetist people give a very good idea with the bag and mask ventilation, how much they're able to ventilate. And that gives a good understanding how much time we have when you are doing an intermittent apnea. So what I did was I just opened that slightly with a sickle knife. After that, just to secure a good amount of airway and to have a sigh of relief, I immediately dilated with a 4 mm balloon first. So there's a good airway achieved after that. It's a good practice to do an intralesional steroid application and then do a balloon dilatation. But for me to have a secure airway first in that case was more important. After that, I gradually increased to a 6 mm balloon. After securing the good amount of airway there, since the child was 6-year-old, patient could have taken a 5 number tube with the outer diameter of 7 mm. So in trachea, whenever you're doing a balloon dilatation, you can use a size plus 1 mm for balloon. So next is going to be an 8 mm balloon. Here I am infiltrating the Kinacort injection in all the 4 quadrants. And now this is the 8 mm balloon that is being used to dilate the airway further. After using that, we usually normally inflate the balloon for a minute or 2, or the saturation if it falls below 90, whichever is earlier. And usually it achieves a good result. As you can see in this case also, immediately after the balloon dilatation, I had a little urge to remove that granulation on the right side, but I kind of stopped myself there so as to like see this, whatever is there in the next sitting. So this is the follow-up scopy after 3 weeks. And you can see a very good airway, though the inflammation is still there. So we again followed this up with a just intralesional steroid application. And no balloon dilatation was done this time. And we could easily pass a 5 mm, sorry, the number 5 endotracheal tube easily. Endotracheal tube is also a good method of sizing the airway. Alternatively, a rigid bronchoscope can also be used to size the airway, what kind of a lumen you have achieved. So coming to the Wegener's granulomatosis, or also known as a GPA nowadays, granulomatosis polyangiitis. It's a necrotizing polyangiitis of small and medium-sized vessels. It's a triad of upper airway, lower airway, and renal involvement usually, mainly seen in younger and older age group. rare in children, extremely rare in children below 12 years. ENT manifestation are seen in 70% of pediatric vaginas whenever they are there. So when you are talking about the laryngotracheal involvement, usually it is going to be in the form of vocal cord granulomas, subglottic stenosis, or maybe sometimes a multi-level stenosis also. Very rarely you can see a bronchial stenosis or a vocal cord immobility as well. So after doing the literature scan, I'm just sharing whatever has been discussed there. So it has been kind of okay now to manage this surgically, because mostly it requires surgical management along with medical management. Endoscopic management is preferred along with intralesional steroid and dilatation, and it really gets good results. Cold steel, laser, coblation, all are tools which can be used equally effectively in all the cases, along with balloon and bougie. Whenever there is a kind of a fibrotic stenosis or a long duration stenosis, cricotracheal resection surgery can also be done. But one must keep in mind, okay, whenever you're doing this surgery, still the patient may frequent balloon dilatation also after the surgery as well. Tracheostomy is an alternative, but preferably should be avoided, because like whatever you're putting a tube also, like a tracheostomy tube or a stent, usually irritates the airway, which may sometimes leads to the increase in the disease activity as well. Relapses are quite common, and diligent surveillance is what is required. So most frequently, these vaginal patients may require 3 to 4 procedures during their lifetime. So subglottic stenosis in vaginas is rarely seen in adults, but most common ENT manifestation in children. Children, you see a relapsing course, often refractory to standard medical management. Anytime, regardless of disease activity, you can see it, unlike other ENT involvement. It occurs or progresses independently of others feature of active vaginas. I'm open to any comments or my esteemed panelists. Thank you.
Thank you. Could you just unshare your slides? I would like our experts to come in and share their experiences on regarding Arpit's.
You want to go in, Renuka? Oh, yeah. Okay. So thank you very much, Arpit. It was really nice to listen to your way of managing the child. I think a couple of comments. One, that we know that this particular disease, the polyangiitis granulomatosis, is a mucosal disease. So finally, the treatment is going to be, endoscopic. We know that it is refractory, it relapses. So lesser the damage we do, better it is for the child. So I think endoscopy as the first line treatment, even if it is multiple times, I think for this particular child is important. I think my indications of doing a surgery in a patient with GPA would be following. At the diagnosis, if I'm already seeing a unilateral vocal cord fixation, meaning we are looking at a proximalization of the stenosis. So if either it is the disease itself or it is the iatrogenic involvement of our procedure, which actually leads into a cricoarytenoid ankylosis kind of situation. Shorter glottis to stenosis distance. So if, again, it is more of a proximal stenosis with bilateral cords which are mobile at diagnosis, I would keep that in mind, that I need to be a little careful and not be over enthusiastic. Otherwise, there's a good chance that because of our manipulations, the patient will get either a uni or a bilateral vocal fold immobility. Those cases which require a surgical intervention for me would be shorter intervals of endoscopic treatment, meaning that this particular patient, of course, it's a child, so we need to think a little bit differently as well. If it is a shorter interval of treatment, and if at a certain point of time a tracheostomy is going to be required for this particular child, I might as well continue with a tracheostomy until we see that the disease is sort of in a static phase, in remission. If it would have been an elderly patient or an adult patient, maybe I would think of doing a surgery basically to arrest the mucosal disease. But again, I think we know that any kind of surgical intervention, a cricotracheal resection or a tracheal resection in these patients will probably require additional procedures. So I think surgical decision is going to be critical and is based on the factors that we discussed earlier, depending upon the proximalization of the disease or by iatrogenic involvement.
Anuka, ma'am, your comments.
Yeah, so just a couple of points. One is the patient on any either methotrexate or any other medication to keep the disease under remission?
Yeah, patient was on rituximab and is still on rituximab. So, but initially it benefited, but again this stridor and the dyspnea worsened. So patient is still on rituximab now.
The other thing is, this I'm saying actually from literature because I have not had the personal experience, but they do say that you can use steroid sprays to help keep the disease calmer and therefore maybe increase the interval between interventions.
Yeah.
And the third thing that I would say is that I would personally like to put a much smaller endotracheal tube in this child than a 7 number one.
I didn't
I
put
thought you said 7.
No, 5 number.
Yeah, I heard 7. Yeah, so I was a little concerned about that. It's a 5 number.
5 with the outer diameter of 7.2.
Yeah, okay, yeah. So that I would be definitely concerned about. But other than that, I have no other comments to add.
Thank you.
Can I just make one more comment?
Yes, sir, please.
So Arpit, if this child has got a recurrence, in my opinion, you shouldn't think twice to do a tracheostomy. So your balance is going to be a tracheostomy vis-a-vis multiple interventions, vis-a-vis a surgery. So I would definitely not do an open surgery. I would think between endoscopic procedures and then keep my tracheostomy as a backup and a long time follow-up again, just to see proximalization of the process. So I think I would keep the tracheostomy because she's a child, she's a 5-year-old. So, to compromise her already compromised airway would be something which would be important to keep under control.
Thank you, Dr. Sandhu. Thank you, Arpit. We move on now to the last presentation by Dr. Biswajit Gogoi.
Thank you, sir. Thank you, FC, and especially Fernando sir, giving me the opportunity to share my experience today. And good afternoon. My topic is on laryngeal cleft, and I especially go with type 2 cleft repair. By definition, it's the craniocaudal slit defect of the party wall between the laryngotracheal airway and the upper aerodigestive tract, and it's a very rare condition, 0.5 to 1.5%. And is my slide is visible, sir?
Yes, you can see us.
So mostly they presented with cough and choking on feed and with a respiratory distress, and that depends upon the involvement of the cleft and with a recurrent aspiration pneumonia, and most sometimes may present with a silent pneumonia also. The whole symptoms depends upon the extent of the cleft. So this is our first experience who have siled with a decannulation issue. When we evaluated many times with the removal of the tracheostomy, then we have found he has a cleft, and that's how. And these are mostly syndrome associated. These are the SILE who is these are syndrome associated with the cleft, Opper's Fries, Polycystic Hall syndrome, Vectoral, and SARS association. These are our first SILE who have a type 2 cleft. And if you can see here, he has a whole midline defect. He had a VSD. He has a bifid scrotum and cleft palate also. And this is some non-syndromic involvement. Recently, we have a type 3 cleft with a tracheoesophageal fistula. This initially diagnosed as a tracheoesophageal fistula, but on bronchoscopy, we have found he has a type 3 cleft. And also laryngomalacia and type 1 or type 2 cleft always associated. So the investigation is always fiber optic bronchoscopy, but with a very high level of suspicion. Cyst excision gives the information of aspiration pneumonia also, and FIS, genetic give the laryngeal penetration, then you can suspect. This is how we can appreciate. We should not go for this is the case of a laryngomalacia. We can also appreciate if there's any kind of cleft efficient with a history of choking on feet. And before putting the conclusion, before going for rigid endoscopy also, you can maneuver, you can slow the motion of the, in a software, our recording, and you can appreciate the cleft. So ultimately, the rigid telescopic evaluation with the vocal cord separation is a gold standard to know the extent of the cleft and to diagnosis also cleft. These are the cleft, the type 1 cleft, you can appreciate. And in type 2 cleft, there's always we should insinuate something and always try to detect the interaretinate area and how much extension. And here you can appreciate the redundant mucosa. That redundant, how much redundant mucosa, that gives the symptoms of respiratory distress. In other way, the redundant mucosa helps the cile from the aspiration. And this is a case with a type 3 cleft, which is extended beyond the cricoid. This is a Rice tube, which is going to the esophagus. So this is Benjamin English classification of type 1, type 2. Type 2 involved the cricoid, and type 3 is beyond the cricoid. And I'll go specifically, this is my type 2 cleft, how we are going to manage this cleft. And this is the child who had 30 weeks of gestation. That means he was a preterm child, the twin baby, birth weight of 1.8 kg. He was delivered by LSCS, but there's no history of birth asphyxia. Soon after delivery, baby developed respiratory distress, which was managed by high floor nasal cannula NICU. The respiratory distress settled in 3 to 4 days. As baby was put on breastfeeding, he again developed respiratory distress with a choking episodes. Mother also gave the history that while feeding, baby has not able to suck properly and sometimes become bluish in color and flowing feed. But they are reluctant to go for, therefore we did a flexible endoscopy, and we have found here the type 2 cleft. And after that, we put on the cile on rigid endoscopy, and how it's very important not to appreciate the cleft, and we should to get the apex of the cleft. That's very important. And just a minute. To getting the apex of the cleft, if you don't demicrosalize with that apex, either it may be laser, either it may be cold. Still here I'm using only cold instrument, and thus cutting the redundant mucosa. And similarly, the opposite side. That means basically we have to, I have no laser, sir, sorry. So that's, I am doing it a cold instrument, cold seizure only. And how much mucosa we, basically we should make raw of the both the edges. Then the real cellage is with the suturing. And it was after lots of counseling, we have put this child on 45 days of life, and he is already low weight, and definitely we have a cellage. And you can appreciate here, I'm not, if we have a person's laryngoscope, then I may get the more walking space here. And I'm using here 50 Brickell, but I think PDS with double-headed, and if this length of the suture should be, if we are ideal, if it is 70 centimeter. 70 centimeter suture is ideal. And that's how the most important, the first knot. So the apex should be repaired first, and this is the second knot. This is mostly hard knot, and we are going to most terminal knot here. And this is, and another important thing is the knot should be always towards the esophageal side, and it is always have a good knot pusher, and you can use the needle holder also with a lubricant. And last mucosal defect on the esophageal side we have repaired. It's very difficult to rotate the knot. It is so much tiny space. and we keep the knot tightly so that it should not be loose. And this is how we have and this is a follow-up bronchoscopy after 1 month. And so I just said two my learning experience forms. This is the ideal laryngoscope for this kind of endolaryngeal suturing. And your needle holder, we have a very delicate needle holder, because if you go for, because I'm trying with a 60 needle first, but this needle holder now does not grasp that 60 needle, it every time it's rotate. And that's why you need a very good needle holder. And this is a different position, how I maneuver the needle during, we should do some stimulation before going for real surgery. And that's how I got the idea from the one I have attended workshop in robotic surgery. They give how do the laryngeal suturing in a lotus leaf, and they don't allow us to fold the leaf. That's how we can do the practice also. And I sharing the case on behalf of my whole team, basically pediatric anesthesia and also SLP, because post-op feeding swallowing is also important in this kinds of cases. Thank you so much, sir.
Okay, Biswajit, can you stop your share slide share? Yes.
Yes, sir.
Can I have comments from the expert, please? Quick comments.
Would you like me to go first?
Yeah.
So, Biswajit, very nice presentation, and you seem to have got a very good result. So, congratulations on that.
Yes, ma'am.
Just a couple of points which I, from my experience, that I would like to share is one is that when we are doing these cleft repairs, I prefer actually to get a double layer closure. So, instead of excising the entire mucosa, I would judiciously decide how much to excise, but also separate the two mucosal flaps, the airway side and the esophageal side, and try and get a double layer closure. And the other thing is you did it very well, but one thing which might even help further is that if you start from the deeper end, taking the stitches, start from deep end, so more caudal, and then come upwards towards the cranial end. I think, and we have done fistulae where we have put, especially when the first time it broke down, one of the cases we did the first time, the entire repair broke down. And that time we put in tibial periosteum, interposing between the two. So that is so far we have done. So I thought I'd share that with you.
Dr. Sandhu, comments from you?
Yeah, Biswajit, thank you very much for your presentation. A couple of things. I think, when you have a type 2 and plus clefts or a neurologically affected cleft or a syndromic child, sometimes we have to do a tracheostomy in these children. So one of the important points in any cleft surgery or any cleft diagnosis is the site of tracheostomy in a cleft patient. So what is the site of tracheostomy? For me, it is 2 rings below the lowermost limit of the apex of the cleft. The problem is that all patients with clefts have got microtracheas and microgastrias. So if you see that, the patient, your patient, in fact, very quickly you see that the trachea is very, very small, very short trachea. So anyway, one of the important things in any cleft patient is sometimes you need to do a tracheostomy. What is the site of a tracheostomy in a laryngotracheal cleft? 1. 2, when we close the cleft, I think one of the important factors is that, as Renuka said, that you need to have 2-layered closure. But when you're using a cold instrument, unfortunately, if let's say this is the cleft, you eventually are excising the cleft. If you're using a laser, you're incising the cleft. So if you are going to incise a cleft, you eventually build up having 2 layers. If you are excising the cleft, you can't develop 2 layers. unless you keep on dissecting between the two layers. So in such cases, you eventually end up doing a mass closure, which a lot of people do that as well. Remember, mucosa is a non-stick surface. So we need to make it sticking by creating a raw area. So when you're excising it, one of the problems that happens is that you're excising a lot of mucosa more towards the airway. And eventually, you end up closing it as a mass layer closure. And towards the airway, you don't have too much of mucosa left. Remember, on one side is the closure of the cleft, and on the other side, you don't want to transform the cleft into a posterior glottic stenosis. So this is something which is very, very critical. Number 3, you talked about the needle. So I think all these devices are extremely critical, and that includes the suture material as well. So you need to think about a TF+1 suture needle, which is the 50 Vicryl. These are long, 70 centimeters long, with a very tiny needle of 10 millimeters. So the manipulation of these needles in a narrow airway is much more better. The PDSs, which are 60 and more, they have small needles, which are 9 millimeters and less. But the problem is that the thread might break whilst you're actually suturing, or we are sort of pushing the knot into the aerodigestive area. Really the last point is that remember, not all cleft closures will prevent aspiration. So we are only trying to close the morphologically deformed area of the larynx and the pharynx, or the larynx, trachea, and the pharynx and the esophagus. That doesn't mean that the aspiration will be taken care of. So sometimes you need to realize that aspiration is different. Closure of a morphological or an anatomical defect is totally different as well. So these were just a couple of thoughts in a laryngotracheal cleft.
Can I just one question? Can I answer one question, sir?
Yeah, we are running out of time.
Sir, will you prefer feeding the gastrostomy or Ryle's tube?
So typically we put in a small nasogastric tube, which is a very small size, either 6 or 8, and we'll try with that how the child does. If it is a laryngeal cleft type 1, they start feeding the same day. If it is a longer cleft, then we would wait for at least about 4 days before we start again. So we would put a nasogastric tube as against a peg.
Thank you, sir.
Dr. Sandhu, we have actually run out of time, but there are 2 questions from the audience directed towards you. One question is from Shruti Bansal, who has asked, some research articles says that the tract or stents in the airway can cause persistent inflammation and reactivate the disease in Wegener's patients. So if we have to choose between repeating endoscopic dilatation and doing tracheostomy, what shall we opt for?
So if I understand the question correctly, that stents in the airway in Wegener's granulomatosis. Right. So it's not to be used. Remember, any tracheal stent is a difficult situation in a benign condition. They are okay for any palliative work in malignancies, but benign conditions, you should not be using them. Stent-induced stenosis are very well known. So we use stents very, very regularly, but the indications are totally different. The GPA, or the Wegener's granulomatosis, the treatment is endoscopic, but no stents used.
So another quick answer. How early can you take up the children with laryngothromalacia for surgical repair?
At any age. I mean, if the patient is within the indications of doing any kind of surgery, remember about 20-25% of these patients will require surgery. So if the patient is in the indications of doing an endoscopy and doing a supraglottoplasty plus minus epiglottopexy, there is no age limit to that. You need to go in quickly. Otherwise, your indications of doing the endoscopy plus minus surgery doesn't hold true. So there is no age limit.
That was from Dr. Sanjay Hildayar from Mumbai. And the last question from Ranjit Peter from Kochi. Do you infiltrate triamcinolone or Kenacort prior to release of stenosis, probably that's what he meant.
Yeah, so triamcinolone acetonide is basically the same as Kenacort, 40 milligrams per milliliter. So yes, we inject it before, the objective being that if you have already taken an incision, the mucosal planes are opened up. So when you actually dilate them, you can't inject it later on. So it's much more better to inject it prior to making your cuts or making the balloon dilation. The only problem is that if you have a very, very small baby, let's say the child is, a couple of days old, 3 days, 4 days old. In such cases, think about if you're injecting it before, you are blocking the airway. You have a very, very short period of time to, actually create an airway with a balloon dilation. In very small babies, forget it. It's not possible. The reason when I'm saying very small babies, it would be less than 5 days old. So in such cases, or even lesser than that, it's not possible to inject because you have A, short period of time, and B, very small airways. You cannot achieve that as is required.
Thank you, Dr. Sandhu. Thank you, Renuka ma'am, for being with us and sharing your knowledge, your vast experience with us. And thank you all the speakers. And sorry, we have overshot by about 8 minutes of the 1 hour allotted time.
Thank you very much. And I'd like to thank the organizers for inviting me to be part of this.
Thank you.
Thank you very much. Very kind of you.
I'd like to thank Dr. Gautam Kaunt, our experts, Dr. Kishore Sandhu and Dr. Renuka Brado, and all the speakers. We've had a very interactive discussion in the airway panel. We now move on to the consultant papers, the consultant paper presentations. Each speaker will have 7 minutes to finish their talk, and I request all the speakers to please adhere to the time limit. There will be no questions for this session. However, if somebody has any query, they can individually contact the speakers. I believe they will be happy to answer your queries. The first speaker I'd like to invite is Dr. Suma Radhakrishnan. Dr. Suma is an additional professor, Department of ENT at the Government Medical College, Manjeri. And Dr. Suma will be talking on pediatric tracheostomy, what is special.
Hello. Hello, am I audible?
Yes, ma'am, we can hear you.
Okay. Slides are visible, no?
Yes, ma'am.
Okay. At the outset, I would like to thank the organizers for this opportunity. And the topic is pediatric tracheostomy, what's special? Children requiring tracheostomy represents a complex cohort with sustained reliance on tracheostomy, and we need to take care of them for quite a long period of time. There is a paradigm shift in indications from airway obstruction to prolonged ventilation. And pediatric tracheostomy is less common in adults than in children, but still it poses a significant morbidity and mortality, partly because of the primary pathology itself. And this diverse group has specific care needs. The timing of tracheostomy and pre-op discussion regarding the ongoing care is itself significantly challenging. The first successful pediatric tracheostomy was done way back in 1620 in Paris by Nicolas Habicot, a 14-year-old boy who presented with breathing difficulty after having swallowed 9 gold coins wrapped in a linen cloth to protect them from being stolen. And we all know that children are not small adults. They have their own peculiarities in the airway, and so also the pathology. And the care of a child is very different, and we have to take care of that. The indications have changing over the years, and in our study also, the major indication was prolonged intubation, and of which the neurological causes top the list. So neurological causes top the list. And at times we all come across with surprises like this. And this child, a 6-year-old boy, presented with stridor of 1 week duration and 6 months of cough and dyspnea. And he was having no improvement with medical management and referred as a case of supraglottic mass and probably a juvenile respiratory papillomatosis. And we have put him on steroids. He was having stridor, and the video laryngoscopy showed this picture with significant airway compromise. So we took a CT before taking him to the OT, and that showed the real culprit, which was hiding behind for about 6 months and having causing lots of misery to the child. It was a foreign body in the subglottic region, and this was the culprit. So tracheostomy was done and foreign body removed. And after questioning them repeatedly, the parents gave a history of choking 6 months back, and the child has violently coughed and vomited. And this has been given, this history has been given earlier visits to the other centers, but all the symptoms were attributed to upper respiratory infection, and they have forgotten about this incident. And the child has been decannulated and discharged, and he came back after 2 weeks, and you can see the granulations have all subsided. So once a decision is made for tracheostomy, we need to have a multidisciplinary meeting with all those who are involved in the care of the baby, and the most important in counseling of the family, and they have to be motivated about the expected results. Because in this study and the study we have done, the weaning from tracheostomy, weaning from ventilator, and so also the decannulation rates are much smaller, much lower in, significantly lower in neurological group than in non-neurological group. And parents to be informed of the risk involved in surgery, need of ICU stay, and expected results in terms of feeding and voice. Because having a child with tracheostomy is a huge impact on the family. They require a constant care 24/7. And because they have to carry a lots of things, a spare tracheostomy, one size down tracheostomy tube, suction apparatus, suction cannula, nebulizer, and may require emergency at any point of time. It's really tough on the families. And so when to do a tracheostomy in a child who is intubated? Traditionally, pediatric tracheostomy was delayed up to 21 days or more. But recent studies suggest that better to do early if we are planning it for mechanical ventilation, because length of PICU stay, length of hospital stay, and hospital-acquired pneumonia are all less in early tracheostomy. And the selection of tube, silicone tube is preferred over PVC, uncuffed versus depending on the situation, and hyperplex in special circumstances. And the two important parameters are, one is the size of the diameter, and another one is the length of the tube. We go by this formula: inner diameter, age by 3 plus 3.5. This, if you are planning it for a prolonged intubation, it has to be reassessed and changed every 2 years. The length of the tube, the length should be such that the tip should rest 8 to 20 millimeter above the carina. Because if it is too long, it can go and rest in one of the main bronchus and may abrade the mucosa of the carina. And the suction catheter size will be roughly twice the size of the endotracheal tube. And the length also has to be measured. It should not go beyond the tip of the tracheostomy tube, because the complications can be minimized if you don't do a shallow suction. And the duration of suction is also important. Every time, only 5 to 10 seconds, not more than that. Now, coming to the technique, we know that the patient is placed in supine position with the neck extended. Hyperextension should be avoided because of these factors. And if you want to have the Albert chin strap can be used for better exposure. So horizontal incision 0.5 to 1 centimeter below the lower border of the trachea, and the subcutaneous fat is removed, and then expose the trachea properly. This is very important because trachea being pliable can be easily retracted to one side. So you have to confirm it by palpation and also by withdrawing air. Then this is another point of debate. Different centers go differently, either vertical incision or superiorly based or inferiorly based FAP, or a circular resection of the tracheal ring exactly the size of the tip of the endotracheal tube, and intercartilaginous incision. We go by vertical incision. And the major concern in the immediate post-op is accidental decannulation. So to prevent that, you can put stay sutures and maturation sutures, 1.5 mattress sutures, and that will make the stoma mature. And once the trachea is inside, slowly withdraw the tube So ask the anesthetist to withdraw the endotracheal tube till the tip of the tracheostomy endotracheal tube is visible, and then that tracheostomy cannula is inserted, connected to the ventilator, and the ties are tied with one finger loose. And always make sure that the airway is secured by EtCO2. And post-op chest X-ray is important. Always remember that you have to carry out the entire procedure with endotracheal tube in place and stay close to midline as much as possible. Never remove excessive cartilage. Post-op care is of paramount importance, and the first tube change is usually done 5th to 7th day with all precautions. To conclude, indications, techniques, and complications have changed over time, and airway anatomy differs, and the complications are potentially severe. Post-operative issues are substantial, and early decannulation after controlled trial should be our aim. Multidisciplinary approach may promote positive long-term functional outcome. Thank you.
Thank you, Dr. Suma. I now request Dr. Devika to start her presentation. Dr. Devika is an ENT consultant at Nightingale Hospital, Guwahati, and she will be talking on stroboscopic evaluation of voice. Dr. Devika, you can please share your screen.
Yes. Thank you, APSI and Phanindra Kumar sir, for allowing me to present it at this prestigious platform. I hope you can see my slides. Hello?
Yes, we can, ma'am.
Yeah, thank you. So my topic is stroboscopic evaluation of voice. Throughout the day, we have seen wonderful videos of stroboscopy shown by everyone. So when we look outside, we can dream, but when we look inside, we see all the pathologies there in the vocal fold, and we can go for the evaluation and treatment of the patient. So it was discovered as phenakistoscope, then named as stroboscope. Early 19th century only it was thought about. Then Harold Eugene Edgerton, he employed a flashing lamp to study machine parts. Then he invented the strobe light. And he also popularized the strobe light photography. So principle is stroboscopy actually does not provide the true motion of the vocal fold, but it provides a illusion because it's an illusory image. It allows routine slow motion evaluation. Then it illuminates some parts of the vocal folds as the vocal fold waves, it's retained on the retina for 0.2 seconds only, and lighted portions of the successive waves are fused visually. We can see in this example of a clock where the clock is moving, but on this part, some of the parts are highlighted. So those are same as fused highlighted, and we can see the wave properly. Here also in a discotheque, it's applying the stroboscopic lamp light. That's where we are using it as in our technology as stroboscopy. So in stroboscopy, there are two types. That is, either we can use a rigid scope or a flexible scope. There is this is a microphone systems are there, 1 foot pedal, and this is the strobe light source. I'm not promoting any company, just a example of a picture. There are different companies are there. So mainly the topical anesthesia we can use for 4% or 10% sprays also can be used. And for rigid, for flexible, this is the sitting position. Patient is sitting upright and its scope is going through the nose. And this is in a rigid stroboscopy. And in rigid, the position should be like this, Bryce Jackson position, where its best visual is on the anterior part also, it's visualized properly. And these are the parameters of the stroboscopy, which are more than the simple endoscopy parameters. So these are very helpful to understand the pathologies. So what is fundamental frequency? Fundamental frequency is actually it's shown by the audio input along with the simultaneous pressing of the foot pedal when the strobe light is flashed over the vocal folds. Otherwise the vocal fold vibration is too fast to be interpreted by the human eye. And to generate the slow motion effect, by this switch, we can just desynchronize by strobe light by 0.5 to 2.5 hertz so that we can see the slow motion effect. So symmetry. So symmetry, what is the symmetry? Symmetry is the mirror image of the vocal folds and the same lateral excursion. Here it is normal on the first, we picture. And here in the second picture, where there are vocal nodules with few leukoplakic patches, keratosis patches, so you can see there is no symmetry in the vocal folds. I'm just trying to give a few examples. The periodicity is the regularity of the successive vibrations, which is determined by observing sustained phonation. When we are unable to maintain a steady stream of expiratory air, then it happens irregularity, that is the aperiodicity. We can see in this supralaryngeal nerve palsy, where we can clearly demarcates the aperiodicity in the vocal folds. Vertical plane is another factor. When the vocal fold lies in the lower plane, affected than the other vocal folds. So it's most commonly seen in case of scar, ankylosis, or the palsy. Here it's a case of vocal fold palsy. And amplitude is the horizontal extent of the vocal fold. It is decreased by vocal fold masses, obstructions, mechanical obstacle, or lateral resistance like growth, wave, spasmodic dysphonia. And it can be increased by increased subglottic pressure, that is by loud phonation. Here it was a case of edema of the vocal folds. And the mucosal wave, which is one of the most important parameters of the stroboscopy, it varies with the pitch. It may be normal, absent, or there might be some adynamic segment. Lesion in the vocal fold will impede the movement of the here. Some hidden pathologies also can be highlighted by the mucosal wave observation. Here we can see only the angioma at first, but while observing this, doing the stroke, while observing the mucosal wave, the sulcus is also revealed on the right vocal fold. And this is an interesting case. The first video is of 2012. The person had both the vocal folds were scarred. He had some surgery somewhere else. After that, he had this. Then after undergoing several treatment strategies, and he also suffered from malignancy also. And after surgery and all, he miraculously survived that. And we can see there is a normal vocal cord mucosal fold has returned on the right side, but left side still some scar is there. So it's very good to keep documentation of the patient, and we can do better follow-up, and we can plan their therapies very well. And this is an adynamic segment. It's a non-vibrating segment. This came out to be a growth. In case of growth of the vocal cord, it is clearly demarcated by the absence of the mucosal wave. Post-operative CA glottic patient. He has been operated in a cancer institute, and after that he came for his chances about the better voice. So we did the stroboscopy. We saw only a scar in the interior part of the vocal fold. So his voice is pretty good, and he is undergoing voice therapy, and he was given the option of lateral vocal fold injection also. So he is undergoing therapy at the moment. So these are the glottal closure patterns, may be complete. There may be an anterior gap, posterior gap, maybe hourglass in case of nodules, may be incomplete, or there might be irregular closure in case of growth and all, or might be bowing because of the fold paralysis. And supraglottic activity is also very important feature. Here is a patient of tuberculosis. When he had a hoarse voice, and there is lateral compression of the false folds.
Dr. Devika, I'm very sorry to interrupt, but I think the 7 minutes are up. Would you please?
Yeah, I'll do it. It's 8 minutes actually. I got the mail. Just a minute. Yeah. So this is on follow-up. And these are similar cases of supraglottic compression. And this is a case of singers. And I got this from Jaikumar Menon sir, because he has got a lot of good collection for the good singing techniques that can be seen by flexible stroboscopy. So here he is using a false fold contraction. He's hearing high pitch voice, and this is not good. But this is a better technique where there is voice is used normally. There is no false fold compression can be seen, obliterating the voice. So its advantage is practical and a good modality. It's a mod of modern era. Can be used for a recurring vocal problem during therapy, post-surgical procedures. And disadvantage is optical illusion. And in case of severe dysphonia, because of poor audio signal, it's difficult to check. And also in cases of rapidly changing periodicity. And noisy environment are also leads to the wrong interpretation. These are my references. I want to acknowledge Counselor and Dr. Menensa. Thank you. Thank you so much.
Thank you, Dr. Devika. We now move on to the next talk, which is hypothyroidism and voice change, a comparison of effects of different perspective by Dr. Ripu Daman Arora, who is an associate professor at the Department of ENT and Head and Neck Surgery at the All India Institute of Medical Sciences, Raipur. Dr. Ripu, I'd request you to share your screen, please.
Dr. Ripu, your mic is mute. Please unmute yourself. Hello, Dr.
Hello.
Arora, you need to unmute yourself.
I think I am unmuted myself. Am I audible?
Yes, now you are.
My screen is visible to you?
Yes, Dr. Arora, it's visible.
Yes. Very good evening, everyone. Greetings from SAIMS Raipur, Chhattisgarh. First of all, I would like to thank all the organizing team for conducting such a wonderful and scientifically oriented conference. My special thanks to Dr. Philendra Kumar sir for giving me an opportunity. Thank you, sir. My topic for today is hypothyroidism and voice change, a comparison of effect of different perspectives. When we listen to our favorite singer on radio, what's our first impression? So voice is a critical aspect of individual's sense of identity, and the normal voice and vocal tracts reflect the changing physical, functional, and emotional state of an individual. So these systems the voice can be altered by either inflammatory, structural, neoplastic, neuromuscular abnormalities, and endocrine disorders. Endocrine problems are worthy of a special attention, and voice is extremely sensitive to endocrinologic changes throughout the normal human life cycle. And we should be familiar to recognize them promptly and generate appropriate treatment and referrals. Now, sex hormones and thyroid hormones directly affect the voice, and thyroid gland disorders are the commonest among the endocrine disorders which affect the voice. And among the thyroid disorders, hypothyroidism is the most common thyroid gland disorder which affects the voice. Now, coming to the burden of the disease, around 42 million people in India suffer from various thyroid-related disorders. Around 11% of Indian population suffers from hypothyroidism, and 1/3 of these patients are unaware of their condition. Every 10th diabetic patient is hypothyroid. Around 44% of the pregnant females in their first trimester are hypothyroid. Such a burden of disease is there of hypothyroidism. That's why I choose that topic. And how the hypothyroidism affects the larynx. It is an end organ target for thyroid hormone, and it affects by the deposition of prostaglandins in laryngeal and respiratory muscles, presence of mucopolysaccharides and fluid accumulation in ventricular folds, paralysis of the vocal cord, and neural edema of the vagus nerve. Now I'll be displaying a voice of a hypothyroid lady. From last 10 years, she is a hypothyroid and currently on treatment or hormone thyroid replacement therapy, and her TSH levels are under control. I'm sorry, there is some issue with the media. So how the impact of how it impacts the phonation? How the hypothyroidism impacts the phonation? It's a gradual hoarseness on following progressive pattern with a low pitched voice rough and respiratory, rough quality of voice, and decreased range of motion, along with the focal fatigue. We choose the topic because of profiling and documenting the voice change in hypothyroid patient with the burden of disease we are having for understanding the pathophysiology and further management. What we did, we took a cross-sectional observation study among 25 patients. We included a patient with a history of hypothyroidism at least for 1 year or more for within age groups of 20 to 75 years. We excluded all the patients with a newly diagnosed hypothyroidism undergoing recent surgery, vocal pathology like vocal lesions, paralysis, allergic rhinitis, asthmatics, and systemic illnesses, any confounding factor with the hypothyroidism. What we did, was detailed history using a questionnaire, the complete physical examination with a special emphasis on the fiber-optic laryngoscopy, and voice assessment was done. Voice assessment was done under two headings, with subjective assessment by the patient using a voice handicap index and subjective assessment by the clinicians using a GRAP scale. These are scales we have used. They have already explained in earlier part of the day. I will be just briefly touching upon them. Coming to the results, we have among the 25 2 males and 23 females. Mean age was around 47. Coming to the subjective complaints, around 80% of the patient complained of change in voice. Vocal fatigue was seen in around 36% of the patient and lump session around 28% of the patient. The VHI index is self-questionnaire which is filled by the patient. It has got 30 items and we mark it from 1 to 4. So the total score is 120 and it has got three parts, the physical, functional and emotional. In our part, the average mean score of physical was around 12, functional 7, emotional 5, and total score was around 25 out of 120. So indicates all domains are affected and the organic domain is the most commonly affected in hypothyroid patients. GRAP score was given GRAP score has got 5 components and this scale we have from 0 to 3. And 0 is normal and 3 is extreme or severe. The grade gives a general idea about the voice. Roughness gives the irregularity of vibration. Breathiness gives a degree of air leakage. Asthenic is lack of power. And strain is the acoustic impression of hyperfunction. In our study, we found around 100% of the patient has an abnormal grade with a moderate amount in 60% of the patient. Roughness was around in 90% patient with 60% in moderate variety. But breathiness around 84% of the patient with 44% in mild variety and asthenic around 54 again in 72. So grade and roughness are more commonly affected than breathiness and asthenic variety, while strain was abnormal in around 60% of the patient. So coming to the conclusion, to summarize the results, a comprehensive voice analysis was conducted in 25 patients. Subjective problem was seen in around 80% of the patients. Perceptual evaluation of voice using GRAPS concluded change in voice or hoarseness is one of the cardinal features of hypothyroidism. And VHI indicates the organic domain most commonly affected. Discussion I will be just skipping, we have already covered this part. So, in all the pre-surgical voice assessment, subjective assessment should be done by patient, subjective assessment should be done by clinician, and objective method should be included. So concluding remarks are, hypothyroidism can affect any part of speech subsystem, creating a speech and voice even after thyroid replacement therapy. Comprehensive voice analysis should be done at regular interval to early diagnose and start management at earliest. Voice-related findings can be attributed due to mixed edematous infiltration of laryngeal tissues, nerves, or muscles. We need to have an educational program, awareness among the different specialty of clinician, and further research about these conditions, especially the endocrinologist and physician should be made aware of these conditions. And whenever we are treating with the treatment of thyroid disorders, other than the drug therapy and surgical intervention, rehabilitative intervention of voice should be taken into consideration. The limitation of study was sample size was small, acoustic analysis could not be done, and long-term follow-up of voice was absent. These are my references. My special thanks to my teacher and mentor, Professor Nitin M. Nagarkar and Mona Lisa, and our speech language therapist. Thank you, everyone. Stay home, stay safe.
Thank you, Dr. Ripudaman. I now request Dr. Shama to come and present her talk. Dr. Shama is a consultant at Kokilaben Dhirubhai Ambani Hospital, Mumbai. She's also an executive member of APSI with a special interest in voice and swallowing. She has been fortunate to train under Dr. Nupur Kapoor Nerurkar and Dr. Belavsky. She will now present her talk on transnasal esophagoscopy.
Can you hear me?
Yes, ma'am, you're audible.
And
Yes, ma'am, your screen is showing, it's showing a slide on advantages of.
oh yeah, it's not moving. Just a second. I think I'll have to go back and. Yeah, now you can see.
Yes, ma'am, now we're on the first slide.
Oh God, when I do the slide share, it's going into the, okay. All right. Good evening, everyone. I'm Dr. Shama Kovre. I'm going to speak on transnasal esophagoscopy today. So transnasal esophagoscopy is a new tool in the armamentarium of a laryngologist. We have been clashing with the gastroenterologist as far as esophagoscopy is concerned. So we heard Dr. Chetri talking about transnasal esophagoscopy or TNE as an office procedure in the morning. We also heard some pearls of wisdom from Dr. Jayakumar Menon in the dysphagia symposium. Why has that come to us is because we are doing it as an office procedure. We are not using any kind of anesthesia or sedation, so it becomes a comfortable in and out procedure for the patient, as well as it is very cost effective. As there is no sedation or there is no anesthesia involved, the complications are very less, so the patient is comfortable with that. So how do we decide that TNE is required for a patient? So esophageal examination is needed when a oropharyngeal swallow is normal in a patient complaining of dysphagia. When you say oropharyngeal swallow is normal, is either we do a face and see that there is no issue in the upper, in the first and the second part of the swallow, or we have done a VFS to see, or a dynamic swallowing study to see that there is no issue with the oropharyngeal part of swallowing. So we need to examine the esophagus. What are the indications when you come to see when we need to do the TNE? So dysphagia, as I said, mainly non-oropharyngeal. So GERD is gastroesophageal reflux disease, when a patient comes to you with a burning sensation or a feeling of something stuck, or dry cough, which mainly increases on lying down. As a screening procedure for a Barrett's esophagus or carcinoma, to evaluate if a patient comes with a complaint of not able to swallow, evaluate stricture post-total laryngectomy. Globus is again a very big issue, part where globus can be presented in cases of cricopharyngeal achalasia or a cricopharyngeal spasm, abnormal visceral sensation, esophageal dysmotilities. As a part of evaluation for chronic cough can be a presentation of an cough variant of asthma in cases of GERD as a neurogenic cough. So we have to find out if there is anything in the esophagus which is giving rise to chronic cough, part of a pan endoscopy. So it has become a very easy procedure to do a pan endoscopy instead of taking the patient into the OR. We can do biopsies in the OPD, and like Dr. Chetri said, that it is difficult to give Botox injections or injections with the help of TNE, but yes, we can do it. In TEP failures, or if TEP is facing any issues, we can also diagnose them with the help of TNE. So how is the procedure done? I generally do it either in a sitting position or a propped up position if the patient is an indoor patient. Under topical anesthesia, nowadays we use pledgets. I give viscous gel. When the viscous gel was banned, we used to have 10% xylocaine spray. The procedure is thoroughly explained to the patient. There is an assistant to help the patient to be very comfortable. Xylocaine jelly is used over the scope, and we need to have endoscope, camera, and monitor. So as Dr. Chetri said in the morning, I'm insisting on the fact that he said that it's a very costly affair and it's a very costly instrument. Even Dr. Menon said it. So we don't have a transnasal esophagoscope in our institute. What I use is a bronchoscope. So I use a bronchoscope for doing transnasal esophagoscopies, either an adult or a pediatric bronchoscope. And the channel, which is the working channel, is used as an insufflator. So what I do is, when we are doing a procedure, assistant is with a infant feeding tube connected to the oxygen, and which is passed through the working channel, which acts as an insufflator when I'm doing a TNE. So as this is an indoor patient, the patient is in a propped up position, and when we go to the cricopharyngeal joint, that is when we ask the patient to flex, so to come in a chin tuck position. So this is a normal TNE, which I've just come. You can either go directly to the cricopharyngeal opening, or you go into the pyriform fossa. You just ask the patient to have a dry swallow. If the patient is not comfortable with having a dry swallow, then what you do is you give a sip of water. That is what we give. We give a sip of water, and you see that the cricopharynx just opens up, and the scope just goes in. So as you can see in the video, we have, in this particular patient, we are having a little trouble in entering the esophagus, but this is what is the most important step in endoscopy. This is what is the most important step in the scopy. In the other other video, we can see that we are easily able to go maneuver up to the lower esophageal sphincter. At the lower esophageal sphincter, you can just insufflate the air so that it just opens up, and wait for the lower esophageal sphincter to open up instead of pushing the scope in. So are there any contraindication? No absolute contraindication, except for presence of diverticular coagulation disorders and if it's an uncooperative patient. Complications are epistaxis, vasovagal reactions in some patients. So we have to have a crash trolley ready. So we have it in our endoscopy suite. Inability to perform procedures, that is, if we are not very confident or we are not very trained in the procedure, that is when a complication can occur. So this is a video of hiatus hernia. The only a disadvantage of using a bronchoscope is we cannot use a we cannot retroflex the scope. So we are going through and you can see that there is a small hiatus hernia there. This is a patient who had come to us with difficulty in swallowing, a young girl, a 16-year-old girl, and her hemoglobin was around 8. We did a scope TNE, and what we could find was a web. So this is like a Plummer-Vinson syndrome. This is another web, but this was not very, this was again a patient who was, but a very, 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 it was like a thickened mucosa or a web, we were not sure, but the patient did benefit with dilatation. This is a patient who came with burning sensation, difficulty in swallowing.
I'm sorry to interfere, Shama ma'am. We are running short of time.
We are done. So this is esophageal web, and this is eosinophilic esophagitis. So treatment options are discussed above. So it's a learning curve. We have to start slowly. We need to be gentle so we can keep calm and carry on. Thank you so much, Mahima.
Thank you, Shama ma'am. We now proceed to the next talk, which will be by Dr. Mohan Reddy. Dr. Mohan Reddy is a senior ENT consultant and laryngologist with 35 years of experience in ENT. He's the founder, chairman, and chief ENT surgeon at Nova ENT Hospital, Hyderabad. He's one of the pioneers of endoscopic ear surgery at the world stage, with special interest in minimally invasive endoscopic techniques in ENT. I request Sir to please share his screen.
Yeah. Can you see the screen now?
Yes, sir.
Thank
So
you.
you're audible and your screen is visible.
Thank you very much, Mahima, for the wonderful introduction. So my aim today to present this, my novel endoscopic endolaryngeal interventions is, it's out of my own personalized experience since 1990s. And this kind of paper, which I presented in the Bhubaneswar National Conference way back in 2005 or 6 or somewhere in that time. So some of the presentations today I could see, already mentioned some of the techniques which I used to do. So the idea is we have the different kinds of laryngoscopes even now. So the endoscopic, this is the era of endoscope, and it has come for the nasal and sinus surgery, and I was one of the first few to take up. And without background of experience of using endoscope since 80s, I have been using it for ear and larynx, and this is my personalized experience of over a period of more than 15 years. So even now, as we see different models of endoscopes, including the Storge video laryngoscope, in my experience, I found the difficulty in certain number of cases, even now with whatever available laryngoscopes. Then I was the first person to use the Macintosh laryngoscope and use the endoscope, and the robotics have come. So my experience, I want to present with few cases now. So I coined the ELS term, endoscopic laryngeal surgery, presented in Bhubaneswar in 2005. So the obvious, the advantage is, it is so easy to manipulate the endoscope using endoscope and get the good exposure of the entire laryngeal commissure and all those things without any big strain to us or without causing a strain to the patient, as in the microscope. So I will present a few cases of videos of some cases, early cases, intubation granuloma here, where I use the regular Klein-Sasser's laryngoscope and I could get the exposure. But I could not manipulate the instruments and those things. Then I tried. These were the first few cases in the early stages, which how I managed. So I passed the endoscope through the laryngoscope and instruments also through the laryngoscope, and I saw that like that. And I used the four regular microlaryngeal instruments, and I could manage in this way. See that this probe, you can see, this is my own designed probe with the insulation. So I could use that probe, long probe with the insulating with the tape. This is the tape, a regular adhesive tape which we use. 1 centimeter wide tape, you can insulate it and you can neatly remove it like that. So in certain cases, see how nicely you can use without any bleeding and all. So there is another case, endoscopic laryngeal surgery by video laryngoscope. That is Storge video laryngoscope. After the Storge laryngoscope has come, so I made use of it. So with a regular Klein-Sasser laryngoscope, this is the kind of exposure we get. But with the Storge laryngoscope, as we know now, many of us are using it, and we can get a beautiful exposure with the 2 hands free. We can use the cold instruments and we can use the lasers, either CO2 laser or carbon dioxide or diode laser, whatever. I use most of the times my cold instrument with effectively, and I use my dynamic movements of my hands, and sometimes use the cold instrument forceps alone, or sometimes both forceps and the scissors to remove such kind of a tiny polyps, benign lesions, and we can get such beautiful results. And this is again a Storge laryngoscope where we'll get it. So now, wherever possible, wherever we get good exposure with the Storge laryngoscope, I feel it's the best scope, and we can use both hands. But sometimes in storage laryngoscope also fails in difficult larynx cases. So then I learned how to manage it by using the regular laryngoscopes. We get the exposure like this. In few cases, we used to manage like this through the laryngoscope. In few cases, fix the laryngoscope beak beyond, anterior to the epiglottis, at the base of the epiglottis, under the tongue, and lift it. I pass the instruments from below the epiglottis with a good exposure with the endoscope passing from behind the laryngoscope, and then we could reach the benign lesions like that very easily. So like that. But what we need is a curved instruments like this. Like this, we should have a bent. Initially I have bent the regular forceps which are available to reach that areas with the exposure we get, and then successfully we could do it. So this is another case where I have found the McIntosh laryngoscope using my best laryngoscope now, I feel. For all my works, 80% of my works with the larynx now, endolaryngal procedures, I use the McIntosh laryngoscope, and I have designed my instruments. There's an 80 plus year old man with a malignant lesion. What we need is a biopsy. Earlier, with regular laryngoscopes or plain saucer laryngoscope, we have to extend the neck, and medical conditions, spondylosis, all those things, which were the dangers in such patients. And it is very easy now with fixing the laryngoscope at the base of the epiglottis below the tongue. We can reach the growth easily and without causing much strain to the patient and take the bath. These are the instruments which I found very useful. This is how I have bent the instruments and I have been using them. Among them, this different forceps. And these are the insulated suction cannulas, bends, multiple double bends. This shaft, please notice the shaft of the instrument. I have designed and got it done with these Santosh fellows. The straight shaft is most useful because we can handle, the handle we can pass onto our wrist, and we can have a good rest of the instrument. So these are some of my experiences with these instruments, special instruments. So I use the different kinds of instruments. And for the small infant, I use my own thumb as a laryngoscope with a little sedation. After sedating the baby with the sevoflurane, I can see how I use my thumb once the anesthetist leaves the baby to her. See how we can see how we can use our own thumb as a laryngoscope and get a good exposure to evaluate the airway problems in babies. So nicely we can see the larynx with a good exposure. And nowadays, recently I've come across these cases, post-corrosive laryngopharyngeal stenosis, and I have managed using the endoscope transorally reconstructing these stenotic segments, both the pharyngeal, supraglottic, glottic, and both hypopharyngeal stenosis cases. So the Harpic being available in every house, people are, I think, youngsters using that as a suicidal attempt, and they are coming with this kind of picture with a feeding jejunostomy and tracheostomy sometimes, with the airway and both esophageal swallowing got affected. I've come across with my good friends with the gastroenterologist, they refer. These are the kind of different synechial bands you see in the hypopharyngeal level, sometimes oropharynx, sometimes at the level of the palate. These kind of cases we come across. And this is one of the cases I managed using the McIntosh laryngoscope and co. And my insulated electrosurgical probes. I have first I see the larynx, glottis, airway, how it is, and then evaluate the pathology. And then I'm using this insulated probes, which I have designed myself, and using them since 90s, and most effective tool I feel in my own experience. It's a personalized experience. Now in this era of lasers, coablators, and then robots, still I find this instrument very useful for me. And I use coablator.
I'm very sorry to interrupt you. running short of time. Can we quickly wind up?
No, just one more video. I hope
Thank you.
Finish up. So this is, sorry, I will go back to this video because this will be very useful, very interesting. So this case, we can see the laryngopharyngeal stones is there. Both larynx and pharynx got stones. This is how we have to use cold instruments, sometimes with electrosurgical probe to get the reconstruct the airway. And finally, I have to design the flaps in this stenotic pharyngeal and laryngopharyngeal stenotic bands. By incising those stenotic bands, you can design the flaps in the pharynx, and sometimes the epiglottis tip will be necrosed, and entire thing will be got stenotic. So design the mucosal flaps in the available pharynx, and sometimes I cut the pharynx epiglottifold or in the epiglottis partly, and then design and put the silicone tube there as a stent. And I got ultimately the airway. And the using cold instruments, the laryngopharyngeal flaps are created and to prevent restenosis. This is how I could successfully do this post-corrosive laryngopharyngeal stone presented in France, this paper. And this is the outcome. So my conclusion is, in this era of various kinds of tools, lasers, coablators, robots, and various kinds of that, still we have to be in a position to use whichever tool suits for the particular situation and particular pathology, including the cold instruments, personalized instrumentation, everything you have to make use of it to have a successful outcome in a particular case. So thank you very much for the organizers, and thank you, Phanindra, for giving this chance.
Thank you.
Thank you.
Dr. Reddy. I now request Dr. Sabrina to share their screen for the presentation. Dr. Sabri is an associate professor at Azizia Institute of Medical Sciences and Research at Kollam. Dr. Sabri will be talking about transglottic interarytenoid angle in planning surgery for unilateral vocal fold paralysis. Do we have Dr. Sabri with us?
Dr. Sabrina, your mic is mute and your video is also off. Yeah.
Is he here?
Yes, sir. I can
Yes.
see him.
Yeah, we can see him.
Can you see my screen?
No, we can't. Have you done the slide share? Dr. Sabrina, have you done your slide share, screen share?
It's
We can't hear you. Sorry?
Hello?
Yeah, now we can see it. Yeah.
Can you see this?
Yes, now we
it has come. Carry on.
Yeah. Good afternoon. We will discuss today about the transglottic interarytenoid angle in planning surgery for unilateral vocal cord palsy. About 2.57% of the patients with voice complaints who are coming to the laryngeal voice clinic will be having unilateral vocal cord palsy. The most common cause of unilateral vocal cord palsy being idiopathic, which is followed by surgery and many other causes. We need to predict the outcome of the surgery, and if we predict the outcome, then only we can, it will aid in the decision making regarding the type of surgery needed, whether it's thyroplasty alone or injection laryngoplasty, or whether we need to go for thyroplasty with arytenoid rotation also. And the timing of intervention is also very important. At present, we are making the decision regarding the type of surgery, that is mainly whether we need thyroplasty or thyroplasty with arytenoid rotation based on the table. We will first do a thyroplasty and then only decide whether we have to go, or after assessing the voice, we will decide whether we need to do a arytenoid rotation also. The factors which may interfere with the type of surgery needed. This type of surgery which I mean is whether thyroplasty or thyroplasty with arytenoid rotation. They are mainly vertical level of vocal cords, arytenoid asymmetry, phonatory gap, and the time of presentation by the patient. Now we will see the vertical level of vocal cords. it can be either at the same level of the vocal cord, or it can be higher than the normal or lower than the normal. Arytenoid asymmetry, when we are telling about the arytenoid asymmetry, when the duration or time of presentation is more, there will be more asymmetry that is seen in the clinical practice. So how we will determine the transglottic interarytenoid angle is, you can see the green line, which is transglottic line, and the blue one is in the interarytenoid line. The point at which these both lines meet just in front of the arytenoid is taken, and it is that angle is measured. So, for example, you'll draw an angle with these 2 points, and you'll get an angle. And the phonatory gap is scored in sections of 3. That is, you will measure the length of the vocal cord, and it will be divided into 3. The 1/3 part is taken as score 1, 2/3 is score 2, and full length of the vocal cord is, or more than that, is taken as score 3. The aim of the study was to predict the apt surgical correction for unilateral vocal cord palsy with preoperative laryngoscopic examination. The objective is to determine the prognostic value of video laryngoscopy in predicting the apt surgical correction for unilateral vocal cord palsy. And we did a retrospective study. The methodology was, it was a retrospective study of 37 patients whose preoperative video laryngoscopic videos were available. These laryngoscopic videos were taken, and it is used to measure arytenoid asymmetry, phonatory gap, and vertical incompatibility. And while measuring this, 3 laryngologists were involved, and the opinion by the 2 is taken into consideration. If there was an difference in opinion, then the 4th one come into view. And coming to the results, the data was expressed in mean plus or minus standard deviation, and it is analyzed with SPSS 22.0.0.0, and paired t-test and chi-square test were applied for statistical significance for finding the critical angle, that is the angle above which we need to go for arytenoid rotation. ROC curve was plotted. And when we analyze the age, out of the 37 patients, the patients were from the age group of 20 to 68 with a mean age of 40.65. And the maximum number of patients were in the age group of 30 to 39, which is followed by 40 to 49. And out of the 37 patients, 21 were males and 16 were females. It shows a male predominance. And majority of the patients were having a left-sided vocal cord palsy. That is, around 29 patients were having a left-side vocal cord palsy. But when we look into the vertical incompatibility, around 11 patients are having higher level, and 20 same level, and 6 lower level. When we analyze the etiology, the most common cause was idiopathic, which was followed by post-thyroidectomy, then post-neck or thoracic surgery, and lateral medullary syndrome. Time of presentation, majority of the patients presented within 1 year of appearance of the symptoms. And for majority of the patients, thyroplasty with arytenoid rotation was done. Thyroplasty was done for 16 patients, whereas thyroplasty with arytenoid rotation was done for 21 patients. And when we saw the incompatibility, that is, we considered both together, that is higher and lower together as incompatible, and the other one is same. For 11 patients with incompatibility, we did thyroplasty, whereas for 20 patients with incompatibility, we did thyroplasty with arytenoid rotation. For the same level, we did for 5 patients thyroplasty, and for 1 patient thyroplasty with arytenoid rotation. That 1 patient was having the lateral medullary syndrome. And when we assess the phonatory gap score 1 was seen for 10 patients with on whom thyroplasty was done, and for 2 patients with thyroplasty with arytenoid rotation, score 2 was seen in 4 patients who has undergone thyroplasty, and 6 patients who underwent thyroplasty with arytenoid rotation, and for score 3 was seen in 2 patients who underwent thyroplasty and 13 patients who underwent thyroplasty with arytenoid rotation. which whose p-value was 0.001, which is highly significant that there's a relation between thyroplasty and arytenoid rotation. Arytenoid asymmetry was taken and the mean angle was taken. For those patients, thyroplasty alone was done. It was 16 patients and their mean arytenoid asymmetry angle was 25.38 with a standard deviation of 13.79. And thyroplasty with arytenoid rotation was done for 21 patients whose arytenoid asymmetry was 43.05 degree with a standard deviation of 11.65, and its p-value is also less than 0.001, which is statistically significant for with the angle. We couldn't find out a correct angle above which we need to go for thyroplasty with arytenoid rotation. So an ROC curve was plotted. With the ROC curve, we reached a conclusion that for those with an angle 37.5 degree or more, you have to go for thyroplasty with arytenoid rotation with a sensitivity of 81% and a specificity of 81%, and it is statistically significant with a p-value of 0.001. Coming to the discussion, when vocal cords are at the same level, thyroplasty alone may be needed. For phonatory gap score of 1 and some cases of 2, thyroplasty alone is needed. When the transclerotic interarytenoid angle increases, the chances of better OIs with thyroplasty with arytenoid rotation is more. For conclusion, we reached the conclusion that thyroplasty with arytenoid rotation is needed when there is a vertical incompatibility, when the phonatory gap is more, when the transclerotic interarytenoid angle is more. And the drawbacks of this study is it's a retrospective study and we need more sample size for predicting the critical angle for thyroplasty with arytenoid rotation. We had only 37 patients, and the vertical incompatibility above or below which in which we need correction cannot be assessed with this statistical data. And we recommend a prospective study with a big sample size to come out with an proper or accurate angle above which we need to go for thyroplasty with arytenoid rotation. These are my reference. Thank you.
Thank you, Dr. Sabrina. That was a very interesting paper. I now request Dr. Anurag Srivastav to share his screen. Dr. Anurag Srivastav is an assistant professor at Sri Aurobindo Medical College and Postgraduate Institute in Indore. He's a senior consultant at BHRC Indore. He was formerly at AIIMS New Delhi and Sir Gangaram Hospital, New Delhi. Dr. Anurag will be giving us a presentation on swallow respiratory patterns and aging, presbyphagia and dysphagia, a diagnostic dilemma in the management.
Yeah, thanks for giving the DAS. Good evening, everyone. Myself, Dr. Anurag. Let it just come. Are you able to see the screen?
Yeah, the screen's visible and you're audible.
You need to slide share.
Oh, yeah.
The slideshow. Put on the slideshow.
Yeah. Yeah. Now is it fine? Yeah.
Yes.
So good evening, everybody. So today I'll be discussing a very controversial and confusing topic: swallow respiratory patterns and aging, presbyphagia or dysphagia, the diagnostic dilemma and the management patterns behind it. Coming to introduction, the presbyphagia refers to age-related changes in the oropharyngeal and esophageal swallowing of healthy adults. The prevalence of dysphagia increases with age, making dysphagia a major health concern in elderly patients. And although there is subtle variation in swallow process due to aging that exists, but the overall coordination of the swallow is well preserved. So a good health is maintained in the presence of a disease-free presbyphagia, but we should understand that the presbyphagia is not equal to dysphagia, and same is the management and same is the approach. So healthy aging is not a culprit. The oropharyngeal swallowing changes with healthy aging. It becomes slower. There is delayed onset of airway protection. The bolus adjacent to airway is longer. Also in esophageal swallowing, there is changes with aging, that there is delayed peristalsis, that there is reduced frequency of secondary peristalsis. So all these lead to a healthy aging process. So can we call it a disease process? So the factors such as the following can predispose to dysphagia or aggravate the condition is basically the poor dentition, the atrophy of the tongue, the alveolar ridge, and the diminution of the taste and smell sensitivity. There is decreased muscle tone also. There is increased ligamentous laxity. All these lead to the dysphagia problem. So coming to the research question, it is unclear if this is due to more impaired swallows or whether there is healthy age-related changes. The swallow respiration coordination patterns, the aspiration and may deteriorate with age. The non-pathological features of swallow in healthy aging and the factors that influence an individual's ability to eat and drink safely that needs greater understanding. The changes in the swallowing pressure and the laryngeal movements with aging is in relation with the movement of the hyoid, and that leads to the relaxation of the upper esophageal sphincters. The superior laryngeal movements protects the lower airway, and as a result, this movement further relaxes the upper esophageal sphincters, and that makes the system that prevents the aspiration to happen. So this is a small animation I would like to share. If it can come. There's some technical issue. There is an increase in unclassifiable swallow that suggests a delicate change in the swallowing respiration coordination. And there is subtle variation in the swallowing process due to aging. Dysphagia rehabilitation in elderly is very important because the part of the decline in elderly swallowing mechanism, it is related to the sarcopenia and the age-related loss of skeletal muscles. We can see that there are various phases, and there is oral phase, the transport phase, the pharyngeal phases, and the esophageal phases of swallowing. And so is the we can see the bolus movement also. It happens in horizontal pattern and the vertical pattern. So in all this cumulative leads to the problem and the process of the presbyophagia and dysphagia, because the bolus movements is very important while the patient is aging. And the diagnostic algorithm in general for dysphagia is that we follow the general history and examination pattern. If it is sudden onset problem, and along with that there is night cough or gurgling present or not, and there is gradual worsening of symptoms or not. So we use various tools in the armamentarium. There esophagoscopy is used, barium swallow is used. So this is the approach for a general dysphagia patient. Along with that, GERD is also a menace. It interferes with the aging population as well as in the dysphagia condition. So taking care of the GERD is also very important. So various objective measurements that includes are pressure, range, strength, movements of swallowing apparatus, and the bolus flow that needs to be objectively quantified and studied properly for understanding the presbyophagia and dysphagia in the elderly. So research suggests that in senescent swallowing, the changes occur even when the patient is healthy aging. It depends on various stresses like the altering medications, the mechanical perturbations due to nasogastric tubes or tracheostomy, and other chronic medical conditions like frailty. Now, this graph depicts the complex interaction between genetic factors, the environmental factors, physical activity, the nutritional status, the malnutrition that leads to further the frailty of the patient, and that this malnutrition further enhances the process of dysphagia and further weight loss and malnutrition and frailty further. So this link, malnutrition and senescent swallowing link, is a vicious cycle. Once the patient gets stuck in that, it is difficult to take it out. So we need to approach the patient with very delicate hands. So what is the new normal? The new normal is there is a small body of knowledge on how the healthy swallowing changes with age. So we need to increase the awareness of what is normal for the patient as he gets older. So we need to modify our thinking that suppose are all of the changes we observe in an 85-year-old post-stroke patient due to dysphagia, or simply it is dysphagia, or it is a simply oropharyngeal presbyophagia. That needs to be understood. So effect on aging on muscles is basically, it's again controversial. Some hypotheses say that muscle disuse comes with age, but another hypothesis and studies say that the muscles of speech, swallowing, and respiration continue to be used in elderly in approximately the same degree. So this is again a controversial point. The interventions and paradigms are basically rehabilitative and compensatory approaches that are used, and that includes the modification of environment, patient's position, texture of food, etc. The indicators of functional research are basically the difference between the maximal lingual isometric pressure and the peak swallowing pressure. So this relation also needs to be properly understood, as it is acting as an indicator for that. So the age-related changes in the generation of lingual pressure also defines presbyophagia. So the theoretical speeding of the elderly patient swallow can be detrimental, and it can be counterproductive. So we need to understand that as well. So that results in insufficient swallow pressures, and therefore it's contraindicated. So the difference in swallow function for elderly versus young depends on various complex interaction of the central and the peripheral mechanisms. And that's why the clarification of neural underpinnings of age-related changes needs to be understood. Also, various literature suggests that the improvement in swallow function follow the performance of tongue exercises in combination with other factors. Now, tongue exercises have been being recently considered a very reliable additional help to improve the plight of the patient. And same is the strength training exercise that helps holds up promise.
Dr. Anurag, sorry to interrupt you. 1 more minute to go.
Yeah. So that holds the promise for the prevention of age-related dysphagia. So treatment of dysphagia also includes the compensatory techniques that it involves the elimination of the symptoms or adverse sequelae of the dysphagia. There is limited evidence that oral care can reduce the risk of developing pneumonia, but postural changes such as chin down position, head turn, effortful swallowing may help the condition of the patient. But still, research is needed to elucidate the benefits and risk of this practice. Further research is needed to improve the impact of the compensatory approaches. The rehabilitative interventions also help in improving the biomechanics of swallowing through strength skill-based treatment paradigms. Swallowing maneuvers like Mendelssohn's maneuver, wherein patient is instructed to voluntarily hold the larynx in the uppermost position for 2-3 seconds and while completing the swallow, and that needs to be seen properly. So various recommendations from literature suggest that we need to understand the pharyngeal residue as well as a predictor for dysphagia, and also take care of the medical condition of the patients. So as the conclusion suggests that as the population ages, the strategies for treating elderly persons with dysphagia will be of crucial importance. Research into the underlying pathophysiology of age-related swallowing disorders is very critical and is trying to create interventions with sound scientific basis. And at the present state of knowledge, we need to do more randomized controlled trials and to understand systematically what interventions we need to do for the patient. So in the end, one thing that never fails is the importance of collaboration in dysphagia management. And for that, interprofessional team partnership and engagement of families and caregivers is very important for the diagnosis and treatment of the patient. With that, I will sum up my presentation. Thank you.
Thank you, Dr. Anurag. The next presentation we have is by Dr. Adarsh S. Pillai on the surgical management of ADSD, a beginner's dilemma. Dr. Pillai is an assistant professor in the Department of ENT at Pushpagiri Institute of Medical Sciences at Thiruvalla, Kerala. I request you to please share your screen. Yes, it's visible. Your screen is visible.
Good evening, everyone. Thank you for the opportunity to talk before you. I am talking about the surgical management of ADSD, a beginner's dilemma. Coming to the background, dystonia is a movement disorder characterized by sustained and intermittent involuntary repetitive movements. Spasmodic dysphonia is a form of idiopathic focal dystonia of the larynx. The disease was first described by Traube in 1871. There are two types. One is the adductor form, which is very common, and the other form is the less common, abductor type. Coming to the evaluation, the diagnosis of adductor spasmodic dysphonia is more or less clinical. I have a very short experience of 2 patients seeking me for a surgical management of the ADSD, and the history was typical. They presented to me with a very strained, strangled voice. For the past 10 to 15 years, it was progressive in nature. It is more or less a disease of the elderly, and it is more common in females, but both my patients were males. We have certain auditory perceptual features that gives a clue to the diagnosis. which is one is the strained, strangled voice, and which will be task specific, and characteristic voice breaks will be there, and it will be more pronounced during sustained vowels and voiced consonants. This is an auditory clip of the patient. Coming to the examination, the maximum phonatory time, MPT, will be prolonged in the case of ADSD, but not always. If it has a compensatory MTD associated, sometimes the MPT might be decreased. The flexible laryngoscopy of this patient whose voice handicap index was very severely handicapped, that is 82, showed that there was spasms happening in between when the patient is trying to adduct his vocal cord. The GRBAS score also helps in assessing the strain, which stands for grade of hoarseness, roughness, breathiness, asthenia, and strain. Now, I would like to talk about some coexistent condition that makes the diagnosis even difficult. My first patient had a coexistent muscle tension dysphonia and a vocal tremor in the background of ADSD. Now, these are conditions that can coexist or make the diagnosis difficult. Now, I would say the ADSD is more or less what you hear, and muscle tension dysphonia is more or less what you see. Now, vocal tremor can be differentiated from ADSD by doing a flexible laryngoscopy and other clinical examinations. Coming to the treatment, yes, Botox injection has been the gold standard treatment for the treatment of ADSD, but the disadvantage is that it is repetitive. The patient will have to take the injection once in a while because the results are temporary. Now, when they seek you for a definitive treatment, these are the surgical options that you can offer, among which the thyroarytenoid myoneurectomy is my favorite because the results compared to the type 2 thyroplasty is more promising, and selective denervation, reinnervation is a more complicated procedure. Now, I preferred an external approach. Thyroarytenoid myoneurectomy is basically a procedure where you make a window in the thyroid lamina, you identify thyroarytenoid muscle, and selectively cut off the nerve to the thyroarytenoid, which is basically the major cause for that adductive spasm happening in the background. Now, before proceeding to the surgery, we should be well aware with the surgical anatomy. One of the largest studies conducted proves that the intralaryngeal course of RLN is more or less stable. Now, it divides into two branches. The posterior division supplies the posterior cricoarytenoid and intraarytenoid, and the anterior division further divides into a proximal branch that supplies the lateral cricoarytenoid, and the terminal branch enters the thyroarytenoid. It can be a single branch or it can be multiple branches. Now, the window should be centered in such a way that the entry point of the nerve should be identified. It will be more or less between 20 to 25 millimeter in the horizontal plane, measured from the midpoint of the midline anteriorly, and the joining point of a vertical line from the inferior border of the thyroid cartilage, somewhere between 4 to 6 millimeters. The basic thyroplasty instruments are what you require, and also an operating microscope. A training in neck surgeries and laryngeal framework surgeries would help you go ahead with the procedure. Coming to the procedure, a horizontal incision was made at the lower border of the thyroid cartilage. The thyroid lamina was exposed on both sides, and a window was taken. Before that, measurements were made and inferior border of thyroid was marked. A window was made in the infraposterior aspect. This is comparatively posterior to what we make in thyroplasty, and drill was required in this case because the patient was elderly and the cartilage was calcified. Unlike thyroplasty, you'll have to excise the perichondrium to expose the thyroarytenoid muscle, and posteriorly, when you split the muscle, you can identify the nerve branch to the thyroarytenoid, and that is what you're going to selectively denervate. I used a needle hook cautery to hook the nerve first, to cut it and cauterize the surroundings, followed by use of bipolar cautery to cauterize the lateral aspect of the muscle. And the abgel was placed in the window, and this is the wound just before the suturing. Coming to the results, the short-term results are very promising. I don't have much cases to claim in my name, but from whatever results I've got, I'm satisfied. This is the patient whom I told had both ADSD and muscle tension dysphonia. His BHI was 86. This video was taken at 3 months post-op. after treating his muscle tension dysphonia, which was more obvious after the surgery. This is before the surgery. This is after the surgery. You can see that the VHI has significantly come down to 22 from 86 at the end of 3 months. This was my second case. This patient had more or less a pure form of ADSD. His VHI was 82. And the post-op video was taken at 4 weeks post-op. The VHI had dropped from 82 to 36 at 4 weeks. He is yet to come for the 6 months follow-up. The other patient at 6 months follow-up had a VHI of 60. Now that tells something that the thyroidectomy myoneurectomy has shown to significantly improve the voice quality and decrease the strain associated with ADSD. At the same time, I respect the learning curve and I don't have any long-term results to claim. So it is important to ensure that the course of action is not merely based on a hunch, but well-informed and calculated evaluation of the situation and possible outcomes. So the recommendation is that more clinical studies need to be conducted to evaluate the cost effectiveness of the surgery, the patient satisfaction, and improvement in the quality of life in the long run compared to the other available modalities. These are my references. I would like to thank all the organizers of Phonocon for giving me this opportunity, and a special thanks to my mentor, Dr. Jayakumar Menon, sir, who's the reason I am a laryngologist today. Thank you. Thank you so much.
Thank you, Dr. Adarsh, for very well adhering to the time limit. Last but not the least, in the consultant paper presentations, we have Dr. Vidyadharan. He will be presenting challenges of dysphagia management in head and neck cancer patients. Dr. Vidyadharan is a consultant in head and neck surgical oncology at Apollo Proton Cancer Center, Chennai. Over to you, Dr. Vidyadharan.
Thank you, Dr. Mahima. Can you hear me and see the slides?
Yes, we can.
Oh, yeah. Thank you. Thank you, Gauri. So my topic is, good evening, everyone. My topic is challenges in swallowing rehabilitation of head and neck cancer patients. I would like to thank Dr. Amitabh sir, Phanindra Kumar sir, and the members of the APSI and Dr. Jayakumar Menon for this opportunity. I'll go straight away to the presentation. So dysphagia is a recognized problem in the treatment of head and neck cancer. It greatly affects quality of life and survival. It can affect up to 75% of the patients with head and neck cancer, even sometimes before the treatment, and also prolong after the treatment. And interventions such as surgery and radiation therapy can cause predictable disturbances in swallowing function, which could be temporary or long-term, and so patient would have a defective quality of life. So besides my own understanding of these challenges, and to get a better idea, I did a small survey using these two online platforms, and I had a list of 12 questions and had 62 respondents who were mainly speech and language pathologists and laryngologists. So I'll be discussing this survey and highlighting the challenges and also analyzing the results along the way. So I classify the challenges as the challenges faced by the diglotologist, the patient, and the patient's relative or the carer. And I've given them each a color, designated a color. So you will see these colors along the slide. So you can understand that for every question, these are the challenges faced by either of these factors. So the survey started off by asking the respondents about the percentage of the head and neck patients they encounter in the diglotology practice. And a majority of them said that they encounter about 25 to 50% of their practice are head and neck cancer patients. So if you actually see, head and neck cancers are slowly increasing in India. The incidence has been increasing in India. And in fact, oral cancer is the third most common cancer in India. A couple of years ago, it was the sixth most common cancer. However, patients still present, over 60% of these patients still present at the advanced stage, necessitating multimodality treatment. So that's a big challenge. The volume of the patients itself is a big challenge. So it causes challenges in resources, which is our staff, in costs for the patient and also for the care of frequent hospital visits. The next question was to check whether the digitalologist is a part of a multidisciplinary team, and about 94% of these respondents said yes. So this is important because it provides, being a part of a multidisciplinary team, you can focus on providing this continued input, starting from beginning of the treatment till the follow-up and long-term follow-up. So this is essential for maintenance of voice and a safe, essential swallowing function after the treatment. And many of the international multidisciplinary guidelines for swallow rehabilitation recommend that patients should have a pre-treatment speech and swallowing assessment. And also they would need to undergo a program of prophylactic exercises before they start the treatment, so they continue and keep maintaining their swallowing function. So by being a part of the multidisciplinary team, you can have frequent access to the patient and you can enforce these things. So the question number 3 was, is there an adequate communication between the referring clinician and the diglotologist? And of which about 85% said yes, there is adequate communication. And the reason for this is that if you don't have adequate communication, there won't be much understanding of the treatment plan and also adjuncts of why the patient still needs a tracheostomy tube or needs to be tube fed. And also you can focus on if there's adequate communication, the patient is convinced that he needs swallowing rehabilitation, then he will be giving a lot of importance to follow-up consultations. And a newer thing regarding pre-treatment assessment, if the treating physician talks about swallowing management as a part of his counseling, then it's easy to convince the patient to get a baseline assessment. Otherwise, patient wonder why I'm eating now properly. Why do I need a baseline assessment? Okay. So question number 4 was that whether do you feel whether the referral has been made at the right time? About 61% said no. The reason is that radiation-induced dysphagia can cause structural, mechanical, and neurological deficits within the aerodigestive tract, and these tend to be permanent in some patients. So I always tell the radiation oncologist or even the patient who undergo radiation to focus on the rehabilitation within the 6 months after treatment. That 6 months is golden period, because after 6 months, the fibrosis and atrophy of the swallowing muscles get more organized and also become permanent. It's very difficult to rehabilitate. So earlier the referral, the better for the patient and for a swallowing specialist also. So the next question was, what percentage of time is your practice based on peer review evidence? And I saw that very few, only 6% said 100%. So there is a chance to keep improving, and conferences and CMEs like this would create more awareness of most recent evidence, and hopefully we practice with peer reviewed evidence. The next question was, is swallowing assessment for your patient multimetric? That means, are you using different type of assessments from patient-rated assessments, clinician-rated assessments, and instrumental examination? 50% said that yes, they use all 3, and the remaining said they use 1 or 2 of the 3. So if you're using only patient-rated assessment or clinician-rated assessment, you might tend to miss out some important findings. And also, you do not get the luxury of biofeedback, which you have with instrumental examinations. So the biofeedback means that the patient can also see what's happening during the swallow, and you can induce certain maneuvers or some strategies during the swallow, and patient can try to see how the improvement is happening, and then they can practice along with that. So multi-parameter assessment of dysphagia allows for better diagnosis based on better understanding of symptoms. Instrumental examinations, which are considered gold standard, objectively assess oropharyngeal swallowing physiology and bolus transit, and we are able to predict adverse health outcomes. So we can say, look, this patient may be at risk. So with the instrumental evaluation, we can convince the referring clinician and the patient that they need to go on a particular type of food consistency or be on tube fed. So we will also miss findings such as silent aspiration, as you see in this video here. So we can see this very easily in instrumental evaluation. Next question was whether the patients are aware of the impairment of swallowing rehabilitation during the treatment, and 58% said no. So this is an important thing, because we need to make sure that patients have realistic expectations of the rehabilitation and also the quality of life after the treatment. And also during rehabilitation, if the patient understands the importance of swallowing rehabilitation, we can help them make them have achievable goals And this leads to better motivation and hopefully improve the quality of life. There are also certain things that referring clinicians have to keep in mind, that when they are counseling for the treatment, they also have to keep in mind that patients with hypopharyngeal and laryngeal cancer have a high degree of pre-treatment functional impairment and considerable degree of aspiration as compared to those with oral cavity oropharyngeal cancers of the same stage. If you think,
sorry, you have 1 minute to wind up.
Sure, madam. Yeah. Thanks. I'll be quick. So the next question was how important diglotologist consultation before and during the course of the treatment. 100% said it's very important. So the swallowing specialist has to attend the tumor board so that when the planning of the treatment itself, they should be present there to give their input. And question number 9 said the patients, how do you believe the patient's carer has to be involved? And for that also 100% said yes, because the carer needs to be regarded as a resource by the hospital staff, and given the key role in enhancing patient motivation, they not only provide practical help, but also give assistance and adherence to a particular type of diet, because sometimes the carer may be the patient relative who cooks for them, and also make sure the patient is compliant with the rehabilitation and does the exercises and the manuals routinely. Does the patient, is comorbidity important? Yes. About 90% said yes. It's because patients with previous comorbidities such as bone problems have problems with posture. They cannot eat correctly. People with high blood pressure have a history of cerebrovascular accidents in the past, so they can have strokes, which wherewith the swallowing center can be affected. Anxiety and depression can cause low complaints to rehab. Dementia, demented patients, you have problem with cooperation with rehab. Diabetes, post-surgery, there could be poor wound healing, and patient anemia have fatigue. So you have to take it slow. So in these situations, rehabilitation gets prolonged. Three more slides. So the next question was, do you feel if there's a need for focused training and certification programs? 98% said yes. And thanks to, India is a very big country with different local culture, different dialects, different habits, 1 billion people. So there is lack of proper understanding of radiation-induced dysphagia among practitioners in oncology and rehabilitation, and there's lack of expertise in dealing with it. So the only recommendation or the only benefit would be telemedicine, CMEs, and conferences, which hope create more awareness. Coming to the last question was, how has the COVID pandemic affected your diglotology practice? About 98% said they were affected. Some said somewhat affected. The rest said very much affected. So from my side is I felt the costs have increased for instrumental examination because for the PPEs. I ended up triaging my patients because I found that some patients I might not do the assessment now, maybe wait for some more time. And the newer set of patients are COVID ICU survivors who have been on ECMO or ventilation, and then post-extubation they've come back and they have their own dysphagia symptoms, which we need to study further. So the limitation of the study was, it is a pilot survey, and we need to a survey which is much larger number of respondents to reaffirm these results and make a statistical significance. So in conclude, early management dysphagia will increase the adherence to the head and neck cancer management protocol during the treatment. So they will not be skipping some radiation days, and they will also have help. That's been reported to reduce the severity of radiation-induced fibrosis and muscle atrophy. So it's pertinent for diglotologists to be working in a multidisciplinary team, and head and neck cancer patient need to be seen by diglotologists earlier during the treatment, if possible, prior to the beginning of the treatment. Counseling for after the pre-treatment assessment is very helpful in making the patient have realistic expectations regarding outcomes of the treatment and motivate them further to cope with the effects of the treatment. And lastly, the role of the carer is vital in maintaining the patient's motivation and compliance to the prescribed diet and exercises. So I'd like to thank you again and acknowledge my appreciation to respondents of the survey, which has gone through WhatsApp. Thank you so much.
Thank you so much, Dr. Vidyadharan. And we have had some excellent talks in this consultant paper session. It was really wonderful. And thanks also to Mahima for conducting the last few sessions. We move on now to the last session for the day, which is the panel on the future of phonosurgery. I'm sure all of the young laryngologists are waiting to listen to this session eagerly. And the moderator for this session is Dr. KK Handa. Dr. Handa is the chairman of ENT at Medanta Medicity in Gurgaon. He has more than 27 years of experience and is an expert CI surgeon in addition to being a foremost laryngologist of the country. Formerly, he was an associate professor at AIIMS, and he has also been the former president of the Association of Phonosurgeons of India and was the association's founding secretary. Dr. Handa has put together here an enviable panel of specialists. We have, of course, Dr. Professor Phanindra Kumar, Dr. Jaikumar Menon, Dr. Nupur Nerurkar joining us, all of whom you have heard today. And joining them would be Dr. Alok Thakur, Professor and Head of the Department of ENT at AIIMS, Delhi. He has been the past President of the Neuro-Otological and Equilibriometric Society of India, past Secretary of the Foundation of Head and Neck Oncology, and the past Treasurer of the Skull-Base Surgery Society of India. He was the organizing chairman of the IFNOS FHNO Delhi 2016 and has received the Shakuntala Amirchand Young Researcher Award in 2002 by the ICMR for excellence in research and has been in biomedical research. Dr. Thakur has been a pioneer of transoral robotic surgery in the Indian subcontinent and has numerous publications with over 2,000 citations to his name and has 10 funded research projects as principal investigator and even has 2 patent applications. Last but not the least, on the panel, we have Dr. Reshmi Nair, a consultant laryngologist at Madhavan Laryngology Clinic at Kochi, the first voice clinic in Kochi. And she's also a visiting consultant at Aster Medicity in Kochi. She has done her fellowship under Dr. Jaikumar Menon and has also been recipient of the Rising Star Award for a young laryngologist at the APSI National Conference in 2014. So I welcome Dr. Handa and the panelists and hand over the session to you, sir.
Thank you, Dr. Gauri. And it is very nice to have a esteemed panel. All the panelists have already been introduced. And the topic is very interesting, future of phonosurgery in India. Now, before we come to the future, let us dwell into the past. Foundation of good future is always an effort put in the past. APSI, all of you know, was first meeting was held in 2004. You are seeing both Dr. Phanindra and Dr. Jaikumar in the photos. And this has been 16 years, year after year. APSI has developed. Annual conferences have been held. And the subspecialty and even the allied specialties of phonosurgery have meanwhile developed. And we have seen improvement in terms of the skills, laryngologist skills, phonosurgeon skill, the quality of surgeries, quality of publications. And each year, things get better. Now, let me start with our panelists. Now, we are in the COVID era. The COVID has taken longer than what we initially anticipated. And probably ENT surgeons, and especially the voice surgeons and laryngologists, are probably the most amenable ones. So let me start with Dr. Jaikumar. In the past 6 or 8 months, has COVID made a difference in your practice of laryngology? And how far are you going now? Are you just seeing patients, or are you seeing select patients? And are you operating all your patients, Dr. Jaikumar?
Hello, yeah, can you hear me?
Yes, I can hear you, Dr. Jaikumar.
Yeah, I was the moment you put the COVID slide, I was expecting that you were going to trap me. Okay. Yeah, it just changed naturally. In April, we know that in March and April, everybody was scared and hardly any surgery was done during that time, except for the emergency. Then after May, it gradually returned, but it was around 15-20%. It was mainly, most of my work was only on cancer or airway. No voice, no swallowing was at that time. But now it is limping back to normal. I will say that it is around 60% of my, and I do now around 60% of my normal work, but still the conventional voice surgeries are still very little. I don't do many microlaryngeal surgery, even thyroplasty. Yeah. But I think airway, cancer surgery, and of course, some swallowing surgery has come back. Regarding the OP, in the first few months, we didn't do any rigid scopy at all. Even now, the number of rigid laryngoscopies means the stroboscopy is less. We still do the flexible scopy, but taking all adequate precautions like the mask, the shield, the gown, and the glove, everything. And I don't actually use the and swallowing therapy and voice therapy has become almost a exclusive video on WhatsApp chat. Physical to the
Dr. Jayakumar, you are losing your sound intermittently.
Yeah, I think, can you hear me now?
Now I can hear. Now we can.
Even after COVID has completely gone, I think our practice is changed forever. I don't think professional voice care and the swallowing therapy will be back to the same as previously. I think more and more video consultation will be done. Now, all my therapy consultations are on video. These are the changes which has happened to my practice.
Now, let me ask Dr. Alok. This is the institutional. Let's take an institutional perspective. Dr. Alok, your laryngology cases?
So as Jayakumar said, we were restricted entirely to oncology for a fair length of time, and even today are largely restricted to oncology because our challenge is also that as an institution, we also provide a lot of COVID care. And that also restricts how much we can handle outside of urgent, semi-urgent care, or how much of the hospital wishes to get involved. But yes, moving on to outpatient procedures, certainly vocal fold injections are back for medialization. Thyroplasty is not back, but vocal fold injections are back, and slowly things are getting back. Benign disease we aren't looking at, but yes, laser dissections and some laryngotracheal stenosis we are back with. With regard to how we conduct our laryngological examination, yes, it's almost fully changed to camera-based endoscopy, and that has required more investment, and yes, largely restricted to flexible scopy.
Dr. Phanindra, how about you?
To be frank, the COVID is still very prevalent in my area. Very prevalent in my area, so I have not started.
Okay.
Not yet started the practice.
It's fine. See,
only we have video consultations.
Right.
Particular patients who need assistance for voice and other problems.
Right. It is perfectly fine. We have to see the perspective of the place we are working. Then secondly, as you said, the prevalence. The third is our own age, any comorbidities. Yes. So it's all right. If somebody is playing safe, it is perfectly all right. And I think we need to be careful before we go into the future. This COVID hurdle has to be crossed. And laryngologists have been hit hard. I think starting from OPD examinations to our OTs, it has affected us. Those of us who are doing also, we are always keeping our fingers crossed. Dr. Nupur, you're also there in the panel. Your comments on this?
The laryngoscopies, like everyone else mentioned, are flexible stroboscopies on the monitor. The volume would be probably 20% of what I normally do. I'm wearing a PAPR for every laryngostroboscopy I do because I'm comfortable in that situation. The surgeries are malignancies, but I have started doing polyps and cysts also of patients who've been waiting for 6 to 7 months and have not improved. I posted a thyroplasty, my first in the COVID era. The first COVID PCR test of the patient was negative, CT screening chest negative. On the day of admission, patient was positive. So the first thyroplasty got thankfully cancelled. But that's what's happening right now. So more of routine work is also starting, but my volumes are about 20% of what they used to be. So I'm just pacing myself, and I use a PAPR in the OR and I use a PAPR in the voice clinic.
So this is the level of protection, and those of us who are doing, I think we have to have full protection. And also the pre-op COVID testing, you'll be surprised. We get about 20% positive patients who are just asymptomatic, routinely pre-op testing done, and about 20% of them turn out positive. Now, going after COVID, now anesthesia, future. I think a lot of anesthesia techniques have evolved with time. A lot of them suits the laryngologist. A lot of us have shifted to jet ventilation, especially before the pre-COVID era. Now in COVID again, there are issues with jet. But what my question is, any of the panelists who are using jet in their routine anesthesia before the COVID time were using jet? Any of the panelists? Or selectively using jet in some cases?
I certainly don't use jet ventilation now in the COVID era.
COVID, nobody is using. COVID, it is against the nobody is using. I'm talking about the pre-COVID era.
Yeah, I use the early.
Yes, you were in England, so I'm sure England they were using that. Now let me ask the panelists: do you see a shift towards total shift of a laryngologist towards jet ventilation in coming years to come? Despite logistic issues, despite it being expensive equipment, but once you get going, your anesthetist get going, definitely the airway is yours, the whole space is yours. And comments on this, Dr. Nupur? Even if you were not fully using, do you think slowly we will all move towards jet?
I don't think we'll all move towards jet, but I think it will be an amalgam. I'm happy to use a Hunsaker distal jet ventilation tube in certain situations. So I think there are certain situations where there's a definite added benefit and the airway is open, but it is an unprotected airway. So you have to select your cases and you can't use it in very strict stenosis either. So I think there are certain situations I would use it, but I don't see myself completely moving towards jet because everything comes with its complications. And of course, you'd want an anesthetist who's very well trained in jet ventilation also. But I don't think it's going to take over completely.
I think the key is the anesthetist. Anesthetist, you must have a one focused full-time anesthetist who's trained in jet. And then there are limitations. As she said, the aspiration is an issue. The second issue is there are cord movements. With each puffs of air going in, the cords are not totally stationary. There is some movement. And then there are few complications. But despite that, the centers who use jet are fairly happy. And with COVID coming after the COVID times, hopefully somewhere next year, a lot of us may shift back to jet. Because yes, there are a lot of centers whose predominantly the laryngology work is done with jet. Now, Dr. Farinder, your comments on anesthesia. Say in papillomas, if you have extensive papillomas, what do? You, apart from your tube, if you want better exposure, any tips for the people? How will you manage those cases?
Usually we do a routine intubation. We're not doing jet.
No, you do a routine intubation, fine. You secure the airway, but after that you find the whole larynx is full of papillomas. So what? How will you manage the posterior part and others?
Yeah. What they're doing in my setup is they first induce the anesthesia. We create a passage for the anesthetist by removing large masses under inhalation anesthesia, and then they put the tube. What they're doing. And for adults, of course, most of the times we are going now office procedures. So the chances for going general anesthesia adults very less now in my practice.
So you have shifted more to office procedures. We'll talk of office procedures later. Dr. Alok Talulkar is also there in the panel. Dr. Alok, if you have difficulty in taking out lesions with the routine endotracheal tubes, any tips? Dr. Alok? If he is not reachable, Dr. Reshmi Nair?
Hello.
Yeah.
Yes,
your comments. Difficult lesions where the access is not adequate with endotracheal tube. What will you do?
মেসেজ করে দিচ্ছি আজকে রাত্রে খেয়ে নিতে বলবো ওটা আর বলবে কাল সকাল 10টায় আমাকে ফোন করতে
You are muted, Dr. Reshmi. Please unmute yourself. Yeah.
Usually I do it with endotracheal intubation with MLS tube. And if required, we may go in for a jet ventilation, especially an usual airway surgeries.
Dr. Jayakumar?
Yes.
Your tips for lesions where you have difficulty with the routine endotracheal tube. So how will you increase your exposure?
Yeah, usually I go with the endotracheal tube, but as you told, the areas, especially the posterior glottis. When there is a posterior glottis lesion, what I will do is that after completing the anterior part surgery, I will take out the scope and reintroduce the scope posterior to the tube, so that the tube is pushed anteriorly and the glottis is visualized, the posterior glottis is visualized. At that time, I will not be using the suspension. I will laryngoscope with my left hand. Mind you, I don't do the microscope. I use the video laryngoscope. So looking at the screen, so pushing the endotracheal tube anteriorly, I can expose the posterior, mainly the microdebrider for the papilloma. Now, coming to the papillomas in the lower, further bronchoscope and then do the surgery.
Okay. Dr. Alok,
I don't use jet ventilation for.
Right, that's okay. We get that. Dr. Alok Thakur? Your tips where exposure is difficult? I think Dr. Alok is not audible. So we have.
You are muted. Alok.
Sorry there.
Yeah.
Sorry.
Your tips where exposure is difficult.
So you can get an idea about exposure by looking at a pre-treatment evaluation by what they call the laryngo score, or the 5 Ts or the 7 Ts or the 8 Ts. And generally, if the thyromental distance is not too close and it's not a high larynx, and if it's not too obese and it's not a short neck, and of course no trismus, all those sort of things, you would get exposure. But if you still have difficulty with exposure, then my trick is primarily to take the scope out a little bit. And when you take the scope out a little bit, you get the angle wherein the rest of the larynx sort of makes an angle and falls down, and you can get access to the anterior bits. Of course, you can use pressure on the larynx, on the cricoid or on the thyroid, and push it down and get access. Or you can tie a bandage. So I tend to use pressure with my left hand. It is unusual to have it is very, very unusual to not be able to complete an operation. The other thing that you need is, of course, a selection of scopes, because different scopes are going to be useful in different situations. And you want to use the largest scope that you can in a particular situation, but you need a separate scope for the anterior commissure and maybe the subglottis. And good suspension. I like good suspension.
So these are all very, very relevant things to increase the exposure. Apart from that, a lot of us at times work under intermittent apnea. We ask the anesthetist to take out the tube. Good compatible anesthetist will give you 4 to 5 minutes. You can use that time, and you must have a good coordination with the anesthetist, and you put back the tube. But but there has to be a coordination. The anesthetist should not get panicky, and we have worked for almost 5 minutes in intermittent apnea, and again put back the tube. So coming to future, yes, new technology, new things are there, but but there are a lot of very good things in the old guard also, and every technique may not change. You may have new things coming up, but old things will also stand. Now let us come to the allied fields. As our specialty of phonosurgery developed, we saw in last 15-16 years, some allied areas also developed. Airway and swallowing are two of them, which we have seen. Now, whenever we hold our annual conference, there is a hall for voice and there is a hall for airway and swallowing. And these are offshoots of development of phonosurgery. Or I don't know whether they have tagged on, but it is not like that. A lot of phonosurgeons, they developed interest into subspecialty of these. And it is very nice to see these areas have developed. Now, my comment from Dr. Jayakumar, you see any other subspecialty or say brother sister of phonosurgery apart from these two developing in future, which has a potential to develop with voice?
Yeah, I think the major specialties are certainly the voice, airway, and swallowing. I don't see much expansion into other field, but you can tell that the people who are dealing with the airway, you can tell that the snoring, anti-snoring, sleep apnea surgeries come to the periphery of our specialty. But I believe that is a highly specialized area, and unless you are very, very, very familiar with the latest development of that, it's not easy to handle. And the second area, what I will strongly suggest my juniors to take up is that one area we have left as voice surgeon is palate. I think that the palate surgery should be, especially the cleft palate, all these surgeries should actually come under. I'm not telling that we should take it away entirely from the pediatric surgeon and the plastic surgeon, but I think as laryngologists who practice voice, really palate is an area, because this is a totally neglected area of voice. The resonance, hardly anybody speak. When you talk about the phonosurgery, it is almost always about the phonation, not about the resonance. And mind you, this is important in swallowing too. So I think palate surgery should actually come into our field.
Dr. Jayakumar, you're already on the hit list of voice therapists. Now you are likely to be on the pediatric surgeon and plastic surgeons also. But jokes apart, yes. Palate is something which we must understand. And you mentioned about sleep. Laryngeal OSA is again an area of sleep medicine, which is very, very relevant. And laryngologists, probably we understand laryngeal OSA better. And there are procedures also which can be done. Dr. Phanindra Kumar, your comments on this? Any other allied area you feel which is likely to develop?
As Jayakumar suggested, I also feel you have to concentrate more on the resonance surgery rather than phonatory surgery. We had to more concentration should be there on resonance surgery, and more people should be trained in that aspect. That is very essential. And I feel even the practice all the three subspecialties is very difficult: voice, swallowing, and airway. It is not that easy to practice all the three subspecialties. So it is better to confine to one aspect, do a mastery in that aspect rather than going to three subspecialties. When you are not doing general ENT practice, stop it. Better to concentrate one aspect rather than going for a three subspecialty, because that cannot come as subspecialties. If you concentrate only one aspect, you will be recognized as a subspecialist in particular area. So it is the better the juniors or the future generation to choose. Again, you have to choose which one, voice, airway, or swallowing. But again, it becomes a general practice. If you do both, all the three, if you practice, it will become again general practice. It cannot be possible. You have to concentrate only one aspect.
That is fine. And when we make teams, we can have people say, you can have a junior who's into swallow and who's another one into airway, and then you make a team. That is a very relevant point. Dr. Alok, any other field, allied field you see coming up in 5-10 years with voice, airway, swallow?
No, I think these are the basic functions of the larynx. These three basic functions, and these three are what we will stay with. Of course, there is the aspect of surgery of the neck and the thyroid, and minimally invasive surgery of the neck and thyroid, which is sort of coming into the laryngologist perspective. If you are a otorhinolaryngologist, then the neck also falls into the laryngologist rather than to the otologist or the rhinologist. But no, that is about it. I think we will see dramatic changes in each one of these areas, because all said and done, we are not currently giving very good solutions to a lot of the problems we deal with, be they swallow issues or airway issues.
We are coming to that. We are coming to that, each one separately. These are subjects, we'll just come to that. Now, swallow programs. Now, this is what this is for. I'll start with Dr. Reshmi. Swallow programs, how to build a swallow program and improve a swallow program. Now, you see, there is a big chunk of load of these patients from head and neck surgeons and from neurologists. You are expected, if you run, if you are known as a known laryngologist, or to run a swallow program. So your tips on how to build and run a swallow program, Dr. Reshmi?
First and foremost, have a good rapport with the head and neck, with your colleague head and neck surgeons, gastroenterologists, and those dealing with a dietitian and those dealing with the dysphagia patients. And we need to have a basic evaluation fees exam, a good setup for a fees, as well as a fluoroscopic evaluation has to be there, which is a basic need.
Okay. Are you doing TNE in your setup? There were a couple of
No. I don't do TNE.
Right. Dr. Jayakumar, can you summarize how to build a good swallow program?
Yeah, I think among the laryngology specialty, it is the easiest to start is swallowing, because there is absolutely no dearth of patients. For the voice and airway, it may take some time to come. Swallowing, there are lots of patients and hardly any takers. Nobody wants to take the swallowing. So there is no competition. So I will advise every youngster to take up swallowing. It is so easy to build up your practice. Okay. As Resmi told, if you're good, if you're in good touch with the head and neck surgeons, neurologists, they are just waiting for somebody to take lots of patients. You can have lots and lots of equipmentation for the diagnosis, but I say that if you don't have the budget, you start with just with a flexible laryngoscope. Most of the time, you can actually manage almost all these patients with a flexible laryngoscope, because with a clinical examination and fees, most of the time you can do that. As the people develop confidence in you, as your colleagues develop in confidence in you, you will get more and more patients. Then you can gradually add the additions. Fluoroscope is very expensive. So most of the bigger hospitals, only very big hospital is going to buy, especially the high-end fluoroscope. But if you don't have the fluoroscope, you can always take a loan from your cardiology colleague, or you can take the CM from your orthopedic colleagues. Then all other things gradually will fall into follow. But the problem here is that treated not by the surgery, but by the swallowing therapy. And this is very tedious, painstaking, persevering. You need a lot of patience to do that. So it is something like a full-time job. If you are unable to do that, you have to find a speech and language pathologist who is committed and interested. If they are not trained, train them. I think it will work.
Dr. Nupur, you also build a swallow program. So your comments? Yeah, I think the backbone of the swallowing program is my swallowing therapy team. The swallowing therapists, we have 4 of them. I think they actually are the backbone. Once you have the therapist in place and you work in an institute where there's head and neck work, there's neurosurgery department, and there's neurology, you're going to have no dearth of patients, as Jayakumar told us. The idea is to work with the whole team, whether it's just a swallowing therapist, or it's even the physiotherapist, or it's sometimes a head and neck surgeon whose help we take for certain surgeries of swallowing therapy. But our swallowing therapy program now has picked up just because of the fact that there are so many patients, because my primary love is actually voice. But by default, because there's so many patients, the swallowing therapy really has come to almost like a 40-60 situation. I just wanted to mention one thing about your previous question, if I may, Dr. Please. About, I've been thinking about the departments which may develop. Of course, it's not a new department, but I do feel that professional voice has become so huge. It's become such an important component of life that I feel that there will be, it's not a new department, but I think there's going to be a lot of connection between laryngologists and the various groups and subgroups of professional voice users, be they teachers, be they singers. We are coming to that. That's a part of discussion. The second point was that I think with neurophysiologists, we should have probably a better team. There are lots of things in neurology. I think we should have more of a connect with a neurologist, and we actually should have meetings with them occasionally, because I think there's a lot of role of laryngologists picking up certain conditions pretty early on. And the third situation I feel where a department or a teamwork or collaborative effort should be built is a medical education or technology cell, where we can actually start doing a little bit of research with the ideas we have and developing certain tools or material.
These are all relevant points, but they're coming up. Most of them are coming up again. Again, a question to you. Are you doing fees yourself or you recruit somebody?
No, I do the feast myself.
Yourself.
I always have the swallowing therapist there, the swallowing therapist of that day.
Most of us like to do feast ourselves or have a clinician do feast. Now, Dr. Alok Thakkar, airway programs. Now, airway again is a difficult area for a variety of reasons. One is the results are not as dramatic as, say, voice surgeries. It's not like chiroplasties. It is not laser vocal cord surgeries where you are getting immediate results. The logistics are there. Sometimes cost issues are there in private sector where patients need repeat surgeries. So your comments on how to build a good airway program.
Well, you need to have a comprehensive array of skills and equipment to be able to provide the entire array of situations. What frequently goes wrong in this situation is that centers and physicians restrict themselves to a part of the interventions and not to the full range of interventions. So that is number one. You need the full array of endoscopic and external interventions, and of course, you need the right equipment in terms of the laser and in terms of basic dilatational equipment. Beyond that, I think it's also helpful to have a team, because these are things which will often happen in the emergency, which will often need multiple procedures, and from that point of view, it is difficult for a single surgeon to be fully. I'm not saying it's impossible, but it helps to have a team. And of course, you need to have your anesthesiologist and intensivist in that team, because there are going to be difficult situations of securing that airway. Having said that, once these things are in place, I think it runs very smoothly. In our issues, there's never an issue, both in terms of the implementation of whatever surgical procedure may or may not be required in that particular situation, because we have a comprehensive array of surgical procedures and equipments for that available. So whatever service you bring up, I mean, ultimately it has to be a comprehensive service. And that is the challenge in whichever one you take up.
Dr. Faninder, are you doing airway right now? Few cases before COVID time, were you doing airway? Stenosis, early, let's say, webs or dilatations? Dr. Faninder?
Sorry?
My question is to you. Are you doing some airway cases or you are confined only to voice? Right?
I am confined mostly to voice only.
Okay. Dr. Reshmi, please unmute yourself. Are you doing some airway cases also?
Yeah, I do balloon dilatations, Kashima, and all those.
Okay. So, in essence, it is probably younger people who have looking at a 10, 20, 25 year perspective and are in field of laryngology. It makes sense to be more wide-based. It makes sense to because there is a lot in common, and once you are termed as a laryngologist in the zone or the area or the city, then you are expected to do these cases also. So it is worthwhile. But airway,
we are working last 20 years. Where we don't know where we are still in laryngology. We still learning, everyday learning. So one aspect is very difficult, I find, to practice in one aspect.
It's all right. Each one can have, but this is mainly for future, for people who are looking for next 15 years. So the messages are from all of your experience to them. And probably airway is one field. Even if you don't become a pure airway surgeon, at least dilatations, early stenosis, Kashima, depths, these can be tackled very well. Coming to, you need to be more trained.
Kumud, can I add one thing?
Yes, please.
Yeah, I think that point is very important, even though you are not an airway surgeon. And I think I want to add one more thing. Yes. Because it is very important to know for every ENT surgeon and for the laryngologist, what are the options available? Because if they don't know the option and they do a mess up a condition, the treatment becomes very, very difficult for the airway surgeon. So I think understanding the basic concept of airway surgery, where should be a tracheostomy done, it should be through, this is a very, very important thing. I think for that aspect, airway has to be taught to everybody, because if somebody there is a stenosis and somebody do a tracheostomy much lower down, then the tracheal resection become incredibly difficult. So I think that part has to be inculcated to everybody.
Yes. The airway message, the airway teachings have to be spread. Yes, everybody may not be able to do one procedure. Everybody,
the residence level in otolaryngology itself. They had to be trained at that level, at residency of otolaryngology. General otolaryngology need not be a specialty.
Say open airway surgeries, there may be select number of people doing it, but the concept should be understood. And in whom are you going to do conservative procedures, in whom you are going to do open procedures, correct counseling of the patients. That makes a lot of difference, because ultimately results. Even say papilloma surgeries, I consider papilloma to be airway surgery. If it is done by senior resident, senior residents are very competent people, but by an inexperienced person in the emergency and who got a scarred for life, they are scarred. So it should be done by experienced person in the elective OT setting, and because they will undergo repeat procedures. So all these things should be driven home properly. Now we come to the next question, what Dr. Nupur was referring to. Are we going to be more and more technology and equipment intensive in future? Already, laryngology probably among all the ENT subspecialties, if you consider the OPD gadgetry required, if you consider what is required in the OT, and then we were talking of jet ventilation, it's already equipment intensive. So, Dr. Faninder, do you see us, our subspecialty in 15, 20 years, becoming more and more equipment intensive?
Of course, it is quite evident. If you compare last 2 decades, there are a lot of changes in the practice of laryngology. Many people are now going for stroboscopes. Many general otolaryngologists are interested to go for a stroboscopy, which is definitely a good sign that there is a lot of interest is going on in the subjects of laryngology. So many people are getting slowly, they're turning towards the university aspects and they're going to buy the important equipment, equipping themselves in the outpatient clinics.
Dr. Alok Kalulkar, have you joined? I'm not seeing you on your face.
So Dr. Alok is not joining the panel.
Okay, no problem.
Dr.
Nupur, your comments on the equipment? What we are doing, we are already very equipment intensive. I want your reaction on what is going to be in 10, 15 years.
Yeah, I think we are going to get more and more technologically advanced. I think there is a lot of scope for it. And for some reason, laryngology has already so much technology. So the way I see it is a lot of people are working on arms getting very much thinner. So what is robotic surgery just at supraglottic or base tongue is going to get to the glottis. So it will, I think, in the next decade become quite common. I think materials are going to get very advanced. So be it fibroblast growth factors, be it implants, be it a product which can really replicate superficial lamina propria. I think we're going to get there also. Be it something for airway reconstruction of the airway with material which is, very biocompatible. I think we're going to get really technologically even more equipped. That's what I see. Yeah.
I think most of us will agree with that. We are already, we have to make provision that we will remain equipment intensive subspecialty. And as the gadgetry improves, the strobes may improve. High-speed cameras have already come. You may get something better. And we will need...
OCT may become something which all of us may use,
Correct. Already NBI is there. You may have something more. And unless you have the latest, again, the issues are there. Now, so Dr. Jayakumar, this strobe, high-speed cameras, NBI, what next? Anything you can predict? Or you like to leave it for future? Anything more which is going to come?
Now the chip-on-tip laryngoscopes.
Yeah, that is already, that is 10 years back. Now they have improved. Yes, anything else?
Purpose, make a lot of difference in the diagnosis.
Right.
Yeah, okay. I would like to have further development, but I think I am very poor in this kind of thing. So I cannot really say what is going to be next. But what we probably want is actually more magnification. Maybe that is what I think. I always think that sulcus remains our biggest challenge in phonosurgery, sulcus and scar. And all the surgeries described are really not very good. They are not actually completely the most ideal. So I think with probably much bigger magnification, we may understand the pathology of the pathophysiology of and pathoanatomy of the sulcus, and we may be able to do endoscopic, much more precision microsurgery if we have got magnification. That is the only thing I can think about. I am very poor in this field.
Dr. Alok Thakkar, anything else? Your wish list, or you see something more coming in
I think
laryngology?
we'll understand physiology a little bit better, and that is happening, of course, with EMG, which is a very gross way of looking at muscle being stimulated. And of course, I think high-speed endoscopy, high-speed cameras will come into swallowing over time, and we'll probably understand it a little bit more. But really, that's it. I mean, that's as far as I can see.
Now, there is a lot of noise over made in India, especially with China in bad books. The cost of any laryngology equipment, I just put some indicative costs. Stroboscope is at least 50 lakhs. Some higher end companies may be more. Chip-tip flexible, 5 to 7, 10 lakhs. 90-degree telescope, 2 to 3 lakhs. So everything is expensive. Now, if we put thrust on, say, Make in India,